Looks like this webinar is being live streamed. Are we good?
Yes, sir.
Thank you. Good morning. I'm State Representative Jonathan Steinberg from the town of Westport, co-chair of the Public Health Committee. We are here once again to hear testimony on a large number of bills, which should provide for a very stimulating day for all of us who will be involved. I will start by welcoming my co-chair, Senator Anwar. Good morning.
Good morning. Thank you, Mr. Co-Chair. I'm Senator Saud Anwar, representing the 3rd Senate District, including the towns of East Hartford, South Windsor, Ellington, and East Windsor. And this is our ongoing journey for this session to continue on to listen to the public on some very important bills. Thank you for our fellow legislators and community members who have recommended some of these bills to be raised. And we're looking forward to learning and making sure that as we move closer, we address some of the issues that people may have, and looking forward to a fruitful day. Thank you, Mr. Co-Chair. Back to you.
Thank you. Good morning, Senator Wong.
Thank you, Mr. Chair. And indeed, another busy day in the General Assembly. I'm eager to get started to listen to people, but I know I've repeated many times that there are many other conflicting committee hearings and meetings going on right now. That membership may be going in and out. That doesn't mean we're not paying attention. We will review on the on-demand, read all the testimony, but I know there are many conflicting meetings going on. I just wanted to point that out to the general audience. Thank you, Mr. Chair. Eager to get started.
Good morning, Senator Summers.
Good morning. I'm just eager to get going, hear what people have to say and their input on these important bills we are reviewing today. Thank you.
And last but not least, good morning, Representative Pettit.
Morning, Mr. Chair. Ready to go, ready for the first testimony. Thank you, sir.
All right, so I guess we are ready to go. Just to remind everyone of our ground rules, we have, as usual, roughly 100 people who'd like to speak today. So we are going to be pretty rigorous about maintaining the 3-minute rule. You will be advised when your 3 minutes are effectively up, and we'll ask you to then quickly conclude. There's a good chance you'll be asked questions anyway, so use your 3 minutes to provoke those kind of back and forth conversations. I will just also remind you that we really want to focus on policy, not on people. So let's keep it focused on how we can make these bills better, or why we should or should not make them law here in the state of Connecticut. As we usually do, we devote the first hour to elected officials and members of state agencies. And today will be no different. If I can just find the requisite page, I'll be right with you. Here we go. First up today, we are honored to have our esteemed Senate Republican Minority Leader, Senator Kevin Kelly, should be pretty easy, followed by the Commissioner of the Department of Public Health, Ywca. Good morning, Senator Kelly. He still hasn't arrived, so why don't we begin with Commissioner Tritani from DPH. Good morning.
Good morning. Thank you for having me here today. Senator Anwar, Representative Steinberg, Senator Summers, Senator Huang, Representative Pettit, and distinguished members of the Public Health Committee. I'm here today to testify on the following bills: 5481, 5482, 5484, 453, 454, and 457. You have written testimony for me on all of these, so I was going to keep my remarks brief. If it works, I will just give a brief summary of each one, try to stay within my 3 minutes so that we can open it up to questions. For 453, concerning transfers and discharges of residential care home residents, this bill will allow residents in RCHs with a home and community-based waiver to continue to receive services. This home and community-based waiver program is a federal program that has specific mandates, and one of which is a specific resident protection under landlord-tenant law. So this bill revision allows for the transfer and discharge statute in an RCH to mirror that of landlord-tenant law and align with the federal requirements. This is the reason for this proposal. Second, for 454, regarding Centers for Disease Control and Prevention Youth Risk Behavior Survey, this bill will mandate the department to administer the school health survey based on this federal behavioral youth risk survey. The bill also requires selected schools to participate. DPH has been administering this program since 2005, but engagement from selected schools has been low because it's been optional. And yet a lot of our decision-making is based on knowing what's happening on the ground. So that's the reason we are asking to make this mandatory. Next, for 457, regarding Connecticut's immunization information system, the purpose of this bill is to increase engagement in Connecticut vaccine program and to maintain safe and secure access to vaccine records for individuals, healthcare providers, and public health officials. This is how we were able to determine COVID vaccination rates and people to have access to records for themselves. For 5481, an act concerning the department's recommendations regarding change of ownership in healthcare facilities. The purpose here is that all pertinent information regarding change of ownerships for healthcare facilities be thoroughly reviewed to prevent any bad actors from acquiring healthcare facilities. Currently, a change of ownership is reviewed when change of ownership is greater than 10%. So this would require it even if it is less than 10%. For 5482, regarding Legionella mitigation, the purpose here is to require water companies to test water at entry points to healthcare facilities that serve more than 1,000 people to prevent Legionella infections and other contaminants. This bill also requires water companies to treat their water to maintain certain levels of chemicals to prohibit the growth of bacteria that leads to legionellosis. And then on 5484, an act concerning the department's recommendations regarding private and semi-public well testing. The purpose of this bill is to require water quality testing of private or semi-public wells prior to sale, exchange, purchase, or transfer of real estate properties and newly constructed or private and semi-public wells. The laboratory performing the test is required to report these results to DPH and to local health. And the tests would include total coliform, nitrate, nitrite, sodium, chloride, iron, manganese, hardness, turbidity, pH, sulfate, apparent color, odor, lead, arsenic, and uranium. So I will stop there so that we can open it up to other questions.
Let me start by providing you with a little bit more time if you so require. The number of bills that you read off, no one could have covered in 3 minutes. So if there were a couple that you chose to skip for a lower priority and you'd still like to say something, let us afford you that opportunity.
So there are other bills that, I mean, in addition to the ones that I just rattled off, that are being heard that DPH is testifying on. So I don't know if you would like me to discuss those or raise more issues regarding the specific ones that I did address, the 6 that I addressed.
I would simply suggest that since we do have your written testimony, if you wish to highlight something particularly we might need to change, that's the thing that we're probably focused on.
Okay, so I think the thing that I would like to highlight most is 457 regarding the immunization information system. And just to really highlight why this is so important. I think what we saw in the pandemic is that the ability for DPH to collect these data, to be able to provide summative statistics, to be able to provide information on these data, and for people to be able to access their records, that this was an invaluable asset. And I think for vaccinations, particularly, of course, COVID vaccinations, but for other vaccinations as well, to have a central registry like this, people can opt out of this themselves if they would like, but that to give this opportunity really is imperative for public health.
Very good. I see we have a number of questions. We'll start with Representative Pettit, followed by Representative Foster.
Thank you, Mr. Chairman. Thank you, Commissioner. I don't know that specifically goes to the bill. You made a comment on the vaccination bill. Just for the public's information, in terms of the vaccination registry, if you will, it's a general question about who has access to it. Is it only a limited amount of people in the Department of Public Health, or who has access to that registry? It's a common question many of us get from constituents.
So just to make sure that we say this most clearly, I would like to ask some of the subject matter experts at DPH to weigh in as well. Okay, so I have two people on. Kathy Kudish, do you want to maybe first speak to this, and then I will turn it over to Henry Salton as well? Kathy, could you speak to this first?
Sure. Thank you, Commissioner, and good morning, everyone. CTWIZ is the name of our immunization registry, and access is granted to healthcare providers to look up their patients. Local health, the bill would give local health providers access, local health departments, and school nurses also have access. And this is maintained using a provider agreement. When providers sign up to give vaccines, they send in who their staff are that should have access to the system. And then those staff can go in and request access. And our DPH staff verify that this person should have access, and they sign a confidentiality agreement saying that they will only use the data for its intended purpose. Other healthcare providers who have access to the system, when they go in, once they're granted access, they can search for patients, and they need 3 search terms to look for a patient. They can't just go in and have universal access to the immunization registry.
Beautiful, thank you. And is there any follow-up, say 3 months later, 6 months later, that someone administratively looks to see who has access, or if there's been attempts to access the system, or is that fully a function of the IT department within DPH?
Yeah, so once a person goes in and they fill out their user request, it's sort of the usual things that they get a password, and they have to have a personal email to access. Like, you can't use a group email, you need your own email address. And if you're inactive for a period of time, then your account is disabled and you have to reach out to our IT support to re-enable it.
And I'd like
our constituents, thank you for that explanation. Thank you very much, Mr. Chair.
Thank you. If I could just ask Attorney Henry Salton to weigh in a little bit more on this. Henry, could you do that, please?
Sure. So Representative Kathy Kudish did provide you a very accurate list of those individuals or organizations that have access. One other thing that is also added in the bill is one is it allows federal health agencies that provide services to individuals to report to and have access. So the VA in West Haven, because they do not have Connecticut licensed physicians often stationed there, this will give them access to participate for vets who receive immunizations at their location or other locations that they administer. In addition, it also allows us to share information with other states' immunization registries. So for example, individuals who may be working in New York cross the Connecticut border, and then one afternoon or after work go to the CVS in the Connecticut office location, their information will be in our registry. But New York, under current law, would not be able to inquiry and say, by the way, we have an outbreak in a local community. We're trying to find out, we know that 20% of them work in Connecticut. Can we get information? The current law would not allow us to share it. This gives us this access. And then finally, the commissioner, depending on, unusual circumstances, for example, where there's an outbreak or whatever, the commissioner can use the information in order to engage appropriate steps to address that kind of situation.
Thank you, Attorney Salton. Thank you, Mr. Chair.
Thank you, Representative. Representative Foster, followed by Senator Wong.
Good morning, Commissioner Jasani. Thank you so much for being with us today. I have 2 questions. The first is about the well water contamination bill, and there's 2 that involve well water contamination on the agenda today. Well, I think actually there are 3 that touch on well water contamination. I would love it if you or your staff could expand upon What are the challenges in our current system that relate to monitoring private wells, and how these bills will impact how we can protect water safety and folks who have private wells? This is a really big issue in our community. You touched on most of the contaminants in our community, but we also have EBVs and PFAS in people's wells. And so I would love it if you could talk a little bit about what the limitations of our current system are that this bill will shift.
Thank you for that. So I'll start with a few comments and then turn it over to our subject matter expert, Lori Matthews. So first of all, I think, this particular bill is allowing for and requiring testing at the point of transfer or at new construction. And I think this is really important so that you really know what contaminants potentially are in a public, semi-public or private well. And then in addition to that, I will just say, aside from this, things like PFAS, the money that we're getting through the bipartisan infrastructure law, we are getting funds to the state to be able to address things like PFAS that are not specifically in these bills, but we do have funds that are going to be able to address some of those concerns. So, Lori, would you be able to expand a little bit more sort of in a holistic way of how, in the big picture, all of these bills are going to improve monitoring safety of well water?
Yes, Commissioner, thank you. Lori Matthew, and work in environmental health and drinking water. So thank you, Representative Foster. Excellent question. So currently, private wells is about 322,000. Yes, 322,000 private wells across our state, many in our very rural areas that serve about 800,000 people. As the Commissioner noted, they're only tested one time when they're drilled. Many of these wells are old, have never been tested. Never. So we're thinking, our thought is to, at the very least, and we've calculated about 10,000 property transfers a year, that on property transfer, that you would at least do a test so that when a person who is looking to purchase a home would have an idea of what their water quality is. It is not the end all of everything. Other states require testing on an annual or more periodic basis, but here we thought, because the need for treatment, as Representative Foster, we've run into many situations where a treatment is needed or necessary, and a homeowner who just purchased a home for hundreds of thousands of dollars didn't realize what the water quality was or what the treatment needs are. And it provides a better information so that the potential homeowner would be able to, provide treatment for those wells or those different varying contaminants that are in the ground. So.
I just want to make, I'm sorry, Representative Foster, I just want to make one other comment on this, just in 456, which also addresses clean and safe well water. One of the things that bill only mentions private wells, while the department would also like to recognize semi-private wells. That's in our written testimony there. And also, we'd like to see that potable water be provided for some of these areas as well. So it's all in our written testimony, but I think those are some adjustments that can be made to that one.
May I ask a follow-up question? And if either the commissioner or if Lori would answer this. First, I want to say I'm incredibly grateful, Lori, to you and your team and the entire Department of Public Health for your support of my community as we've been really grappling with lots of folks having unsafe drinking water access in their community. It's been one of the biggest issues that I've faced since I've been elected with our community, and your department has been really helpful. The follow-up question that I have is, right now, there's a lot of different ways that reporting related to well water contamination gets to a variety of different agencies. Do these bills go far enough in generating a centralized database that we will get a better understanding of regional or street by street understanding of where we might need to look out for contamination? So let's say you get 3 people on the same side of a road that you have now been notified during property transfer that there's an issue. Are we going to have enough data in a centralized location that we could warn other people that it might be appropriate for them to also test their wells? Are we getting is this going to allow us to be more proactive related to well water contamination and concerns of that?
Go ahead, Lori.
Thank you, Commissioner. Yes, very good question. Along with the bill that our department is proposing is a data system. We're asking for a little bit of money to stand up a Maven instance so that that information can come in electronically within DPH. We're also asking for one staff person who can help analyze and put the information together to do exactly what you said, Representative Foster. To be able, the information would be shareable with local health directors, and we can work together on where the needs are, and the data can be shared, within this, within us at the Department of Public Health, working with local health to better understand the water quality in different parts of our state. As you noted, there's various areas of EDB or PFAS is an up and coming item, but also certainly sodium, chloride, uranium, arsenic, manganese, iron, you name it, it's there. And we can put it in this data system, and under our team, Ryan Tatro is the supervisor of our private well program. We have a team of 2 people, but he works very closely with local health directors to help support them in the time of need. But this will help us, for the very first time, be able to see where the concerns are in a regional area, but also statewide. And to your point, to be able to help, to Commissioner's point about the infrastructure funding, to be able to look at where we need to do investment.
And this is my last comment that I'll sort of raise is there's a lot of regional concern here around these issues. And when I reached out to my local health department, they are all working really, really hard. But as we know, in many of our health departments, local health departments, we have folks spread really thin. The way that our data exists right now in local health departments, in many times it's paper copies sorted by street address. And so if you were to say, I want to understand how big of a concern road salt contamination of private wells is, quantifying that is really challenging because of the way that the data exists in the current infrastructure. And so if you have institutional knowledge that retires, which is happening, I'm sure, in health departments and state agencies across the state, we could be in a really big issue if we don't have computerized data entered in analyzable format. So I'm super grateful for this bill and how it was raised. My last sort of closing thought is, are we going far enough? Are people who are struggling right now with well water contamination going to have what they need to have safe drinking water in their home for themselves and their pets?
I would just say that this is a work in progress. I think these steps are major initiatives that will get us on that road. Is there going to be more work to do? I definitely think so. But I think that this is going to be first steps that can help us get there. Lori, anything else you want to add?
No, Commissioner, well said. Exactly. It's a road. We're starting this road. It's taken us a long time to get to this. I want to thank the working group and the team led by Dr. Mike Dietz at UConn, who led the effort to put together a white paper. That white paper is noted in our testimony under the Water Planning Council. It's one of the initiatives under the state water plan. You might be all pleased to hear that this was one of the top priorities, was to deal with private well issues, knowing where the wells are and understanding their water quality. So I want to thank the members of the implementation team that worked so hard to put that white paper together. Thank you, Commissioner.
That it, Representative Foster?
That is, thank you very much.
Thank you. Yes, and I think we're all very appreciative to see a very tangible example of how the state water plan is working to protect people in the state of Connecticut. Before I hand it off, I have a quick follow-up. Mention was made of PFAS in the water supply. Given its virtual ubiquity in the water supply, what is the protocol? What can we do about it, even if we detect it?
You mean, how can we remediate for it? Is that what you mean, Representative? So I've learned a lot, I will say, from Lori about how we can do that. And as you said, it is ubiquitous in a lot of different places. But there is a methodology to do this, and I'm going to let Lori speak to it since she really is the expert on this.
Commissioner, thank you. Yes, and as the Commissioner noted, PFAS is the forever chemical. It is in many products, and it's found in many places. Under the governor's task force, started right before COVID, we have a task force report which outlines a strategy between ourselves and our colleagues at the DEEP. We work very closely together. And within that strategy, we're working on where to start testing, what our action levels should be. Our toxicologists have been taking a careful look at that. EPA has not moved fast enough over the last many years, but they are starting to move toward setting a maximum contaminant level for at least 2 of the 9,000 chemicals that make up this chemical family. So it's quite the challenge. And under Governor Lamont and the task force that was formed, we're following through on the steps. We've purchased I could go on, and I won't.
Yeah. I think, Lori, maybe you could just, to his point in terms of actionable levels, like what actions with the equipment, maybe you could just give a very brief, like sort of how do we act on it?
So yes, exactly. So it's simple treatment actually, but expensive. It's carbon treatment. That's the good news. But it's expensive because the vessels, it's not a simple vessel. It has to have a lot of contact time in the carbon. So it is treatable, but it's expensive treatment.
Thank you for that. I don't think the general public, and I wasn't aware that there are at least solutions in the most extreme examples where concentrations are clearly a manifest danger. So that's good to hear. Senator Anwar, followed by Representative McCarty.
Thank you so much, Mr. Chair. I do have a series of questions. I will start with the water issue first. Commissioner Tritani, thank you for you and your entire team for the work you're doing and your testimonies this morning. With respect to the PFAS, we know there is some federal funds that is available. And I asked this question in another forum, but I think it's worthy to repeat it. And then I'm hoping we'll get a better answer. Many of our towns have a number of other contaminants in their well water supply, and they have not been tested for PFAS. And as a result, they do not have the resources that the federal government is willing to contribute right now. Is there a simplistic way the state can help do the PFAS testing as well for some of these well water remedial opportunity and then money that would be needed? So that's the first question. And the second one is, ultimately, in an ideal world, we will need community water supply across the state. Do we have a strategic plan for the next 5, 10, 15 years, how we're going to be able to achieve that, and how can we learn about it, and what resources we need to place as a state, because ultimately that's what is going to be needed, because the Band-Aid strategy is only going to go so far.
Yeah, I think your Senator Anwar, your points are very well taken. And I think what I would say, first of all, I'm going to ask Lori to expand on this, but in terms of your question on whether certain well waters could be tested for PFAS, I think what you're asking is, sort of the cost of testing for that, and then in order to become eligible. And what I would say is, Lori's going to have to expand on this, but there are only certain systems that are eligible regardless of testing. So just to make that clear first, it's, correct me if I'm wrong, Lori, but I think it's 725 water systems that are eligible. So out of all the water systems that we have in the state, not all are going to be eligible for this PFAS remediation monies. So I think the first thing is to identify which ones are actually eligible. Then out of those that are eligible, doing testing to be able to identify whether, if eligible, PFAS was identified, then could, an application for those PFAS remediation funds specifically be made, is where I will turn it to Lori. And then sort of your more global question, which I think is a really important one, on how we could consolidate. I'll have to see if she has other thoughts on that. So Lori, if you could answer those 2 specific questions for him. So, one, how to determine if you're eligible. Second, how can we determine PFAS testing in those areas? And then third, the sort of global approach to water.
Yes, Commissioner, thank you. Yes, you're absolutely correct. There's 725 public water systems that are eligible for the bill funding, the bipartisan infrastructure money, also known as the Ywca money, that is coming for drinking water, for safe drinking water. So the 725 systems, why are they the only ones eligible? Well, they are all of the community systems and all of the non-profit, non-transient community systems, such as a school, or an office building that is serving a municipality, so nonprofit. So there's 725 that are actually eligible. And right now, one of the things that we're working on with our colleagues at DEEP is the vulnerability across, I think Senator Anwar, there's a vulnerability assessment that has taken place with our colleagues at DEP under the action plan from the governor's action plan and task force. So we've looked at vulnerability statewide. We have many points of vulnerability and we're working with DEEP. DEEP is looking to potentially sample around areas that are of concern, such as landfills. And there might be there are private wells and public supplies that are nearby. So that's one effort. Another effort that we're working on is, just to Commissioner's point, is to utilize the infrastructure funding, which is about $40 million over 5 years, so about $8 million a year, to invest in systems that have concerns. And it's up to 100% reimbursable. So it is a loan. And again, it's to Commissioner's point, you have to be eligible for the funding. You have to come in through the Drinking Water State Revolving Loan Fund process that we have under Commissioner Tritani and within our drinking water section. And it's a process with a lot of federal crosscutters, which means a lot of federal rules that you have to follow. So that funding comes along with a lot of rules and requirements, but we're here to work with the communities and the systems that do find PFAS. We're always here working with our colleagues at DEEP to help with the technology and understanding to be able to deal with it. We've worked in Greenwich and Windsor, in Ellington, in East Hampton, and a variety of communities, Killingworth most recently, where they found PFAS, and we work together to help the local health directors. So there's so much more to come with this, forever chemical. Oh, and on the planning, I do want to mention, so Commissioner, and Senator Anwar, there is a planning effort, and it's been in state law since 1980. It's known as the Water Utility Coordinating Committee. Is an up and running process. In 2018, the plans were developed. They are regional water supply plans. There's 3 of them for the state. They are signed off on and approved through our department in 2018 by Commissioner Pino. It's an up and running process that everyone is invited to, and I could provide more information. So the plans are to look at where the issues are, where the needs are, and plan how to get public water out to that area to serve those needs. So I could share more information, Commissioner.
Thank you so much, because I think there will be significant investment that will be needed from the part of the state and maybe some from the towns. And that's why it's worthy to have a plan, and they can make it the part of their strategic plan. I just want to make a comment, and I'm not sure you'll be able to speak a lot on that, but water is one of the most essential parts of our survival. And the team that is overseeing the safe water in our state, because there's been a push to make a lean government, that we have become so lean that it is unsustainable to have 1 or 2 bodies maintain the quality of water in our state to oversee that. If one person is sick, we will be in trouble. And I just worry about that. And I give that example that we cannot get any more lean because we'll starve to death, because the water is essential, and that's what's happening in multiple departments. Do you have a plan to address that, to have a understanding that don't have enough bodies to address some of these things? If God forbid anybody was unwell or had a family emergency, what would happen?
So I think what I would say is, first of all, pandemic has highlighted the need of public health when it comes to infectious diseases. But as you accurately point out, Senator Anwar, water is a very basic, essential element, and safe water that people can turn on the tap and feel comfort that they're getting safe drinking water is such an essential, important aspect of an industrialized society. And I think you could not have said it better in terms of resources to the Department of Public Health that are necessary to sustain this. Again, this is one of the things that people take for granted. And it's not only to DPH, but to local health, as you identified. So part of my initiatives as a new commissioner is workforce development. And that workforce development goes not only to DPH, but to local health as well, because you're exactly right. What we're looking to do is to build up more expertise. We need sustained funding and, a little bit of extra as we try to be judicious in what we ask for, but to be able to sustain these programs and be able to have something we take so for granted as to be able to be on top of it so it doesn't fall through the cracks, both at DPH, but then in this workforce development idea, which we are starting as the pandemic is getting to a place where we can manage it, on a more routine basis a little bit, even if we have surges, but to be able to focus on workforce development so that we can help local districts recruit good people, get them trained up and sustain them and maintain them so that we can have that continuity across from the state level all the way down to local municipalities. Lori, anything else you want to specifically add?
Yes, Commissioner, and I want to let everyone know that Commissioner Tritani has been incredibly supportive and has actually one of the first things that Commissioner, when we first met each other, we talked about workforce. We talked about how many staff, Senator Anwar, to your point, how many staff, how many people are leaving, how many people are retiring with so many years of expertise. On today is Mike Cage. He's an example of someone with 36 years. He's been around since the 1980s, and he recently retired. Replacing people like that is incredibly important for us. So Commissioner Tritani has, we have actually under her direction, have put together a very good staffing plan. And we are, as much as you can be on top of being proactive for replacing people who have retired and people that leave, and to get ready for the infrastructure funding. It is really important to be able to have the staff that you need to be able to invest the money correctly. So we've been working very hard on a staffing plan and workforce development.
Thank you so much. I wanted to bring to your attention bill number 448. This is about the Department of Correction. SB 448, and I wanted to share with you the reason we are putting this bill forward is that Department of Correction almost on a yearly basis has pretty sad cases which are not up to the standard of care, resulting in the state having to lose lawsuits, which are something that we should just provide the level of care so that we do not expose. So the taxpayer end up paying a lot of money because of that. Department of Correction is not a healthcare organization. Can we have DPH oversee that part of the Department of Corrections healthcare that is provided to the people who are in correction?
So, we usually license practitioners and facilities. That's our standard sort of licensure categories, right? So are you specifically asking about licensure of a healthcare facility within DOC? Is that what you're thinking of?
Yes.
So I would need I'm sorry, go ahead.
I said if the DOC chooses to use that path, I want to make sure that there's DPH overseeing that in some respect that would make sure that not only the practitioners are there, the ratios are appropriate, and the facility is up to speed to provide the standard of care.
Yeah, so I mean, I think, like as we just mentioned, the providers are licensed, but if we were to go down a road where DOC were to establish facilities, then that is something that we could explore. Then they would be subject to facility licensure. I think one of the challenges would be what type of facility would they be? It's probably not something we have in our docket. And I see that Henry Salton has come on. Henry, do you have other comments on that?
Well, I think that we would have to get legislative authority because under the general principles, state agencies like the Department of Corrections, unless there's a grant of authority to DPH to oversee and license them, and I think you did that a few years ago, for example, with Wildling, in the absence of specific legislative authority, they're not subject to the jurisdiction of the department. We would have to have that. We don't have that authority, and of course, if DOC, as it has in the past, decided to, for example, contract out to a private healthcare organization, let's say, to say we want you to set up clinics or hospital level services for our inmates, that organization would be licensed in Connecticut, and then be, but for the time being, under the existing system where corrections operates within its own purview, they don't fall within the department's jurisdiction, absent a new legislation.
I'd like to have Barbara Cass also comment to give us sort of the breadth of what DPH and other entities do within DOC. Barbara, could you comment?
Yes, thank you, Commissioner. Good morning, everyone. Good morning, Senator Anwar. We have had conversations through the years about licensing outpatient clinics or as infirmaries, as they are referred to in the Department of Corrections. But as Attorney Salton has indicated, there may be some jurisdictional issues because they are a state entity. We do currently license methadone delivery in several of the jails and in the prison system, but they are licensed by an outside entity who brings the services to the correctional facility.
Okay.
So if I were to summarize, if I were to summarize from that, I think the things that would need to be thought about are whether, you know, some sort of entity that's licensed who's coming to provide services to DOC would be, you know, the way that it would be approached, which I'm assuming something like that is happening currently versus licensing clinics within DOC, or some other statutory language that actually gives the department authority, since we don't have that right now.
Okay, thank you so much. This is very insightful, and I have a feeling that obviously the status quo is failing, and that's why we have this bill to look at that aspect. Yes. And we're trying to legislate the quality, if you will, and the ratios, and then that's one way to approach this. And maybe the second phase is going to be to have somebody who has the expertise, who oversees all of the facilities in the state of Connecticut, to be able to help guide the Department of Correction, who do a good job in what they're doing, but this is not their expertise. So that's why we feel there's an area of opportunity. The third bill I want to talk about, thank you, Mr. Chair, for allowing me further, 449. This is about highly skilled workforce for the recruitment of physicians and retention. If we stay on the current trajectory with the environment that we are in, it would not be a place to get old in our state, and we are one of the fourth oldest state in the country, and I do feel that a lot of people like to be here because of the quality of healthcare, but we are going to lose that unless we make some drastic strategic changes and then have a plan of action for the next 4, 5, and 10 years to retain the physicians in the community and attract more. And then we look to your office to be partner in this effort. And I would love for you to reflect on the bill as well, if you could.
Sure, absolutely. So I share your concerns. I very much would be a supporter of the basic premise of what you're talking about, which is, you know, to retain and recruit good physicians in the state of Connecticut. We absolutely need to do that. I did that for decades as an educator and as somebody who ran training programs to try to keep people in the state of Connecticut who we train. So I very much echo those principles. I think some of the points I would just raise, and some of the department's comments about this, which are in our written testimony that we've provided also, are that the loan repayment, you know, the governor's bill does offer loan repayment to a broader group of health professionals, not just physicians. And so I would advocate that we have a healthcare crisis in our state. I am in complete agreement that we need to do this for physicians, but I think that keeping it broad for a broad range of healthcare providers is also necessary, because we know of other providers that we're also having shortage with. The other just comments I would make are, you know, regarding waiving physician license renewals for 3 years, I believe it is, that you had in there. That would be about $9 million annually that we would lose. I think that would be a very heavy hit for us. So I think that would be a tough one to really swallow. I think another thing I just wanted to comment on was, you know, the increasing medical residency program slots in fields. As much as I'm in agreement with the idea that we want to increase recruitment to people who train in the state and potentially might stay in the state, as a former educator, as somebody who did do that successfully for one slot, let's say for an ID fellowship program, it really is, the onus is on the educational program to demonstrate that there is an educational need, not a service need for patients who are there, but an educational need and service that you can be providing to those who are coming into a program. And because we have no oversight on medical education, actually, right? That's not part of where DPH sits. As much as I'm supportive of the idea, I don't know that DPH has the lens or really the expertise at being able to comment specifically on increasing residency or fellowship slots in those positions, because I think that is something, maybe the combination of the Office of Higher Education, I can't speak to that for sure. But you know, that there are other areas where that they would have a better view into that than we do as a department. But I do support the premise of what you're trying to get at.
Thank you so much. And while there's an increase in the number of other healthcare professionals coming to the state, but we don't have the physicians, and they're the ones who are leaving. So that's why it has to be tailored towards the ones who are leaving or not choosing. Even you would probably attest to the fact that all the residency programs, majority of the people are leaving when they get trained. So we train the best physicians in our state for the rest of the country, not for our own state anymore. That's part of what I hope that we will be able to address at some point. But thank you so much, Commissioner. Thank you, Mr. Chair. I will stop here.
Thank you. And Representative McCarty has been waiting very patiently. Sure.
Thank you. Thank you very much, Mr. Chair, and I'll be very brief, but good morning, Commissioner, and thank you for your testimony today. If we could circle back just for a moment to SB 457 with the Immunization Information System. As I was reading through it, particularly looking at the lines 52 through 60 that dealt with the school nurses and the immunization record, could you just briefly comment on that process, how it will work? It looks like from the language in the bill that it would be DPH reaching back to the schools with the information. And then there were two lines in that particular area that said that it would enable provision of outreach to assist in getting each child vaccinated. Just wasn't clear on what exactly DPH would be doing as far as an outreach provision. And then just finally, if you would again clarify that if to be part of this, and I understand the rationale behind it, but just to put at ease that for those individuals that may have some hesitation with their information being shared, that this is a voluntary process. So just really the process between the school nurses and DPH.
So I'm going to ask Kathy Kudish to give more details, but I do want to just emphasize your last point that this is optional. This is not something that is a mandate, but it allows us, it gives us that opportunity, you know, for all the things that were previously outlined. So I just want to really emphasize that point. But go ahead, Kathy, if you could specifically comment on the school interface first in terms of her question.
Happy to. Good morning, Representative McCarty. School nurses can request access to the immunization registry, and it follows the same verification process that DPH staff verify the school nurse works there, and they can get access. And they can search individual students and create a roster of their students, or there's a functionality in the system that they can upload their student roster and the system can return their students, and they can check that their students are up to date on their immunizations by running specific reports. And if they determine that a student, say, is missing an immunization that's required, they can then easily identify that student and go to the parents and say the student is due for a vaccine for school entry and they need to get that vaccine. And so when they search for a student, if the parent opted their child out, they won't find that student in the system.
Okay, thank you very much. Yes, that clarifies. So it would be kind of a mutual interaction there. So thank you very much.
Thank you. And Kathy, if I was to just expand on that a little bit, you know, for many parents, and correct me if I'm saying anything incorrectly, but for many parents, you have to fill out a you know, immunization record that you submit to the school. If you have opted into it, a school would be able to identify what immunizations a child has received. That would be correct. Correct, Kathy?
Yes.
Yes. So for those parents who would be normally, filling out that form that we've all done when your child is entering kindergarten or something like that, this is another system, another way where it would all be centrally registered.
Mhm. Okay, thank you very much.
Thank you.
I don't see any further questions. I'll just echo the comments of my colleagues. There's an extreme focus, as appropriate, on workforce in the healthcare field these days. So rest assured, not only are we seeking to address the burgeoning access crisis caused by practitioner shortages across the spectrum, we're going to be very interested in making sure that DPH is also appropriately staffed with the requisite experts to do your job, because we're only going to be leaning on you heavier than ever before. So thank you for all that work, and we hope you weather the prospective pension cliff well with your plan. Seeing no further questions, I understand that Senator Kelly is now in the room, though I imagine he will use up the remainder of our elected officials' hours, so we will be shifting after him to the public. Donna Shaw will be next. Welcome, Senator Kelly.
Good morning, Mr. Chairman. Thank you for the opportunity to address the Public Health Committee. Also like to thank Senator Anwar, Senators Summer and Huang, and Representative Pettit, and all the members of the Public Health Committee. I'm here to testify in favor of Senate Bill 451, an act establishing a work group to study the expansion of mental health resources to children. I'd like to thank the committee for raising the bill in recognition of a request submitted by myself and Senators Ywca, Huang, Summers, seeking to raise a bill in memory of Norvan Edwards, a Connecticut child who passed away at the age of 8 years old following his and his sister's significant challenges with mental health and struggles accessing needed supports. Earlier this year, the Public Health Committee heard the heartbreaking testimony of Norvan's mother and grandmother. No child should experience the barriers to mental health supports that this committee heard about in their testimony. Any parent or caregiver who sees their child struggling with mental health challenges must have needed support, care, and treatment for their child without barriers to that care. That is why I seek the committee's support in establishing a work group of healthcare professionals, child advocates, and the Department of Public Health and other stakeholders and experts to develop a plan to expand access to important mental health resources for Connecticut's children and study the impact of racial, ethnic, and socioeconomic health disparities, inequities, and barriers to access and delivery of such care to children. This committee has shown strong support for expanding access to mental health resources for children, but we also must recognize that when talking about access, we must also identify and address barriers to care. To build a healthier Connecticut, we must examine and confront systemic injustices involving race and ethnic health inequities and barriers to care across the healthcare delivery system. At a time when mental health issues are increasing at alarming rates, Connecticut must also address the state's mental health crisis facing our children. And our efforts must include a focus on better understanding and addressing racial health disparities and issues related to the access in child's mental health care. In honor of the life of Norvan, gone far too soon, and his sister Norve, who struggles with serious mental health issues, I ask that the committee consider including the names of Norvan and Norve in the bill language and working group mission and title. I also ask the committee to please pay close attention to the recommendations that will be presented later in testimony by Antonia Edwards, the children's grandmother, which regard task force membership to ensure community, service provider, and parent representation. In addition, I ask that the committee also consider the value of establishing family care coordinators to bridge communication between our children's care providers and support systems such as schools and pediatricians or acute medical care, to ensure a continuum of care. I thank the committee for raising this bill, and I look forward to working together with the committee to advance the bill forward in memory of the Edwards children. No child should ever experience the pain and tragedy their family has faced. Thank you, Mr. Chairman.
Thank you, Senator, and thank you for this legislation. It really highlights the key aspects of what we've all been talking about, particularly in the Public Health Committee, but really ever since we've seen the ravages on children's mental health that the pandemic only exacerbated. We've had longstanding problems, and having a laser-like focus on children's mental health is not only perhaps the signature initiative of this session, perhaps one of the highest priorities for everyone here in the state of Connecticut. So we very much appreciate this bill and its focus on maintaining that focus going forward with a working group, not simply to look at things that we could do better, but perhaps with all the legislation that we hope to pass this session, we'll be able to keep an eye on how some of those initiatives are actually helping outcomes. So we appreciate that very much. I don't see any questions for you, but thank you for your testimony. Since it's still before 10 o'clock, I understand we can stay with the elected officials, and next up will be Sarah Egan, followed by Donna Shaw. I don't know, maybe we don't have Sarah Egan available. Let me check.
Mr. Chair, she's here.
Okay. Sarah, please.
Sorry, I was just promoted to panelist a second ago. Okay, good morning. Good morning, Senator Abrams, Representative Steinberg, Senator Huang, Representative Pettit, and all distinguished members of the Public Health Committee. This testimony is being submitted on behalf of the Office of the Child Advocate, the obligations of which are to review, investigate, and make recommendations regarding how our publicly funded state and local systems meet the needs of vulnerable children. Support of several bills before you today, and we've submitted written testimony, but I wanted to highlight Bill 448, an act concerning the delivery of healthcare and mental health care services to inmates of correctional institutions. We write primarily to highlight that at any given time, DOC facilities confine between 40 and 50 children, mostly boys under the age of 18, at Manson Youth Institution, and a couple of girls at Ywca Correctional Institution. As many committee members know, nationally and in Connecticut, many incarcerated children have significant histories of trauma, substance misuse, and suicidality. According to the Department of Justice, some studies show that suicidal ideation for post-adjudication youth in secure facilities was 51% in the past year and almost 60% lifetime. Research also shows a significant relationship between youth substance misuse and serious delinquent behavior, and a much higher percentage of confined youth than youth in the general population report having tried alcohol, and 84% of youth in custody admit to marijuana use. Following legislatively required public reporting by the Office of the Child Advocate, recently the U.S. Department of Justice completed an investigation into conditions of confinement for boys at MYI, issuing a report in December of this past year, which found sweeping civil rights violations at this facility, including constitutionally deficient mental health assessment, treatment planning, and service delivery. The DOJ's December 2021 report determined that there is reasonable cause to believe that conditions for children at MYI violate the 8th and 14th Amendments of the United States Constitution and the Individuals, Disabilities, and Education Act, specifically finding that isolation practices and inadequate mental health services seriously harm children and place them at substantial risk of serious harm. The DOJ found the following: that MYI fails to provide adequate mental health services, fails to conduct adequate mental health assessments, fails to adequately assess and treat children with dual diagnoses of substance abuse and other psychiatric disorders, and that Manson fails to provide adequate mental health care treatment for children. OCA recommends that so long as minor youth continue to be housed in the Department of Correction, that the bill language specifically reference the need for developmentally and clinically appropriate services for children with an emphasis on trauma-responsive care, substance abuse treatment, and access to professionals who have experience working with children. JJPOC could be tasked with receiving regular information from DOC officials regarding improvements to adolescent mental health care and data regarding utilization, completion, and progress with clinical and rehabilitative treatment. OCA also supports Bill 451, an act establishing a working group to study the expansion of mental health resources to children, and deeply appreciates the bipartisan commitment to transformation of our children's mental health delivery system, and we remain available to legislators to assist in any way with the development of an effective governance and oversight structure for the children's behavioral health system. And finally, OCA supports Bill 454, an act concerning the Department of Public Health's recommendations regarding the Center for Disease Control and Prevention Youth Risk Behavior Survey. This is a critical public health survey in Connecticut that tells us, frankly, astonishing information from our children about their experiences, their use of alcohol and drugs, their feelings of despair, suicidality, and their confidence in their own access to care. Given everything that's going on nationally and in Connecticut in terms of our children's mental health crisis, ensuring that we have active participation from school districts in this CDC model survey is going to be imperative in the years to come. So thank you very much for the opportunity to provide this testimony.
Thank you so much, Ms. Egan, for your testimony, and thank you for highlighting the challenges that the children are having within the Department of Correction. Based on the report that you're mentioning, I think the status should be unacceptable, and we have to start to have an intervention. Do you have any opinion at this point whether an independent private group can be the one provide this service versus the Department of Correction add more clinicians with oversight from Department of Public Health?
Yeah, I think it's a very important issue, Senator Anwar. As to so let me just break that up into a couple of pieces. The first piece is the Department of Justice report that I cited the findings from. So that report, those findings are still active in the state of Connecticut. There's a negotiation going on right now between the Justice Department and the Attorney General's office to resolve a settlement of those findings. So there'll be some agreement that ultimately comes out of that some point this year. I don't know when, I don't know how long that's going to take, but I would assume it would happen in the next few months. That we'll hear about that. We know that the governor's proposed budget calls for putting about $1.7 million into Manson, in part to, I think, completely to address the findings of the Justice Department and to enhance mental health services. But I think that oversight is always needed. And for MYI, to some extent, the Office of the Child Advocate provides oversight regarding conditions of confinement generally. But I think as a matter of good governance, having state-run mental health infrastructure that is not subject to any outside licensure or monitoring by public health professionals is not a great idea, right? I mean, just like the legislature a couple of years ago ended the license exemption of state hospitals like the Solnit Center and like CVH, to give DPH a role in monitoring mental health care delivery to highly vulnerable individuals. I think that I would recommend that something similar be looked at to see what role the Department of Public Health can play, not only in monitoring licensed officials, right, and reviewing complaints, but looking at the delivery of mental health care itself within the Department of Correction.
This is very helpful. Thank you so much. And I see Representative Zupkus has a question or a comment. Please go ahead, Representative Zupkus.
Thank you, Mr. Chair. Good morning, Sarah. Nice to see you.
As well.
And it's kind of what Senator Anwar was talking about, or I guess my question and somewhat of a comment. I have found over the past, years that it looks as though our mental health services are in either hospitals or in our prisons. And I don't necessarily think that that's a good idea. I know there has to be oversight and regulations. However, I do believe a lot of times the private sector can do just as well or even better sometimes than government. And so if you could just expand a little more on that. Again, I know there needs to be oversight, but what is happening now is not working. I mean, we just heard in this committee a few hearings ago, a huge mental health bill that one agency wants $700 million. We don't even know what the other three agencies want. You know, that could be over $1 billion, close to a $2 billion piece of legislation. We have all these other mental health bills out that need funding. And I understand mental health is a problem. And now I hear it's a crisis, but it didn't become a crisis overnight. And so why have we not been analyzing things that are being funded? Are they working? Are they not? Stop funding what's not working and do something else. And so I guess that's a lot in that one question, or comment. So if you could just kind of talk a little bit about that and what has been analyzed and what is not working that we're continually funding.
Yeah, I think if I nodded anymore, I fall out of the screen. I think, Representative, those are all, there is a lot there in your comment. I think, starting with your first comment about children in the Department of Correction. And we know both nationally in Connecticut that this population, and it's in the adult system, it's mostly boys. That's actually true in the juvenile system too. I mean, we incarcerate relatively speaking, very few girls, either in the Department of Correction or in the juvenile justice system. It is important to note though that if for as significant as boys' treatment needs are, research continually finds that girls are even more significant. So almost all girls that are, for example, that are incarcerated in the adult correctional system, so 15, 16, or 17-year-olds, every time OCA looks at that, every single one of those girls has a history with DCF and a history of physical or sexual abuse. So that's part of what leads, to that trajectory. For boys, we know that these boys have an average educational performance rate of about 5th grade, that the vast majority live in homes that have been investigated multiple times by DCF. The last time OCA analyzed this, more than a third of boys, minor boys at MYI, lived in families that had been investigated 10 or more times by DCF, and that almost all of the children have had histories of significant unmet clinical needs, including substance abuse, right? So to your point about what role the private sector can play with that, well, a big one, which I think was really your second comment, the nonprofit service providers in the community are the children's mental health delivery system. And we have underinvested in that aspect of our system for a long time. And then ultimately, when we do that, there are certain children and young adults who will wind up in the public sector, the hospitals and the prison systems. So I think there's a really important role for our nonprofit providers to play, both on the kids who are justice involved and for kids just in our mental health delivery system as it is. To your third point, Representative Zupkis, about coordination and analysis, I think we've had, and many, I know legislators have heard me talking about that a lot this session, we've had a dearth of analysis. We are flying blind to a large degree in terms of where the dollars have to go, what's most effective, who are most underserved children and young adults. And I think that we can change, right? I mean, I think we have to change that this session, right? To make sure that we have a governance and oversight structure that is empowered and mandated and supported with probably some staff to look at the key things that you all are raising, right? How are children accessing behavioral health systems across payer systems and across regions of the state? Who are the most where are the most underserved children, right? Where are the gaps in services? What's the gap between the reimbursement rates and the payments and the actual cost of delivering care that's worsening our workforce and services? And what's most effective for children and families? What are the outcomes that we're getting? So I think we can build that governance and oversight structure this session.
But Sarah, don't you think, again, this has been years, right? This just didn't happen yesterday. And right. So haven't these things been done prior, looking at all of these things?
Not really.
Well, shame on us.
I mean, I hate to say it that way, but because that sounds very critical, but we haven't really done that the way that we need to. And while we have many advisory committees, right, we have a BPOC, a Behavioral Health Policy and Oversight Council, we have a DCF Children's Behavioral Health Plan Implementation Advisory Board, and where a lot of really smart, gifted people meet and come together, we have not had, and certain things get analyzed, certain things, I mean, it was a little flippant with that, but we have not systematically analyzed how children are accessing care, how they're benefiting from that, comparisons between commercially covered families and publicly covered families, where the service array gaps are. We have not systematically addressed or analyzed that.
Well, shame on us, because until that happens, nothing is going to get better. We just keep throwing money at things and we're still not solving the root of the problem.
I agree.
Thank you. Thank you.
Thank you, Representative Zupkus. Thank you, Ms. Egan, again for your testimony, and look forward to reading it in more detail as well again.
Thank
Seeing
you.
no other questions or comments, we are going to move to the public, and then we'll be sharing between public as well as elected officials or officials. Next person is number 20, Donna Shaw. There you are. Yeah, Donna Shaw.
Good morning.
Morning. We can
Senator,
see you, but so we can hear you, but we cannot see you. If you want to turn your camera on, you're welcome to do so.
Okay. There. Good morning.
Morning.
My name is Donna Shaw, and I've been a Connecticut licensed optician for over 25 years. As a licensed optician, we have similar responsibilities to that of a pharmacist. We interpret prescriptions written by optometrists or ophthalmologists. We are technical practitioners who design, fit, and dispense lenses for the correction of a person's vision. To become a licensed optician in the state, one must hold an associate's degree in ophthalmic dispensing approved by the Connecticut Board of Examiners for Opticians, or have completed at least 4 years, that's 8,000 hours of apprenticeship training under the supervision of a licensed optician. During that time, we need to also pass 2 national exams and then pass a 2-part state practical exam. We, as with other healthcare providers, are also required to complete an additional 7 hours of didactic continuing education on an annual basis. With this training, it is our job to first evaluate a patient's prescription. Based on our training, their prescription in consultation with the patient, it determines how they intend on using their eyewear and under what conditions and environment. Then, based on their prescriptions and needs, help determine what type of lens best be used in filling their prescription. It is only after that evaluation is done, we then assist them with proper frame selection. I stress this process because it is important that these steps are completed in this order to assure their prescription gives them the desired outcome that their doctor has prescribed. SB 329 is asking to operate without any professional supervision. Unanticipated circumstances occur in business. These should be anticipated in any business plan. Therefore, that business must create fail-safe plans to be prepared for these instances. This is their responsibility to create a plan. One does not try to change laws put in place to protect the health, safety, and welfare of the public to cater to the needs of the businesses. By passing SB 329, it leaves open an opportunity for interpretation of period of time deemed reasonable. That means that many different things, that can mean that many different things to many people. By allowing these showroom hours, it can certainly be misleading to the public. Signs posted or not, a patient may still trust that there is a qualified professional assisting them, or they simply do not understand the importance of the need of working with a licensed optician. The laws regarding optical dispensaries were put in place to protect the people in our state. There's been no change in that model that makes it safer for the public to not have these laws in place still. As you consider voting on this bill, please think of the constituents you have been elected to protect. And I thank you for your time and consideration this morning.
Thank you so much, Ms. Shaw, for your testimony. I see my co-chair has a question or a comment. Please go ahead, Representative.
Thank you, Mr. Chair. Thank you for your testimony today. I think the obvious question is, you raised the issue of safety. What is it that we're most concerned about here? What's going to happen? These are ostensibly just ordering glasses. What can go wrong? Why should we be concerned?
There are many things that can occur if a patient's prescription is not filled properly. Obviously, there are extreme cases where their vision can be hampered if the measurements are not taken properly. Their vision will not be what the doctor anticipated them to be. The type of materials used to fill the prescription may not be what's in order for their prescription. There are many things that can occur as a result of not having proper dispensation and evaluation of the prescription.
Thank you for that. Obviously, you're aware that this model is being employed in other states. What's your response to other states being willing to do this? They don't seem to be obviously as concerned about the safety outcomes.
Obviously, and I think that that's the key. In the state of Connecticut, we have high standards. Our licensure is a very difficult process to achieve. And my feeling is just because our standards are at a higher level, we needn't lower our standards to match the models of different states.
Thank you for that. Thank you, Mr. Chair.
Thank you so much, Mr. Co-Chair. Thank you, Ms. Shaw. I think for a second I saw Dr. Pettit may have had a hand raised. No, I was just, yes, you do. Go ahead. I was reading your mind, Bill.
Thank you, Mr. Chair. So follow up on Chairman Steinberg's line of questioning. I mean, the question we get from constituents is, I'm sorry, Mrs. Shaw versus Dr. Shaw?
Donna Shaw, licensed optician, not doctor. Thank you, though.
Okay. Constituents say, if I'm just going to go in there and look at frames, what harm can befall me if there's no optician on site and I'm just shopping frames for style and the like? What are the health or eye health implications for looking at frames without an optician on site?
Well, I think the key is in order for glasses to be made, again, we're referring to the doctor's prescription. The doctor's prescription is going to tell us a portion of what the patient's needs are based on their prescription. If they choose the improper frame, they're not going to get the desired results. Their lenses may be too thick for the prescription. They may need safety lenses, different materials. Children are required different lenses. Anybody can pick a frame out, but to sit down and pick a frame and then put a prescription in it doesn't always give the desired outcome that the doctor had intended, because the frame selection may be poor. The frame may not fit them properly, which can cause issues with the fit, thus creating a problem with the vision in the lens. So you can go in, it's like going into a shoe store and picking out several different pairs of shoes, but they might not fit you properly, and in the long run will cause discomfort or harm.
And perhaps this goes in the line of conjecture, but I thought over the past 4 or 5 months we had heard discussions that the retail establishments and some of the optician societies were attempting to come up with compromise language. Is there any way that you can see that there would be compromise language that would protect patient safety and allow the result that the retail establishments are looking for?
I not necessarily can see that, because anybody that walks into any optical shop, whether it's posted or not that there's a licensed optician on the premises, it's their assumption that whoever they're talking to has to know something, must be knowledgeable in the product that they're showing. And with this model that they have, what they're saying is they're just going to have salespeople. And here, this frame looks good on you. Here's a card, go home and order it online. I think it's an opportunity to take business out of Connecticut and harm the local business owners that are working so hard to be successful in Connecticut.
Mr. Shaw, thank you for your answers and your testimony. Thank you, Mr. Chair.
Thank you so much, Dr. Pettit. Thank you, Ms. Shaw, for your testimony. I see no questions or comments. We will move to the next person on our list, which is number 13, Mayret Painter, who is the State of Connecticut Long-Term Care Ombudsman. Please go ahead. Good morning.
Good morning. Senator Abrams, Representative Steinberg, Senator Summers, Senator Wang, Representative Pettit, and distinguished members of the Public Health Committee. My name is Mayret Painter, and I am the State Long-Term Care Ombudsman. Thank you for the opportunity to offer you this testimony today on SB 453, an act concerning the Department of Public Health's recommendations regarding transfers and discharges of residential care home residents. The State Long-Term Care Ombudsman's Office strongly supports this bill and believes it's one of the most important bills related to long-term care this session. The bill offers greater support for residents living in RCHs, and the change to the language expands the rights protecting residents when an involuntary transfer or discharge is issued, and that there are reasons that this is so important. Providing this notice to my office will allow the opportunity for intervention and potential mitigation for the reason why the involuntary discharge was issued and to stabilize the situation. These changes are also to allow the RCH to begin to align with the federal guidance related to home and community-based services and the rule. Bringing residential care homes into compliance with the federal rule will allow residents in this setting to engage in the care and services that best meets their individualized needs while living in the least restrictive environment. Currently, other than the elder waiver, older adults are provided. Residents living in RCHs do not have access to waivers or other long-term services and supports within the setting, other than, again, the older adults who are at risk of losing this option if we cannot come into compliance with the federal rule. Today, if a resident in an RCH has a significant issue, they have to call 911 because they are not medical and cannot make recommendations or an assessment. Cities and towns spend thousands of dollars and countless hours responding to situations that in most cases could have been mitigated if the resident had access to appropriate long-term services and supports. This would happen if we were able to meet this federal rule. The bill takes a step toward meeting this rule and eventually being able to provide access to these supports. This added support would alleviate the need for unnecessary emergency room visits, hospitalization, and even nursing home stays. This makes sense for the individual, the community, and the state. The stay for the majority of the residents living in RCHs is paid through state funds. Bringing the RCH into compliance with this federal rule would allow the resident to access additional services and for the state to receive a federal match for the financial support provided. The bill also ensures that the resident and the Ombudsman's Office receives appropriate written notice, and this would increase the opportunity to respond in the outlined timeframe, to be fully advised of the rights related to the discharge, and to respond as the resident sees appropriate. If it's not an emergency, the resident should be allowed to remain in the RCH pending the outcome of the appeal. And the addition of the stipulation allowing the resident to appeal to a superior court, also their RCH, is required and necessary to comply with the federal rule. Thank you, and I'm available for any questions.
Thank you so much for your testimony. This is an important issue, and thank you for the work that you and your office do. It's truly helpful and much needed right now. I see Representative Pettit has a comment or a question. Representative Pettit.
Thank you, Mr. Chair. Thank you, Mrs. Painter. Thank you for advocacy for our very vulnerable friends and family. In terms of the appeal to the Superior Court, do you envision that typically happening prior or in the midst of a discharge discussion or after the fact?
It would depend. If it's an emergency discharge, it's done post. If it's part of a normal involuntary transfer or discharge, I see the person staying until their appeal rights are met. They would follow the rule. I believe the new language allows for them to receive the notice, to go all the way through the appeal process, and then whenever able to be stabilized. And again, it would be the resident's choice.
You're muted. Yeah.
Have you had any experience with that? Obviously, we're coming off a pandemic where the courts were closed for a long time. How long would you think this type of appeal would typically take? Are we talking days, weeks, months? What kind of time frame are we looking at with this kind of appeal process in the courts?
We would hope to have the opportunity to have it expedited. Right now, through the commission, when it goes to the commissioner's office, they are expedited. They aren't treated like a regular appeal due to the set level of sensitivity, and that it impacts someone's place to live. So we would hope to see that as well with the Superior Courts.
Thank you for those answers, and thank you, Mr. Chair.
Thank you. I just wanted to ask you a quick question, Ms. Painter. Have you heard of the insurance companies giving incentives for early discharge and some of these transfers?
So this setting is not covered by insurance. The majority of the individuals who live in this setting, it's paid for by straight state funds.
Okay.
And so for that reason, we don't normally see that for insurance.
Right. Okay, good. That's helpful. Thank you so much. Seeing no other questions or comments, we'll move on to the next person on our list. And this is from the public, which we have Melanie Wildling. Ms. Wildling.
Good morning, Senator Anwar, Representative Steinberg, Senator Summers, Senator Wong, Representative Pettit, and members of the Public Health Committee. My name is Melanie Wildling. I am the Executive Director of the Connecticut Association of School-Based Health Centers. I come before you today to show our support for SB number 375, an act concerning telehealth. The Connecticut Association of School-Based Health Centers very much appreciates your continued support of our school-based health centers and are in 100% support of the proposed extension of telehealth services through June of 2024. In Connecticut, all DPH-funded school-based health center contractors transition their sites to telehealth models during the 2021 school year. Due to the telehealth option, Connecticut school-based health centers were able to serve a comparable number of students during the 2021 school year, when most students were home or attending school on a hybrid basis. Going forward, school-based health centers are now able to connect with students who are unable to attend school for any reason, COVID-19 related or not. As well as providers can reach families for medical and mental health consultations more effectively through telehealth, eliminating barriers to schedules, work, and transportation. Many of our DPH-funded school-based health center sites currently have a wait list for mental health services, which has not been seen in past years. Providers are struggling to keep up with already full caseloads and are seeing students with more complex mental health needs. Telehealth has helped school-based health center providers in many ways to stay connected with their students, connect with families and parents who have a need for a more flexible schedule, and provide services to students during this mental health crisis. I thank you for your time and am open to questions.
Thank you so much for your testimony. I agree that in the last few years, telehealth has been a lifesaver, and I'm so glad that our state remained focused on this aspect. If I was to say that telehealth should be made permanent, not necessarily the first priority, but an opportunity for access, especially for certain segments of our population where that may allow for both the parents who are working and are unable to take time off and be a part of the conversation and management. What are your thoughts on it? Because there is a sunset right now, and then if there was no sunset date.
I think our association would be 100% in support of any extension. It does take away the barrier. It allows our staff to be more flexible with parent schedules, and it just takes away many of the barriers. So we would be in 100% support of that.
And with the experience in the last couple of years, would you say that were there any challenges associated with this? Were there quality of care? Was it compromised in your experience from the school-based healthcare centers?
So I'll answer the first question. absolutely, there were some challenges putting telehealth services into some of our school-based health centers. Like anything new and new technology, there are challenges. We did it very quickly, though. And then going forward, the quality of care was not compromised. Absolutely not. I think it was better. We were able to get a full comprehensive picture of the families in their own settings, to be able to connect with parents, extended family members that we would not have necessarily been able to connect with.
Okay, this is very helpful. Thank you so much for your testimony, and
Very
we
welcome.
appreciate you coming in.
Thank you.
Back to from the community members to the elected and representative leadership. I have, I believe, the team of the Department of Correction next. Should we say the entire team is going to present together? I will start with Sharonda Carlos.
Good morning. Thank you so much, Chair. Good morning, Representatives Steinberg and Pettit, Senators Doherty Abrams, Wong, Summers, Anwar, and members of the Public Health Committee. My name is Sharonda Carlos, and I serve as the Deputy Commissioner of Administration for the Department of Correction. The Department of Correction is submitting its testimony concerning Senate Bill 448, an act concerning the delivery of healthcare and mental health services to inmates of correctional institutions. The department actively seeks to ensure quality healthcare for persons in DOC's custody and supports the interests of the Public Health Committee in addressing the challenges these efforts present. However, while the bill is very well intended, there are numerous obstacles in its implementation. Throughout the bill, the ability of medical staff to perform care is not matched to current standards of care. For example, only a doctor, physician assistant, or APRN could, under the bill, administer medication, vaccine, or an HIV test. These tasks are routinely handled by nurses and others in DOC and differs from how such care is handled in the community. Indeed, in the community, HIV tests and some medications can be self-administered by the patient. The bill also requires that only a doctor oversees medical treatment of an individual withdrawing from drugs or alcohol, although this is well intended. The competencies and licensures of an APRN and assistant could take care of these needs. With me on today from the Department of Correction is Robert Richardson, Chief Operating Officer, Dr. Craig Burns, Chief Mental Health Officer, Dr. Byron Kennedy, Chief Medical Officer, and Director Violet from our Addiction Treatment Unit. We are here today to answer any questions pertaining to our testimony, and we look forward to further discussion. Thank you.
Thank you so much. If you may, I do have a lot of questions, but thank you, Commissioner, for you and your entire team coming in. Do you think the status quo is acceptable?
I do. I will also turn it, and let me ask this because I know it's two-pronged in regards to medical and mental health, and I will ask for both Dr. Kennedy and Dr. Burns to be ready to assist. As an agency, we do see an opportunity for improvement within our healthcare system. And again, with our testimony, not only did we outline some of the obstacles, but some of the resources that it would take to implement such a bill. But Dr. Burns, if you don't mind, if you can speak from the mental health standpoint.
To echo the Deputy Commissioner, and good morning, everyone. Thank you for the opportunity to present today. We're always seeking to improve the care that we provide the people who we are responsible for within the Department of Correction. So I don't know if we're ever completely satisfied with what we do. And I think that having an attitude of being satisfied with the care that's being provided would miss those opportunities that there may be to improve the things that we do for our patients.
Thank you so much for that. On the same note, I can say from the outside, because we're not doing the hands-on direct evaluation of how system is working within the Department of Correction, but we are privy to the lawsuits and also the stories from the families whose loved ones have died or have been damaged permanently because of not getting the timely care. and also their concerns not being heard, and also the staffing related issues. And there have been horrific stories of women's health and detox related challenges and so on. With many of those situations that we're seeing or we have heard of, we feel that all of these lawsuits have almost seemed like a open and shut case against the Department of Correction, because the staffing ratio was not there, the documentation was not there, the communication and getting the expertise in the timely fashion seemed to be not there in many of those cases. And from legislators who are interested to save the state money, we feel that spending the money to provide the standard of care with the right ratios and empowering you, if you will, to be able to achieve the goals would be a better way to do this than to actually pay a lot more money in the lawsuits that we lose almost every year.
Grateful for that, Representative Almore. I'm Senator Almore, very, very grateful for that, because that does get at the core of one of the issues that we have, especially as it relates to staffing. I think it was mentioned earlier, and you appropriately identified in a comment that you made earlier, the difficulty in actually recruiting physicians and or APRNs into our system. I'm in complete agreement with that and actively work towards trying to get people into our system. I think when people are in residency training or training to become an APRN, the last thing that they're thinking about is actually working in the Department of Correction. And the unfortunate piece is that in addition to the service need that is always there, the educational opportunity for people in training within DOC is like nothing else. It's here that we see people who have either new onset illness in our younger folks, untreated mental illness. It's an environment that's free from managed care, so we can actually treat people and see their improvement over time, actually see improvement in their functional capacity to move them from a mental health environment into general population. We also see rare presentation of illness. We have a couple of patients recently who I believe have a condition that's known as misophonia, who are extremely sensitive to sound, so much so that it'll increase their anxiety, it'll increase their agitation and aggression just based on hearing certain kinds of sounds. And you're not going to find this in the community. So being able to draw more people into this environment as a training space, which would hopefully then create an interest in maintaining a connection to correction to provide psychiatric care, I'm all for that.
And I can tell you that healthcare systems are having difficulties to attract the workforce, but what they're doing is they're creating incentives and identifying ways to find the right workforce. What can we do to help you get the workforce that you need so that we are not providing the very basic level of care? How can we help you, and what policies you already have in place?
In the interest of time and recognizing that my colleague also has to potentially provide you with some answers around this, I would be more than grateful to have an opportunity to actually discuss just that with respect to potential ways that we could potentially not only retain people, which we don't have that much difficulty doing once they come into our system as psychiatric providers, where we have the harder point is the recruitment of people into our environment. And I would love to speak with someone at your level about this to see if we can figure out a way to make that happen for our department. And
Okay,
Dr. Kennedy,
so,
I don't know if you have anything to offer.
Yes, thank you. Thank you, Senator. Appreciate, maybe the question. I would say that, from my perspective as a CMO, as you look at the landscape and where we are, in the Connecticut, like maybe market, I think everyone perhaps maybe on this panel and everyone who's listening will agree that I think our biggest challenge is really, if you will, being competitive with the market. And I think, that existed prior to the pandemic. And I think when the pandemic, I guess, maybe came, that put a strain on all healthcare systems, including ours. And certainly, I'm not specific to just Connecticut, but we see this nationwide. And we certainly have seen that and heard this, from our colleagues in other correctional health systems and other states. But you also hear that in other hospital systems and other states maybe as well. And so I think when you have, this huge need, for clinical staff across maybe the board, on the one hand, when we are trying to recruit people and even when we interview them, we highlight the fact that, well, there are benefits for working for the state of Connecticut because you know how many employers actually offer a pension, you know, so that is attractive, although it may be less attractive these days compared to what it used to be. And then quite frankly, we also talk about, you know, the paid time off that you might have. And given that you're working for government, a lot of that paid time off aligns oftentimes if individuals have families and children, those days off that they have for that side as well. So it allows them, if you will, to offset what they might have to pay for childcare, if you will, when they have the same days off to share with their family and with their children. That said, you know, we still hear, you know, routinely that, you know, well, that's nice that there's the pension. It's nice that you have the PTO. It's nice that you have these other benefits. But at the end of the day, I'm looking at the overall total compensation, the overall pay. And to that extent, you know, our hands are somewhat like maybe tied in what we can do as an agency to address that. And so to that extent, we need a tremendous amount of help outside of our agency.
And Senator, if I may, this is Deputy Commissioner Carlos.
Yes.
And amidst the challenges that we have faced, and as Dr. Burns and Dr. Kennedy have spoken from their respective seats, in regards to our intake facilities, in regards to our prison, we receive individuals, citizens of the state of Connecticut, that have not been to the doctors, some of them in years. Unfortunately, some of these individuals, when they are out in the community, their healthcare is not a top priority. So when they come in and they're able to get a physical examination done, when they come in, we have Director Violet on, and they're able to participate in addiction treatment, that speaks volume. And unfortunately, the cases that, of course, we would not like to happen, we would never want to lose anyone. Those are the cases that get highlighted, but the thousands or hundreds of individuals that have come through our door that have received the proper healthcare services, those are not often the testimonies that we hear. So again, there is an opportunity for us to expand upon our services and to continue to provide community standard healthcare, but we definitely appreciate those who are on the front line that are providing those services to those individuals that come in and may not have had an examination. I served as the warden of York CI, so to know that they're able to get OBGYN services, again, speaks to this state and the commitment to provide the healthcare.
I will also add, just thinking about some of the, you know, the big elephant in the room that we've gone through has been the pandemic, the COVID-19 pandemic. And I will say that, you know, for our clinical staff that we've had, they're second to none. You know, and I know others may have a different opinion, but when we actually look at the data, for example, we look at the case fatality rate. That case fatality rate is usually a measure of quality of care. It's usually a measure of acuity as well. DOC has consistently been about 0.5% or less. And you contrast that with the state, which has been above 1%. And that's also true for the country and also true worldwide. And then what some of the other measures, we look at the positivity rate. That gives you an indication of transmission. Our positivity rate in our agency has been consistently lower than the state. And so while, you know, we have what we have, including our infrastructure, we have what we have in terms of our staff, I think what we're doing with what we've been dealt and what we have in terms of resources, I think that's been second to none. And so I'm proud collectively of the work that our staff maybe have done. And I would say that when we're talking about managing COVID, really sick patients in the outpatient setting, our staff, particularly our nursing staff, they are second to none. And I will say that every day of the week and twice on Sunday.
So thank you so much for your responses. I tend to respect the fact that we have good staff. It's the quantity issue. It's a ratio issue as well. And some other communication aspects that I think may be an opportunity from before and person before their sentence and then after they are back in the community. What are the communication systems? I think those we're trying to figure out a way to legislate them, if you will, because that would push us as a state to be in the right direction and not necessarily have to deal with all the unfortunate sad cases that we hear of. If you can help me untangle something, Deputy Commissioner, or anyone in your team, there is an opportunity to strengthen the existing Department of Correction healthcare personnel providing the care so that it's with the ratios and the quality and other aspects is the standard of care versus having a private entity outsourcing this to a private entity to be able to manage this entire situation. And the third part is that whether it's option A or option B, having Department of Public Health legislatively oversee this or create a separate oversight board that would oversee this, because there needs to be checks and balances created within the system to make sure that we are, as a state, doing a better job than where we are at right now. Do you want to reflect on some of these thoughts and then help me understand what would be the better way?
Yes, I'll begin and then I'll turn it over to the team. So in regards to the first option that you mentioned, yes, we do have an opportunity to strengthen the services, the personnel that is within the Department of Correction. As mentioned by Dr. Burns, Dr. Kennedy, and myself, we are appreciative of the staff that we have. One of the things that has become an obstacle just in regards to recruitment and retention is the compensation piece when it comes to recruiting staff. That is one area. In regards to the Department of Public Health, we are in communication with them. Dr. Burns, Dr. Kennedy, COO Richardson, even Director Violet, and the different facets and areas, we work collectively with our sister agency. In regards to an oversight, I will speak with Commissioner Quiros in regards to his thoughts on that. I do not want to misspeak in regards to a support or not support of such of an oversight committee, but I will turn it to Dr. Burns and Dr. Kennedy just in regards to the two recommendations that somewhat were presented to us by the senator.
Yeah, I guess I'll start. I will certainly maybe echo, what DC just stated. We have frequent and constant communications with our Department of Public Health. And that was true, as one example, but not the only one, certainly during the pandemic, even when it started. We basically took, a lot of the conversation and guidance from them. We vetted our ideas. Anytime we did a major change in our policy, we had conversation with DPH. Separately, when the governor had established, the Connecticut reopen, and it had different experts, including from Yale. We've been in communication with some of those experts along the way. And then we've also been in communication with the CDC, particularly their epidemiologists that specialize in correctional healthcare. So we've had communications with them. And then I would also highlight that some of the other efforts going on at the state level, led by other agencies, including the Medicaid Transparency Board. We participate on that board. And from that, you're looking at standards, you're looking at benchmarks. Agreements about looking at Medicaid benchmarks and having that reporting on a dashboard from multiple agencies. We're participating in those discussions, and we'll participate where we can with our data. So I think to the extent of having, if you will, that view and having that sharing and having that transparency and having that accountability, I think we have efforts that are in place right now that speak to that.
Thank you. And I hear you loud and clear that if we are not able to, here's something that I think has not been said, and I'll just add from my perspective, is that the job to provide the care for the inmates in the Department of Correction is a very difficult job, because many of their underlying illnesses may have contributed for them to get to the point, whether it's mental health or substance use issues. They may have resulted in getting them to become inmates. And then there may be other medical problems that they have not had the care for in the past. So all of those things makes the job very difficult. And so therefore, appropriate and a fair compensation should be a no-brainer from a policy perspective to retain the right level of care and the ratios that we are hoping to be able to achieve. And then also making sure the people who stay there and continue to provide services rewarded appropriately, because that's what's going to happen outside of your Department of Correction setting. So that's something that I think we may have to look at as a legislative body for sure. But we do feel that there is an area of opportunity to try and maximize some of those areas. I think to one of the points, Commissioner, that you had made, for detox and some of that can be life-threatening. So you need monitored space for that. We do that in the intensive care units, and you do not have them in Department of Correction. People die in that situation. They have seizures. So this is a serious situation, and again, women who are pregnant in that situation, the children. So that even the Department of Justice, as we had heard, has said that, look, this is not safe, this is not adequate, and we have a responsibility. So that's why I think that we have this bill, and we are hoping that we can improve on this further after the testimonies, and make sure that the next time we have conversations in the next few years would be about thanking you for the service that you're providing and making sure that we are identifying illnesses early and preventing mental challenges and behavioral challenges from progressing in some of the people. So thank you so much. I do not see any questions or comments from any of my colleagues. Any last words before we move on to some the public?
Just briefly, Senator, one of the things that you had mentioned was the concern around communication with outside agencies. We regularly communicate with jail reentry, jail reinterview, probation, parole, the Department of Mental Health and Addiction Services, Department of Children and Families, DDS, Department of Veterans Affairs, Social Security Administration. We communicate with those folks all the time in the context of people transitioning from being a person in custody to a returning citizen at a number of different levels. So there really is not just the intention, but active warm handoffs of people when they're leaving our facilities into people who would be providing the care when they leave us. That's a very active part of what we do, especially as it relates to mental health and medically impaired people.
Thank you so much. Thank you so much for your testimony, and seeing no other questions and comments. Go ahead, Commissioner.
I was saying thank you, Chairman. Thank you, committee, for allowing us this time. Thank you.
Thank you. And we move on to the next person on our list, which is Melinda Johnson, the YWCA Hartford Region Director for Community Engagement and Advocacy. Ms. Johnson, welcome.
Thank you. Good morning, Co-Chair Senator Anwar and Representative Steinberg and members of the Public Health Committee of the Connecticut General Assembly. My name is Melinda L. Johnson. I am the Director of Community Engagement and Advocacy with the YWCA Hartford region, and I live in Hartford. In solidarity with the Regulate DOC Healthcare Coalition, I stand in support of Senate Bill 448, an act concerning the delivery of healthcare and mental health care services to inmates of correctional institutions. Connecticut is currently the only state where the Department of Corrections oversees and operates its own healthcare system. Due to systemic challenges, quality of care for incarcerated individuals in the state of Connecticut has been subpar, contributing to poor health outcomes for incarcerated individuals and returning citizens. Poor healthcare is expensive. Connecticut has paid out millions of dollars in lawsuits related to medical negligence for the Department of Corrections. However, there is a deeper cost to families and communities of returning citizens. Daily, through our programs and services like Soramundi Common Shelter and Permanent Supportive Housing, and through community engagement and advocacy, YWCA region serves women and families who are bearing the weight of this cost. The stories of formerly incarcerated individuals, former and current healthcare workers, and justice advocates throughout the state has informed us of the gaps and challenges that have been created. And these expenses, that has created these expenses and inadequacies within the Department of Corrections medical care system. So while Senate Bill 448 moves the needle forward to improving healthcare for incarcerated individuals, the bill can still stand for further strengthening. And included in my written testimony is a comprehensive list of the recommendations that the coalition has created as a result of deeply reviewing the bill thus far. Some of those recommendations also include a body of accountability, whether it be the Department of Corrections or, as has been mentioned, a commission or board that is created for the oversight of DOC healthcare, especially receiving annual reportings on the matters of health outcomes and morbidity rates for incarcerated individuals. Making sure that there are fair ratios for healthcare workers, including physicians, dental hygienists, nursing staff, the whole gamut. When we look at health outcomes and improving health outcomes for returning citizens and currently incarcerated individuals, dental examinations need to be done annually. And we realized in looking at section 2, subsection I, that this was missing within the document itself. Additionally, the current bill speaks to a discharge conversation taking place or a discharge interview, but it is the recommendation of the coalition that this discharge interview land in a medical discharge plan, including the release of medical records to the individual, guidance to obtaining insurance post-incarceration, and identifying follow-up care within the community they are returning to. We also looked at the matter of withdrawal and monitoring.
Excuse me, Ms. Johnson, your time is almost up. If you please summarize. Thank you.
Yes. In closing, I urge you to support Senate Bill 448, an act concerning the delivery of healthcare and mental health care services to inmates of correctional institutions, and consider these additional recommendations to improve outcomes for incarcerated individuals, the Department of Healthcare workers, and returning citizens. Thank you.
Thank you so much, Ms. Johnson, for your testimony, and thank you for your leadership in building the coalition for making sure that the healthcare and Department of Correction is just appropriate as well. I had the chance to listen to some pretty sad stories of individuals who were impacted negatively from the care and the experience in the facilities. Could you share some of them and how, rather than helping out, it exacerbated the underlying illnesses for people?
Certainly. So what we have heard in collecting testimonies and interviews from individuals and hearing their stories is that small issues or small health issues that present at the onset become exacerbated because of the fact that there's not enough staff to provide sufficient care. Additionally, unfortunately, many of these stories aren't heard until they are at the point where someone is investigating and looking for these stories like we have been, or they have gotten to the place where they are now pursuing legal action. And now we hear about them in the newspaper in the regards of children being born in toilets, in regards to overdoses taking place under DOC healthcare. And the reason why we don't hear about these things until they're at that extreme is because there is no accountability, there is no oversight. Unfortunately, anytime you see any agency that is able to operate and oversee its own abilities, I don't know about how you were when it came to taking tests, Senator Anwar, but in high school, I had the ability, if it was on me to do a self-test, I got an A every time. But when it comes to healthcare, when it comes to the lives of individuals, when it comes to how an individual returns to their community, the reason why we're seeing these drastic health outcomes with individuals who go in for things like a tooth decay that then exacerbates to becoming an entire tooth that needs to be removed, or blood poisoning that takes place as a result of that tooth decay. These are things that could be solved or could be remedied. The system itself could be changed if there was a body of accountability or an oversight that was provided.
And we discussed briefly from the Department of Correction and as well as DPH. In your opinion, and looking and hearing the stories, would DPH be the right oversight body?
DPH could be the right oversight body if it is done with intention. When our coalition considered the matter of the Department of Corrections taking on things, we recognize that staffing and the limitations of staffing can be a challenge. And one of the concerns that was brought up by justice advocates and individuals who have been formerly incarcerated alike is that we don't want this to be something that's put on somebody's plate whose plate is already full, but there needs to be intention to this, that it be a department that's established for this particular work, an individual, a sub-department within the Department of Corrections, a team that is identified to do this work and to assist and make sure that there are check marks and milestones and standards in place.
This is very helpful. Thank you so much. Any other aspects that the advocates feel that need to improve? So we'd love to hear that, and we'll continue the conversation. And thank you for your advocacy work.
Thank you. Yes, there were just a few more items that, given your permission, I'd like to identify. When it comes to improving outcomes for individuals who are experiencing withdrawal, there was a section, section 4, subsection B, that speaks explicitly to certain kinds of withdrawal. And it is our recommendation that opioids and alcohol be included within that subsection. Also, when it comes to improving health outcomes for individuals incarcerated at York Correctional Institution, as the bill currently reads, there can be some discrepancy in what is counted as adequate paternal or prenatal visits. And it's so our recommendation that it be more descriptive to describe minimal prenatal visits once a month from 0 to 28 weeks of pregnancy, every 2 weeks from 28 to 36 weeks of pregnancy, and once a week from 36 to 40 weeks of pregnancy. And this was the recommendation of the physicians that have participated within our coalition.
This is very helpful. We will make sure we take notes of all of your recommendations. One last thing. Within the entire spectrum of where the care is poor, my understanding is that the women have been the ones who have suffered the most in this situation because of some of the lawsuits and the stories that I've heard. Can you expand on that for a little bit too, for benefit of everyone? That's really my last question for you.
Yes, I believe you are going to get some firsthand testimony from the mother of Tiana LaBoy. I believe she is registered to testify on today. Tiana LaBoy was a young woman who gave birth within her cell, in the toilet of her cell. And that case moved forward in 2018 and subsequently was won in 2020. These are, again, that was also very similarly the premise for the West versus Manson case years ago. So how is it that several years later, we are dealing with the same situation? There is a lack of oversight. There is a lack of intentionality behind how healthcare is delivered. Ms. LaBoy's instance could have been prevented had there been adequate care provided, had she not been instructed that the OBG would be in on Monday while she was giving birth on a weekend, had there been actual steps taken and actual documentation had to show that these steps were taken.
This is very helpful because West versus Manson was never codified, and even though it was very clear what was expected, it never has happened. And this bill would actually start to move in that direction so that we do not come here with the same situation and horrific stories. Thank you so much, Ms. Johnson, for your testimony. Truly appreciate you coming in.
Thank you.
Thank you. And we're going to the public officials next, which we have Representative Tammy Nuccio. Representative Nuccio, thank you for waiting. Good morning.
Thank you, Mr. Chair. It's not a problem. I understand the process, and I'm enjoying hearing what's happening in public health today. I'm here to actually testify on two bills, if I can do that in the allotted time here. First and foremost, to the chairs, the ranking members, and the members of the Public Health Committee, the House Republican Caucus would like to thank you for raising Bill 5480, which is an act concerning the accessibility of mental health services. During the COVID-19 pandemic, the mental and behavioral health of Connecticut citizens has really suffered greatly. We've seen skyrocketing reports of anxiety, depression, substance use, suicide, and general discontent. And now, 2 years into the pandemic, a mental health crisis has emerged. Some of us said it's been brewing for a while, and this really just pushed it over that tipping point a lot faster than we expected it to get here. However, the state does not have enough mental health providers to adequately cover the care of all of its residents during this time. According to the Kaiser Family Foundation, only 14.9% of Connecticut's residents, which is the lowest in New England, by the way, have their mental health care needs met by health professionals, while 28.7% of its adult residents are currently reporting symptoms of anxiety or depression as of October 2021. Passing House Bill 5480 is an important first step in closing the gap for our residents who are suffering in direct need one-to-one therapy, either in person or through telehealth. This simple measure will reduce wait times, lower costs, and allow more choice of providers for patients. Additionally, this bill benefits doctoral students in clinical psychology programs by providing practical field experience during their education with direct supervision by an already licensed psychologist. And this also will expose them to a new method of treatment that a lot of them haven't been really focusing on in their current doctoral program up until the pandemic, which is how to accurately and effectively treat mental health issues via telehealth. So by allowing these students to provide care to patients, Connecticut's healthcare system will be more responsive to the mental and behavioral health needs of its residents. We urge the committee to pass House Bill 5480 to give Connecticut's residents more accessible and affordable mental health care and to help prepare our doctoral candidates for their careers in clinical psychology. The second bill that I would like to testify on is Senate Bill 456. Holy moly, wrong words, 456. Over the last 6 years, I've heard story after story from my hometown residents regarding the fight for clean drinking water. I live in the land of wells out in the northeast corner of the state here, where just about everybody has a well for their water delivery system. Over the last decade, we've started to see an uptick in the contamination of wells with chloride sodium. That is also the same chemical that is applied to the roads to keep our roads clear of ice and snow. The assumptions of the report to the state in 2007, which included the belief that road salt would dissipate with rainwater, have been proven to be inaccurate. Starting around 2013, DEEP has seen an increase in complaints related to elevated sodium and chloride in private wells. Elevated sodium and chloride in drinking water supplies can cause health impacts associated with high sodium intake, corrosive to plumbing features, failures, leaching of lead and copper, and mobilizing of manganese, iron, radium, and radon. Quite frankly, it's not even safe to give to your dogs or boil water in. This is a problem that's multifaceted. First, we must ensure that people have clean, chemical-free drinking water. We need to establish the source of the pollutants definitively and stop polluting our drinking water. Last and most definitely not least, we really need to remediate the environmental impact of placing these chemicals into our environment unchecked. Currently, this bill is asking for assistance, that the assurances that the responsible party or parties at the very least pay to remediate the issue. I urge the committee to pass Senate Bill 456 to provide aid to Connecticut residents with contaminated wells.
Thank you so much for your testimony. Would you like to add more to it? I know we sort of cut you short because there are two important aspects, and if you want to add more, please feel free to do so.
Thank you, Senator Anwar. Both of these bills are really important, and I feel like at a time, it's like we're kind of getting slammed all over the place with all of these high impact needs. From the well water perspective, I tried to put legislation forward, but in the short session, it's not always easy to. But I really think the state of Connecticut needs to take an aggressive look to see within the next 3 years what we can do to treat our roads in a way that is not detrimental to our environment. Because not only is this killing our wildlife and the foliage and everything else, but it's truly impacting the lives of our residents. Not having potable drinking water for 6+ years, not being able to shower comfortably without getting rashes and having stuff happen into all of your appliances. And that is just, it's something that I don't think you understand if you're not living through it. And water is one of the most essential things of life. So really, truly taking this seriously, I think is going to require us to look for an environmentally safe way to clear our roads that isn't going to impact the environment. And everybody knows I'm big on mental health, and I'm big on trying to find ways to bring forward more resources. And I truly feel that our colleges are a tremendous resource. If they have doctoral programs and they have students in there that are learning, they are trained and ready to provide community resources. So anything that we can do to help that, to provide more accessibility and affordability to our residents, I'm a partner to whoever is seeking to do that. So thank you very much for giving me a couple extra minutes there to just throw in my non-formal testimony and more of a plea for people to kind of hear the needs on both of these sides. And I appreciate it. Thank you very much.
Thank you. I have one quick question, and then I'll have Representative Foster ask the question. Representative Nuccio, right now, from the attention that we have, your towns, your area that you represent may have a lot more homes that are impacted, but this is not a regional issue. This is essentially across the state. Can you speak to that if you could for a bit too, so that people recognize that it's not necessarily one region, it's beyond?
Absolutely. Thank you for giving me the opportunity to answer that. In speaking with DPH and DEEP, we're noticing this is popping up all around the state. And what's really scary about that is where we're noticing it right now is in cities and towns that have wells, because people have gotten to the point where they notice something tastes funny in their water, and then they test it and find out that their chlorides and their sodium are really high. I kind of like tag this to the silent killer thing. You don't know you have it until you taste it, but when you taste it, it's already too far gone to do anything to fix it. That's the problem. But we're seeing it pop up all over the homes in these private wells. What's really scary though is that we've just started to see some of the research from DEEP coming out about what it's doing to the frogs, to the fish, to the environmental impact. And when this chemical is getting into our tributaries and the aquifers, at some point it's not going to matter where the water is coming from, because you have a contamination that's building up so fast. You can't do anything about it. This is definitely not in my towns. It's not even regional. If you look at the maps that DEEP and DPH have, it's all over the state. And as Joe Courtney said, I was talking to him and he said, Representative, I didn't even know about this. You mentioned it and now it's popping up everywhere. I feel like I'm playing whack-a-mole. Like it's just popping up all over the place. So if it's not happening to you, it will be happening to you soon. So those of us that have kind of jumped on this train are really kind of begging for people to listen to us, because it will spread. This chemical does not dissipate from the water. It builds up in it. So it's something that I think we really need to take some time to study, get Ywca involved, figure out how this salt is moving through the system and find a way to reduce it.
Thank you so much. And I see Representative Foster has a question or a comment.
Thank you.
Good morning, Rep. Nuccio. How are you?
I'm good. How are you?
Good. Thanks so much for testifying on this today. I think one of the things that we have been having a lot of conversations about in our community is that we are sort of in the rural parts of the Connecticut have a higher concentration of wells, but we also have a higher concentration of contaminants. So we have this road salt issue, which is huge, but we are also impacted by former tobacco farming products, ethylene dibromides and nitrates as agricultural runoff. Can you talk a little bit about the impacts that your homeowners have had? I know you've talked about sort of the health impacts. We've talked about our concerns with the water contamination in the groundwater, but what does it look like in someone's home when they have sodium chloride contamination? What do their pipes and their appliances look like and run like? Or what is the impact on homeowners?
Thank you for asking that. I know a few of my residents have sent in written testimony, and what they find is, once again, when they taste it and they're trying to figure out what's going on, then they start to notice that they're getting pinhole leaks in their homes, and pipes that are rotting, appliances that are dead that they've only had for 2 years and they can't figure out why, washing machines, heating coils, especially when you think about heating your home with a hot water boiler or anything like that, your water tanks. So I have one family that has spent already over $30,000 on replacing fixtures and pipes, appliances. And again, like their grandkids come over, they give them a bath and they come out with really red, rashy skin. Their hair is thinner and drier. I have one person whose dog died of kidney disease and they didn't know what was going on with it. And they linked the amount, they were giving the dog water still out of their faucet, not thinking, not realizing how much we depend on water for everything that we do. It's affecting clothes, it's affecting pipes, it's affecting so many different things. And if a town comes and gives you bottled water, they're giving you bottled water to drink. You don't get enough bottled water to shower in every day. You don't get enough bottled water to do laundry in. So this is the same water you're using to do all of these things that all of us take for granted. I, every morning, get up and fill this cup with water and ice from my freezer, which is made from my water. I take for granted that I can grab a glass of water. And I have dozens of residents in my town that can't even do that. It's expensive. It's definitely mentally draining. It's exhausting. And there's a battle. The 456 is important because there's a battle between who is responsible for this and who is going to pay to fix it. And that gets along, Representative Foster and I, we talk quite a bit. We talk a lot about this because both of our areas are impacted by it. the fact that we don't have any kind of testing. Every year, people don't get their wells tested. You have no idea. And then next thing you know, you've got a problem and there's nothing you can do except spend thousands and thousands of dollars while somebody's trying to figure out what the cause is. When we know for fact, we see this uptick since 2013, and that was 6 years after we started using sodium chloride on our roads. So there is a correlation. It's just a matter of getting everybody at the table to agree with that. And then, I'm sorry, it becomes our problem, because if we're causing it, then we have to find a way to remediate it.
My last question is one of the ways the bill is structured, it has people testing on palm conveyance, but based on everything that we have heard in the community, when Senator Anwar, you and I are talking with the authorities, people are recommended to test their well. How often? When should they be testing their well?
Well, right now they're not recommended to test their well, right? So what I think it would be reasonable.
Right, but how often are they recommended to test it?
In general right now?
Yeah, what's the public health recommendation? I know it's not a requirement, but
Yeah,
we're
isn't it-
recommending annual, right?
Yeah, they recommended annual, but I don't think that there's enough education out there to say, hey, you should be testing your water annually. There's nothing out there that I know people who lived in their home for 30 years and never tested their water until they go to sell. And it's only because somebody asked them to. It's not required, and it's not even strongly recommended at any level if you don't know about it. So
one of the last question, I'm sorry, and then I'll be done for today. But as we're sort of communicating with our communities around these issues, this is like the tip of the iceberg. We recognize that this isn't a long-term solution. But can you talk about how many wells you know of that are impacted and how many we sort of estimate might be unknown or unrealized in our region?
Oh, well, I can tell you that from the sheets that I've gotten from Eastern Highland Health District and the town of Tallinn alone, I have 68 wells in the town of Tallinn that have that are contaminated with sodium or chloride sodium alone. And that DPH has told me is the highest concentration of well contamination in the state of Connecticut. But I've just been contacted by 3 other people that said, hey, I'm over on this road or I'm over on this road and I'm having this issue now too. I think if we were to actually test it, we would see that it's a much more prevalent issue. And more importantly, if we were to actually test it, we might be able to catch some of those people who are very early in the stages where their levels are, I hate to say, I have some people in my town that have 600 times the recommended level of sodium in their wells. Like I can't even imagine. It's more salinated, their water is, than the ocean. Like it's crazy how much salt is in it. But if we can catch some of these earlier and then have a remediation plan for them, the problem is, though, Rep. Foster, and I think you know this, the problem is to me, this is a 3-pronged problem. 1, get people drinking water. Just get them water, like the necessities of life. 2, figure out exactly what's causing it. And if it is the road salt, then we have to be big enough to take responsibility for that and find a more environmentally friendly way to do it. And 3, definitely not the least important, is we need to remediate what this has done to our streams, our tributaries, our marshes, and our water. You know, if we can find a way to catch this earlier, we'll have a better shot. Waiting until it's this far gone, it's just so detrimental at that point.
Well, under this committee's scope, the public health stuff I think is top of mind, and I think Senator Anwar and I can say that we have about 70 homes that are known to us with a variety of different contaminants. And I'm grateful for the opportunity for this bill to have been raised and for your work together. Thank you very much. And thank you, Mr. Chair, for giving me the opportunity to ask questions.
Thank you. Seeing no other comments or questions, thank you, Representative Nuccio, for your testimony and raising awareness and support. Thank you.
Thank you very much.
And the next person on our list is Ms. Kay Krenitsky. Please go ahead, Ms. Krenitsky.
Hi, my name is Kay Krenitsky, and I'm actually just a consumer, but I am here to testify against Senate Bill 329. The first thing I want to start by saying, I think somewhere along the line, we've lost in translation that eyewear is a medical device. It is something that I place on my face every day to help me be able to see the world, to see everything. While style is important in the selection of my eyewear, it's the least important aspect of getting a pair of glasses. When I, as a consumer, walk into an establishment to sell me a pair of glasses, I just assume the person has been trained and knows specifically how to do it. I'm someone who has an extremely difficult prescription. I should start by saying that I've had a cataract surgery, so I've already had one of my lenses fixed and the other one still has a cataract growing. So it's extremely difficult for me to be able to see even with glasses. I went to a place to get help and I bought a pair of glasses. They didn't help me see until I went to an actual licensed optician. Was she able to determine what exactly I needed to be able to make me to see, where in the glasses it needed to be. I'm not an optician, so it's harder for me to explain, but there are so many important things that go into selecting a pair of eyewear to make sure that they're gonna make you see. There's things like how they're tilted on your face, how they're sitting on your face, exactly where they are on your face to make sure you're looking through the right spot of the lenses. And if at any point in time during the transaction, when I am purchasing eyewear, the person who's assisting me doesn't know all of these things, they really can't help me see. And I think that's an important part of why licensed opticians are important. They go to school for a really long time to be trained, and specifically, they can do so many things wrong. It's not even just a matter of the frame fitting my face properly. If they sell me the wrong lens material and something hits me, it can hurt me. There's so many things that go into play, and it just should be a requirement that someone assisting me with a medical device should be licensed to do so.
Thank you so much for your testimony. Could you help us understand a little bit that just buying the right frame isn't enough? If you can share that, why is just having the right fit of the frame not as simple as just going in and ordering it online or buying it in a store going to be in not perfect solution? Why?
It's not a perfect solution because so many things come into play. When I walked into my optician, she actually, the place that made me be able to see, she sat down with me. She had a conversation with me. She discussed what I do for a living, the fact that I'm on a computer for a great length of time during the day, because that changes how they make the glasses to make me be able to see the computer. It matters depending if my prescription is an add or a minus, the thickness of your lenses. I personally also have neck issues. So when I'm wearing my progressive lenses, I can't move my neck or move my head the way everybody else can. So she needed to adjust where the progression of the change of the trifocal was, so that I could see without having to bend my neck. Someone who's not trained in optics doesn't have the ability to do that.
Thank you so much. This is very helpful. Thank you for your testimony. Seeing no other questions or comments, we'll move to the next person on our list, Diane Lewis, number 25.
Good morning, Senator Anwar, Representative Steinberg, and members of the Public Health Committee. My name is Diane Lewis, and I'm a resident of Hartford, Connecticut, born and raised. I am also yes.
Before you speak, do you have your camera intentionally off? You're welcome to turn the camera on if you choose to.
I thought it was on, but it's not, and I don't know how to get it to come on.
The left lower corner of the screen, you will see
stop video, right? And so I stopped the video and I don't get to see anything.
Okay, but we can hear you loud and clear, so you're welcome.
Okay, good. My name is Diane Lewis and I'm a resident of Hartford, Connecticut, born and raised here. I am also the communications director for the Voices of Women of Color. I am a mother of a formerly incarcerated son. In solidarity with the YWCA and Regulate DOC Healthcare Coalition, the Voices of Women of Color stand in support of Senate Bill 448, an act concerning the delivery of healthcare and mental health care services to inmates of correctional institutions. Mass incarceration is a health issue, and Connecticut is the only state in the country where the DOC oversees and operates its own healthcare. Just like any other entity that oversees itself, it undermines public trust. Developing a trusting relationship can be very challenging when the same entity that is responsible for taking away your freedoms is the same entity that is responsible for all of your healthcare needs. Secondly, as the COVID outbreak proved, incarcerated individuals have higher healthcare needs than people on the outside because they are living in cramped and overcrowded facilities, which is a health risk in itself. Not only for incarcerated individuals, but for the prison staff and the communities they will eventually return to. The majority of incarcerated individuals will be returning to the communities where they lived before they were incarcerated, and any untreated health conditions will be coming home with them. These are mostly low-income communities of color who are already underserved and often lack adequate healthcare resources. The correctional system is mostly concerned with punishment and public safety, while the healthcare focus is improving health and projecting life through trust and mutual respect between an individual and their healthcare provider. They are not the same. Correctional facilities are the healthcare providers for some of the state's sickest people, and if done correctly, this bill can actually reduce the burden of disease for low-income communities that carry the greatest burden. The Voices of Women of Color urges you to support SB 488 and hold the DOC accountable by establishing a commission to oversee its prison medical system, including providing data on the health, safety, and well-being of people in custody, routinely monitoring conditions, and providing information that will reveal what is happening inside those walls. By the DOC seeing themselves as others see them, will not only bring positive change, but safety and security to our most vulnerable communities. Thank you for your time and your attention to this urgent matter.
Thank you so much for your testimony, and then thank you for sharing and highlighting the challenges as well, and suggesting solutions. Seeing no other questions or comments, Ms. Lewis will go to the next person, that is Dr. Robert Russo. Dr. Russo.
Good morning, Senator Anwar and Representative Steinberg and other distinguished members of the committee. I'm here today to testify on Senate Bill 449, which is the bill concerning retention and recruitment of physicians for the state of Connecticut. I have submitted written testimony. What's most important, I think, just a few statistics off the top. The first one, of course, is that as the AMA and other groups have shown, Connecticut ranks 47th in retention of its medical students. We have some of the best medical schools in the country, yet we're 47th in retaining those students in Connecticut. What's very important about that number also is the fact that these students have spent 4 years in Connecticut. They know Connecticut, they know the life and the lifestyle, and yet they still leave. It's also important to realize that a lot of the students that stay in Connecticut from our own medical schools go into research and don't really go into the practice of medicine, or in quotes, boots on the ground. The second most important statistic is the fact that within a few years, 40% of the practicing physicians in the state of Connecticut will be 65 years or older. So you can see the necessity of replenishing the physician corps that's behind us. The competitors for us, those that are more attractive, let's say, than the state of Connecticut, have various programs, loan forgiveness. There's important work on how to integrate into a system where in the state maybe there's a need. It's also important to point out that Connecticut taxes are somewhat different than our competitors. For instance, our property taxes are very high. If you're going to put an MRI that is maybe a $3 million piece of equipment in Hartford or put it in Shelton, the amount of tax you pay is significantly different. We also have a surgery center tax that is one of the only gross revenue taxes in the country. So when people are coming out and they're looking at these sort of things, they kind of back off of Connecticut because it's less expensive to get integrated into the system, and the opportunities are just so much greater. The loan forgiveness is by far and away the biggest problem. It's not only the outrageous expense of medical school, but a lot of medical students are carrying their college debt forward. The other competitive thing that's sweeping through the South that we don't have is reform in malpractice. And we all understand that years ago, we had a task force with the state legislature about malpractice. It came up with 9 points of thought, none of which, by the way, have been implemented yet in the state of Connecticut. But the big one that's changed in Connecticut is the Homestead Act. 10, 15 years ago, in the medical malpractice, physician homes and bank accounts were not attached. This has now become quite a problem where every time there is a lawsuit, and there's insurance. I mean, everybody in Connecticut has to have malpractice insurance to practice medicine, but to attach the private assets, especially the home, is a real problem. So we need to build around this. Another strong suggestion by state medical is in 2016, we sat down with CHA, the state legislature, and other people and worked out what we thought was a pretty good compromise on the non-compete clause. We therefore don't think it's necessary to put the non-compete clause back in another law and bring it back to the surface after we've all kind of agreed to the system that's in place in Connecticut, which is as fair as it can be, noting that there's going to be a difference of opinion from the smaller private practices to the larger hospital-based corporations. But we did work together to come up with a solution. So we're comfortable with removing that from the law as so proposed.
Excuse me, Dr. Russo, if you would please summarize. Thank you.
Thank you. I'm just not used to testifying in the morning in front of you all. It's usually 1 o'clock at night. Thank you for your considerations, and there's more information in my written testimony. Thank you.
Thank you, Dr. Russo. I was checking my watch as well. I said, well, is it 9 p.m. because Dr. Russo is here, but today it's a little early. Dr. Russo, I wanted to think aloud with you about the non-compete. Now, we unfortunately are going to come to a point where in the state of Connecticut, there will be 2 or 3 healthcare systems. And the healthcare systems are spread all over different parts of the state. And if the non-compete says that from any of the facilities, I'm just going to use the names of either facility, Yale or Hartford Hospital, any of the facilities, you cannot practice 10 miles away from them. And if you're a primary care physician who, from the heavy-handed approach of any one of them can say, hey, I cannot practice here any longer. If you look at the, and draw a margin of the 10 miles, you basically have no place in the state of Connecticut to be able to practice, because the large entities are the ones who are employing the largest number of physicians. And that's why readdressing it with the ground realities is worthy. And then this bill actually looks at practices less than 15 physicians, it would not apply, but more than 15, which includes the larger entities where it would become relevant. I'll give you another example. Let's say ProHealth, which is spread all over the state too. And if they said, well, you cannot work within 10 miles of that space, that's more or less the entire state. And that's why you're losing physicians to that as well. There are multiple reasons for loss of physicians in our state, but you've alluded to some of them. But I want to talk about the non-compete. Would you be able to speak to the new ground reality?
I think that the real importance about a non-compete is where the physician primarily practices. When he or she is based in a town or an office, that's where non-compete should be the real issue about taking patients away from somebody that may have helped you get established. The concept, and I understand what you're saying, that because they spread out now so widely across the state and they have offices. But if the doctor's not actually practiced in that area, it's really not a non-compete situation. In fact, I think if you look, you're not going to find a lot of cases that have been brought against a physician that perhaps practiced in London and now has moved to Greenwich, although, say, Yale has a spot near both. I do believe that to protect the smaller practices, as you said, the under 15, because of the investment to encourage somebody to come into a practice. You know, we usually cover moving expenses, we cover the initial malpractice and healthcare and everything else. You can't have somebody move in and then walk across, in quotes, the street and join a bigger or a different organization after you've invested sometimes hundreds of thousands of dollars to attract somebody. So I really think that non-compete for the bigger corporations would be more a question about patient moving with the doctor moving. So if it's 10 miles within the where the physician primarily practiced, not where the health system has got offices, because a health system that is, for instance, Hartford health system might have an office in Greenwich, but there's no reason to say that that physician's going to take patients out of the Hartford area all the way down to the Greenwich area. So I think those were the things that were discussed. What we're concerned about is it's more important at this moment in time that we be able to recruit and retain physicians rather than worry about the financial health of a major corporation. We do understand that this rapid movement from smaller private practice into the corporate world is eventually going to hurt the state of Connecticut, and we'd like to protect the private ones. So we cannot ask somebody to invest $100,000 in recruitment and then lose it in 30 days. It just would discourage them from doing that sort of thing.
And Dr. Russo, another question is for malpractice reform. Right now, within this committee and some of the other committees, we are having conversation about loss of OB services across the different parts of the state. And while there are multiple reasons, one of the reasons that has not been talked about as much is the fact that it's because of the malpractice cost, it is almost impossible for an obstetrician to stay in the state of Connecticut with the homestead law and so on. So they are very comfortably moving to other parts of the country, which are more appropriate for protection of the physicians. And if we keep this trajectory, multiple other specialties will be moving out of our state, but OBGYN would be one of the first one where women's health will be deeply impacted. Can you speak to that a little bit too, please?
Yes, I think you've basically hit the nail on the head about OB. One of the problems is there's not a lot of time in OB. Babies come faster than sometimes you can expect. Not to have that sort of physician population widely spread throughout the state is important. The problem you have then is what will attract and retain those physicians in that area. And it may have to be some of these things that we've talked about. Put in a Homestead Act, put in some of these other things that protect those practices. And we do at the state level, OHS and CON, we have the ability to control the services in various areas. It's come up many times about the worry of corporate practice coming in and removing services from a rural community, of which OB is such. And without the volume, it's tough for an OB to stay in practice in a rural area without support. So perhaps what needs to be built in on the retention side is some way to financially incentivize people to stay in those areas. And then from the OHS side and the state side through the CON process is to make sure that those services stay where they're desperately needed.
Thank you so much for your testimony. Dr. Pettit, Representative Pettit is next.
Thank you, Mr. Chair. Thank you, Dr. Russo. The bill as written 449, do you think that the 20% loan forgiveness for each year someone's in or in section 4 or 5 under in the bill 5, the $20,000 potential grant, do you think those are significant enough to change and impact our recruitment significantly?
No, it's not nearly enough. You're talking about some people. In fact, I think later on today, you'll hear from a medical student and her partner. They're in debt $1 million. If you're in debt $1 million and somebody offers you 20,000 compared to somebody, the latest one that I know of is out of Tennessee, where there's some upfront money, but what there is a deferral of money. For instance, the state will give you a no interest loan for X number of time and then start the interest on the tail end. But if you're talking about debts that are $400,000 to $1 million, offering 20,000 is you're not going to make the top 10 of a list of where I would want to practice if I was a medical student. You need to. The other thing you need to do is open up like SBA loans or things like that to establish a practice. Let's say 2 or 3 younger physicians want to go into practice together. To establish a practice like that in today's world, where the computer setups and everything else, you're talking about $500,000. So now you're coming in with $500,000 to $1 million in debt. You want 500,000 to be able to open the doors. How are you going to do that if somebody says, well, here's 20 grand? That just isn't going to work. It's not even close. Bill.
Thank you. Thank you for stating the obvious for those who are trying to recruit people. To follow up with that, are there other things that you would add, other things that would help in recruitment, or does it come down to, given the significant debt that many people have, does it come down to major loan forgiveness or larger grant programs? Are there other issues we can tackle? You've talked about the malpractice and protecting people's homes and the like. You talked a little bit about covenant not to compete. Anything else you'd add to the list?
Yeah, I think basically you need to rework the financial package is the issue. You have to be able to sit and say, this is what it's going to take as a startup. If I was going to start an internet company, I could get funding. If I'm $1 million in debt and then want to start a company, I don't have the ability to go to anybody to, in quotes, borrow money. And the other thing is there's no centralized, I don't want to say employment agency, but there's no centralized place that a physician that wants to come back to Connecticut can look at the market. There's no repository or depot that you could say, well, I'm a primary care physician. I'd like to practice in Connecticut. Where could I find the opportunities? If you look at, for instance, the way the Army does it, the Army pays for tuition during medical school with a commitment for further work in the Army, a number of years as, in quotes, payback. Perhaps there are systems where you could say, if you work in the inner cities or you help us with the health equity problems we have, we would pay off your debt as you work in these federally funded clinics, or perhaps Hartford or New Haven or Bridgeport, where you would be able to get a buyback towards it. I don't think you can come up with a cash amount, say, look, we'll give you 100 grand and it's going to make it attractive. I think what you have to do is say, here's 10 years. If you give us 2 days in a clinic, or if you work in the underprivileged region, in a particular specialty, maybe where there's a shortage like OB that Senator Anwar had pointed out before, perhaps those sort of incentives would be very helpful.
No, thank you. Perhaps if this bill moves forward, the section 6, which talks about consulting with medical schools and teaching hospitals for trying to increase, so maybe some of those suggestions could go there. And finally, perhaps not totally on this bill, but on licensing, reciprocity, forgiveness of licensing fee and the like. A concern always in the background is the funding for Haven, and $5 of every licensing fee goes to Havens. Do you think in general, you may not be prepared to answer for the society per se, do you think in general that it's reasonable to increase the fee for Haven to $10 and to continue to collect the fee even if licensing fees per se are forgiven?
Yeah, I think that the real issue is under the licensing fee, what is funded? We fund Haven through the licensing fee. Is that the right mechanism? And for those that may not know, Haven is basically our mental health group that works with physicians, nurses, and other healthcare professionals in the state of Connecticut. It's extremely important that especially now, I mean, talk about stress and burnout and everything else. The reality of it is that the right mechanism for funding for Haven? Should it not be a different policy? I mean, one of the concerns that came up was maybe in a young physician coming to Connecticut, you would give them the first 3 years of licensure for free. On the other hand, that damages Haven. They make money and do all those treatments and save a lot of lives in the mental health side. You can't rob Peter to pay Paul. My suggestion would be to find a different way to fund Haven, and then we don't have to worry about that. There are very few people, by the way, that know that cutting the license fee would cut Haven. And that's a desperate two-edged sword that I'm totally against. I've seen too many burnt out physicians and nurses and APR, the whole crowd, to think that Haven should be funded by state licensure.
Which is why I bring it up. So I thank you for educating the public, and thank you for your answers. Thank you, Mr. Chairman.
Thank you so much, Dr. Pettit. Thank you, Dr. Russo. Seeing no other questions or comments, we appreciate you coming in and speaking to us. Next person on our list is number 27, Sue Hodgen. Ms. Hodgen, thank you for your patience and welcome.
Thank you, sir. Distinguished members of this committee, thank you for the opportunity to be a part of your hearing today. As the director and legislative liaison of a regulatory board in North Carolina, I understand and appreciate legislative bodies' responsibilities towards sometimes cumbersome bureaucracies and the balance between business and the public to which you're obligated. As lawmakers in Connecticut, I urge you, however, to rethink the ramifications of your esteemed body's consideration to lessen the standards for quality vision care in your state. As we're seeing in North Carolina, the aging of all states' populations mandate that individuals involved in all aspects of healthcare have even more, not less, training and experience. All our respective publics, older and younger, face increasing health issues. Your constituents are looking to your recognition, not diminishment, of their needs and making the best decisions to see to those needs. Like their North Carolina peers, licensed opticians in Connecticut deal daily with patients' vision anomalies and perform hands-on fitting of eyeglasses and contact lenses. The education and training they receive before licensure and afterwards, with mandated continuing education, is necessary to properly protect the health and welfare of the public. Currently residing with your committee, Senate Bill 329 appears to open wide the door for unscrupulous optical businesses to have unlicensed and untrained individuals performing acts of opticianry when no licensee is on site, and to allow this activity for periods of time established by the Department of Public Health, which could be, and most likely would be, subverted by these unscrupulous businesses. Incorporation of Section 1.20-150B would be calls for businesses to always have, quote, reasonably unanticipated circumstances, unquote, and claims that they were taking, quote, reasonable action, unquote, to have another licensed optician present. In the end, this would mean less than qualified personnel working and providing services to unknowing Connecticut individuals. Liken this, if you will, to a pharmacy. Would you want someone other than a trained and licensed? Make no mistake, the corporate entities who may purport to be seeking ways to stay open to, quote, help the public or to support the economy by making it easier for Connecticut residents to obtain jobs are looking solely to their own profit margins. Do you see anywhere in this proposed legislation or anywhere in their testimony to you mention of assuring quality vision services and public protection? No, they're more concerned with keeping stores open 7 days a week, keeping the revenue flowing, getting eyewear properly checked before dispensing, and then the very act of properly fitting a pair of eyeglasses to a face for maximum product service is not the concern of these companies. The retail aspect is their concern.
Excuse me, Ms. Hodgkins, your time is almost up. If you please summarize. Thank you.
Thank you. Just like the unanticipated circumstances provision, how will B3 hope to be enforced if there's not going to be an optician there all day? Please eliminate Senate Bill 329 from your committee's consideration. The nation will watch with great interest to see your position on lessening the requirements that well-trained and licensed individuals supervise and operate Connecticut's optical dispensaries. What will your stance be? Showing your citizens that you care for their eye care, I hope will be your answer. Thank you so much.
Thank you so much for your testimony. I see a question from Dr. Pettit, Representative.
Thank you, Mr. Chair. Thank you, Mrs. Hodgin. I think about 35 states regulate opticians and 15 for some reason do not. Does North Carolina not allow a eyeglass retail facility to be open unless there's an optician on site? Is that the law in North Carolina currently?
Yes, sir, it is. We do have provision in our law that there has to be a licensed optician on site at all times that acts defined in our state as opticianry are being performed.
And again, maybe you're not in a position because you're not an optician, correct? What from your society's point of view, what's the biggest health harm if someone's in looking at frames or non-prescription sunglasses? They're like, what is the public health harm in the view of your organization or the opticians that you represent?
Well, I'm actually the director of the state board here in North Carolina, rather than an association. We regulate the actual operations of those dispensaries, and what we see coming into the dispensaries from reports that we get and from our inspectors' viewpoint is that there are individuals coming in with eyewear that they've either purchased online or that they've purchased somewhere else that they're having problems from, where our opticians actually find that lenses have been put in backwards or manufactured that way, or they've been put in the wrong eyes. So for frames. And so there's obvious the implication that there could be serious consequences for folks wearing eyewear that's been improperly manufactured.
Okay, maybe I'm this and perhaps the chairman can educate me. I don't know that they're asking for that. I think they're asking to be able to be open to sell frames and non-prescription eyewear if there's not an optician there. I'm not hearing anything about putting lenses in or that kind. So I don't know if there's a fine line or there's an issue with regulation, but I think they're not asking to do some of the things that you referred to. In any case, thank you for your testimony. Thank you, Mr. Chair.
Thank you so much. Seeing no other questions, we wanted to thank you for your testimony. The next person on our list is number 28, Raymond Burrell.
Yes, hi, good morning. Thank you, Senator Anwar, and good morning to the members of the Public Health Committee. My name is Ray Burrell. I'm the Assistant Manager of Water Treatment for the Metropolitan District, and I appreciate the opportunity to testify in opposition of HB 5482 regarding Legionella mitigation. I'll just state right now that, you know, as one of the largest providers of drinking water in the state of Connecticut, the MDC takes great pride and cares more deeply about the quantity and quality of the water and the safe aspects and all the characteristics that surround safe drinking water than than anybody else within the state of Connecticut, as far as I'm concerned. This bill is very concerning. The requirement of adding or maintaining a 0.1 part per million chlorine residual throughout the entire distribution system really puts the onus on the public utilities, the municipalities, and doesn't guarantee the protection that I think healthcare facilities need in regards to the prevention of Legionella or a Legionella outbreak. Just last week, I sat in a Connecticut public health workshop where data was presented that even showed a chlorine residual dose of 4 parts per million didn't even prevent Legionella. So I don't know where the 0.1 part per million came from, but and how that they derived from that. But all I could tell you is that there are unintended consequences when it comes to adding additional chlorine. Certainly, you'll have to deal with taste and odor, but more importantly, disinfection byproducts. Because if you have to add additional chlorine to the water, that's going to react with natural organic matter, which will in fact increase your DBPs. And that's one of my largest concerns here. As you know, DBPs can cause bladder cancer, and it could have an impact on a greater population within the district service area. I don't know what the issues are at these healthcare facilities. I don't know if they're isolated. I do know that for the few incidents that we've been involved with, typically the issue was with the facilities management. So the unintended consequences is a very serious concern for us, because every action, there's a reaction. Every healthcare facility is supposed to implement a water management plan, which addresses areas where Legionella could occur, water towers, heating systems, identify those areas and create mitigating responses to those issues. Just to give you an example, and especially since COVID, this is recognized in a number of examples where buildings became less occupied or even not occupied. Chlorine residual doses that we typically seen were actually reduced almost in half and even further because of no occupancy or because no water was moving through that facility. It's important to note that if I have even a 1 part per million chlorine dose on the curb of a healthcare facility or any building for that matter, is not going to guarantee a residual of 0.10 inside. It has everything to do with the management in the flow and movement of that water within that facility. And I really think
Excuse me,
that's
Mr. Burrell, your time is almost up. If you please summarize.
All right, thank you.
Thank you.
I really think that's where the focus needs to be. And the MDC would like the opportunity to collaborate with the Department of Public Health, collaborate with healthcare administrators to help mitigate Legionella and build upon their water management plans.
Thank you so much, Mr. Burrell. This bill was raised because of requests that had come to us. I wanted to just talk to you a little bit in more depth about your testimony. First thing was currently, what is MDC doing to prevent a larger outbreak of Legionella?
Well, currently what we do right now, and this really falls under the surface water treatment rule, and actually Legionella is encompassed under that umbrella. So we do disinfect our water post-filtration, and we have large storage tanks, which allows the water to come in contact with our chlorine disinfectant. And it comes down to contact time. So that's how we prevent, any bacteria growth within the distribution system. It's that contact time within those storage tanks that provides that protection. And I also note that the requirement currently for chlorine residual leaving a water treatment facility is 0.20 part per million. On average, the MDC sends water to the distribution system at a residual of 0.9 parts per million.
Thank you. And I think if you look at the intention of the bill, because there's a certain amount of coliforms that can stay in the water, and for somebody who's immunocompromised, that may mean different to the general population. And that's part of the rub here right now, is that for a nursing home or a hospital where they're immunocompromised individuals, the criteria has to be a little bit more stricter to reduce that risk.
Absolutely. I agree with you, and I understand the intent. But again, for every action, there's a reaction, and the disinfection byproducts are already regulated, and those are over the last few years, municipalities have been struggling due to climate change, changing conditions in their source water. which have increased and elevated DVPs, currently. So mitigating those on our end is always a challenge, and we always, maintain, levels below the maximum contaminant levels. And if we have to increase our chlorine entering the system, at the treatment plant, that may have an impact on the rest of our, customer population.
On the same note, from the distribution point of view, so if there was a way that there's a standard for the general population, but the distribution points that are going to a specific nursing home or a hospital setting where we know they're immunocompromised, is there opportunity to address and change the risk mitigation strategy locally in that space?
I've never myself personally never been involved with a healthcare facility as far as helping them either develop or review their water management plans, but that's vitally important that they engage us. There was when everybody came back to work from COVID, the public health department was urging building owners, system owners to contact and reach out to the utilities, because that water that just sitting stagnant for so long is a concern where bacteria could be growing. But again, that's where we come in to play. We could partner with those, facility or public officials and try to help them mitigate, even further than whatever's outlined in their water management plans.
So that could theoretically be done distally, not proximally, or in the central part. That could be done at a later part in the distribution.
Yes, the healthcare facilities, nursing homes, and so forth, they also have the ability to install treatment systems if they so choose. Again, not knowing, some of the building piping systems, they could be miles long, depending upon the structure of the building. And so there's a lot to look at. So it may at times require a localized chemical feed system or disinfection system.
Thank you so much for your testimony. We will follow up and we will try to get the proponents of the bill to reach out and coordinate as well further. But we wanted to thank you so much for your testimony. Seeing no other questions or comments,
thank you very much.
To the next person on our list, which is Mr. Matt Barrett. Mr. Barrett.
Good morning, Senator Anwar, and to the distinguished members of the Public Health Committee. I'm Matt Barrett, President and CEO of the Connecticut Association of Healthcare Facilities. And I thank you for this opportunity to testify on House Bill 5481, an act concerning recommendations regarding the change of ownership of healthcare facilities. The bill represents a significant overhaul of the change of ownership process. And while we're not opposed to reforms to this process, we do recommend a more active stakeholder input process before significant changes are made. My association, the Connecticut Association of Healthcare Facilities, would offer to be helpful in any way in such a review. We, as guiding principles, we recommend that any revisions to the change of ownership process in Connecticut should balance the department's need for sufficient information to determine the suitability of the new owner, while not burdening the ability of individuals and corporations from making simple and inconsequential changes to ownership structures, which are currently addressed both under Connecticut's law and under Medicare rules, rather. We should also thoroughly review the body of law that now exists in statutes and regulations that provide for disclosure of any ownership, direct or indirect, of 10% or more of an institution, including fingerprinting of all such prospective owners and affidavits disclosing whether or not such owners, officers, or directors or others have been convicted of any felonies, held civilly liable for fraud, misappropriation, or have any other federal or state license suspensions or revocations. And finally, we hope that the process would enhance the owner suitability review, but not in a way that is an impediment or a deterrent to new businesses wishing to invest in our healthcare industry in Connecticut at a time when we think investments are vital to ensure improvements, many of which were uncovered during the COVID-19 pandemic, that we learned quite a bit about, and that we hope that change of ownership reforms don't impede those investments. In any event, I thank you for the opportunity to testify, and I'd be happy to answer any questions you may have.
Thank you so much for your testimony. I think your testimony is very helpful. And then we will definitely keep that in consideration. Seeing no questions or comments, we'll move on to the next person on our list, which is Sarah Lemaster. Hi, Sarah.
Hi, good afternoon, distinguished members of the Public Health Committee. It's my pleasure to be before you again. I feel like we meet every Monday. My name is Sarah Lemaster. I'm the Manager of Government Relations and Public Policy for the Community Health Center Association of Connecticut. The CHC Act is Connecticut's primary care association. We support the work of 16 of Connecticut's health centers. And today I'm testifying on a number of bills, the first of which is Senate Bill 375. This bill would protect access to telehealth. Many health center patients receive Husky benefits and live at or below 200% of the federal poverty level. These patients experience health disparities that put them at increased risk for developing chronic conditions like diabetes and hypertension. And in order to serve these populations, our health centers specialize in making healthcare accessible and convenient to everyone. Prior to the COVID-19 public health emergency, most health center patients did not have access to telehealth services. And telehealth has been a tremendous tool in ensuring access to these services by reducing many of the physical barriers to care. Video and audio telehealth have been powerful tools in improving access to services for many of our patients. This bill will continue this access beyond the likely scope of the public health emergency, which we all hope is ending soon, or at least at the federal level. Additionally, providing these services has allowed health centers to break new ground in many aspects of how they deliver medicine. I will be including with my testimony some stories that we collected last year that give details on how the impact of telehealth has vastly improved access to care for our patients. Additionally, Senate Bill 449, I know you had a doctor on earlier that talked about the importance of recruiting and retaining primary care providers in Connecticut. We do support this bill, and we support any effort to increase the recruitment and retention of physicians in the state. The COVID-19 pandemic has put an increased stress on the healthcare workforce, especially for health centers. And this bill, we strongly support any effort to recruit and retain more primary care providers. I know that the bill outlines a $20 million grant available to providers who are willing to come and practice in the state. I believe that will be very helpful in helping to recruit and retain providers. I know that there's also multiple bills before the General Assembly this year to address various recruitment issues, including strengthening the state loan repayment program and adding additional funds to that. I will also note that more globally, we recognize that the Public Health Committee is taking a concerted interest in recruiting and retaining additional providers and ensuring the continued access to care through telehealth. Both these types of initiatives are necessary to ensuring the continued access to care and in helping Connecticut to address a lot of the health disparities that have been highlighted by the public health emergency. So CHC commends the committee for raising these and other items of legislation directed at addressing these public health disparities. Thank you for giving me the opportunity to speak today, and I'm happy to take any questions.
Thank you so much, Ms. Lemaster, for your testimony and the work that you and your organization do. But the telehealth, there's a sunset date. Do you think we have reached a point that there shouldn't be no sunset date?
In my written testimony, we asked that the legislature essentially continue coverage of telehealth benefits indefinitely. I think that at this point we have clearly identified how beneficial telehealth is to all Connecticut residents, including especially patients in areas of high need. A lot of our health centers serve patients in rural areas where it's difficult to access a doctor. Some patients have to drive as many as 10 or 15 miles just to get to a clinic. So telehealth cuts around a lot of those barriers. It makes it easier to access care. In some parts of the state, patients will ride bicycles to get to a clinic. So it takes about an hour to ride 10 miles on a bicycle if you're in reasonably good condition. continuing telehealth indefinitely will absolutely continue to increase access to care. I'll also add that since we started offering these services, we've developed some new technologies and better ways of connecting with patients. In the beginning, it was sort of, figure out what we could do. And since then, we've found new ways to connect with patients. We've enhanced access to care. This has been a really powerful tool for a lot of patients in maintaining access to their providers. Thank you.
Thank you so much. Again, thank you for your testimony, and I see no other questions or comments. Move on to the next. And next person on the list, thank you, Sarah.
Thank you.
Next person on the list is Colleen Lord. Ms. Lord, good afternoon.
Honorable Chairs Anwar and Steinberg and distinguished members of the committee. My name is Colleen Lord, speaking in support of SB 448, ensuring medical and mental health care for those experiencing incarceration. I'm a resident of West Haven, board member of NAMI Shoreline, and a proud mom of 3 kind and brilliant adults. My oldest, Robbie, is in heaven, and his 2 siblings live just a few blocks from where their big brother died inside New Haven jail 3 years ago. Today, his angelversary is today. My life ended that day. I would never see him or hear him laugh or dance or hug him again. Robbie was shaped like a big soft pillow, and he gave the best hugs in the world. Rob was disabled with a no-fault brain disorder, unjustly incarcerated for nonviolent breach of peace. But to use NAMI's mantra, he required help, not handcuffs. Help that did not exist in our state for the thousands with no insight into their own illness. I appreciate the hard work that's being done to fix the mental health system in Connecticut. I truly do, but it would be a tragic mistake to also not fix the broken corrections department. Robbie was denied prescribed methadone medication in custody, so he predictably suffered withdrawals from it, which then prompted a psychiatric episode that I warned the nurses could happen if he did not receive his prescriptions. He was sent to the medical unit to await a psych evaluation, but when brought for a shower, he just didn't get off the shower floor when being ordered to due to his psychiatric status. Guards grew impatient, and Rob's obvious presentation of illness is all that prompted several brutal pepper spray attacks and a heartless boot stomp to his face by Lieutenant Carlos Padro. Ignoring the psych evaluation, Nurse Sukowska approved Rob for solitary confinement instead of providing medical care. Robbie was unhandcuffed while in excruciating pain from the pepper spray, burning the insides and outsides of his skin, swelling mucous membranes and respiratory tissues, begging for help but ignored. The brutality continued, pepper sprayed again and again, despite his compliance, until he was left unconscious, trapped in a tiny box full of toxic fumes, then discovered in the exact same position 90 minutes later, long deceased, still in in-cell restraints. Pepper spray is not safe in the manner that it's being abused at the DOC while the medical staff just looks on. The actual creator of weapons-grade pepper spray has agreed with me. It will kill when misused the way Connecticut uses this weapon. My dear son was a poet, but he died in pain and abusive neglect. His last words were, "Can't breathe." The nurse and a dozen officers did not intervene. Internal investigators deemed their behavior appropriate this year, despite it being categorized a homicide. Lieutenant Padra was sentenced to a year in jail for assault for the face stomp only, which he won't serve. But as a victim, I want to be clear that if he or the others are ever in jail, I do not want them tortured or denied medical care. This is inhumane, whether you're a cold-hearted killer or a gentle teddy bear like my Robbie, or anyone in between. In closing, we must fund what's necessary to bring the processes and ratios of medical staff to safe levels, provide crisis intervention training to jail and prison staff where 40% in their care have a mental illness, and then demand quality work from all. In Robbie's memory on his 3-year angelversary, I ask that you vote yes to SB 448. Thank you, and I will take any questions.
Thank you so much, Ms. Lord, for sharing your pain and I'm so sorry for your loss. And I know each and every one of us are so sorry for the loss. And then I think you're highlighting the need for intervening and then having a better plan for our Department of Correction. I don't think we have a question, but I can tell you that knowing all of our public health committee members, we are all sending you love and hugs. Okay. Thank you for your testimony.
Thank you for raising this critical bill.
And the next person on our list is Dr. Timothy Segrist. Dr. Segrist.
Good morning or good afternoon. My name is Dr. Timothy Segrist. I'm a board certified practicing urologist in Middletown, Connecticut, and I am the current president of the Connecticut Urology Society. I am here on behalf of over 800 physicians and physicians in training in the above mentioned specialties of urology, dermatology, otolaryngology, and ophthalmology in strong support of RB 449 AAC, the recruitment and retention of physicians in the state. Some of my colleagues may have testified before me on the urgency of passing SB 449. So in addition to the testimony I have submitted, and because time is short, I wish to add some personal remarks supporting the need for immediate action to help retain and recruit physicians in Connecticut. These are my personal experiences in private practice and the obstacles that led me to change my practice model. In 2011, I finished my urology residency in New York City and endeavored to find employment here in Connecticut. My wife and I are both from Connecticut, and we knew we wanted to raise our family here. I interviewed with 5 different urology practices across the state and ultimately settled on a practice in Middletown. 10 years later, 4 of those 5 practices with whom I interviewed have closed their doors in favor of employment by a large healthcare system, including my own. I've spoken with physicians at all of those practices, and like my own practice, the #1 reason they were unable to remain independent was the inability to recruit new candidates to their practice. In my experience, unless a candidate has family ties that compel them to return or remain in this state, it is nearly impossible to attract new physicians to Connecticut. The physicians in Connecticut thank the legislature for returning its attention to this very significant aspect of access to care for our Connecticut patients. This is a crucial bill addressing critically needed changes to improve the healthcare outlook for our state. The bill contains many specific provisions that will improve the environment for the practice of medicine and make Connecticut more attractive to physicians entering practice or considering a change of location. I will focus on a few salient points. With growing economic pressures, increasing demands on healthcare, and growing need for improved access to care due to factors including coverage issues and an aging and sicker population, the strain on our diminishing and aging physician population has been increasing annually. The burdens of caring during the COVID pandemic have stretched an already thin margin even further. We are seeing record numbers of providers of all types planning to reduce care or leave practice entirely. This is not new. As early as 2008, the University of Connecticut produced a report indicating, quote, "There is a growing concern about an impending shortage of physicians, including primary care physicians. Several factors contribute to these concerns, including population growth that is estimated to exceed growth in physician supply, an aging population that typically requires frequent access to healthcare and whose care is best coordinated by a primary care physician, the decrease in medical students pursuing careers in primary care, and the difficulties in quickly shifting priorities in medical education due to the length of time required for physician training. Thus, while Connecticut may be able to absorb near-term increases in primary care services demand without any improvements in primary care capacity and workforce policy, this may not be the case in the future." End quote. Strains on the healthcare system fall hardest on those with the least resources.
Excuse me, Dr. Segrist, your time is almost up. If you please summarize. Thank you.
In summary, I would just strongly urge you to lend your support to SB 449. Thank you for your time.
Thank you. Thank you so much, Dr. Segrist. I have a question, but before that, I know Representative Steinberg, my co-chair, has a better question.
Now you put the pressure on. Thanks a lot.
That's what we're trying to do.
All right. Thank you, Dr. Segrist, for your testimony today. Obviously, a lot of the emphasis in the legislature this session has been on mental health and behavioral health practitioners and primary care practitioners, but your testimony brings in an entirely different realm of specialists who I hadn't really thought about that much. You know, my initial reaction when you started talking about dermatologists and ENT guys is it's just not quite as urgent, perhaps. And, you know, given the fact that no matter how much we'd like to say otherwise, our resources are somewhat limited. If we want to do the kind of bigger loan programs that we discussed with Dr. Russo, we may not be able to be all things to all people. So help me make the argument that we should be looking at all these specialty areas as well. I think your story about the almost implosion of urologists in the state in terms of private practice is instructive, but do you have other reasons why it's so critically important that we also support specialty physicians?
Well, outside of the reasons that I've already highlighted, I mean, I have colleagues in ENT, colleagues in dermatology, and it's always the same story, you know, that they have a partner who's approaching retirement, and they are absolutely scrambling to try to find somebody to replace them. In the 10 years that I've been in this practice, we've hired one urologist, we've interviewed probably 20. And all of them end up, you know, outside of this state, or I would say the vast majority. And, you know, I can't speak to the specifics of their circumstances, but I know from my own circumstance, you really do need somebody who's from Connecticut, or whose wife is telling them you have to, or spouse or husband is telling them that they have to be in Connecticut for some other reason. Otherwise, nobody comes here without a reason.
Thank you for that. If we could do just one thing well here in Connecticut, fully fund it, make it really work, what would it be?
Well, that's a big question. I can't put my finger on a single thing. I mean, I can tell you from a surgical subspecialist point of view, you know, many of us have confronted the economic challenges of staying in practice by looking for alternative sources to supplement your income, things like ambulatory surgery centers. And, you know, we did that in our practice about 5 years ago. And literally the day that we opened was the day that the state passed an ambulatory surgery center tax, and really has crushed us. And we're not the only ones. So I can't say that there's a single thing, but, you know, from my standpoint, that's been the one that's been the most devastating.
Thank you for that, Doctor. Thank you, Mr. Chair.
Thank you. I see Representative Carpino has a question or a comment. Representative Carpino.
Thank you, sir. It's a little bit of both, and maybe it answers a bit of Representative Steinberg's question. Dr. Segrist, thank you for being here. Having had friends and family walk through your office, not for you in particular, I just want to make the point to everybody out there. It's these specialty groups are essential health care to those who need them. That these are not just, and I'll talk about urology in particular, because I have family members who walk through these doors. You know, anyone who ends up in an emergency room because of a condition gets wonderful care at our local emergency room and then needs to follow up the following week. That's what we're talking about when we're identifying who needs our help to maintain a high quality list of providers here in the state. And I just wanted to make sure that we understood this. Our specialties are providing critical care. And I just want to make sure, whether it's urology or some of the others that I know we're going to hear from today, just because they're not at the forefront of our minds, they will be if you have a friend, family member, or constituent who needs their services and is faced with the grim reality of a substantial wait time when seeking care. So, Dr. Segrist, thank you for making sure that we realize that our mental health needs are in shambles right now, but our need for high quality providers goes much further. So thank you for being here.
Thank you.
Thank you for those eloquently stated comments, Representative Carpino. And I see Senator Huang has a comment or a comment.
Thank you, Mr. Chair. And Dr. Segrist, thank you for your testimony. And You were a particular fit for a question I had on this bill. Senate Bill 449. We're focused in on the loan repayment, but has a individual practitioner that is now in a large group practice. What are your thoughts about the non-compete provision of this language?
I've never been in favor of non-compete language, in contracts. I think it really limits physicians. And I would strongly encourage the legislature to get rid of any, contracts that allow non-compete clauses.
I appreciate hearing that. And it's particularly interesting to hear it from a large group kind of entity. You have 16 physicians in your practice?
Well, I mean, when we were in private practice, there were 4 of us, but now I'm an employee of a large group health system. So there are, probably hundreds of physicians in our practice.
And do you have a non-compete provision in your agreement as a large hospital-owned group practice?
Yes, we do.
I wanted to get your thoughts on that because I was curious about that. And obviously, number 3, the third part of this provision is to have a task force related to medical malpractice. I didn't hear a lot of people mention of that, but that's got to be very welcome to at least make an inroad to look at the significant cost of you doing business in the state, in any state, as a physician, is the malpractice reform.
Absolutely, particularly for those who have not succumbed to the pressures to join a large healthcare system, who are trying to make it in private practice. The malpractice issue is huge.
I appreciate that. I wanted to get your thoughts on other components of this very important bill that we haven't heard a lot of engagement. And obviously, the financial burden of so many of our medical practitioners have to kind of accumulate is an incredible burden. So thank you for your service in the community. Thank you, Mr. Chair.
Thank you, Senator Wong. Dr. Segrest, all the questions I had have already been asked and the comments I wanted to make have been made, and I know that you're going to the OR shortly. So thank you. Good luck with your surgery that you're doing.
Thank you. Thanks for your time. Appreciate it.
And the next person on our list is Dr. Arlen Aceto. Dr. Aceto. Dr. Aceto, we can't hear you.
All right, can you hear me now?
Yes.
Sorry,
yes, very well.
Over my computer is his gaming computer, so he switched the settings. Sorry for the interruption. Thank you, Senator Anwar, Representative Steinberg, and the esteemed members of this entire Public Health Committee. Thanks for the opportunity to speak with you today and all of your diligent hard work on all these important issues. My name is Arlen Aceto. I'm from Hampton, Connecticut, but I'm also the Associate Professor and the Program Coordinator for the Opticianry Program at Middlesex Community College in Middletown, Connecticut. I'm here to ask you to oppose SB 329. Quite frankly, this bill appears to be a thinly veiled attempt to bypass statutes and regulations that serve to protect the public in the area of eye care. Seems unnecessary and potentially disservice to our community. I only see support from one particular group. This is the rules and safeguards that every corporate entity and private optical company has adhered to for years successfully. And I don't see a lot of support from other groups and other companies. Rather, it seems to be a newer outside corporation that appears on changing the current rules to suit their current business model, rather than focusing on ensuring quality care to the general public. Our opticianry program in Middlesex Community College is over 30 years old and is one of the most respected in the country based on the scope and the education provided to our healthcare providers in our state. I happen to be a graduate of this program as an optician, but I actually went on to become an optometrist to practice and have come back since to teach. Middlesex Community College was actually visited by Education Secretary Miguel Cardona, Governor Lamont, U.S. Senators Blumenthal and Murphy, and a whole host of other luminaries. And we were one of the featured programs, the opticianry program, and we got rave reviews for our facilities and what we do for our students and for our community. Our program is one of the premier education programs in the college system, and we focus on getting students great jobs upon graduation in the healthcare arena. We don't just teach the optics and laboratory aspects of the profession, but or just the fitting and dispensing of contacts. Dr. Pettit had mentioned that what would be the problem with trying on a frame? And I would submit to the group here that it's impossible to separate the tasks of just looking at frames from advising on the thousands of lens modalities, on the materials, the treatments, understanding and interpreting doctors' prescriptions. Our program teaches and our profession requires intricate knowledge of FDA requirements for impact resistance, FTC regulations as they pertain to contact lenses, duty to warn standard of care in our industry, especially for risk to our pediatric patients, our monocular patients who have vision loss. We have to know intricately the OSHA regulations, other federal standards, Z87 for industrial safety standards, ASTM standards for sportswear, when we can protect our patients, our children, and those at highest risk. Also, we teach when to refer to ophthalmologists and optometrists based on complaints and interactions. We've had opticians refer in timely manners to optometrists and ophthalmologists for things like strokes and retinal detachments because they knew what to look for, even if it was just looking around in for a new set of glasses based on what they told the opticians. Now, what I'm really here for today, though, is the workforce development aspect of this. Workforce development is something that we have in our community college system and in our program specifically, and it's key to allowing opportunities for advancement for our students. Our
Excuse me, Dr. Aceto, your time is almost up. If you please
Very
summarize.
good. Thank you. And so we have a very diverse background of students, underserved communities, second careers, people joining the military, and we feel that this bill, if is enacted, would limit the chances that our students have and our graduates and our alumni. It would not be in the best interests of our communities. I would have more, but I will keep it at that. Thank you very much for your time.
Before I hand it off to Representative Foster, I'm going to give you a moment to finish that last point.
Sure.
I think we're intrigued by the fact that you find this bill problematic and would create limitations. If you wouldn't mind amplifying.
Sure. And I appreciate that very much, Representative Steinberg. So right now, we actually have a very diverse student body. We actually, this year, we reached out to a whole host of national groups that were offering specific scholarships to underserved communities and people of color. This program is actually only available for Atlanta and New York City. We actually lobbied to have it also apply to our particular college, and so we have 2 of our students with a full ride to an opticianry program through this. We actually have multiple single mothers. We have folks for looking for second careers. We have people in the military coming back and looking for a way to join the healthcare profession in this manner. The vast majority of our students are currently female, which gives more opportunities in a profession that was predominantly male when I started 30 years ago. And I would also argue that we've been working on access and diversity, and we've actually changed our program from a fully in-person 3-day-a-week program to a hybrid program. And what this allows people to do is have more opportunity to engage in and learn and have a higher level of education, but also have better access when people are in the further reaches. It's more accessible than ever. We have one of the largest classes we've had since I've been in the business. Since I've taken over as program coordinator in 2018, we have the highest level of minority representation in our classes, significant level of female gender equality, equity, opportunity. And I feel that this is because these are all going to migrate into the workforce, into the healthcare profession, into being team members of other healthcare professionals like ophthalmologists, optometrists. And again, I can take my optician and instructor hat off for a moment and put my optometrist hat on, because I also happen to be a practicing optometrist, and I want to let the other groups speak to that. But my own personal anecdotes are, I've actually helped open 2 optometry schools, one in Massachusetts, one in Illinois, and I was able to practice. I have to practice to support my teaching habit. And I've worked in strong licensed states like Massachusetts and Connecticut, but I've also worked as an optometrist in a non-licensed state, or one that has lower regard for patient care. And I can tell you, it was quite frankly a train wreck. The problems that our patients had, the people that came back to my chairs, the miscommunication, the lack of education, the remakes, things that should never have come back to my chair and never do when I'm in Massachusetts, Connecticut, continually came back into Illinois, and it was quite frankly, didn't do a service to us as optometrists. It didn't do a service to my patients, especially when they've spent lots and lots of money. So quite frankly, I think that these requirements, having educated, qualified, and licensed professionals, being able to look out for the patients at all times is like any other licensed professional, whether it's electricians, pharmacists, what have you. I've never seen another group where they said, hey, we'll just only apply the laws here or there. To me, it doesn't stand to reason, quite frankly.
Perhaps I misunderstood you, but I thought you were suggesting that the efforts we were making with regard to recruitment and retention would inhibit these activities. Your answer didn't really cover that. Did I miss?
Oh, no. So I apologize. So what I'm saying is we've gone a long way in encouraging diversity and inclusion and access to this. And by making it so when they're at the end of the day, there's no need for the license, and undermining the entire profession would be problematic for our students and alumni.
I think I see. I'm not quite sure. I'll go to Representative Foster while I think about that.
Thank you so much, Mr. Chair, for allowing me the opportunity to speak. Dr. Aceto, thank you for being with us today. Before I sort of ask my question, I just want to say that I probably have about as much optical knowledge as enough to be very dangerous and use the wrong terms at the wrong place. So please correct me if I'm using the wrong terminology. My parents 30 years ago went to school to be opticians, no longer practice, but I was running sort of this bill by them this weekend and they were concerned. And so I think I understand a little bit about something, but I'm sure I'll use the wrong terms. And so I'd appreciate you correcting me when I'm wrong.
Sure.
So my first question is, we spend a lot of time in this committee in particular, encouraging folks to practice at the top of their scope.
Right. Mm-hmm.
And I think that for a lot of people, we hear optometrists, ophthalmologists, and opticians, and these terms are being used interchangeably. Can you tell me about what the top of scope is for opticians and why
Sure.
that role is different in administering a prescription for the manufacturing of glasses versus an eye exam with a doctor?
And quite frankly, the scope is different. And some people have said, why don't we do this in other states or other opticians? I will say that the state of Connecticut has a unique position in that all of our licensed opticians are actually able to fit contact lenses from and doctor's eyeglass prescription because they have higher training, they have more expertise, they are licensed. And that, quite frankly, gives more opportunity for competition for when we're talking about eye contact lenses and those types of things. So the higher scope is, it's not just glasses, but it's also contact lenses, which encompasses anatomy, physiology, disease processes, those types of things. So they're not doctors by any stretch, but the level of care that they provide is maybe the highest in the nation. And for the folks that have been talking about other states that don't do this, we're actually, I'm a member of many national organizations that are actually trying to use Connecticut and Massachusetts and the Carolinas as an example to bring other states up to the fold so that all states have a higher level of education, licensure, and certification, because quite frankly, that's what our communities and our patients deserve.
So what's different between when a patient goes to the eye doctor and gets a prescription, and then what the optician does at fitting lenses, fitting glasses, and selecting?
Sure. So the biggest difference is that the eye doctor, the optometrist, ophthalmologist, oftentimes do a complete health check. They double check the operation, the physical structures, make sure there are no diseases, fix them if they find them, refer appropriately or treat when necessary. The optician will actually take that eyeglass prescription, and it's just not a series of numbers, and you just can't pick a frame out. And if you do it, you're probably doing the patient a disservice, but it's looking at their lifestyle, their needs, their particular status, whether they are monocular, whether they have vision in one eye, or if they're lost one, whether they have industrial requirements, what materials are best, what lens designs are best. Quite frankly, much of what we do is what my students do are troubleshooting. When things don't work well, they have to come back. And if somebody just spent $800 or $900 or $300 on a set of glasses and they're not working, oftentimes it's an educational thing or a problem solving issue. And it's not just looking at frames. There's a science and an art behind everything that an optician does.
So what I have come to learn to understand from talking to an optician in practice in my community and conversations with folks that I know in the field is that there's this sort of common sentiment that when people get new frames, particularly not from an optician, that they're like, oh, I have a headache. This doesn't feel good. I have to get used to them. How often is that because they need to get used to them versus something's wrong?
And that's where you would need a licensed professional to look at about even the input. We actually have a small issue where, again, put my optometrist hat on. And again, I don't want to steal the thunder for the other groups. I'm here primarily as the program coordinator here for Middlesex, but in my own personal anecdotal experience, I actually spend a lot of time and make a lot of money trying to fix people's problems when they got things online because they typed it in wrong, or because they ordered it wrong, or because their combination of lenses, materials, designs, computer glasses, progressives, bifocals, you name it, just weren't sufficient. And so if those aren't made properly, they don't work properly. If they don't work properly, they were sort of they didn't get the service that they need, and there's no one to help them out. And again, you can't separate the purchasing of, the fitting of, and the selection, the advisement, the patient history of from just the frame selection. It's all one and part of the entire continuum, in my opinion.
And so I think a lot of times people think of glasses as the frame and the lenses are the thing that gets made in the lab, and that's just going to be fine. Like they input the information, let's say, even if there isn't a typographical error, they input the information was inputted correctly, then the lens that they're getting is correctly. Are there things that an optician is trained to identify that a salesperson just handing the lens made in the lab might not know? Like I think the example that I heard from the opticians in my community was like the difference between bifocal versus transition lenses. And again, correct me if I'm using the wrong terms, but can you explain what an optician would be doing at
Sure. Well, even something as difficult as verification of the parameters that were ordered when they came from the lab, there's a whole series of standards, the American National Standards Institute Z80, that are encoded in our state statutes because of licensed opticians that they need to meet that some other states don't have. So just literally being able to verify that what was sent correctly, because we have a large percentage that are coming back from the lab, not because they're inputted wrong, but because they're made wrong. And that portion of it, oftentimes they're made correctly, but the education wasn't there for the patient to learn how to use the lenses, or what they were made for, or what distances, what tasks, and what items they're actually using the eyewear for. So, I mean, even if they are made right, if they're not adjusted right, if they're not educated right on the use of it, frankly, for those of you in the room, I just got my very first progressives, and even knowing what it was a little bit of an adventure. They can walk people through on what actually is working, what to avoid, how to make them properly, how to use them properly. And quite frankly, those aspects are all part and parcel of it's just not buying the frame. It's the entire FDA regulated medical device that we have from start to finish, on making sure it's made properly, ordered properly, adjusted properly, educated properly. And there is no just, hey, pick out a frame. That's just not how our industry works.
I appreciate your question. The thing that is sort of like ringing in my ears now is that you've spent time in your clinical practice correcting issues that people have obtained through having poorly fit or purchased lenses that aren't appropriate for their vision, and that if they had seen an licensed optician, they likely would have been caught and they wouldn't have been in your chair for remedy. So I'm grateful for your answers to your questions today. If I missed anything or you don't answer it, I hope you'll email us, because your testimony today has been really illuminating. Thank you very much.
Thank you very much, Representative Foster.
Before I hand it off to Representative Berger-Gervalo, I just do want to comment as well that you used the term medical device, and we have had glasses available to humankind for so long that we tend to treat it as something less than that. In fact, perhaps in the extreme example of what we're talking about here, we're treating them as effectively an accessory, a fashion accessory, as opposed to a medical device. And I think that the distinction that you draw, and I'm just, before Representative Berger-Gervalo goes, I just want to ask you, since you have, as you described, straddled the divide between opticians and optometrists, and you've had experience in other states, could you, our big focus is on making sure we assure patient safety. And you said you had to fix things up, or you found unfortunate situations in other states. Could you just briefly amplify on what you actually saw and what the ramifications were for sloppy efforts in other contexts?
Well, the first and easy one is if things aren't measured properly or ordered properly, now it's a waste of money. And I can tell you, for as many people as came back, I'm sure many people didn't come back after spending a fair amount of money, just saying, oh, that's so our patients need the expectation of competence from their folks and licensure and making sure somebody knows what they're doing are part of that. Some more of the extreme designs, we've actually had opticians who were in the dispensing program or fixing glasses where somebody came in with a problem. It turned out that they were referred to me or other optometrists or other ophthalmologists where somebody was not a blurry vision, but it was a vision loss based on pathology, whether it's diabetes, whether it's retinal tears, whether it was a stroke recently we had. And that optician knew enough about anatomy and physiology to say, this isn't just blurry, I need to refer immediately. And that sooner access to care was part and parcel of taking care of that patient. Even those conversations that someone is having in an optical shop, it's something that seems innocuous could be very serious. Oftentimes, if right now there's something called an accommodative isotrope, where if a young child has a very high hyperopic or farsighted prescription, when we put the glasses on, their eyes straighten, but without them, their eyes, they think they're actually focusing. It turns, if those are actually measured incorrectly, ordered incorrectly, or not verified, if that actually isn't put in the right area, we're going to have a persistent eye turn in the visual development of a child, especially youngsters under kindergarten age. Just like you learn to walk, you learn to talk, you learn to ride a bike, well, you also learn to see. And if that eye is not actually positioned properly, I've had issues where where uncorrected vision in that particular case, or if it were improperly placed, could actually go a long way in stunting the development permanently in the development of the vision of that one eye, causing only one good eye and one reduced vision eye. So again, I could go over content. I can keep going if you'd like, but there's numerous ways where something that sounds innocuous, and like you said, it's a fashion accessory, the way that it was looked at. And again, you can go and buy non-prescription eyeglasses, I suppose, but in the confines of a optical shop whose job is to make sure that the prescription stuff is done properly, and that the doctor's efforts and prescriptions are executed properly, and that, again, there are impact resistant safety standards. If you put a glass lens or a thinner plastic lens as opposed to some of the higher impact resistant lenses like a polycarbonate or Trivex, which I apologize for the terminology, but you could do physical damage if you don't know what you're doing. Certain lens materials are reserved for folks who have vision in one eye, not both. Certain lens materials are reserved for pediatrics or sportswear. So if you're working and you came to my office for a pair of safety eyewear that's OSHA approved, and I don't know what I'm doing, or there's no one there to check with that has that knowledge of those federal standpoints and those federal regulations, whether it's OSHA, whether it's ANSI, these are all things that are very, very important to have somebody who knows what they're doing, even in the selection process and the patient process of speaking to these patients in the initial onset. And even if there's somebody helping, there's always an optician there to run that off and verify. And that's the purpose of having a licensed professional there.
Thank you for that answer. I've kept Representative Berger-Travallo too long. I'll turn it over to her.
I could listen to you talk for hours, Mr. Chair. Carry on. Thank you so much, Dr. Zito. I really appreciate you're breaking this down in a way that I have not understood until your testimony, to be quite frank. And actually, when Representative Foster talks about people have assumptions about I'm people. I've been talking to Jamie trying to figure out with her parental experience within in the field. And I would love if you could just take what you explained based on some of her questions just a tiny little bit farther. I am looking for what I should expect as the law currently stands in the process. If I see, and this is a real world experience for me, but I know it is for a lot of other folks too. I see my ophthalmologist so that I can make sure that I've got the eye health, I've got all of that stuff done. Now, as I've done that, I have had in that office, just this past year, I had the pupillary distance, I hope I'm getting that term correct, measured, because the expectation was I was going to purchase glasses from in that office as I was walking out, because I figured that was probably the best continuity of care. And then I saw the price tag and I freaked out and ended up going to another place that seriously discounts the exact same glasses. In doing that, so I had the pupillary distance measurement. And when I walked into this place, which I will not name, but it is a national group, I walked into there and I did not see, and it is not a place that is exclusively an eyeglass place. I was I showed them that I had that measured already. And so I was given what I assumed was probably just a salesperson. Could have been an optician. Don't know for sure. But I was given then, I handed them the pair of glasses that I liked. They placed the order and didn't try anything on my face except to make sure that the actual glasses fit the side of my head roughly. And then when the order came in, I went to pick it up at the end of the business day, and they grabbed someone from another department who grabbed them for me, put them on, said, shake your head, do they fall off? No, they don't. That's great. Oh, this is your first progressives? We don't know what that means. So I'm assuming I was not given an optician. Is that against the law? Do I need to have an optician see me when I'm buying it at another place entirely?
I would use the analogy, and I can't speak to that particular instance and not knowing how it is. I do know that the law does require currently that there's a licensed professional on the premises for things like questions to verify, to make sure the glasses are right prior to taking the order, but prior to even taking the pupillary distance. For example, oftentimes we require not just that it's made with the distance between your center of an eye, but how about from the center of one eye to the next? How about how high or how low your particular progressives or eyeglasses are made, and making sure those are all correct. In terms of the current statute, again, I'd like to equate it to pharmacy, because we have pharmacy techs who will, I may not see the pharmacist in my entire transaction with them, but the pharmacy tech who's there will be checking with them, will be verifying with them, will be having it signed off on, those types of things. And so oftentimes you may actually have a sales representative that will be conducting a lot of the business, but there's always that one person, that one licensed optician for questions, verification, problem solving. If necessary, I would worry about if they drag somebody from another department, but I can't speak to that. So I'm going to have to defer on that question without knowing the specifics, but there should always be a licensed optician on the premises in order to prevent any confusion and to make sure that all their I's are dotted, all the T's are crossed. And again, while they're there, they're also training those techs, if you will, or the apprentices as part of their training. So depending on how far along they are in their training, versus someone who's brand new for a few weeks, that may also determine how often you see the actual optician or how often they're actually delegating to watching, training, those types of things.
Okay, so if I've got someone who is present but never actually engages with me as the customer / patient, that still falls under?
I would say that as long as the person was there for answering questions, and quite honestly, all our opticians in my corporates, I've worked at corporate, I've worked at private, I've owned my own stops, and oftentimes most things are nothing's ordered, nothing's dispensed, nothing is taken care of until someone has a once over, and if there are any issues, they catch them before. And oftentimes there are people who haven't stepped foot there, and over the minute for a few weeks, you would have almost your entire interaction be with the opticians. I would argue that if somebody had been 4 years into their apprenticeship, you may get a little bit more hands-off, again, like a pharmacy tech, because the pharmacist does not do everything in the pharmacy. That's why you have techs. That's why you have apprentices. So there are things that can be delegated as long as they're on the premises and can sign off, double check, verify before anything makes it out to the patient.
Okay, terrific. I really appreciate you clarifying.
Thank you so much.
And all of your time. It's been very, very helpful.
I really appreciate it.
Thank you again, Doctor, for your testimony and answering our questions today. You did help us have a clearer picture of what we're talking about. We appreciate it. Seeing no further questions, well, thank you. And we will move on next to Michelle Clement, followed by Kevin Brophy.
Can you hear me?
Yes, we can. Okay. Can't see you, but we can hear you.
You can't, let's see. Allow. Can you see me now?
Yes,
yep.
We can.
Hi, good afternoon, everyone. I'm going to try not to be redundant in my testimony, as Donna and Dr. Aceto have been really informative to the committee. But there are a few things that I did want to point out, and I'm going to try and be as quick as possible. I feel like, so the bill as it's written will actually enable these companies to sell eyeglasses, kindred products, other instruments to aid vision, and plano contact lenses. Everything in subsection A, not just the frames, which the frames themselves do pose another threat to the public. Some people have allergies to the metals or the plastics that the frames are made of. Someone who's not trained will not know that. However, when you purchase glasses, it is not just the frames. The eyeglasses are comprised of the frame and the lenses, and one part does affect the other. If you want, I can go further into that after. All of this is circumventing the real issue that these companies are having, which is the shortage of opticians. So I ask you, would you consider this option that you're making for opticians, would you consider it as an option for your physician shortage that you're discussing with 449? The shortage of opticians is not because the exam is too hard. I passed my exam the first time. Many people have to sit for it multiple times, but I feel like it kind of stems from the education process. A formal education from the college has information included in it that you don't really need, and in the field training doesn't have enough that you need. The state has also paused the exams and is yet to restart them. So I feel like that is another issue. They need to restart the exam process so that we can get more opticians out there and alleviate part of this stress on the industry. When you're purchasing glasses, also part of the cost of the glasses is for the knowledge and the experience of the optician that is fitting them and the company you are purchasing from. So if you're getting sticker shock on the glasses, well, another thing to consider, like, oh, I'm going to get these glasses here, but they're probably going to be made right and they're going to be useful to me. A patient once told me that it's expensive to be cheap. You end up spending the same money twice and you end up spending the original cost in addition to what you saved. As written, the current subsection B is too broad. It'll be very difficult and costly for the state to enforce. Large corporations with money, like the companies proposing this bill, will fight the fines and the cost the state more money in litigation fees than the actual fines would have generated. To second Donna's point on how it says a period of time deemed necessary, it really needs to be defined. There's nobody saying whether it's 1 day or 90 days. If the bill stays as written, it should be clearly defined.
Excuse me, Ms. Clemens, I hate to interrupt, but your time is almost up. If you please summarize. Thank you.
Yep, no problem. So I am actually a business owner of an optical in the state of Connecticut, in addition to a licensed optician. I apprenticed in the field for many years before I actually sat for my license. So I understand the struggles that they're going through, but I assure you this is not the resolution. In my written statement, I did suggest edits to the bill that would make more of a compromise between the two, but I just want to be clear that I do strongly oppose it. I also would like you to consider what it really means to sell a pair of eyeglasses and to dispense them. It can create something called PRISM, which is created accidentally when you use the improper measurements. It leads to headache, fatigue, ocular muscle issues like diplopia or double vision. And it's difficult to make someone understand how someone sees, because you can't just put on someone else's eyeglasses and see what they see. You can't feel what they feel. I mean, and what's going to happen to a child who wears glasses, who's prescribed glasses, and someone who doesn't know what they're doing makes those glasses, and well, that child may be an infant, maybe they can't talk, maybe they can't tell you that they don't feel right. Maybe they can't tell you that the prescription is too strong or they can't see. Now that child has a lifetime of issues because the state decided that an optician didn't need to be present to check those glasses. Thank you.
Thank you. You made mention of this bill enabling everything in the standard category, including contact lenses. Do you sell contact lenses at your shop?
We do.
Do you have any concerns about opening up the sale of contact lenses in this way as well?
Oh, absolutely. Contact lenses are something that's in your eye. People are, I see things on TikTok all the time. They have life hacks where they tell you, oh, if your contact's bothering you, take it out of your eye, stick it in your mouth, and then put it back. So much bacteria. I mean, and on the other end, if someone comes in with a red eye, is the person that's there going to know the correct questions to ask them to come to the right conclusion? Someone who's got a red eye, I mean, they could have slept in their contacts and ripped a piece of their cornea off when they took it out in the morning. They might mistake it just for pink eye. It could be a herpetic infection in your eye. If you put your contact lens over it, it's going to exacerbate the issue. There's many things that can go wrong with contacts, even more than glasses. That poses a serious health concern to the public.
Thank you for that. You know, this committee in the past has had some interesting conversations about the sale of contact lenses. We haven't talked about it as much today. We've kind of focused on the framing business, but thank you for your testimony. It's been very helpful.
No problem.
I don't see any further questions. We will move on next to Kevin Brophy, followed by Jenny Rivard.
Good afternoon. My name is Kevin Brophy. I'm the managing attorney of the Elder Law Unit of Connecticut Legal Services. We're one of the legal aid organizations. I'm testifying in opposition to SB 453 as currently written. That's the Department of Public Health's recommendations regarding transfer and discharge of residential care home residents. I submitted written testimony and proposed substitute language to improve the bill and strengthen protections for RCH residents. The Department of Public Health and the Department of Social Services established a housing work group. I chaired that housing work group for 2 years. Unfortunately, we were unable to reach consensus. To be a home in a community-based setting, the Center for Medicaid and Medicare Services must determine that residents of RCHs have comparable protections to tenants under the state landlord-tenant law. In my legal opinion, the protections for RCH residents in SB 453 do not meet that comparability requirement. I'd like to make 3 key points. The first point is RCH residents have the least protection as to possession of their home than any other group. For many RCH residents, this has been their home for several years. Tenants in private and subsidized elderly disabled housing have more protections. In order to evict them, the owner must go through a court process. Residents of assisted living facilities have more protections. The owners must go through a court process. Residents of nursing homes have much stronger protections, even though discharge from a nursing home is an administrative process rather than a court process. My second point is legal services proposes several modest revisions. Strengthen the discharge notice, including specifying the location where the resident's going to be discharged. Another point, SB 453 requires a discharge plan, but SB 453 should provide more detailed requirements for the discharge plan, such as requiring the discharge plan to show how it is going to minimize the negative impact on the resident of the discharge. Lengthen the timeframes to appeal, hold hearings, and find alternative housing if there's an adverse hearing for the resident. Ironically, by having such short timeframes in SB 453, RCH and residents will be less likely to resolve disputes, and it could lead to more appeals. Clearly state that the RCH has the burden to prove that it has complied with all the requirements of the discharge statute. My third point is, if CMS approves, all residents of RCHs, including physically and mentally disabled residents, will be eligible for home care services. Currently, only elder clients receive these services. Please reject SB 453 as currently drafted. With our modest recommended revisions, it would strengthen current protections for residents, more likely pass the comparability requirements of CMS, bring in more supports for residents of RCHs and more dollars for RCHs. And before I conclude, Representative Pettit had asked a question about the appeal process earlier, and I just wanted to clarify that. So when there is a hearing from a discharge and there's an adverse decision by the Department of Public Health, the Administrative Procedure Act lays out the appeal process for going to the Superior Court. Thank you for your attention and concern and interest in this bill. Thank you.
Thank you, Mr. Brophy, and thank you for giving us some very constructive suggestions we'll look at very carefully and discuss further with DPH. Early in your remarks, you made reference to an attempt to achieve consensus, but that didn't happen. Could you explain who were the parties to that and why did it fall apart?
Okay. So the Department of Public Health and Department of Social Services, this was several years ago, got all the critical stakeholders together, including representatives of the for-profit RCHs and the not-for-profit RCHs, the long-term care ombudsman. I was representing legal services, and then also some representative from the Department of Social Services. So we met for 2 years, the work group, on a regular basis. We probably met, I'm guesstimating, maybe 10 times. And there was a good faith effort, both by all the stakeholders, including industry representatives. But this was the most difficult issue around this comparability requirement. And we just, unfortunately, we just couldn't come to a consensus.
Thank you. It sounds like we have work to do. I don't think the average person recognizes that RCHs really have fewer protections to the degree that you described. So it's something we'll look at very carefully. I don't see any further questions. So thank you for your testimony.
Thank you so much for your interest.
Thank you. Next up is Jenny Rivard, followed by Margaret Watt.
Good afternoon, members of the Public Health Committee. Thank you for letting me speak in opposition of Senate Bill 329. My name is Jenny Rivard. I've been a licensed optician for 45 years, taught optics on the college level for 27 years, and currently am on the Board of Examiners for Opticians. Today, I'm speaking to you as a member of the Board of Opticians. At our last meeting, the Board of Examiners went on record as being firmly opposed to the passage of Senate Bill 329. The board doesn't feel that there's any part of this bill that protects the health and safety of the public and consumers. In fact, we feel it may accomplish just the opposite. Our public member even agreed wholeheartedly. This amendment to our current statutes, introduced by Warby Parker, removes the need for a licensed optician on the premises during some business hours. The amendment states that this would be for limited times, but the board feels that this is unacceptable. When a consumer enters an optical shop, there's a presumption of competence. If there's not a licensed optician on the premises, there's actually no competence or very little competence. It'd be very similar to entering a pharmacy and asking someone other than the pharmacist for advice. We do realize that there's a shortage of opticians, as well as a shortage of all healthcare workers and workers across the state. And since the spring of 2020, the board has granted 59 new licensed opticians. Reducing the need for a licensed optician on the premises doesn't address any of the shortages. It only increases the opportunity for poor care for the consumer. One aspect that Dr. Aceto touched on was the cost. Any of you that wear eyeglasses know glasses can be expensive. Eyeglasses can be expensive. If you're ordering them from a kiosk in a store, who do you bring them back to if you have a problem? Who does the troubleshooting if there's a problem? Certainly not the people that are just manning the kiosk. The average consumer, if they're having a problem with their eyeglasses, tend to just put them in a bureau drawer and forget about it. And people work hard for their money. They really deserve to have the very best product possible. Board of Examiners for Opticians urges you to reject the passage of Senate Bill 329. There's really nothing in the amendment that protects or maintains the public safety and care. Thank you.
Thank you. Playing devil's advocate for a moment.
Okay.
These stores exist in a number of other states. You would think that if there were such bad outcomes, they would be in real legal trouble. How come they're still in business?
I honestly don't know. I've seen some online eyewear that's just been terrible. I've seen some that's been really darn good. I can only speak for Connecticut, and we have a very high standard for optical goods and a high standard for our consumers. Sometimes, as I said, sometimes they're very good and sometimes they're just horrendous. So yeah, they're in business, but at what cost? At what cost to the consumer?
I guess that's really what we're wrestling with right now, which is we have to recognize changes in the marketplace that meet certain needs, but this committee's primary responsibility is, safety, quality access, and safety are our priorities. So thank you for that. I don't see any further questions, so thank you. Next up is Margaret Watt, followed by John Hudak.
Good afternoon, Rep. Steinberg, Senator Abrams, and committee members. I'm here today in two capacities to talk about some of the mental health bills that are before you. First, I'm here as the board policy chair of the Connecticut chapter of the National Alliance on Mental Illness, NAMI Connecticut. And I'd like to start by thanking you for so much attention to mental health this session. It's really wonderful to see. NAMI Connecticut strongly supports SB 375 to extend telehealth, and we hope that that'll be made permanent past 2024 with equal reimbursement for services provided in homes and offices. We also support HB 5480, which would use doctoral students to extend the workforce. As you know, that's very needed. We have comments on two of the other bills. SB 448 would provide mental health and substance services in the correctional system. We do support that. Would ask that you include language prohibiting any solitary confinement because that creates or exacerbates mental illness. There's a section on inmates' exit interviews. This is also in my written testimony, by the way. Please consider changing the language in there, which talks about the exit interview having a discussion regarding any continued medical care. Make it an actual discharge planning conversation, not just a discussion, and to ensure connection not just to medical, but mental health care as needed. And please also consider including peer support services as part of the services available to inmates in the correctional system. In terms of SB 451, which would create a working group, we would just ask that you add family members of children or adolescents with mental illness as one of the critical stakeholder groups. And I also noted that State Department of Ed did not appear to be included, and that seems like a big stakeholder group to me. Finally, from NAMI, we are concerned about Section 6 of HB 5485, which is a section that would expand the list of clinicians who could administer an emergency certificate to send someone to the hospital in a mental health crisis. What generally happens at that point is they wait a long time and often get sent home with no services. We really don't think it's necessary to expand the list of people who can send someone involuntarily to the hospital, but rather we should be addressing the need for safe and supportive alternatives for people in crisis, such as respite programs, which could include peer-run respites, which do exist in our neighboring states. That's something that's come up in other hearings. Really, this might be the time to strike while the iron is hot and start bringing in alternatives into our system that we don't have presently. I said I'm here in two capacities. I'm also here as prevention director at a nonprofit behavioral health agency, where just last year we conducted youth surveys in 3 communities in order to have current local data. So I want to comment on SB 454 about, which is about the need for data, and I highly support that. It's a bill
Excuse me, Ms. Watt, your time is almost up. If you please summarize. Thank you.
So again, you can refer to my written comments, but basically I'm proposing you consider an alternative to the youth survey, to mandating that schools participate in the youth survey. There are many reasons why they don't always want to in DPH's survey, but I think Connecticut should really be moving towards having a statewide, like, robust survey to avoid the inequities that we have where some communities have data, others don't. Local towns can't use the state data because it's just a sample. And we spend a lot of time and energy with small local prevention councils with little money and a lot of volunteers trying to scrounge around for data, whereas other states just literally commit to this. Thank you.
Thank you, Margaret. Yeah, I think we're all a little frustrated with the fact that there seems to be resistance in some quarters for collecting quality data that can be so useful in identifying opportunities to address problem populations that are not being adequately served. I'd like to think that sooner or later we're going to get there. It seems like we're tending towards later. Getting back to your comments, obviously this session, and as you alluded to, in other hearings, other bills, there have been lots of discussions about how best for us to spend what is I guess you could call a one-time largesse that the state has provided us. I think we risk being like the characters and the producers, where we sell interest in the show so many times over that it becomes a scam. We don't want to go there. We want to spend our money wisely, and we recognize we can't take care of every last shortcoming in the healthcare system. But if you can point us in the direction of specific programs that we might consider scaling up in the context of support services, respite, you name it, now is the time for us to understand what the opportunities are, because we're going to be on the brink very shortly of making some very hard choices where we know we will disappoint some. So thank you for speaking up for those who would really benefit from those kinds of programs. And we look to you and others to get us good information to make informed decisions.
Thank you. Yeah, well, I think really we don't have a level of care such as peer run respite, and that is something that other states, 14 to 18 other states, have invested in. And this state has been talking about it forever. And, if not now, when then? We've got a mental health crisis. We don't have enough workforce to treat them. There's this alternative model of care that is proven effective for adults in other states. It's less traumatizing, it's cost efficient, it's shown to be effective. Why can't we invest in that now? But that's on the crisis side of things, because Jonathan, as you know, on the far other end of the continuum, what about prevention? What about promotion? And this state does not invest in it. Just that example of the survey data collection. If you look at DPH's testimony, we only collect data if CDC funds it, right? Our local communities only collect data if they've got like a federal grant. The prevention, substance use prevention, mental health promotion, all the things that you've seen in discussions such as about the regional behavioral health action organizations, the catchment area councils, the state is not committing to funding any of these entities. As underfunded as they are, we're only funding them with federal money. So if we really are serious about preventing problems before they start, we also have to put some fundamental money into staffing and supporting agencies at local and regional levels that can truly work on primary prevention of mental health and substance.
Well, Margaret, I was wondering when you were going to get to the regional behavioral health action organizations. As you know, I concur with you that depending on federal funding, which could be fickle, is not a way to support these important organizations who we have tasked with a significant role in prevention and oversight of other programs. I think we have fallen well short on this score. I'm appreciative of the fact that we're codifying them, getting in the statute in the appropriate manner, making those changes, and that significant efforts have been made to secure federal funding. But I think to your point, if we're talking about really addressing problems that we may only have once in a generation opportunity to address, we really ought to look at making sure they have adequate support as well.
If I can add one more comment, I put this in my testimony on the RBHAO bill last week, but the RBHAOs and that whole system were created 45 years ago when there was an effort to create a vision and a strategic plan for mental health in the state of Connecticut. And I think everything that everyone's doing this session is like a piecemeal approach, right? We're in a crisis and everyone's trying to figure out where to put the money. And what we really need is to take the time, take a step back, starting next session, put together a new vision that's for the 21st century and a 10-year strategic plan, because mental health in this state is under DCF, DDS, DSS, DMIS, the private sector, hospitals, everywhere, federally funded, not locally funded, et cetera. And we're not going to be able to make the best choices if we don't have a guiding vision and a real strategic plan that covers all of that.
Thank you. I might concur with your vision. I don't know if it matches up with the harsh realities of what we're facing. The federal dollars won't be there forever. What you're talking about is revolutionary, even if necessary, and are not going to happen in the effective timetable that we have to make some of these choices.
Right.
I hate to say that you're just going to have to be satisfied with us making some questionable choices. So what I'm going to say instead is that we depend on dedicated people across the state who have a pretty good idea of what's working and will help us make good choices. And it's important. This is the moment that you can get us that critical information so we make as few errors or inefficiencies as possible. But I don't think we can afford to wait to get a comprehensive solution. Those dollars will be spent elsewhere if we don't find a way to use them now. All right. Thank you for that. We'll move next to John Hudak, followed by Seth Lauderman.
Thanks, and good afternoon. I'm John Hudak, Environmental Planning Manager for the South Central Connecticut Regional Water Authority. I'm also a member of the Connecticut Water Planning Council Advisory Group, and I'm here to testify in support of Senate Bill 248, an act concerning the Connecticut drinking water supply. We also support the recommended revisions to the bill, submitted in testimony from Save the Sound and the Connecticut Council of Soil and Water Conservation. The Regional Water Authority is a public drinking water provider to the greater New Haven area. We own about 27,000 acres of land, most of which is maintained as forests for the protection of our reservoirs and groundwater sources. Forests are by far the most beneficial land cover for protecting drinking water source quality. While we're a supporter of clean energy initiatives, including our own 1 megawatt array in Hamden, there are inherent conflicts in the Connecticut Siting Council's criteria for reviewing and approving solar array projects versus protecting Connecticut's sources of drinking water. In 2020, we learned through the media of a petition through the before the Siting Council to construct a solar array in Hamden on the watershed of our Lake Whitney Public Water Supply Reservoir. This project would have clear-cut 12 acres of forest on steeply sloped land containing sensitive wetlands. The petition did not identify the site as being within a public water supply watershed. Furthermore, there are no requirements in the Siting Council's process to do so. So it's thus entirely possible for potential impacts to drinking water sources from solar projects to go unreviewed and unaddressed by both the Department of Public Health and the affected water company. For this project, we filed as an intervener. We delivered testimony on why this project would pose an unacceptable risk to our water supply. And even with that, the petition was denied by only one vote. What this bill would do would require this Department of Public Health, in consultation with the affected water company, to rule if a petition before the Siting Council for a solar project within a public water supply watershed or aquifer would have a significant impact upon the public drinking water supply. And I'll add that adoption of this bill will help to ensure that Connecticut's clean energy goals do not conflict with the goal of our first state water plan to manage or maintain highest quality drinking water. Lastly, I'd like to also support sections 2 and 3 of the bill, which would allow water companies to receive electronic notifications concerning local land use development applications within public water supply watersheds and aquifers. This is just a sensible amendment, given the advances in electronic communication since the original water company notification laws were passed. And with that, thank you for the opportunity to share our support for this bill.
Thank you. As somebody who's been in this business for a while, I'm sure you're intrigued and concerned at the same time about the use of this precious land for solar. We've seen other states be fairly aggressive in promoting fairly large scale solar projects within reservoirs and watersheds. Do you think we have adequately protected these important parts of our state while we continue to encourage the adoption of solar?
I think there's a significant gap here where we're forgetting that forests are also responsible for helping mitigate climate change, as well as to providing a lot of other ecological and environmental benefits. To think that you can actually propose a solar project that would clear cut a forest and along any sensitive water course is just doesn't seem right to me. And I think we can look to other, creating incentives for making it easier to use other areas that are already developed, or rooftops or parking lots. I think that's the direction we need to move, but we can't be building solar projects at the expense of our public water supplies.
Yeah, I'm a big fan of solar, but I agree with you. We've already seen some pushback here in the state of Connecticut when clear cutting became a possibility of one project. Are you familiar at all with the floating solar projects that are actually on the surface of the reservoirs that don't require any clearing of trees?
There are none that I know of in Connecticut. There are a few in other states that have been, but not too many. It's something I think in the future would be worthwhile to look at. But obviously the stakeholders, the environmental stakeholders, the Department of Public Health would want to study this very closely.
Thank you for that. I'm intrigued by that as well, because in theory that does not necessarily interfere with the ecosystem, but I'm not 100% confident about that. Seeing no further questions, thank you for your testimony. We really appreciate it.
Thank you.
Next up, we have Patrick Kearney, and I'll figure out who's after Patrick.
Good afternoon. My name is Patrick Kearney. I'm the Water and Sewer Administrator for the town of Manchester. Our goal in the water industry is to protect our customers by providing high quality water. However, I'm opposed to House Bill 5482 as written. The bill doesn't seem to fulfill its title to mitigate Legionella, while it places an undue burden on water systems that serve over 1,000 people or chlorinate their water. I count at least 10 hospitals or nursing homes in Manchester, and to do all of the sampling required in one day is unrealistic. It may also be unnecessary to do this with all of daily monitoring.
Hey, can I get a small coffee, just cream?
Sorry.
Please continue. Sorry about that. Unless anybody else wanted coffee. Okay, go ahead.
Also, maintaining chlorine residual at our farthest reaches of our system isn't as easy as just turning up the chlorine residual at our treatment plants. Never mind what can happen with disinfection of byproducts. I'm willing to work with DPH to provide a practical solution to this issue. Thank you. I've also provided written testimony, which has a lot of questions that probably need to be answered at some point. Thank you.
Thank you. Obviously, you can see what we're trying to accomplish here. We are concerned with larger density facilities which are at the end of the line, which may have particularly older buildings that might have a propensity to start having problems with those kind of contaminations. If it's not as simple as you state to remedy that situation, what are you proposing?
Well, right now, and there's EPA basically says, as you heard earlier, the surface water treatment rule takes care of Legionella. But the problem being, if you wanted to move up to a residual chlorine throughout the system, you really have to do a study. You actually have to look at your system, see how you can do it, see what disinfection byproducts are happening within your system. This all takes time in order to do it. I'm not sure if you're familiar with Manchester at all, but most of our sources are in the southern portion of Manchester, and we provide all the way to the northern portion to the South Windsor line. There's a nursing home right at the South Windsor line. We can sometimes maintain a 0.1 chlorine residual there, but not necessarily all the time. But we also have a sampling point that's fairly close to it, and we know what's going on there constantly. So is that good enough? I don't know. What are the ramifications if we don't have that? What protection does the water system actually have? Because in essence, what happens is these large facilities where the water warms up is a breeding ground for Legionella, as you probably know. And they're not actually looking at containment for inside those buildings. So if there was a problem, and we had a problem with our distribution system, the water from that building could actually come into our distribution system and contaminate another area. So there's a lot of things. It's just not a real simple fix practically. By just saying move up the chlorine residual, you're not necessarily killing the Legionella. It's more of a, we're looking good to do this. It's not necessarily killing, because I had an instance at the hospital here where we maintained a 0.3 to 0.5 parts per million, and they found in their routine sampling and monitoring Legionella within their facility. They had subsequently flushed and did what they needed to do, but still we had the chlorine residual that the proposed law has. So it's quite a bit of different things and a lot of working with building owners completely. Sorry for being long.
No. I think we're getting to the crux of the issue here. The focus of the bill primarily was that of assuring that we know what's happening, that we do testing in a way in which we can assure the safety of those residents and other dense facilities. I think we all take your point that the solution may not be as simple as simply adding chlorine at the main plant, but really the focus is on making sure we know what the problem is. So I think certainly DPH would appreciate your input on how best to enforce the law should there be a problem. But do you dispute the need to have timely knowledge, which can only be accomplished really through testing?
Well, I mean, every system is different. Every system requires different testing. We do 60 samples within our distribution system a month. Every month we have to do at least 60 samples for basically the parameters that we're talking about. Those sites were approved by DPH. We had to submit these. They were at the farthest reaches of our system. They're at different points within the system. And that's what we monitor our system is. So if we have, say, 10 places, so we're adding another 10 every quarter, it would probably be better to modify our sampling locations in that 60 that we normally do, so that we have a few more that are hitting some of these spots in order to monitor them better, instead of saying, for instance, and I'm not sure if these fit, within my neighborhood, on one street, I have a group home. On the next street, I have a group home. Do I have to monitor both of them because they fit under their nursing home scenario? I'm not sure. Those are not even the 10 that I counted. I counted large facilities. These are more like homes. So I think what they're trying to do, monitor, make sure there's chlorine residual, is probably good. The method in this law, I do not think hits what they want to do. That's why I'm willing to work with them and sit out. And I'm sure there's other people within the industry that can work with them and try to come up with something that would fit everybody's need.
Well, thank you for that. And I think that we're onto a good thing here. It's a matter of your ability to reapply for an adjusted testing site list that might allow you to be flexible if you're taking care of these facilities. Something nearby might not need to be tested as well. Sounds like a path to a solution. So we'll read your testimony with interest and discuss it when we talk to DPH. Seeing no further questions, thank you. We appreciate your testimony.
Thank you.
Next up is Dr. Seth Lauderman. Sorry, I got out of order for a moment there. I appreciate your flexibility. Followed by Craig Patla. Doctor, thank you for joining us.
Thank you for having me. My name is Seth Lauderman. I am the current president of the Connecticut College of Emergency Physicians, and I am here with a testimony on a couple of bills that Dr. Dan Fries, who's one of our past presidents, has also submitted a written testimony on. The first is SB 449, an act concerning the recruitment and retention of physicians in the state. Connecticut College of Emergency Physicians is supportive of this act. Both myself and Dr. Fries work in Hartford, and we work with residents in emergency medicine at the University of Connecticut Emergency Medicine Residency Program, and we assist them in getting jobs after graduation. And we certainly would love to see many of them stay in our state. We are certainly supportive of loan forgiveness and revisiting malpractice environment for helping keep people stay in the state. The second bill that we would like to talk about is House Bill 5485, an act concerning various revisions to the public health statutes. We have a couple of concerns in this bill that are in section 11. There's written testimony that you can refer to for further details. But first is in subsection D2, talking about corresponding Medicare facility fee reimbursement rate for services. We are concerned about this and recommend that this is deleted. The concern is that there's the reimbursement rate for many hospitals with Medicare is roughly neutral, and so we think this would be kind of similar to, having a rental car company give their corporate rates along with their listed rates. Another section that we are concerned about was in subsection F2 of section 11, which talks about for financial information be provided for emergency patients as soon as they're stabilized. And one of the concerns we had about this with EMTALA, like we often determine a patient stabilized right about the same time they're being discharged. And if the expectation is to have this information be given to the patient before they leave the building, it's going to be very difficult in our workflows to accomplish this. And we're not sure if this is something that's really necessarily feasible. And we think there should be a exemption for emergency medicine, kind of this EMTALA function. And similarly for subsection H of section 11, there's a discussion about displaying public display for information regarding facility fees and financial consequences of these fees. And we also think there should be a carve out for emergency medicine departments due to the way the federal EMTALA law is written, that this could be perceived as illegal or kind of influencing patients' decision to seek care. Thank you for your time.
Thank you for your testimony. I think we're going to have to take a good look at section 11 is the way you describe it. There are a lot of elements there that we need to make sure we get right. So we'll take a close look at your testimony. Seeing no comments or questions, we appreciate it. Thank you for directing us to see if we can make some quick fixes. Next up is Craig Patla, followed by Tracy Wodash.
Thank you, and good afternoon, Representative Steinberg and members of the Public Health Committee. My name is Craig Patla. I'm Vice President of Service Delivery with Connecticut Water Company. I'm also a board member with the Connecticut Water Works Association. I'm appearing before the committee to speak on House Bill 5482 regarding the Department of Public Health's recommendations regarding Legionella. We in the water industry are keenly aware of the issues related to Legionella, and especially those issues affecting the most vulnerable of populations, those in nursing homes and healthcare facilities. We do see ourselves as key partners in addressing Legionella in these facilities located on our systems, but do have concerns with some of the key tenets identified in the bill as potentially having unintended consequences. For facilities such as these, the necessity of a water management plan stands primary in the fight against Legionella. That plan must consider the water quality parameters and most notably free chlorine levels of the water entering those facilities as just one of the critical variables informing the overall plan. Requiring the public water suppliers to maintain a minimum free chlorine residual of 0.1 parts per million is difficult, as chlorine residual will dissipate over time and will most certainly decay to below 0.1 parts per million as required, and especially within facilities with high detention times. As a result, requiring the minimum suggested will require the elevation of chlorine treatment, and as a consequence, runs the very real risk of elevating disinfection byproducts which are carcinogens themselves that will affect not just those in health facilities, but also all consumers on the distribution system itself. We have a common mission of preserving and promoting public health. And with that common ground, we do feel there is a way for us to be a key contributor to developing a plan to mitigate the potential of Legionella, and stand ready to work with all stakeholders, Department of Health, this committee, whether at the facility level or at the policy level, to get on this issue and address Legionella. Thank you, and I'll take any questions.
Thank you. Once again, we take your point that it may be complicated to achieve our objective via simply adding chlorine at the main facility. Do you have an alternative solution? We hear that each circumstance is a little different, but is there a way to accomplish our ends through other means?
Well, there are so many variables that affect each individual distribution system that it's hard to make a blanket statement with each, which is why I really wanted to put the focus on the work, the plans within the water management plans within the facilities themselves, because they really need to take into consideration just what that chlorine residual is at their facility to formulate an appropriate plan at the facility level. We, of course, would be a willing participant in the development of any of those plans and have done so. An alternative to chlorine disinfection, there are alternatives. They do not necessarily provide the lasting disinfection that we are looking for within our distribution systems. But there are as well organic issues within our surface, specifically our surface water supplies, that are causing disinfection byproduct issues when in contact with chlorine. So it is a fine line that we do walk across the state, and those of us with surface water supplies, we keep a keen eye on that on a daily basis to make sure that we're not putting too much chlorine in, so that we would not run the risk of elevating our disinfection byproducts, but as well understand the language within the bill itself. I think there is an ability to work with the department to come up with a plan that helps to best address both the interests and affect what we commonly want to here with the mitigation of Legionella.
Well, thank you for that, and we'll take you up on your invitation to work with the agency, something we'd like to get done this session. So your input would be very much appreciated.
Appreciate that. Thank you.
Seeing no further questions or comments, we'll move on to Tracy Wodach, followed by Khurram Guman.
Thank you. Senator Anwar, Representative Steinberg, and distinguished members of the Public Health Committee. My name is Tracy Wodach, President and CEO of the Connecticut Association for Healthcare at Home. I'm also an RN with nearly 40 years experience in home health, hospice, long-term, and acute care. The Connecticut Association for Healthcare at Home is a united voice for our licensed home health and hospice agencies, as well as several non-medical homemaker companion agencies. Together, our members provide services that foster cost-effective home care for Connecticut's residents in the setting they prefer most, their own homes. I'd like to testify today on House Bills 5481 and 5485. While we support the concept of HB 5481, an act concerning the public health recommendations regarding change of ownership in healthcare facilities to restrict the ownership of healthcare facilities by unscrupulous people, we are concerned about the breadth of the requirements and the strict decision-making that does not provide the Commissioner of Public Health with an appropriate level of discretion to do an independent evaluation rather than a blanket denial. It is essential that we all work together to develop a system that allows DPH the necessary information to make an informed decision, but also balances that with a need to develop a process that will not put unnecessary hurdles in the way of appropriate ownership of healthcare facilities. In Connecticut, we have seen multiple chows within our home health and hospice agencies due to economies of scale. To slow down that process puts significant undue strain on both parties. Regarding HB 5485, an act concerning various revisions to the public health statutes, We oppose the proposed change to the definition of assisted living services agency in Section 7, which adds those in need of supportive end-of-life care to the current chronic and stable definition. This change impacts just one ALSA in the state of Connecticut, the Fairfield County House. We recognize Fairfield County House as a good end-of-life option and model in Connecticut. They require a DPH license that's currently as an ALSA, but that's the closest fit. It's not a perfect fit. They also contract with multiple hospice providers in the area that coordinate with them to provide expert hospice services. They are not licensed as a hospice provider, and I don't believe they have any intent to do so. They plan to continue to utilize our providers through contract. Rather than change the definition of an ALSA for just one provider, we encourage Fairfield County House to apply for a waiver that requests an amendment to their particular ALSA definition. If their model with a waiver proves to be a solid model, then perhaps DPH can consider a future amendment, or perhaps a better idea, DPH can develop regulations that better suit this model while ensuring hospice providers are still used under contract or via the facility's own license as a hospice. Thank you for considering our association's testimony.
Thank you, Tracy. Staying with the Fairfield House for a moment. What's the real difference between the concept of a waiver and the carve out that we're describing? But what's the impact?
Well, I think the impact right now is that this is a very unique model in Connecticut, and it's very creative. It comes from another state. When they first came up with their plan, they really weren't sure that they needed to get licensed until they realized they were providing both an RN and a CNA model, which requires some level of license in the state of Connecticut. So we worked with them initially, and the only licensure option that worked was assisted living. So that's what they opted for. But that assisted living definition says chronic and stable. I encourage them from the get-go, because they're, again, a unique model, to just apply for a waiver. We have many of them within our home health and hospice providers, because our regulations are so old, written in 1979, that we've had the need of our providers to apply. And it's a pretty simple process. You cite the regulation, the section, what you want to waive and why, and you put a plan together for DPH to consider how you're going to accommodate that level of service. DPH has regular waiver consideration meetings, and as long as it meets the need, they'll approve it.
So you're saying it's fairly straightforward and it shouldn't take a lot of time. If you could do me the favor, directing me to the information that talks about what that waiver process is, I think that would be great as we consider how best to move forward.
Yeah, I would need to get it specifically from DPH. We have a template that we use within our with our own provider level, but I would think it would be a similar process.
Thank you. And just going back to one of your earlier comments, you talked about the problem of a summary denial from DPH versus what you described as an evaluation. What would that evaluation accomplish short of the up or down vote that DPH currently has now?
You're talking about the chows, the change of ownerships. Yeah. I truly, we're working together with CHA and Leading Age and CAF on this. We have seen a significant number of changes in ownership in home health and hospice. And I suppose it's, for us, it's really, it is a yes or no, but they do evaluate everything that we submit when we have to go through the process. You know, a couple of things within there, and I know CHA will probably address a lot of the details when they speak later, but a couple of the details that are in there are looking to pending complaints. We don't even know many times if we have a complaint before us until DPH walks in the door and says, oh, there's a complaint that we need to investigate. So we may not be able to divulge any of that out of no knowledge of it. And the other piece is the FOI, or disclosure of the actual written agreement. That shouldn't be anything that DPH needs to see. We agree that there's certain areas that DPH should be reviewing as part of the process, but the actual written agreement between the two is a legal agreement, not I don't think a DPH consideration.
Well, it's hard to tell these days, some of the relationships that have been driven, but thank you. We'll look at your testimony carefully.
Yeah, one other thing, if it's okay, Coco Selman, our chair of government relations, just went through a change of ownership, and she just submitted testimony today, so she might have some good details for you to review on that.
Thank you for that. We really appreciate it.
Sure. Thank you.
Seeing no further questions, we'll see you around, Tracy. Next up is Dr. Guman, followed by Christina Glade. Doctor?
Thank you. Representative Steinberg, Senator Anwar, Senator Kushner, Representative Gilchrist, Representative Pettit, and distinguished members of the Public Health Committee. My name is Horam Guman. I'm one of the family physicians in East Granby, and I'm testifying on behalf of physicians and physicians in training of the Connecticut State Medical Society. I want to thank you for this opportunity to provide testimony to you on Senate Bill 449, an act concerning the recruitment and retention of physicians in the state of Connecticut. As Dr. Bob Russo mentioned earlier in his testimony, the Connecticut ranks among the bottom of all states, 47th to be exact, in the rank order list for retaining residents and fellows that we train here in Connecticut. Connecticut has some of the top physician training programs in the country, and yet the numbers show how much our state struggles to retain those physicians. I'm a family medicine clerkship director at Frank H. Netter MD School of Medicine at Quinnipiac University, and I hear the same story from our medical students I work with. They want to stay here to practice in Connecticut, but the high cost of living combined with the lack of loan forgiveness and other factors make it almost impossible for them. It is not uncommon for residents to have upwards of $500,000 worth of debt by the time they finish the residency training. The loan forgiveness program in this bill would be a good step in the right direction and helping to not only retain the physicians that we train here, but also recruit new physicians in Connecticut. In addition to the lack of the loan forgiveness programs, Connecticut also struggles to attract and retain physicians due to other reasons, and some of those reasons may include highly concentrated insurance market, which prevents physicians from fair and equitable negotiation with insurers. The certificate of need, while most other states continue to remove those burdens of certificate of need, but Connecticut continues to have very stringent law needs in the country. Industry-specific taxes on ambulatory services and overall licensing costs may also impact this retention. Medical liability climate in Connecticut continues to have some of the highest judgments in the country. In addition, information on closed medical liability claims required by the PA 05-275 to be provided by the Connecticut Insurance Department identifies that the cost and impact of the tort system continues to increase. And my colleague, Dr. Russo, earlier testified already to support our medical liability study outlined in this bill. And I want to share some personal stories from me practicing as a primary care physician in a small town in East Granby. It is very challenging for me to hire or attract any primary care physician. The last physician I hired in my practice was in 2016. So that kind of tells us, how things are becoming much more harder and challenging. The one physician career, it's about 30, 40 years long. And in that physician's career, they touch hundreds and thousands of lives during the entire career that they serve that community. So it's not only impacting the practice for physicians, but also it's the access challenge for our communities. Patients have limited access to good quality physicians, and when they do, there's challenges. I have had to close my panel for accepting new patients because I cannot keep up. I can have 2 more physicians tomorrow because I don't have to say no to new patients, but I'm only unable to do so because I don't have enough clinical hours in my day to see those additional patients. Secondly,
Excuse me, Dr. Goodman, your time is almost up. If you please summarize.
I just wanted to finish off by highlighting a comment on developing or at least piloting a program based on North Carolina's 3+3+3 program, where we can we can support some of those students when they are in medical school, developing a path for their training and residency programs within state of Connecticut, and then they commit to service for 3 years in the state. And during that time, the last comment I will make also is this bill is intended in the right direction, but I will also say it's not only for employed physicians to have those benefits, but also support the smaller practices in community that they can also support incoming physicians and then retaining them in Connecticut. With that, I will take any questions if you have. Thank you. Thank you for your time and thank you for listening.
Thank you, Doctor. You've covered a lot of ground in that 3+ minutes. I think you've done an excellent job of cataloging all of our state shortcomings when it comes to healthcare practitioners. Just focusing on one before I hand it off to Senator Anwar. We're familiar with all the issues that you raised, but you also talked about negotiating with insurance companies. Could you just clarify a little bit what your frustrations are in that quarter?
So that kind of comes from being in a smaller practice and not having to have that large system behind for the negotiation. So the challenges are the smaller practices have different kind of challenges when it comes to, your contracting with insurances. And for example, like the same, if you call your physician for ankle sprain, or if you call your physician for a sore throat, the same service may have a different cost based on which system are you working with, and versus a smaller practice versus a urgent care setting or in a different facility. So the same service may have a different cost just because of the different insurance contracting. And also with the high deductible insurance plans these days, that may end up different out-of-pocket cost for the patient at the end of the day. So I think it is something of another context, but needs to be, looked at, in a different lens.
Sounds like there's an opportunity for smaller practices to band together and maybe develop some negotiating clout, but I'm not going to interfere with the marketplace, just an observation.
Right.
But thank you for that. And I really take very much to heart your comment about you don't have enough clinical hours in the day, which reflects the changes that managed care brought to the practice of medicine. And I'm now going to hand off to somebody who never has enough regular hours in his day to do everything that he takes on, let alone just clinical practice, our own Dr. Anwar.
Thank you so much, Mr. Chair. Thank you, Dr. Goman. Good to see you. Thank you for your testimony. Dr. Goman, I also am on faculty at the Quinnipiac University too. So, and your interaction with the medical students, help us understand what they're going through and how much debt that they have and the stresses that they also are looking at, and why can't we have it's one of the best medical schools and the newest medical schools in the country. Having said that, we are not able to keep those medical students here in our state. Can you expand on that a little bit with your direct conversations with the students?
So thank you, Senator Anwar, for the opportunity. So absolutely, you're right. So there's several different challenges that the medical students are going through, as medical school is stressful as it is. And with Quinnipiac's Frank H. Netter and School of Medicine's focus on primary care, so we have been wanting to provide nurturing environment for our medical students so they can continue to grow through medical school into residency training and then commit to hopefully serving the communities that they would like to. Some of the challenges that I hear directly from the students is their challenges with the cost of their education, and then competing demands once they are going into the private practice or the clinical practice. The choices may be limited for them to see private practice models. Secondly, they are having hard time in when they are in their practice. The path in primary care sometimes is perceived as not giving them enough of the protections in loan forgiveness. For example, the FQHC models may have the loan forgiveness opportunities. Smaller practices like myself are exempt from those because of our not-for-profit and for-profit status. So some of the ideas that I would like for this esteemed committee to consider is, while we are supporting the physician retention recruitment within the state of Connecticut, but I think we should also be carving out or maybe making some of those same benefits available to the smaller practices who are for-profit status in a different way. For example, one way could be some sort of tax incentive if you were to recruit and retain a primary care physician or any physician in any specialty area for that matter, and if they retain in the state of Connecticut. So the benefit, if there was a student who is interested and wanting to stay, the practice has some path to support that student, resident, physician now in the state of Connecticut. And the other comment I just wanted to highlight, I'm aware of one such program in state of North Carolina, where they have a path for students. They have some tuition reimbursement for those medical students who commit to a career in certain fields and they would like to commit to stay in that state. So for example, if you have Ywca, which is a state medical school, we can have a pilot program for maybe 2 students, 4 students, I don't know. And then maybe we can help to see if those students early on have some tuition waiver of some sort to support their medical education. And then University of Connecticut has a lot of training programs. There can be a carved out path for them to go through training within the state of Connecticut. But then that student who has gone through these 6 years or 7 years of training is now committing to practicing within the state of Connecticut, and those training and those practice years will benefit hundreds and thousands of families and thousands of patient encounters. So I think that is one opportunity for us to consider supporting early on when they are in medical school and starting from there on till they finish their training.
Thank you so much. This is very helpful. I'll look up the North Carolina model in more depth going forward. Thank you. Thank you, Mr. Chair.
Yeah, I think we all are intrigued by this North Carolina model. We're going to have to look at it. Normally, we just send North Carolina our retirees, but maybe we can get something good from them in return. Representative Zupkis.
Thank you, Mr. Chair, and thank you for sharing with us today. I just wanted to make a comment because you mentioned the price of medical school and also how expensive it is to live in this state. So I really think those are 2 issues that we need to look at, not only in this committee, but every committee on why is medical school so expensive? So let's start there and look at what those costs are and how can we help do something or something be done there. And also the cost of living in Connecticut. Every year we see more and more taxes. We see all of these things. And I agree with you 100%. And I've heard it in different committees this year and all the time on how expensive it is to live and stay in the state. So I hope that we will all take a look at that and to help our citizens and our medical students and doctors and everyone be able to afford living here. So it's just a comment. Thank you.
Thank you, Representative.
Thank you, Representative. Yeah, my father was a primary care physician, and he never encouraged me to go to med school, even though I was pre-med for freshman year, mainly because look at the proposition. You spend less time in direct care. You have all sorts of things you have to do to satisfy the managed care system that we have. You have increased educational costs and decreased income. So, what can go wrong? Well, that's why, unfortunately, we are also suffering a shortage of primary care physicians. So, Doctor, thank you for what you do. It seems like you want to comment on my musings, but go ahead.
I just wanted to say, it is very challenging, but at the end of the day, it is the most rewarding profession that I know of. If I had to do it all over again, I will still do it again. The best part of my day is the time I spend with my patients in my exam rooms. That is and especially in primary care, we live and breathe relationships. I serve a small community of 5,000 people, and my kids go to the same school where my patients go, where their parents go. So I am part of this community, and it is the most beautiful part of being a physician is when you're able to serve a community, when you're able to be there for them when they need you. So yes, it is challenging, no denying, but at the end of the day, this is the best part of my day. And this is still something that I will recommend to anyone, any young physician who is training to be in primary care. But thank you for your time. Thank you for listening. I won't take too much of your time.
Well, Doctor, we've recorded this testimony, so we may use you in a recruitment video as we go forward, because I haven't heard a better argument for getting into primary care in Connecticut.
Absolutely.
Thank you for your time.
Thank you.
Next up is Christina Glaudy, followed by Marietta Capobianco. Going once, going twice. I guess you're up, Marietta. Welcome.
Thank you. Thanks for the opportunity to speak today in front of all of you. I'm here as a licensed optician in Connecticut. I've been in the optical field for 31 years now, and I'm here to oppose Senate Bill 329. When I entered the optical field many years ago, I did so because it was a way for me to be a healthcare provider without being a doctor. As a healthcare provider, I take pride, especially in the way Connecticut has such a high standard in how we get and maintain our license, as well as the expectation that the licensed optician is on the premises at all times to better protect those that we serve. Dr. Aceto touched on a lot of details earlier, and everything an optician does are measurements, adjustments, fabricating of lenses, fitting contacts. All that gets done in a precise, prescribed, and customized manner. And any of these actions are performed with errors, it can cause they can cause eye fatigue, double vision, eye pulling, eye stress. And a lot of these symptoms can turn into physical injury. If you have an elderly person who has double vision, they're driving impaired, that is not necessarily the safest thing to have. In my written testimony, I did include some diagrams for those of you who are not in the optical field, so you can kind of get a better idea of what it looks like when measurements are not done. And it does explain a little bit about that stuff. One of the points I want to make is that, in my opinion, I've been listening to all this testimony for a lot of the other medical bills that are in place right now. And it's my impression that when these bills are introduced, it's because either harm has been caused or could be caused to the general public, and that these bills are presented so that it can eliminate the harm, or even if the bill is okay, it can improve the service that our citizens get. Nowhere in the Warby Parker bill is there language that explains that our current way of running our business hurts the public, and there's no language in their proposal that shows how it could improve the treatment of our public that we wait on. I believe that they're basically a disgruntled business, that their business model does not fit into our statutes that we follow and take pride in. And I don't really feel if that's the case, then they maybe need to not do business in our state and look for another state where their business model will fit better.
Thank you for your testimony. I'm not sure I really agree with you. In any industry, change happens, innovation occurs. I believe that this company's argument is that they are making the acquisition of quality products easier, more accessible, and that they have made this model work in other states. And I take your point that Connecticut has to this point held a very high standard, and that we have done everything within our power to limit bad outcomes. And that's why we're having this conversation about this bill. But I think it's difficult sometimes for us to recognize that the way we have done things for a long time eventually is going to get challenged by other ways of doing business or delivering services. We're in the hard position. We're not the Department of Consumer Protection. We're not in this for the business side of things. We are here to protect the public health. So this is why we're having this discussion. We don't really have these kind of commerce debates all that often, but oftentimes it seems that the promotion of the public health touches on the business world in a variety of ways that we never really contemplated. And as we see when it comes to regulating hospitals tertiary care facilities and the like, it can be quite challenging for us. So thank you for your testimony. We'll continue to wrestle with this one. Next, I'm going to give one more chance to Christina Glade. If she's here, I know she's in the room, but she hasn't jumped in. If not, we will move shortly to the next person on the list. Looking like you're up next, Attorney Ward. Welcome.
Thank you, Chair Steinberg, and thank you to the members of the Public Health Committee for allowing me the opportunity to speak today in strong support of SB 448. My name is Devon Ward, for those who don't know me, and myself, along with Attorney Kenneth Krajewski, are responsible for the majority of taxpayer-funded settlements against the Department of Correction over the last 4 years. In 2018, we settled the case of Wayne World for $1.3 million. Mr. World was a Hartford resident whose cancer went undiagnosed and untreated for nearly 3 years. In 2020, we settled the case of Tiana LeBoy. Ms. LeBoy is a New Britain resident who was forced to give birth in her jail cell. In 2021, we settled the case of Karan Neely for $1.6 million. Mr. Neely was a 19-year-old Waterbury resident that died from undiagnosed lupus complications. And currently, Mr. Krajewski and myself represent every inmate in the Department of Correction serving a sentence of more than 12 weeks. In their quest to receive hepatitis C treatment and testing. And since we filed that litigation and DOC has amended its policy, 18,000 inmates have been tested for hepatitis C, and nearly 2,000 inmates have received treatment at a cost of over $39 million to the state of Connecticut. And it's from that perspective that I'm coming to speak in favor of this bill. Just really want to briefly touch on 2 points. One, is that I think a multi-layer oversight approach is probably best, having DPH do the facility licensing inspection like they do for every medical provider, but also accreditation. The National Commission on Healthcare used to be the accreditation body for DOC. Connecticut moved away from accreditation some time ago. So there is an outside body that could come in and accreditate our healthcare in the Department of Correction. And I strongly advise that we do that in addition to having DPH come in. We've seen what happens when you have two state agencies overseeing one another. Case in point, you guys are talking about drinking water today. It's another example where you got DPH and DEEP, two agencies overseeing one another in one area, and it usually never works out. So I would really caution against giving DPH the sole regulatory or oversight provision, but really rather give them a portion of it, particularly with the facility licensing inspection. And then also do accreditation. And then, I also would support a public entity or body with a multidisciplinary team having some oversight as well. And then the last point I just wanted to make is I would be remiss if I didn't mention Ms. Tiana LeBoy, who is the impetus for this bill. When I litigated her case back in 2020, the Office of Attorney General William Tong's office told me that West v. Manson was an expired consent decree. And West v. Manson's been in place in Connecticut since the 1980s, ensuring everything from AIDS prevention to inmate prenatal care in York. And so I think it's really key that this body codify that. But I also would respectfully urge the committee to uplift Ms. LeBoy's name in putting forth this legislation, because she is the impetus for it. Without what she went through in York, it really wouldn't have shed a light on West v. Manson and the need for this for that consent decree to be codified, and the need for this legislation to be memorialized in statute, so that attorneys cannot argue that they don't have to provide prenatal care or detox treatment to women in York. So I did submit some written remarks that are more detailed, but in the interest of time, I'll leave it to that. Thank you all for the opportunity, and I stand ready to answer any questions you may have about DOC or litigation or this bill. Thank you.
Thank you for that. Do you know offhand, why did the state move away from accreditation for DOC?
Cost. I mean, it's a simple. It's cost, right? And it's cost on two ends. To be accredited by the National Commission on Healthcare, or inmate, or I think it's correctional healthcare, excuse me. It's about a $20,000 to $25,000 annual fee. That's one. And then the other reason why is once, in order to be accredited, you have to meet certain standards, and those also come with a fiscal impact as well, right? Meeting certain staffing ratios, having particular equipment in your facilities. So the bottom line why Connecticut moved away from those standards is a cost a reason. And so, as many other folks have opined, in addition to not only just mandating oversight, I think there has to be some fiscal support and resources put around the Department of Corrections to allow them to be able to be successful. Because, as much as I litigate against them, I earnestly believe in all the depositions and the investigations that I've done, that the medical providers within the Department of Correction do care about the population that they're treating and want good outcomes. But we have to, as a public and as a state, have to give them the resources that they need to be able to do that job.
Thank you for that. Yeah, you get what you pay for. So if we haven't made the adequate investments, we shouldn't be surprised that our standard is not where we'd like it to be with all those ramifications. I see Representative Pettit has a question.
Thank you, Mr. Chairman. Thank you, Mr. Ward. We had talked going back 4 or 5 years on hepatitis C and other issues.
Yeah.
So this is kind of broad. From your perception, you've been looking at this number of years now. Do you think it is more of a money issue per se, or an organizational issue, or a little of both in terms of trying to get the best possible healthcare in an efficient way at DOC?
Yeah, I think it's both. I think, I use this analogy often, but it's very easy to blow up a building, right? It takes 2 seconds to blow up a building, but it takes a longer time to be able to build that building up, right? It takes maybe a 2 or 3 year time span. And I would say the same about, the provision of healthcare in the Department of Correction. That particular unit was decimated by budget cuts under the previous administration. And so trying to rebuild back the level of medical care that meets the constitutional standard, because I do want to remind the committee that inmates are the only folks who have a constitutional guaranteed right to healthcare. To get the state of Connecticut's Department of Correction back up to that constitutional standard, community standard of care, it's going to take some time. And, it's a matter of resources in terms of staffing ratios. So in that, then in turn, speaks to recruiting. It's tough to recruit. I empathize with Commissioner Quiros in that it's tough to recruit folks when I'm suing them. For bad outcomes, and that's in the paper. It's probably very difficult to find competent nurses and doctors that want to work in his facility while I'm suing them. But it's also, it's kind of a chicken before the egg issue too, because they wouldn't be sued if they had adequate staffing ratios most of the time. And some of these healthcare outcomes just simply didn't happen. And so, it's a tough job, but I think if the state does put significant resources by the way of funding for staff and also for the facilities, we can eventually get back up to the level we need to get up to. But I must say that this arrangement that we have here in Connecticut, where the Department of Correction is engaged in the business of healthcare, essentially with no health oversight, or no oversight by the Department of Health, is very unique. And I can say from my own experience that the outcomes that we're seeing now that DOC has taken over healthcare are not much better than when UConn was providing healthcare. And most states around the country usually contract with an outside provider or multiple outside providers to provide their healthcare. And that may be something Connecticut wants to take a look into. But in the meantime, while the Department of Correction is engaged in the practice of medical care, I think they should at minimum be held to the same standards that every other medical facility in the state of Connecticut is. And so Barbara Cass from, the Department of Health was on earlier. She does the facility licensing inspection. I've routinely heard complaints from medical providers in DOC and from inmates that they don't have proper equipment to monitor blood, your heart rate. It's a routine thing when I'm doing litigation that folks do not have their weight monitored when they are coming in for visits, which often leads to them missing critical illnesses. And so just making sure they have those basic fundamental facility equipment I think could help prevent some of these outcomes, and having DPH go in and inspect those facilities could also help prevent some of these bad outcomes as well. And so thank you for the question, Dr. Pettit.
No, and I appreciate your hard work on hepatitis C and other issues. And I guess the next we got to look at the system and try to get Medicaid coverage in the prison system so that people have coverage that they need. So thank you for your hard work. Thank you, Mr. Chair.
Thank you as well. I think you get the sense that we're all very concerned about the Department of Corrections and that how we have shortchanged them in a way in which it has an impact on inmates, and we have to do something. The problem is it hasn't necessarily been for lack of trying. We have tried over the years, but I think some of our choices in hindsight were regrettable, and now we have to make harder choices. So thank you for your testimony. We're sorry that you have to spend most of your time suing that organization. We'd like to reduce your business in this area and have you focus elsewhere.
Me too.
So
thank you for that.
Next up is Namor Edwards, followed by Olivia Rinks or Rinkus.
Hello, how are you? I think that there was an error with regards to the input of the name. I'm Antonia Edwards, and Namor is my daughter, and she was supposed to come next, according to the list, 51 and 55 or 51 and 52.
That might explain why we have you listed twice. So
yes, exactly.
why don't you go ahead and we'll take it from there.
Thank you so much. So I'm Antonia Edwards. I'm the grandmother of Navon and Nove Edwards, who Navon expired on August 20, 2007 and 2020 due to mental health crisis. I'm here today to, first of all, I want to say thank you to all. One second, something's happened. So I want to thank everybody first for personally having us today. So to personally thank all the, something keeps blinking on and off, I'm sorry. I want to personally thank you and all the distinguished members of the legislation body for expediting the work in a bipartisan manner and to immediately address the children's mental health crisis that is now an emergency. Namor Edwards, my daughter, and I would like to extend our special thanks and consideration and also acknowledgement to Senator Kelly and his staff, Nicole and Jason, who had compassion, concern, and understanding to present a very special bill designed to support culturally competent mental health services for all of Connecticut's children. The empathy and compassion that the body and the legislation have showed us in our last hearing that you expressed while my daughter and I testified on the FHB 5001 hearing on 225 was truly heartfelt, and we truly thank everybody for being compassionate. We'd both be very much pleased if you would be able to name the SB 451 in honor of both Nove and Navon. Both children suffered significant losses as a result of the racial implicit biases and also cultural incompetency that continues to plague the mental health and medical profession communities in Connecticut. We were asked to have our input specifically as to what we'd like to see change and also to add what we want to for the task force. So the first thing that I'd like to ask is to have community-based organizations that are on the ground to interact with the community already, and this is in the Black and Brown community. So I want to ask the Favor CT, which is a family and the family to design the family coordinating liaison. They already have family support managers, but to expand upon that position so that they have a person who knows all the services that can assist a parent with their child with special needs. Also, to have the Children's Behavioral Advisory Commission, which is also Beacon Health, as a mental health administrator, be a part of the task force as well too. The Greater Hartford African American Alliance is basically a community-based organization that supports the Black and Brown community. And so we basically have ties to the community and can service people in a more congruent area. Also underneath that, I wanted to add the African Caribbean American program, which is called AFCAM. Most people know that. So if we have these 4 entities a part of the task force, I think that we can make significant strides in how to combat the mental health crisis in the Black and Brown community, but also overall with the CBAC, which is the Children's Advisory Board, can help with the mental health crisis with people for all over. The 3 things that I'd like to ask real quick is that, and it's a part of Senator Kelly's bill, is that we have a non-governmental, extremely competent and medically diverse family liaison coordinator that services all mandated so that are all mandated up to take mental health providers. Also, the family liaison is trauma informed crisis intervention and would be dispatched along with 911, especially if there's a mental health crisis or a violent matter. That should be something that should be put in place. The third thing that we're requesting, Noma and I, is that all DCF 136 forms must include the race of the mandator. And this should be no longer optional. Right now, it's not mandated, and that this key information will be helpful to disaggregate the data. I want to just say thank you to everybody for listening to our testimony in HB 5001. I want to say thank you to this commission, the Public Health Commission. There's so many people on here who have extended their condolences and who have diligently worked to make this happen today. And so again, it would be an honor to have this bill named on behalf of Nove and Novan, who both have suffered. One had passed, one died as a result of the negligence and incompetency of the mental health crisis. And I want to thank everybody for listening. And no more may be on later on. I'm not quite sure, she's at work. So I just wanted to get in and say thank you to everybody.
Well, thank you for your testimony. And yes, we do recall the testimony in 5001.
Thank you.
It had a big effect on all of us.
Yes, thank you.
Very specific suggestions we'll take very seriously. To your
Thank
point,
you.
I think we're still at work. We don't see her in the room, but maybe she'll get a chance to.
Yeah, she may come on at the end. And thank you so much.
We have Senator Anwar with a question or comment.
Thank you.
Thank you. Hi, Antonia. How are you?
Hey, Senator Anwar, how are you?
I'm good. Good to see you. And thank you for your advocacy and the work that you're doing.
Thank you.
And we appreciate you. And your every time you come to this committee, we are here for you. And then we learn from you, and then we are going to be your voice. I just want to make sure you know that a lot of the work that is happening in 5001 and also in SB2 also comes from our conversation. You have been instrumental in helping us do that. So we will continue the journey, and we will continue to make this effort in all possible ways. So some of these things that we are in the already in another one. So wanted to thank you.
Thank you so much. I really appreciate everybody. I really do. Thank you.
No further questions. Thank you. Remind your daughter to give us, come on by later.
I will. She will. When she gets on, she'll be there. Thank you so much, everybody. Have a wonderful day.
You too. Next up is Olivia, followed by Desi Guerra.
Thank you. And thank you to Senator Anwar, Representative Steinberg, and members of the Public Health Committee of the Connecticut General Assembly. My name is Olivia Rinkus. I'm a resident of Northampton, Connecticut, and I'm also here as a supporter and member of the Catala Center for Equity, Health, and Justice. And I'm testifying today in strong support of SB 448, an act concerning the delivery of healthcare and mental health care services to people in correctional institutions. Healthcare is absolutely a human right, and healthcare needs do not stop when a person enters the custody of a correctional facility. As incarcerated people are in the care of the state, it is the state's responsibility to be providing these basic needs. Access to healthcare services, especially the inclusion of dental and mental health care services, should definitely be a priority for lawmakers this session. We rely on incarceration far too much in our state, and people who come home from correctional facilities often have more healthcare needs than when they go in. I've witnessed people get swept up in the criminal justice system, especially in the last as an activist, especially in the last 2 years of the pandemic and the uprisings. We need significant changes to our criminal justice system, and healthcare is a necessary step to be helping those already caught in the system. In many ways, I do believe this bill could go further, such as by providing regular access to health services that include yearly examinations, especially in regards to dental health care. Also, with the inclusion of a discharge plan, which would include referrals and appointments for released individuals to continue maintaining their healthcare plan and support with obtaining health insurance, expansion of mental health services for incarcerated people, and also an improvement of health outcomes for incarcerated women at your correctional institution by expansion of Section 5C, line 238, to describe minimum prenatal visits once a month, 0 to 28 weeks pregnant, once a month for 0 to 28 weeks pregnant, every 2 weeks for 28 to 36 weeks pregnant, and once a week for 36 to 40 weeks pregnant, or more frequently for high risk pregnancies. In closing, thank you again for the opportunity to testify in support of SB 448, an act concerning the delivery of healthcare and mental health care services to people in correctional institutions. And please consider these additional recommendations to also improve outcomes for incarcerated people. And also please consider changing the title of this bill to exclude the word inmate. Thank you.
Just on that very last point, excluding the word inmate, what would you replace it with, or?
Just people who are incarcerated.
Okay. Thank you for your testimony. Obviously, we're trying to do something of consequence with regard to the Department of Corrections. We appreciate some insight as to how we might go about doing that. I don't see any questions, so thank you for your testimony. Next up, we have Betsy Guerra, followed by Louis Rosado Birch.
Thank you, Representative, Senator Anwar, Representative Pettit, members of the committee. My name is Betsy Guerra. I'm the Executive Director of the Connecticut Council of Small Towns, and I have submitted testimony on 3 bills, but I just want to summarize some comments relative to Senate Bill 456, an act concerning safe, clean well water. As you've heard earlier today, we have a number of communities that are struggling to address issues relative to contaminated residential private wells. Some are facing issues relative to sodium chloride levels, PFAS, uranium, or other contaminants. And it's, very disturbing. And I know that the towns are struggling to work with their residents, work with the state agencies to try to develop comprehensive solutions to addressing this, but it's again, very challenging. And so we do support the intent of Senate Bill 456, which amends DEEP's potable water program. I do, however, have concerns in relying on the plain reading of the statute as amended by 456, because there are circumstances where if DEEP is unable to determine who the responsible party is, it would be able to order the municipality to repair or replace a contaminated well, which, as you know, can be expensive and not particularly effective if the actual source of the contamination isn't eliminated. I do think the potable water program can be useful under these circumstances. However, you do need to increase the funding for the potable water program, which assists municipalities in providing potable water where they have contaminated water sources, and also to fund remediation and efforts to either provide additional alternative sources or to ensure that they can tie into a water system, which is a more permanent solution. Again, we have issues with the bill as drafted, but we are very supportive, and I know there's a few bills pending this session. We do think that this needs a comprehensive approach. Senator Cassano, in talking with him before the Planning and Development Committee, has also likened this program to the issue of crumbling concrete foundations, because it's something that is devastating for those communities that are struggling with it. And it's extremely expensive, but there needs to be some kind of statewide solution to help these individuals address these issues. And so we do agree that there needs to be a comprehensive approach. I think part of it is going to be adequately funding DEEP's remediation division, which investigates and remediates properties that are facing contamination such as PFAS. DEEP has already identified 2,400 potential locations throughout Connecticut with potential PFAS sources such as landfills, manufacturing sites, and whatnot. And we also need to, again, identify a mechanism to adequately fund long-term strategies to address contaminated water wells. It could be the repair or replacement of a well, but until you remediate that area, repair or replacement isn't going to be sufficient. It could involve water treatment efforts, and it could also involve, again, the connection to a public water system. This is an issue. I know that, again, there are many bills pending before the legislature to deal with this, and we are looking forward to working with DEEP and the Department of Public Health to make sure that we, again, have a comprehensive approach for addressing this. So thank you.
Thank you, Betsy. I hesitate to ask you to put on your other hat, but you seem to be sort of doing that anyway. Short of further consolidation of the way too many water companies we have in the state, do you see there any real path to addressing some of the issues that you've raised in terms of potential for contamination?
Well, some of these issues, and just for the committee's edification, I also serve as the executive director of the Connecticut Waterworks Association, which represents municipal, regional, and private water utilities. And so I do have kind of see both sides of this issue, and I discussed with both of our boards ways of addressing this. In many cases, these are not small systems. So they're private residential wells. They may not be part of a community water system that I know that the Department of Public Health has often spoken about. There is a bill before the Energy Committee that would ensure that PURA considers, when they're looking at the acquisition of a smaller water system, which could include some deficient well water systems, that they consider efforts to remediate those wells and determining the costs that should be approved as part of their rate base. I do think in many cases that extending water mains to these areas provides a very permanent solution, because those water utilities are required under the Federal Safe Drinking Water Act to be very proactive in testing for approximately 90 potential contaminants on a regular basis. As you know, because there is a bill before this committee, private residential wells, private wells, and semi-public wells are not required to test. And it's unfortunate because in some of these communities, the local health directors, the towns have said to their residents, you really do need to test. We have issues here in the town. You may want to test your well water to determine whether or not there are any contamination issues that you need to be aware of. And as Representative Nuccio mentioned, when you start to taste sodium chloride in your water, it's too late. You've been drinking high elevated levels for too long. So I think those are part of it. I do think we need to, at some point, get DEEP and DPH, which have tremendous amount of expertise in this area and understand these issues very well, with our public water suppliers and with our municipalities, to try to figure out, and our lawmakers, of course, try to figure out, again, a comprehensive approach for addressing this.
You know, we've been talking about testing of private wells for many, many, many years. Why is it, do you think, that we fail to accomplish rural reform in this area?
It is, I know, a difficult issue for some residents. They don't like to be told what to do. And so I did submit testimony on it indicating that it may be appropriate to require testing where, particularly in communities that are struggling with these issues. I'm meeting with our board tomorrow. It's not an issue we've discussed, so I don't know whether or not they will raise any concerns about it, but certainly we need to make sure people are informed about the quality of their water and to understand that they need to test on a fairly regular basis. It is expensive to test. And so to the extent that the state can assist, or the municipalities can assist residents in testing, I think that would be an appropriate consideration.
Thank you for that. It's something that's been nagging me for a good number of years, that homeowners don't know what they're dealing with. They don't know what they don't know. And that's a serious problem.
Right. And I do think the bill before the committee, HB 5484, I believe, takes a more moderate approach and only requiring testing when there's the construction of a new well, which is probably done anyway, and also the transfer of the property. I think that certainly makes sense. I believe home inspectors generally recommend that water be tested, but again, it's something people want to avoid, that extra cost, and they just don't get it done, and it's unfortunate.
Thank you. Considering they're putting themselves and their families at risk, that is a tough one. Senator Anwar.
Thank you, Mr. Co-Chair. Thank you so much for your testimony, Ms. Gara. I wanted to ask you, are there models within the communities you represent where bonding money was used to connect homes or a community with public water?
There have been incidents in or models, I should say. So for example, in the town of Durham, Durham had a manufacturing site that was also declared a Superfund site right on Main Street. And as a result, the homes on that street had contamination issues. Under the law prior to 2013, DEEP was required to provide them with water treatment or potable water. And so they did have some filtration added to the homes. It was not considered a permanent solution, but it was something that those homes had to utilize for many, many years. Fortunately, under the 471 program, otherwise known as the potable water program, DEEP was able to provide funding from that program, in addition to funding from EPA, to tie into Middletown water system. And so they're just about finalizing, or not maybe final at this point, the water main extension from Middletown to the center of Durham. And this was significant. The problem with the program at that time, however, was that DEEP would only fund the size pipe needed to address the contamination issue, and not a larger pipe that might be needed for fire protection or economic development purposes. So actually Senator Kennedy and others representing the district had to get a special act to address that. So that is one situation. In Tylerville, which I think is East Hampton, that 471 program has also been used to fund water main extensions. So it can be a great program. I don't know, given the fact that some contaminants are naturally occurring, and this only provides assistance for man-made chemicals, and whether or not it's easy to determine who's at fault here. When you have a manufacturing site and a Superfund site, you kind of know, okay, that's where the source of the contamination is. With PFAS, it's very difficult, as you know, Senator. And with sodium chloride, again, I know Tolland has been struggling to figure out, and other areas struggling to figure out, whether it's road salt, whether it's the way the wells were constructed, or whether it's water softeners. Not an easy solution.
Yeah, I want to thank you for your testimony. I just wanted to add, I'm hoping we can strategize. This bill isn't going to solve all the problems. And in the challenges that we have, we'll have to have a comprehensive strategy going forward. And I think the permanent solution is that we continue to expand public water supply, public sewer, public water supply. That actually gives much more options to communities and is part of economic development in the community as well. So thank you so much again. Thank you, Mr. Chair.
Thank you.
Mr. Chair, and I concur with you that our only way out of this is to make sure we have an effective, safe water network in our state, and we're still quite a ways away from that. I see Representative Foster, you had your hand raised, you took it down. Are you okay now?
I have nothing to add at this point. Thank you very much.
All righty then. Thank you, Betsy, for your testimony as always. We're not trying to create undue burdens on municipalities, but it's interesting in and of itself that this committee has 4 different water-related bills on its agenda this year. The connection between the public health and safe potable water is very clear to us. So we appreciate your input. Next up is Louis Rosado Birch, followed by Debbie Osborne. Welcome, Lou.
Thank you, Representative Steinberg, Senator Anwar, Honorable Vice Chairs, ranking members, and distinguished ranking file members of the committee. I'm Lou Rosado Birch, Legislative Coordinator at CEA, testifying today on behalf of the Coalition for Healthy Air in Schools, which is a group comprised of parents, educators, labor unions, building trade workers, public employees, environmental advocacy groups, and healthcare workers working to promote safe, healthy learning environments in our schools. We've submitted coalition testimony in support of House Bill 5479, an act concerning indoor air quality in schools. We applaud the committee for raising this important bill, and we urge you to strengthen this legislation for the benefit of Connecticut school children and educators alike. We know that indoor air quality can have adverse impacts on students' health, and that air temperatures can have a profound impact on their ability to learn. Something like 68% of Connecticut school districts have reported indoor air quality problems in one or more of their school buildings. This contributes to higher rates of respiratory health impacts and school absenteeism among Connecticut students when compared to the national average. And so our members appreciate the leadership, time, and resources this committee has already committed to this important issue. I would like to highlight that the Labor Committee has also introduced a bill, Senate Bill 423, to establish health protective air quality and indoor air temperature standards. And Finance has introduced measures to fund HVAC system upgrades using school construction bond monies. Given that there is tremendous interest among legislators to address this issue, we ask these committees to work together to pass the strongest, most health protective legislation possible, with enforceable indoor air quality standards and a sustained funding stream to support HVAC repairs over time. This bill is well intended, though it appears to be based off of bill language from previous sessions, which had already been watered down from more comprehensive proposals. And so we must make our position clear. The most important policy measures needed to address this issue are clear, enforceable indoor air quality standards and a dedicated funding stream. The indoor temperature limits spelled out in lines 40 to 47 apply to school gymnasiums only. And while these are helpful, they completely ignore the universe of school facilities beyond the gymnasium where students and teachers spend time. Year after year, we've seen indoor air temperatures breaking records, with many classrooms registering temperatures in the 90s and above. And so we need strong air quality and temperature standards to protect the health of our students and teachers. Furthermore, we need to establish clear monitoring and reporting requirements and assure that necessary HVAC repairs are being made by trained, certified technicians. Senate Bill 423 includes these measures, and we recommend this committee incorporate these critical health protective standards in House Bill 5479 as well. We support the intention and respectfully urge this committee to strengthen the bill by including the air quality and indoor air temperature standards, certified technician requirements, and reporting mechanisms spelled out in Senate Bill 423. Thank you so much for the opportunity to testify today, and we look forward to working with you all on this important legislation moving forward.
Thank you, Lou. Focusing for a moment on the importance of standards, are you generally satisfied with the direction of the labor bill when it comes to establishing an effective standard?
Yes, that bill was actually was put together with the help and consultation of industry experts, working to put together a policy that would help to meet ASHRAE standard number 62, which is important indoor air quality standard that's federally recognized. And so, yes, we do feel strongly that that bill strikes the right balance of being, having the right protective measures in place.
Thank you for that. Well, it sounds like if labor's got the standards covered and finance is supposed to come up with the money, though I'm not so sure they can come up with enough money for the problem we have across the state, perhaps this committee should stay focused on what remedies are really going to allow us to achieve the standards. I think you touched on one of them by talking about the importance of regular maintenance and monitoring to make sure that we don't make a problem worse. But I'm very interested in making sure that whatever limited funds are made available by the state, that we're spending those funds as wisely as possible and are helping as many schools as possible. And what concerns me is that we fall into sort of the old paradigm assumption about simply replacing out boilers or doing wholesale changes of venting systems and the like, without that fundamental understanding that you refer to by way of standards that take into account air circulation per hour, temperature, humidity, all the factors that go beyond simple HVAC and really talk more about climate control in a more unitary sense, which also obviously means that we need to focus on controls and the understanding of those controls, because they can be every bit as important as sort of the hardware fixes that we might choose to make. Do you have any suggestions or insights when it comes to determining how best to allocate these funds such that we are actually impacting as many schools as possible, even if we're not necessarily doing wholesale swaps of existing HVAC infrastructure?
Yes, sir. That's a great question. In fact, one of the other pieces that is included in Senate Bill 423 is exactly what you've just described. And one of the reasons why that's so important, going back to what we were saying about having standards in place, in specific in being able to achieve that ASHRAE standards 62, is making sure that there's routine indoor air quality assessments being done over time, at least every 3 years. And that's one of the things that's included in Senate Bill 423. The other thing that I would like to just point out that you've helped to highlight in your question, perhaps without realizing it, is that this needs to be just as much about identifying old systems and replacing them with energy efficient, state-of-the-art systems, and not just repairing old broken HVAC systems that have been broken for years and years and years. And so that's one of the things that having those strong standards in place will help to do, is to ensure that we are meeting the best available standards, and that we're offering the best available technology to our school districts in order to meet them.
Well, thank you for that. I am concerned that the money will run out very fast if we reflexively simply revert to replacement when there may be other supplementary options, including improving controls. So striking that balance is going to mean we're going to need some real expertise. We're going to need some very clear criteria. You know, I think that there's been a lot of focus typically on, as we discuss, humidity and temperature, water incursion. But I think that thanks to the pandemic, if I can say thanks, we've also learned that you have to be able to control for not merely circulation and ventilation, but also filtration. And that's an area in which we can still learn a lot, and establishing the right filtration standards are something we need to talk about further as well. So this is a much bigger subject. It is, in my surmise, a widespread problem in our schools. And I only hope that we can apply this kind of thoughtfulness in determining how we're going to allocate scarce funds. Senator Anwar.
Thank you so much, Mr. Chair. Thank you so much for your testimony. This is a very big issue. If you look at the asthma rates, allergy rates in our children, but also in our teachers and their well-being, we clearly have a major problem, and we need to intervene. I wanted to explore something with you. Look, many of the schools are 40 to 60 years old in our state, in that range. And many of the towns have made their own plans that they anticipate building a new school in 2 to 7 years' time. And I think we may have to create a criteria where a school is going to be rebuilt, because we would have limited resources, that if that is part of the plan, the ones that are going to be there for another 10 years or so, those are the ones we should probably target first, with the major problems in indoor air problems, and ones that are going to be there for another 10 years for usage. We should target those rather than the ones that are going to be replaced altogether. Any thoughts on that suggestion?
I think your point is well taken on the fact that there's a spectrum of schools that are at all different levels of this issue. That was also addressed. I keep referring to the other bill, but that was quite a comprehensive undertaking that went into developing that legislation. And that's once again one of the reasons why a routine indoor air quality assessment is critical, so you can do some of that prioritization. And there's also language in that bill that you all may want to refer to that actually clarifies that school districts and school buildings that are in the process of making those necessary HVAC repairs would be treated differently because of the fact that they're already doing the legwork to actually meet those goals. And so the school districts that are actually making progress on this issue would not be penalized in the same way that, say, for example, a school district that's in violation of the chapter. So yes, those are all things that we've looked at, and once again that we've weighed very carefully in putting that legislation together, and we hope that there's some lessons that can be learned there.
And the second part I wanted to quickly run by you was there would be economy of scale opportunity. Like Carrier, one of the companies over Connecticut based, at least in the past, they have looked at plans, but have we gone to the granular level to start to look at what would be the strategy so we can make the taxpayer money or the federal funds go farthest?
Again, without sounding like a broken record, I think it's all part of the assessment that needs to happen. That I believe was included in previous versions of the public health language, but is not represented here in the current bill that you all are looking at. So I can take a deeper look. Admittedly, some of this was a little bit before my time in terms of actually conceptualizing that legislation, but we'll certainly look at that issue and get back to you with more information.
Thank you so much. Thank you, Mr. Chair.
I too would encourage you, Lou, to get us whatever information about the stronger version. We hope to dovetail with the labor bill and fill in any gaps in terms of establishing appropriate criteria for moving forward. So that could be very helpful. I see Representative Zupkis has raised her hand.
Thank you, Mr. Chair. I apologize about my camera. Hi, Lou. Nice
Hi,
to
great
see
to hear
you.
from you. How are you, ma'am?
Good, thank you. My question is, I thought a couple of years ago, we passed a bill about the air quality in schools. So I don't know if you recall that or not.
I would have to take a closer look at that legislation. That predated my involvement in this issue by some time.
Yeah, I think we did, and I'm going to look into that also. But I'm curious to know: are there some specific schools that you're talking about?
My understanding from the time that I've spent working on this issue is that there are schools across the state in almost every district that are in some level of disrepair or need, and so I know that there are some schools that are at the higher end of that list, but I don't have that information with me right now. I'm happy to circle back with you.
Yeah, I wish you would, because if there's schools that have bad air quality right now, those should be the ones that should be focused on. And I find it interesting that if that is the case, why is the local health departments not in there? Why are they not talking to the superintendents and the school boards?
Yeah, you raise a very good question, and I just want to point out, as many of you already know, that the budget, that Governor Lamont's budget includes $90 million in ARPA funds for beginning this work. We think that's an important step towards addressing some of those high need districts. And once again, just want to reiterate that big part of what we're doing is working to make sure that we're able to get sustained funding through those school bond construction monies so that we can continue this work once those high need districts have been addressed.
Right. Well, I would be curious, thank you. But if you would please send me the schools right now that are in this situation, I would appreciate it.
Will do. Thank you, ma'am.
Thank you.
To amplify on his answer, Representative Zupkis, I don't even think we know the order of magnitude of the problem, because many schools don't have an effective means for monitoring their air quality. Certainly, we discovered that there's no standard requirement for them monitoring it currently. So the magnitude of the problem may be on our comprehension at this point, because we haven't done the effective inventory that you described. Sounds like it should be one of our first steps, though.
Well, because I know my school district, I remember, and I will look back regarding that bill, because I talked to my superintendent about it, and they were upgrading their system even before that whole bill. So I'm going to look further into that. But I mean, there has to be some schools that have come out and said, or where Lou's getting some of this information. So thank you. I would just, if there's any of that out there, I would appreciate it.
Absolutely. And one real quick thing, if I may, and then I won't take up any more time. I believe that I'm not certain if it was done through the legislation that you're referring to, or if it was through another section, but one of the things that has been established is a minimum temperature rating for Connecticut schools, right? And so, in other words, schools have to maintain a certain minimum temperature during the winter time. We don't have an upper range yet. And that's one of the things that I really want to point out in this legislation that you all have before you, where it really falls short, is that it only sets an upper limit on gymnasiums. And we really need to make sure that we've got some clear temperature standards in place. You all have passed temperature standards for pet shops, dictating what is the highest temperature allowed by law in a pet shop. We have not done the same for our students and our educators. So I urge you all to look at that important issue as you prepare to move forward.
Well, you know, Lou, we always treat our pets better than we do ourselves.
I'm guilty of the same.
And as long as you're at it, I think we should add the legislative office building to this, because I think we let the temperature go way too high there. It's always like 73 in my office, which is tremendous waste of energy.
The Capitol would be nice too, Mr. Chair. It's always freezing in there.
You're freezing and I'm overheated, so maybe we can't find an accommodation. But thank you for your testimony, Lou. We look forward to your helping us find the right standards and the right criteria.
Thank you all for the incredibly important work you do for our state.
Before I hand off to Senator Anwar again, I will introduce Debbie Osborne. And before I do that, I don't want to alarm you, but there's a very large person behind you that you might want to be concerned about. Oh, okay. Welcome, Deb.
You're muted.
So thank you, Representative Steinberg, for that. I appreciate that. And I have a very windy backyard where trees are coming down behind me. So if I seem a little bit shaky, it's because any moment now I think that there's going to be a tree on me. So hello, everyone. Senator Anwar, Representative Steinberg, and Representatives I see Pettit and Tershak. So wonderful to see all of you here today and other distinguished members of this committee. For the record, my name is Debbie Osborne. I am here in strong support of Senate Bill 449. I'm the executive director of 4 medical specialty societies which specialize in dermatology, ophthalmology, otolaryngology, which is our ENT physicians, and urology. I've worked for these organizations for over 27 years, during which time I have seen seismic shifts in healthcare due in part by both federal and state legislation that have affected the quality and access of healthcare. I want to thank this committee because I know it's been a long day and you have a lot more people to testify after me. You have a lot of important issues out there, but I wanted to touch base on not just the specifics of this bill, but the fact that there are other issues in healthcare, other elements that would greatly improve the for physicians the ability to practice and keep their doors open in Connecticut. Some of you sit on the insurance committee, and I want to briefly talk about the high deductible situation out there that, you know, as this bill moves forward, I think that these are important things to consider. We strongly feel that the insurers and not the physicians should be burdened with this administrative cost of the high deductible plans. They've created these plans, they have sold them to the employers, and they have shifted all of the risk onto the backs of the healthcare providers out there. That's the physicians and other behavioral health people out there. They have the resources, they have the retained earnings to, and quite frankly, they are the better administrators to this. So we're hoping that the risk is put back and the administrative burden is put back on the insurers and not the physicians. Another piece of legislation that would greatly help improve the climate out there for physicians to practice in is the ability to get a reasonable prior authorization in a reasonable amount of time. 15 minutes is not a big ask for a provider today to ask for that they can get prior authorization in 15 minutes. Currently, they're waiting between 45 minutes and 2 hours for a prior authorization. And then even once they obtain that prior authorization, they are not guaranteed payment. So what happens is they usually are denied even after they get prior authorization. They have to go through an appeals process that delays their payment up to 60, 90 days of getting paid. So the physicians right now are seeing these high receivables out there. They're trying to pay their staff. I've had doctors call me and say, Debbie, I can't even make payroll this week because my bills are all tied up in, my monies are all tied up in receivables. You're going to hear from many of my doctors today talking about their individual practices and their struggles, but there's so many things we can do out there, even on the tort reform issues. We had a case most recently within the last 4 years where the provider pre-judgment, his personal assets were attached. He couldn't use his personal checking account. This happened to the nurses in behavioral health. That sends a chilling effect across the medical community. Why take some of these serious cases if their personal assets are going to be attached pre-judgment? So there's things we can do to protect our behavioral health providers, our physicians out there, our nurses, that they don't have that fear out there that their personal assets are going to be attached. Most recently, 2 years ago, we had language changed by the plaintiff attorneys that, if that would allow them to go after a physician who did not report in good faith a child abuse or domestic violence case. So now we have 4 cases involving physicians that they're being sued because they didn't, in good faith, know that, this particular case or patient of theirs was a child abuse case or domestic violence. So now
I'm sorry, Deb. I'm sorry to interrupt, but you need to summarize.
No. I get it. And I want to open the floor because I want to talk about all these other things, but there are so many things out there that we can do. In 2018, we raised a bill similar to this to put this into a task force. It passed through your committee. It went to Judiciary Committee and it stalled. So we're beyond the point of just doing a study. We've got to take action, and we can do small little things to give support to these providers that were here for us during the pandemic. They kept their doors open. They took risks, tremendous risks. And, you're going to hear testimony about how many jobs they support. And, I can go on and on, but I'd like to open the floor up to any questions there might be out there.
I'll start. Thank you so much, Debbie, for your testimony. This is going to require the challenge that we are facing did not happen overnight. It's been going on for many years, and then we have sort of created an environment in our state which is resulting in major obstacles for anybody who's in as a physician to stay in this state. Do you have a list of all the recommendations from some of your specialty organizations? And the reason I say that is that there's a lot of conversation on primary care, rightfully. I mean, that's going to be the most important thing going forward. But as Representative Steinberg was talking about, the fact that specialties will need help as well. Right now, all your specialists have gone through formalized training, as opposed to others who just one day say, oh, I'm a specialist in this without training. So that's why it's critical to have well-trained specialists in the various fields. Do you have specialty groups recommendations for keeping them in our state and recruiting more?
Thank you for that very good question, Senator Anwar. We do. We have a list, big and small. And it starts with, we have some wonderful things in Connecticut. And one of those things is the DPH has a scope review process. We can vet a lot of the, scope issues through that department. And we do it in a meaningful way that everybody can vet their issues. We worked hand in hand with the APRNs. We testified, in that, those hearings in the DPH, and we came out with legislation that we now have in place. So that system does work, okay? There are a lot of small little bills that we don't think are really important, but they have just made tremendous changes in the way physicians are able to practice medicine. I just want to give you one quick example. Dr. Emmel, who is the legislative chair for the Connecticut State Medical Society, he started out as independent practice. He's a fantastic physician. He had 10 people working for him by the time he retired. Of those 10 people, about 6 of them were just used for administrative stuff, prior authorization, step therapies. Every time he'd write a prescription, they have to go, jump through this hoop or that hoop to get to the prescription that he really had to have this patient on because of the inactive ingredients. They may have had allergic reactions, but it was he that should be responsible for making those medical decisions. Okay, he is the expert here. And so when the insurers put into place these procedures and these hoops for physicians to go through, it takes more of their resources and takes them away from treating patients. That's why we have, a problem seeing, it takes us 8 weeks to get patients in. When he had to leave private practice and through the pandemic, he did not take any salary. All he did with his receivables was pay his employees so that they will continue their jobs. That is so important to understand what our physicians have been through in the last 2 years. And they're going to be continued to go through situations like this. And we have got to figure out ways that we can help support them. When he left and he joined a bigger practice because he could no longer, he didn't have the means to combat all the insurers and all the, the tort reform that was needed. He left to go to a bigger practice. Of his 10 employees, none of them were absorbed by the new system. So if you think about this, physicians are responsible for 51,000 direct jobs, not to mention the 122,000 jobs out there that they are attributed of giving as well. That is a huge number that they are helping support this state with jobs. And they have all of the, the administrative burdens that are placed on them, the CON issue, that they're looking for other revenue streams to help support their medical practice, keeping their doors open. The forgiveness of loans, that's a great first step, but, we can look for other bills that will really help maintain the quality in our healthcare delivery system. So I can provide you all with a list of the bills, big and small, that would definitely make Connecticut more attractive to retaining those.
I'm sorry to bother you again, but you need to summarize. Thank you.
That was a question.
Okay, thank you. All right. And it's an unrelated quick question, a very short one. What's the ophthalmology organization's position on the 3 to 9? You guys have not spoken anything about that. I've heard from optometrists, I've heard from opticians, and I haven't heard from your organization.
So that's a very good question. And, I am so proud of my guys because they are really trying to involve themselves in the really big pictures of healthcare. These guys are, supporting the behavioral health, which I would have liked to have testified because I just lost 2 years ago my nephew to the opioid crisis. And, I have some really interesting thoughts on that. But we will tell you this. We support quality. I understand what Representative Steinberg has talked about. The other states are doing this, but we cannot not afford to support those trained individuals, those opticians who really provide a tremendous service for our state. And I will tell you that the ophthalmologists that employ opticians, when they are out, their optical shop is closed. And the patients realize it's okay that they have to come back. Okay, so, that they aren't going to veer away from quality or putting some medical assistant into that role to provide those glasses because, the people that walk in have a expectation that they are going to get somebody who understands their needs. So that is the reason.
Okay. Thank you so much. That's very helpful. I mean, you're not supportive of the bill, is what I meant. Thank you so much for your testimony. Seeing all the comments or questions, we will move on to the next person on our list, which is Ms. Tina. Thank you. Thank you so much. Tina Yates.
Good afternoon.
Hi.
Hi, good
Good
afternoon, Senator Anwar. Thank you so much. I apologize for being in my car. I assure you I am not moving. My name is Tina Yates. I am the president of the Connecticut Association of Residential Care Homes, also known as CARCH, and the administrator at the Ywca Huntington Home. On behalf of CARCH, thank you for the opportunity to offer testimony in support of Senate Bill 453, an act concerning the Department of Public Health's recommendations regarding transfers and discharges of residential care home residents. CARCH has been in discussion with the administration, including the Office of Policy and Management, Department of Public Health, and Department of Social Services, along with other parties, including the Long-Term Care Ombudsman's Office, for several years on how to ensure our model of care could be considered a home and community-based model under federal regulations. And CARCH, OPM, DPH, DSS, and the Ombudsman's Office are all in agreement with the language in this bill. After much negotiation and compromise, we feel this language strikes a balance in ensuring that there is a functional and transparent involuntary discharge process. The legislation provides residents with the right to now appeal an involuntary discharge process to the Superior Court. Despite our concerns that this could lead to some legal costs by improving the process of the department, we hope the additional clarity for homes and residents on what the process entails and more cooperation in ensuring the best interest of the resident and all the residents and staff in the home. This change will help ensure that residential care homes will meet the settings requirement as part of the home and community-based care settings waiver. About 10% of our residents are currently on the waiver, and the hope is that this will allow additional residents to gain those waiver services, which may include a variety of services from personal care to adult day programming to medical services. By way of background, most residential care homes are a small communal arrangement averaging about 24 beds, with most bedrooms being shared and often shared bathrooms. It's a congregate setting with meals and other activities done together. The great majority of our residents are low income with a mental or subcommunity, and one disruptive resident can have a hugely negative impact on the other residents and the staff. Our residents are not living in a private apartment, so the involuntary discharge process is unfortunately necessary when residents jeopardize the health and safety of our other residents or staff. Residential care homes do not want to involuntary discharge residents, only try to do so in serious circumstances are warranted. We would recommend you advance Senate Bill 453 with the current language to clarify the involuntary discharge process and ensure that residential care homes qualify as a home and community-based setting. Thank you for your time.
Thank you so much for your testimony, and thank you for your time. Do you have a written testimony which has the recommended changes?
We submitted written testimony supporting the language that's currently in the bill.
Okay, perfect. This is helpful. Thank you so much. Seeing no other comments, we will move on to the next person on our list, which is Barbara Fair.
Hello, my name is Barbara Fair. Good afternoon, Senator Anwar and other distinguished members of the Public Health Committee. I'm a West Haven resident and a licensed clinical social worker, and I'm here to testify in strong support of Raised Bill SB 448. And I want to first commend the women of Hartford's Ywca for the efforts that they put into this bill to at least call for independent oversight over DOC healthcare. Right now, Connecticut is the only state that doesn't have oversight over their healthcare, and it's one of the very few states that has oversight period over DOC. There's been countless lawsuits, and that was talked about earlier, so I won't even talk about that. And I also was thinking about people like Karan Neely and Robbie Talbert, who lost their life at a very young age inside DOC. I was going to talk about Tiana LaBoy, but I see they've talked about her, and I guess she has her mom's going to be here. So I won't waste my testimony talking about them, but I do want to talk about this one kid that wasn't mentioned, another 19-year-old, Jamari Taylor, who died in his cell while he was desperate. His cellmate was desperately calling for help because he had problem breathing. And a video showed that there was 2 guards that were just kind of leisurely walking to the cell to answer the call. And in the meantime, this young man died. And so to hear that these young people this age losing their life needlessly when they should still be here is just very sad and troubling to me. A recent Freedom of Information report that we received revealed 282 people have died either within the facilities or soon after leaving the facilities and community supervision. That shouldn't be happening. Many of them are dying from chronic disease like cancer, cardiovascular disease, drug overdoses, suicide, which is really troubling that people are committing suicide within the prisons and some within like less than 6 months after they return home, which shows how that pain and trauma of incarceration is following them home. We look at the fact that 28 people died during the COVID pandemic. So it just tells me that DOC does not have the ability to provide quality care for incarcerated people during a health crisis. I have talked to people who, some work in DOC now, some used to work in there, some people have gone there and left. And I asked them what were the reasons, the top 3 reasons why, people don't want to go to DOC. And they were saying that it's the wages that don't compare to private sector. They talked about the toxicity in the environment and how it impacted their lives. And they also talked about the fact that they felt that the policies and the behaviors that were going on behind the DOC were things that actually challenged their code of ethics to do no harm. And so some of those people left, and they don't talk about this. And these are some of the things that I think that can help with getting quality people inside of DOC, but I think it's going to take a transformation of the prison culture. One of the speakers before talked about the, okay, I'll wrap it up.
Thank you.
I'll wrap it up. One of the speakers talked about just the fact of that we call people inmates. And I think I would love to see that transformation just in policy, that we call people incarcerated people, because to call them inmates diminishes their humanity, and it makes it easier for people to look at them in a different way and not really care about how they treat people. The same kind of thing when African people were in slavery, instead of saying African people, they called them slaves. It diminishes their humanity and then allows them to treat people in different ways and be able to live with that. So I'm gonna stop my testimony here because I did submit testimony, but I'm hoping that this committee will adopt SB 448, and I strongly support that happening, and that we don't put it off for years to actually get the work done. It's desperately needed now.
Thank you, Ms. Fair. Thank you so much for your testimony. I found it very useful. Can you expand a little bit about the culture of toxicity and the culture for the workforce to come and work in the Department of Correction? What do you mean by that?
It's mainly, and I say this coming from people that I know that went in DOC. One particular one said she went in, she thought it was a wonderful job. She actually thought it was a great job, according to the wages and the benefits. But then she said she was a nurse, and she said the way she had to treat people went against her code of ethics. And she said it just made her so uncomfortable, and that's why she left. She said she was not allowed to provide compassionate care. And so that's something that she just couldn't live with. There was another one who was on our committee who was a counselor, and she said the same thing. She actually left because she said the environment got too toxic for her. The things she had to see and witness, and it traumatized her, and she left there, and she now suffers from PTSD. So those are the kind of things that people say make it hard for them to work inside of DOC. And that's why I think the most important thing we can do right now to make things better is to change the environment that people are in. People go in there, they want to provide good care, but they want to be able to be, give compassionate care and not have to follow some of the DOC policies that says discourages it.
Thank you so much, Ms. Fair. Seeing no other questions or comments, we wanted to thank you for your testimony, and we'll be looking at the details and adjust the language accordingly.
Senator Anwar, can I just add one comment, just one comment? And because I want to respect the Commissioner Quiros right now, because these problems, like many people have said, didn't start with him, but I think it can be, the process of change can begin with him. So thank you very much.
Well, thank you so much. Next person on our list is number 61, Ben Shaken. Hi, Ms. Ben, how are you?
Hi, how are you, Senator? Good afternoon. Thank you for having me this afternoon. My name is Ben Shaken. I am the Director of Government Relations at the Connecticut Community Nonprofit Alliance. We are the statewide association of community nonprofits, which, as you know, provide essential services in every city and town in Connecticut to 500,000 Connecticut residents. I am here on one bill, primarily with brief comments on a second bill, and that bill is Senate Bill 375, an act concerning telehealth. I want to say, first of all, I appreciate the intent of the bill, which is to extend the telehealth provisions that the legislature passed last year, which are set to sunset next year by 1 year to 2024. We are very supportive of that bill that passed last year. And I would like to respectfully submit to the committee that instead of simply extending those provisions for 1 year, that you eliminate the sunset entirely and keep those provisions in statute in perpetuity. Public Act 21-9, which is what the legislature passed last year, essentially in very broad strokes, does three things. First, it pays for telehealth at the same rate as in-person visits and allows for its services to be delivered from any setting. Two, it allows for telephonic and audio-only telehealth sessions. And then finally, it allows the use of any HIPAA-compliant platform to deliver telehealth, all of which are extraordinarily important to community nonprofits who have been providing behavioral health services to Connecticut residents throughout this pandemic. While we appreciate that this issue is one that needs some study, we also know that these services are working. This is one of the things that came out of the pandemic that is providing good service to our residents, even after people have become more comfortable returning to healthcare visits in person. And then with the remainder of my brief time, I just wanted to offer some brief comment on House Bill 5480, which is an act concerning the accessibility of mental health services. This bill would allow doctoral psychology students to practice under the supervision of a licensed psychologist and while they're still in school. And we're supportive of the concept of this bill, but I just wanted to flag a note of concern, which is that as drafted, our read of this bill is that it would allow those students to practice under the supervision of a psychologist in any setting, including private practice. And while the testimony on this bill is correct that this is a thing that's afforded to many other behavioral health students, master's level clinicians, et cetera, that those supervision, those sort of working under supervision are restricted to clinical settings, not clinical settings, excuse me, to facility settings, to clinics. And our read of this bill is that it would be pretty pervasive and would allow for student practice of telehealth services under the supervision, perhaps of a psychologist across the country. And so we just want the committee to make sure they take a quick look at that and make sure that that we are both allowing for better access to mental health services through psychology students, but also that we are doing so with appropriate sort of protections for people who are receiving services, as well as an adequate workforce for the community providers that often rely on these interns and other sort of people working towards licensure to fill their ranks. So thank you very much for your time this afternoon and for your consideration of these important issues. Happy to take any questions.
Thank you so much, Ben, for your testimony. We have noted all your concerns. I'm seeing no questions or comments. I wanted to thank you again for your testimony. Thank you.
Thank you. Have a great day.
You too. Next person is Skip Rivard with the Connecticut Opticians Association. Hi, Mr. Rivard.
Good afternoon, Senator Anwar, Representative Steinberg. It's been a long day, members of the committee. So thank you for listening to me. My name is Rene Rivard. I go by Skip. I've been before this committee years ago but never like this, never where we're looking at pictures on a frame. We're going to be back looking at you at a table soon, I hope. Anyway, I've been a practicing optician for 51 years. I retired after 36 years of teaching opticianry. I've been an instructor in contact lenses at Yale. I maintain a private practice in contact lenses and formerly ran 10 optical shops in Connecticut that were privately owned. But today, I'm here to speak to you as Executive Director of the Connecticut Opticians Association on SB 329, which, as you may have guessed, we are opposed to. You know, I've listened to a lot today, and I have a prepared testimony, but I'm not going to read that because you're tired. So let me tell you a little bit about what it's all about. Opticians and eyeglasses have been around for a long time. But in 1935, Connecticut decided they had to be regulated. Technology was much different than it is now and much more simple. But yet Connecticut was the first state in the country to license opticianry. And that's because they felt there was a need to protect public health, welfare, and safety, and to separate it from the optical shops that used to go with bags going door to door to deliver eyeglasses. Since that time, we've had optical shops come and go. We've had corporate opticals come in and try to change our laws. But in the end, everyone learned to play by the rules. And that's what we're talking about here, is businesses playing by the rules. What advantage is there to the patient to have online eyeglasses or a frame showroom? I'll show you that in a minute. But over the years, technology has changed. Methods have changed to sell or distribute eyewear to the ultimate wearer. But what hasn't changed is the need to protect the public, just to fit the business model of an out-of-state corporation that's seeking profit rather than protect the public. Let me show you a little bit, if I can. This is a pair of glasses. This is a pair of glasses that was ordered online. The patient came into me with difficulty with it. Now, just looking at me, you can see one side I'm magnified and upside down, and one side I'm right side up. This pair of glasses that was manufactured is a travesty to what opticianry is all about. One prescription is a very strong, what we call plus prescription, which magnifies. The other side is a very strong minus prescription, with minifies.
Excuse me, Mr. Rivard, but your time is almost up.
Uh-oh.
Please.
So very quickly, the difference in this prescription is 10 diopters. And when this patient put the glasses on, you can see how one side magnifies and the other side doesn't. She was unable to wear them. There was no quality control. There was no testing on this product. There was no measuring for PDs. And you've heard a little bit about PDs, and if you have questions, I'd love to answer those for you. Opticianry is a profession. Eyeglasses are a medical device. They're not a commodity. They're not a commodity, and this is how it's being approached with this new business model. So if I can wake you up and you have any questions, I'd be happy to answer them in detail.
Thank you so much for your testimony. We were awake. We were looking at you and the glasses, and I was feeling dizzy, and I was saying if somebody else has
exactly. Dr. Pettit put his back on.
And I woke up when you said Connecticut is a country, because there are a number of people who feel that way too. So that's
opticians. It's an optician's country.
Do you want to talk about the PDs in like
well,
short...
PDs, if you can. I'll go back to this pair of glasses. There's a point in this pair of glasses that has to be lined up directly with the pupil of the eye. And even on the strong one, has to be lined up directly with the pupil. If it's off a little bit, Dr. Aceto alluded to this, if that center is not properly lined up, if it's out a little bit, the eye will turn out. If it's off in, the eye will turn in. It only has to be off, in this particular pair of glasses, 1 millimeter to cause this prism that will deviate the eye. And if both of them are off going in, the patient's eyes will turn in. and they adjust to it. They adapt to it. Now, this PD that we talk about, many people think it's not critical. You can go online right now and you'll get instructions how to measure your own PD by taking a credit card and holding it up to your face and doing a selfie. And comparing the measurement of that credit card to your eyes, they'll determine your PD. However, it's critical that the PD be measured from the center of the face to one eye, center of the face to the other eye, not with a credit card. It also has to be evaluated by the optician, not only horizontally, but vertically. And if it's off too much vertically, the eye will turn up or turn down. And if they're in opposite directions, the eye have a tendency to turn this way. Oftentimes, patients won't get used to them, but they wear them long enough and the eyes will adapt to them, or else they throw them in a drawer and forget about them.
Thank you so much. Thank you.
Love to give you a course in optics, but that's 2 years.
Well,
thank you.
We got started. Just final question: which credit card do you prefer for the?
It's got to be the new black Amex.
Okay. All right. Stay well. Take care. Next person on the list is Chris Grimm.
Chair Abrams, Chair Steinberg, Vice Chairs Anwar, Kushner, and Gilchrist, ranking members Huang, Somers, Pettit, members of the committee. Thank you for the opportunity to testify in support of Senate Bill 329. My name is Chris Grimm, testifying on behalf of Warby Parker. Before getting into my testimony, I want to request the committee consider an amendment. While an optical retailer should be able to remain open during a licensed optician's unscheduled incidental absence, a store should not be able to sell optical glasses or kindred products or other instruments to aid vision that are produced or reproduced to personalized given formulas or plano cosmetic contact lenses. That is language directly from the statute, and Warby Parker is not looking to change what can or cannot happen when an optician is not on site in the store. We just want the ability to remain open. Again, but not engage in the regulated acts. We heard a lot of testimony about the dangers and issues of, I'll use the term dispensing. That's kind of the general term in the industry for selling prescription glasses. It's not a term in the Connecticut statute, but essentially a lot of the testimony has been concerns with dispensing when an optician is not on site. That's not what we're trying to do. That's got nothing to do with our business model. We're just seeking the opportunity to keep the doors open, provide signage that an optician is not on site, but not engage in those regulated acts. So I want to make sure the committee understands that. We have amendment language that can address that issue, and we're happy to continue to discuss it. We've worked over the past 12 months with the stakeholders to address their concerns. The other big concern that we've heard a lot about is this concept of a kiosk opening in the state where someone could try on frames for purchase online. That's not our intent. And I want to highlight two issues for the committee. Anyone, anywhere in the state can purchase prescription glasses online. Every member of the committee can pull out your phone and go to over a dozen different websites, probably even more, and purchase glasses online. Quality varies like everything else. Some of these companies are based offshore. Others do not meet the same standards that others do. Warby Parker meets very, very high standards on our e-commerce business. Secondly, nothing in the statute prevents this from happening currently. I want to say that again. Nothing would prevent that from happening currently. The laws in Connecticut are around the activity of dispensing, those regulated acts that I enumerated earlier. If a store is not engaged in those regulated acts, you could set up a storefront tomorrow, Senator Anwar, if you wanted to, have people come in and try on frames, and they could purchase them online because you're not engaged in dispensing. So this bill would not allow that to happen because it's already allowed to happen and is not currently a widespread practice. With our requested amendment, the bill would not allow dispensing without an optician. The language that we're adding at the bottom of the bill that's already in there would prevent this so-called kiosk model from operating, because in order to be an optical, in order to have an optical selling permit, and that language would require someone operating on a kiosk model to have an optical selling permit, the store either needs to be owned by or under the supervision of a licensed optician.
Excuse
So
me,
that
Mr.
language
Grimm.
would prevent this kiosk from happening. With our amendment, we think this would be, fairly straightforward and would bring Connecticut in line with 48 other states that allow optical retailers to remain open, but not dispense when the optician is not on site, including North Carolina. And I'm happy to answer any questions.
Thank you so much for your testimony. Some of the individuals from other states had actually testified as well, Mr. Grimm. You're the only one who's been in favor of this bill so far, and pretty much everybody else who's spoken has been against it. And even individuals where the states where this is happening had raised some concerns. So again, the issue comes down to is that would you have an online presence in future? Is that what the long-term plan is? Would you have a telehealth with somebody sitting in another state and an optician working in that capacity? Is that one of the business plan?
So the telehealth issue came before this committee a number of years ago. There are regulations on how to do telehealth for Connecticut residents for contact lenses. Glasses were carved out of that bill. So there are less restrictions on telehealth for glasses currently than there are for contact lenses, which would require an in-person examination for an initial contact lens prescription and then a second follow-up prescription. I worked for a different company then and worked really hard on that bill, which was a very contentious fight. But I believe that was a really good compromise. As to the folks from other states, again, I believe the issue that they had was with the way the bill was drafted, which would allow for dispensing to happen when an optician is not on site. And the woman from North Carolina, said that we don't do this in North Carolina. And she's right. You cannot dispense in North Carolina if the optician is not on site. However, the store can remain open, just like a pharmacy, right? I heard a lot of talk about pharmacies. Everyone here has gone into a CVS to purchase paper towels or laundry detergent or Easter candy or any other item that is not a prescription item when the pharmacy counter was closed, and or been in a Costco and the optical counter was closed, but non-prescription sunglasses are available for purchase by the checkout counter. Cases for glasses and lens cleaner are available for purchase. That is a proven model that works in other states. It works in Connecticut in other industries like pharmacies, where you're just restricting the regulated act. In a pharmacy, you can't dispense pharmaceuticals when the pharmacist is not on site. In an optical retail store, you should not be allowed to dispense glasses when a licensed optician is not on site. It doesn't mean that the business needs to be closed. It doesn't mean that we can't sell non-prescription sunglasses or gift cards or lens cleaner or any of the other things that you can purchase on the other side of the optical counter at a big box store or at a Sunglass Hut that's right across from our location in one of the malls there in Connecticut.
Thank you so much. I see Representative Steinberg has a question or comment.
Thank you, Mr. Chair. Thank you for your testimony today, Mr. Grimm. I remember that contentious conversation with regard to telehealth some years ago. Actually, it was that conversation that kind of put us off telehealth for a number of years. And it's only ironic that it took a pandemic to get us back on considering telehealth. That's how concerned we were about the sale of contact lenses over the internet. We had real issues with the tools, the diagnostic and prescriptive tools that were being used online. And yes, we did not put the same restrictions on glasses because we were much more concerned about contact lenses for the reasons mentioned by some people who testified earlier, that, yeah, you're putting that directly on the eye, the potential for bad outcomes is even greater. But that does not reflect any lack of concern or sensitivity to making sure that eyeglasses are also safely prescribed and dispensed. And that's why we're having this conversation today. I take your point that there are some analogous circumstances to a pharmacy or to a big box store, though I would say they have a much broader range of other merchandise for sale that has no relation to sort of the primary business. Whereas in your case, you were selling almost exclusively products that are related to the eyes, if you will. And our concern, or at least my concern, is that we are obliged to kind of trust you that you're going to adhere to the rules if we make this possible. That enforcement is truly problematic. And I'm sure it'd be very tempting once you've got somebody to be interested in buying a pair of frames and they want to seal the deal, conclude the purchase, get a complete set of glasses and go home, to want to do that for them. And I know it's much harder to tell them, you'll have to come back, you'll have to find another way to get it done. But today, at this moment, we can't complete your total sale for you because our optician is not on premises. And it makes me nervous. It makes me wonder whether we can come to any accommodation that will give me confidence that this change in the law will not lead to some abuse or bad outcomes. And that's really what we care about here. Can you reassure me in any way?
So, you know, all I can do to reinsure you is say that the penalties for violating this statute are very stiff. They carry criminal penalties. I don't know that anyone that works in a Warby Parker store, any store manager or anyone else would risk a criminal penalty to close on a sale of a pair of glasses. I also think that allowing the store to be open is not creating any greater risk of someone breaking the law. Because if someone's going to break the law and complete that sale on a pair of glasses, they're probably got their front door open now anyway when the optician is not on site. So I don't see any greater threats being introduced here by allowing for this very narrow exemption to when an optician needs to be on site. The penalties are incredibly stiff. Like I said, they're criminal penalties. So we're talking about possible jail time for violating the statute and fines in the thousands of dollars. So, you know, it's worked well as a deterrent, I think, so far for companies to not break the law, which would currently allow them to have their door open. And I think that same deterrent would carry over to finalizing a sale.
Thank you for that. And I would strongly recommend that if you have data from the states in which you currently operate that speak to your safety record and the actual outcomes, adverse outcomes, I know that may not be a perfect piece of data because there's a certain amount of self-reporting involved, but I think that would be helpful for us to understand, put in context, the very serious and potentially alarming testimony we've had today about potential bad outcomes.
Of course, and happy to do that. You know, the incidence of, you know, returned items or prescriptions not matching, to my knowledge, is no greater in any other state than it is in Connecticut. And again, I appreciate the testimony from the opposition. Again, the way the bill is drafted would allow for far more to happen when an optician is not on site than Warby Parker would like to engage in or feel comfortable engaging in or would support in legislation. And that's why we've asked for that amendment. And I think if that amendment was adopted by this committee, you know, if the bill moves forward, along with the language that would close that kiosk loophole that currently exists, I think that goes a long way towards both protecting Connecticut residents and sort of updating the statute to sort of allow for this type of activity, again, which would just be keeping the door open, but not engaged in regulated acts.
Thank you for that. And we appreciate the fact that you're interested in actually making this legislation more rigorous. And if that's part of your submitted testimony, we'll take a close look. Thank you, Mr. Chair.
Thank you, Mr. Chair. Representative Burgers-Rallo.
Thank you so much, Mr. Chair, and thank you so much for your detailed testimony. I really appreciate it. I just want to, I'm just seeking a little tiny bit of clarity in your open but not dispense. I would just love for you to define dispense if you could for me, because I'm curious, does that include both ends of the transaction? So when you use your prescription to place the order and when you come back and try on and pick up, or does dispense end at the ordering process in terms of having someone there in order to complete that dispense portion?
So that's a really good question. The current statutory definition is selling optical glasses or kindred products. And the rest of that definition that I read out at the start of my testimony. So there's probably some interpretation there on what constitutes selling. Again, I would maybe look to how pharmacies are regulated, right? And what the definition of selling prescription drugs might be. There are probably some other good examples that are out there, and we can look at other states. California is a state that we looked at for an early draft of this bill that has language about these unexpected incidental absences by a licensed optician. So I'm not fully sure how to answer the question because the current statute is pretty vague. It just restricts the selling of, essentially prescription glasses or prescription contact lenses or cosmetic contact lenses are the three products that are enumerated in statute. So it may require some statutory cleanup to better define what constitutes selling glasses and what constitutes the regulated act, right? If that would include measuring pupillary distance, I think that would make sense. And final fit when a patient comes to a store to pick up, I think would make sense. So there's certainly a lot of room to enhance that and make it much more specific. Working within the confines of the current statutory construction, though, it's really just focused on the selling of these prescription items or cosmetic contact lenses.
And correct me if I'm wrong, it sounds like you would be in support if that were tightened up to include final fit or whatever language around like that. That doesn't seem like something that you would be opposed to.
I don't think so. We'd have to work through, specific language and obviously look at it. And I'm not a lawyer. I just play one in real life, so we'd have to run it by the real lawyers. But in concept, I don't believe that's problematic.
Great. I really appreciate that, especially that part where you kind of stretched to guessing on my hypothetical. But thank you very much, and thank you, Mr. Chair. That's all.
Thank you. I do not see any questions or comments. Thank you for your testimony, and we will move to the next person in line. We will move to Dr. David Boisno first, and then we will come back to Debbie Chisholm after that. So, Dr. Boisno, thank you so much for waiting, and go ahead.
Thanks. Thank you. Good afternoon, Senator Anwar and Representative Steinberg and the other distinguished members of the committee. My name is David Boisno. I am a board-certified ENT practicing down in southeastern Connecticut. I'm past president of the Connecticut ENT Society. I've testified in front of this committee in the past, and I represent over 800 physicians and surgeons in the state in the specialties of ENT, ophthalmology, dermatology, urology. We support any legislation that will help recruit and retain physicians in Connecticut, and that includes SB 449. So today you have been or will be hearing from many of my colleagues from the above societies. Their presence today, whether in written or oral form, speaks strongly to the importance of this bill and the concept it advances. We, as physicians, appeal for immediate help. We're struggling to keep our practices independent. There's large for-profit organizations that are reaching into the very heart of private practice medical care. We've watched practice after practice succumb to the grip of these private ventures. Our practices have struggled under the burden of increasing regulations, insurance bureaucracies, etc., just impeding our ability to provide employment for our staffs, especially during this critical time over the last 2 years with the pandemic. This is not the first time the committee has heard about these provisions to our statutes to help attract physicians. And as Deb Ogburn mentioned earlier, many of you will recall in 2018 that there was a bill that came before this committee asking for a task force to study this very issue. The Connecticut State Medical Society provided a lot of insightful testimony at that time. We say that the future of medical care is in jeopardy in the state of Connecticut unless we did something to recruit new physicians in the state. Well, that was about 4 years ago, and the future is now. It's not gotten any better, it's gotten worse. We ask you to consider some of the following points that underscore the importance of the economic contributions that private practice medicine has on the state of Connecticut. We provide over 12 jobs per each physician is accounted for by each physician in the state, which is up about 80% since 2000. Now, I'm sure, that's a lot of that is bureaucratic regulatory need, but each physician on average in the state of Connecticut needs about 12 other jobs to support his or her activities. Physicians provide over 51,000 direct jobs. Also to consider is the aging of providers in the state. And with that, the impact of the lingering pandemic that has forced many experienced physicians to opt out for an early retirement, which is what in fact happened in my practice over this past year and a half. My two older partners opted out of continuing their practice. They were close to retirement, but the pandemic pushed them through quicker than they thought they were going to want to. So the economic contribution will be further highlighted by the Connecticut State Medical Society, but just some quick demographics that I found alarming in the state of Connecticut. About over a third of Connecticut physicians are 60 or older, but only about 2,000 or so are under 40. And that gap is widening. We're getting older and not enough younger coming in.
Excuse me,
Nationally,
Dr. Listino, your
yes.
time is almost up if you'd.
Okay, no problem.
Thank you.
Thank you. The points are, and they're outlined in the legislation, that anything we can do to help keep physicians in the state of Connecticut is welcomed, whether it's big, small, in the middle. We're open for discussion, and thank you for your time in this important matter.
Dr. Boisno, you were going to share some data. Please go ahead. I wanted to...
Yeah, I was going to say that, I got to find it first, that we expect a nationally projection by the year 2025 about 100,000 doctor shortage across the United States. And specifically in Connecticut, when we ask the UConn and Yale residents about why they're not staying, retention is an important aspect of this. We have two very good medical schools, 3 medical schools and residency programs in the state of Connecticut. But we are ranked 43rd in the country for medical school retention in our state. And there's got to be room to improve that. So I thought that was just statistics that particularly jumped out to me, that we're only retaining 43% of, we're ranked 43rd in the country of keeping the doctors that we train here in the state. That's all I got for.
Thank you so much.
Sure.
Yeah. And can you tell us about trying to look for a partner and how long it takes to try and recruit an otolaryngologist?
Well, I'm in the middle of that now, so I can tell you that it's already taken about a year. We have put out a lot of feelers, and I'm part of a lot of national societies, so I'm networked throughout the nation, and we're coming up empty. We're getting a headhunter and doing that kind of approach is the next for us. We're a private practice, and that's really, we don't have any support of any large institution to help us do this. We have to do this on ourselves, and that's expensive. We're learning about how expensive that is right now. So again, we're a 5-person practice covering an entire hospital. We're a 3-person practice covering an entire hospital in southeastern Connecticut, where we're really need to be a 5-person practice. We do have a physician assistant, which is helpful, but they can't perform surgery and take call and take care of the emergent issues that we have to take care of. So there's a need. We hear a lot when I go to national meetings that Connecticut, it looks like a great place to live. We'd love to come live there, but there's a cover charge to come into this state. It's an expensive state to live in, as we all know. High quality of living, but a high cost to attain that quality. We have a difficult tort environment in the state of Connecticut. That doesn't go ignored by residencies and medical schools across the country either. So those combination of factors sort of is a perfect storm, unfortunately, right now. And unfortunately, it's only going to get worse. So we all are strongly in agreement of anything that we can do to start task force or keep the conversation going.
Thank you so much. I see our ranking member, Senator Summers, has a question or comment. Please go ahead.
Yes, good afternoon, Dr. Boisno. Nice to see you.
Hi there.
And I would also like to thank you. Dr. Boiseneau was kind enough during our COVID vaccine informational sessions we had repeatedly. As somebody who sat on that task force, Dr. Boiseneau was kind enough to participate in that so people could hear directly from an ENT who actually had COVID himself, the importance of the vaccination. So I appreciate that. But I wanted to see, after you looked at this bill, you know, everything that you touched on, I hear directly from my husband that took over a year to add another heart doctor to his practice. And are you seeing huge burnout? I know they are, with being overworked, understaffed, and some of the folks that are on the verge of being able to retire are pushing, saying, I'm done, I'm out, I can't work at this pace any longer. You know, we don't have enough doctors. Even if they're not in a private practice, the larger institutions are obviously concerned about costs, and it's really hard to recruit somebody here. So those who are left behind are carrying really large patient loads, and the burnout rate, God forbid, you know, somebody go on maternity leave or sick, is really immeasurable. And we're seeing more and more people opt to leave or retire early.
Yeah.
Can you think of anything in this bill that you would add to help enhance the recruitment of physicians? You know, I've heard too, you know, the younger folks or, you know, the residents that are looking for full-time positions, Connecticut's not one that they look to. You know, many of the physicians that I know came here kind of out of default because maybe they married somebody from here, or, you know, they knew somebody here, but it wasn't like they were choosing to come to Connecticut. And I also think that we need to look at the investment we're making in our own medical school here. I know you're a UConn grad, I believe, or med school, that, you know, what kind of return of investment are we getting as taxpayers if we graduate these people from our med school and they're all leaving Connecticut? So is there anything that you would add to this bill to try to help Connecticut be a more physician-friendly state?
Well, yeah, no, you hit the nail on the head with everything you just said. In fact, the only reason why we have a third partner who came in immediately pre-pandemic was that his wife was from Connecticut and wanted to come back here. She's an ophthalmologist and was pregnant, and he only came and sought us out. We didn't seek him out. He sought us out because he needed to come to Connecticut, and that was his only connection. We've often said that pretty much the only way we're going to get somebody is if there's some local connection. So there's that. And what do we hear? Number one from these young folk coming out of training is debt, is just medical loan debt. Without getting into the specifics, my young partner came out with a combined debt with him and his wife that is basically equal to a mortgage on a really nice house. So the numbers are alarming for them. So any kind of service-based debt relief, I've always sort of been a proponent of that, where I think that'd be low-hanging fruit to recruit someone to the state of Connecticut. Well, I don't know what percentage it would be, or whether it be full or partial, but some kind of reassurance is that if you come and you establish yourself in the state of Connecticut and practice and see patients and serve the citizens of this community, there should be some degree of forgiveness over your medical debts. It's very expensive to train doctors. It's only getting more expensive. And physicians are following their wallets a little more than they're following their hearts as they're coming out of school. And that's sad. That's sad. And I don't like to see it. So there's that. Debt relief. You can talk about tax breaks. There's everything that you basically said is important. Connecticut is one of the more difficult states for non-compete clauses. I'd like to see thorough and strong discussion about eliminating non-compete clauses. My example, for instance, I'm in New London, Connecticut. I am literally, on my right-hand side is Yale New Haven, on my left-hand side is Hartford Healthcare. We're not affiliated, we're not owned by either, an independent practice, but there's nowhere else to go. If I wanted to go somewhere else in the state of Connecticut, I don't know where I could go that would be not competing with somebody. So, and the last thing you talked about, older physicians or getting closer to retiring physicians when they should be sort of backing down and handing off their practices to the younger generation coming in, are looking at the writing on the wall and just leaving, which is again what happened to my two older partners. And I don't blame them, but they left us with three physicians with a large cashman area. And oftentimes what they're doing now is the big for-profit health systems and the venture capitalists are seeing this trend and paying these doctors to come and join them towards the end of their career. They're pulling them, and unfortunately, these doctors feel they have to do that. It's the only way that they're going to continue to keep an income going. So they have to leave their practices. They're still working for a healthcare system. They're not particularly happy about it, and then they sort of, unfortunately, kind of fade away within that healthcare system. And the patients lose all continuity, and they lose their doctors. It's amazing. Every day, patients ask me who they can go see as a primary care, and every day I try to come up with somebody, and it's very, very difficult.
I had another question too, just
sure.
quickly. I'm probably some of the same people that we know are not quite ready to retire, but are burned out because of the understaffing. And they are now looking to team up with other physicians in different specialties to really create a concierge service that's outside of everything, which again is another loss to the system. And there are people willing to pay that in Connecticut. Do you see that as another complication to recruiting or to losing maybe more established physicians that have that option with a very high patient load? So now we're taking them out of the equation also because they can work better hours. They're not under the RVU system of generating X amount of RVUs for a big hospital system. They don't have to worry about a non-compete. And I think that's going to become an increasing problem as the demographics change.
Yeah, and I've seen that in my area as well. A couple very good general medicine doctors have switched over to, they've switched to concierge, which is good for them. They literally get to pick and choose what patients they want to see. And that's good if you're one of those patients and can afford it and pay if you buy your way into a situation like that. They get very good care from these are very good doctors and they're getting very good care, but it's definitely a two-tiered system when you put it that way. And yes, and I think that's a barrier as well. I don't know how, if you legislate against it, I don't know what you do about that, but you talk about it for sure, like you're doing now. And part of the reason why they do that is, dealing with insurance companies is a huge burden, huge. The prior authorization process, as you all know, is incredibly cumbersome. We almost always win our prior authorizations. And by the way, we use the word win. I mean, it's like you're on the phone, you're nervous, your heart's stopping, you got to talk to a medical director about getting something done for your patient. In the meantime, you've got a patient in room A that's bleeding out of the nose, and you got a patient in room B that's spitting out. So, it's a 5-10 minute process to get something authorized that they were already going to authorize anyway, and their algorithm told them to call the doctor. So there's a lot of room for administrative help with that. Maybe that's why some of these doctors are going to concierge medicine. They say, pay me the $2,000 a year. I'm not going to run anything through your insurance company. Every once in a while, I get asked to do a cash paying case to take out the tonsils, let's say, and somebody will, and we all love that. That's, we'll a fair price, pay the cash, not have to deal with administrative burdens. But that's not a sustainable model for most people, obviously. You're not taking care of the people who really need to be taken care of when you do it that way.
Well, thank you for your testimony. It was very helpful. Thanks for testifying today.
Thank you, Senator.
Thank you, Senator Summers. Thank you, Dr. Boisneau. I see no other questions or comments. We will move to the next person on our list to testify, and that is Debbie Chisholm. Debbie, thank you so much for your patience with us, and please go ahead.
Thank you. Good afternoon. My name is Debbie Chisholm, and I'm a licensed pharmacist practicing in a community setting in the state of Connecticut. I'd like to thank you for raising this legislation, House Bill 457, which allows pharmacists to administer vaccines to patients as young as 12 years old. Pharmacists are woven into the fabric of our community, and they have been essential in allowing adults in the community to protect themselves against vaccine preventable diseases for almost 15 years. Pharmacists have been at the forefront of increasing vaccination rates in Connecticut, particularly in underserved communities where vaccine rates have been lower, and there's a big barrier to patients getting vaccinated. Since 2021, with the help of pharmacy technicians, pharmacists have been playing a vital role in vaccinating hundreds of thousands of people, 5 years and older, in the community and giving our state a fighting chance against the deadliest virus in our nation's history. Pharmacists are available after common working hours, on the weekends, and often without the need for an appointment. removing some of the barriers that the public may have to getting vaccinated. This legislation will allow pharmacists to continue to protect not only the adults, but also their children at the same time, removing the need for a separate adult vaccination and separating them from getting their children protected at the same time. I can tell you, as a mother and a pharmacist, I am strongly in support of House Bill 457, and I thank you for raising this legislation. I'll take any questions at this time.
Thank you, Ms. Chisholm, for your testimony. And I'm glad you came and spoke, because we are looking forward to a pharmacist coming in and sharing this with us. Have you heard any pushback at all from people, or can you share some examples where part of the family would come and some kids could get the vaccine, others could not?
Yes, so we've had that several times where you'd have a 17-year-old coming in with their parents, and we're not allowed to vaccinate under 18, and mom and dad are able to get their vaccinations, and then we have to send the child away and tell them that they have to go to their pediatrician to get the vaccination. And then they have to make an appointment, which, takes some time, and then allows that time period where that child is not protected. We've been vaccinating children against COVID, 5 years and up, as it allowed by the federal government and the state. And, we're ready. We want to be a part of this. I can tell you the community response has been huge. I've spoken to people just this weekend about the availability of pharmacists and their accessibility. And I think being able to vaccinate children, I spoke to a mom actually this weekend where we vaccinated her 12-year-old against COVID, and she was very grateful at the opportunity for us to be available for her to be able to vaccinate her child. And so I think allowing pharmacists to be able to do this would be a huge service to the community.
Good. Thank you so much. I don't see any other questions or comments. We appreciate your testimony. Thank you for your patience today.
Thank you.
That brings us to the next person on our list, which is Mr. Thomas Burr. Welcome, Mr. Burr. Please go ahead.
Yes, good afternoon, Senator Anwar and members of the Public Health Committee. My name is Thomas Burr, and I'm the Community and Affiliate Relations Manager at NAMI, Connecticut. You have my written testimony, so I'd just like to highlight the following. We support SB 375, an act concerning telehealth. Increased use of telehealth has helped many people, and providers have seen their appointment cancellation and no-show rates drop significantly with telehealth. In other words, more people are receiving the care that they desperately need. People in Connecticut that do not have easy access to transportation or childcare find telehealth of great value. We fully support telehealth as a delivery mechanism and ask that telehealth be made permanent. We support SB 448, an act concerning the delivery of healthcare and mental health care services to inmates of correctional institutions. To echo the testimony of the Regulate DOC Healthcare Connecticut Coalition, quote, "Poor health is expensive. Connecticut has paid out millions of dollars in lawsuits related to medical negligence with the Department of Corrections. However, there is a deeper cost to families and communities of returning citizens. We at NAMI Connecticut also know that poor health leads to poor mental health. Therefore, we support SB 448 and ask that you consider the additional recommendations as outlined by the Regulate DOC Healthcare CT Coalition. We support HB 5480, an act concerning the accessibility of mental health services. This bill allows specific and supervised higher education students to provide professional psychological services in person and via telehealth in order to improve the accessibility of mental health services in the state. Having more people able to provide services for people with mental health conditions is a great thing, as it will aid in people having timely access to care. We support SB 451, an act establishing a working group to study the expansion of mental health resources to children, with the proviso that the committee add language to include parents with lived experience of having cared for a minor child with a mental health condition. Nothing about us without us, guys. We support SB 454, an act concerning the Department of Public Health's recommendation regarding the Centers for Disease Control and Prevention Youth Risk Behavior Survey. We also encourage the committee to include NAMI's Ending the Silence program, which will greatly aid in reducing suicide and improving mental health in schools. Finally, in regards to HB 5485, an act concerning various revisions to the public health statutes, we object to the language in Section 6, subsection D that adds the following, quote, professional counselor licensed under Chapter 383C or marital and family therapist licensed under Chapter 383. We strongly believe that we have more than enough people capable of writing emergency certifications to force people into locked psychiatric wards, an environment where far too many members of the mental health community find way more traumatic than therapeutic. We ask that this language be removed. We also appreciate the questions raised earlier by Representative Zupkis, and we would welcome an opportunity to discuss her concerns in greater detail. So thank you for your time and attention. I'd be happy to answer any questions you might have.
Thank you, Mr. Burr. I just wanted to make a comment that you have brought this into a level that is above and beyond others. You discussed about 7 bills within 3 minutes and very clear. And we should all learn from you. And I wanted to thank NAMI for their involvement in so many bills and then going through them and giving a perspective which we truly value as a committee.
Yeah, we're always open to weighing in anytime anyone has any question about anything related to mental health. We have a deep well of knowledge. We're a national organization. We have lots of resources and, you know, are again, happy to weigh in on anything and share our perspective.
Perfect. With that, the language change that you had suggested, is that in your written testimony as well?
Yes, sir.
Okay, perfect. I just wanted to make sure of that. I do not see any comments or questions. We wanted to thank you for your time today, and then thank you for your questions. Thank you.
My pleasure.
And moving on to the next person, number 68, Mary Valdovinos. Go ahead, Ms. Valdovinos. Welcome.
Thank you, Senator Anwar, Representative Steinberg, and distinguished members of the Public Health Committee. My name is Mary Valdovinos. I am a resident of Norwalk and the Operations Manager at Women Against Mass Incarceration. In collaboration with the Regulate DOC Healthcare Connecticut Coalition, I am providing testimony to support Senate Bill 448, an act concerning the delivery of healthcare and mental health care services to inmates of correctional institutions. Connecticut is still the only state with no third-party healthcare oversight, and I don't want to repeat what other people have said, but poor healthcare is expensive, and the state has paid out millions in lawsuits due to negligence, staff shortages, among other issues. I do believe implementing third-party oversight can reduce this. I'm a formerly incarcerated woman who experienced firsthand the poor medical care provided, as well as the lack of concern during or after a medical crisis I experienced, in response to which I was put into solitary confinement. That should not be an option. The Department of Corrections is not a medical facility, clearly, nor is well equipped to act as one sometimes. Just a few days ago, I was told by an incarcerated friend of mine at York Correctional, who frequently visits the medical unit, that their intercom system is not working in the medical unit. Without it, they cannot communicate their medical emergencies and thus are left unattended. Incarcerated people are also being prescribed powerful substances with little insight, drastic changes in prescription, missed doses, and no follow-up care, all of which have led to even more serious medical issues, both inside and when returning home. We have recently seen overdoses, which should not be happening with the proper medical care. And with issues such as these, it's no wonder why there are so many 911 calls, serious medical crises, and even deaths that could be prevented and handled better in-house. While SB will be providing healthcare for those incarcerated, you can strengthen the bill by including some things which I will not go over again. I have written in my testimony, but I do also wish to mention, as others have prior, the people first language. The word inmate is dehumanizing. And when you're incarcerated, they do not call you by your name. You're lucky if they call you by your number. They yell inmate at you. And the way it makes you feel, I mean, it's not okay. Other states have implemented and changed printed language, including New York. And I do believe that's something that we should be looking into as well. To wrap things up, medical negligence inside leads to an increase in health problems and financial burden when returning home. The state must do its part to prevent the same quality of care from continuing and improving health outcomes for those both inside and returning home. Incarcerated people are human beings, and access to proper health care is their right. In closing, I do urge you to support Senate Bill 448 and consider these additional recommendations to improve overall DOC conditions. Thank you.
Thank you so much for your testimony. I have some questions, but I know Representative Ywca would have better questions.
I am flattered, but I actually only have a comment, if I may. You're not the first person to mention changing the language around the use of the word inmate today, and I don't believe, unless I missed it, anyone has really acknowledged that among my colleagues. And I just want to say that I'm definitely hearing that, and I know that my colleagues are as well, and appreciate that. It is something that would have been very easy for us to overlook. So thank you for bringing that to our attention, and to the others who also mentioned it earlier today. I want to acknowledge that. So thank you very much.
Thank you for recognizing that.
Thank you,
Representative. Thank you.
I was right. You were going to make a better comment than I was going to. You're absolutely right. You have had lived experience. If you feel comfortable, only and only if you feel comfortable, would you be able to share some of the experience of what some people say dehumanized management?
Absolutely.
Only if you feel comfortable.
Absolutely, Senator Anwar. And this is something I do for work now, is helping others and being a voice for the voiceless who are still incarcerated. My personal experience, I was addicted to opiates. So upon my arrest, which was related to my addiction, I went into York Correctional for some months. And at the time, I also had suffered a brain injury, which led to a seizure disorder. So in combination, those things should be addressed medically. However, they're not. You're one of many, and especially in this day and age, which it is so common to see addiction leading to incarceration, something that can be treated in a different form. I suffered a few seizures, one of which led me to being in solitary confinement. I was initially in the medical unit, but when other girls would call for help, they would just come to the door. They'd say, "Is she breathing?" and walk away. So not really checking in as much as they should. I know that they do standard blood pressure checks, but that's not going to save a life. Another incident which I must mention is a girl who tried to commit suicide. And in the medical unit, all your cells are closed most of the day. You're allowed out perhaps an hour of the day. So for other women to be screaming catches your attention. And when you're all screaming in conjunction for a guard to come and nobody's coming, but you see them from the window glancing your way, I mean, it's something that really needs to be addressed. And because we are seeing more suicides now, not only that, but deaths due to such negligence, something must be done. Somebody needs to be held accountable. And unfortunately, you know, the way things are right now, I believe that third-party oversight might be one of the major ways to correct this issue.
Thank you so much for that. Actually, that leads me to the question, because we are exploring the possibility. First of all, agency policing themselves is not a sustainable model, and that's why we are in the conversation that we are in right now. One of the thought was to have the DPH monitored, because the DPH monitors all the other facilities, and it would be one way to do this. But tell me about your vision of the third party. What would that third party look like?
So we're thinking of having a coalition. The YWCA has wonderful ideas, and this is something that might be able to make a difference besides just the Department of Public Health. And, I know you do so much as it is, but because there is so much that needs to be overseen, that needs to be addressed, issues like mothers and families losing their children and not finding out until they arrive to the hospital and there they are declared deceased. I believe that a coalition with constant interaction, check-ins regularly, that will be updating and providing information on what is really going on. That's one way to hold the DPH, the DOC and DPH accountable.
Okay. As I'm listening to you, I think that in the children's issues for DCF, we have Office of Child Advocate. And in the same way for the seniors and long-term care facility, we have an ombudsman position, and they spoke today as well. I wonder, working with the DPH, but having an independent office of an ombudsman or a incarcerated individual advocate, health advocate, maybe a way to look at this, and then they collaborate with an advisory group of some kind. Again, we need, what happens is that when we make this oversight group, the oversight groups may not have the teeth, and the DPH has the teeth, if you will.
Mm-hmm.
So they would have the capacity to make a decision and see if things can be done. Now, they have been able to do this on state-based hospitals as well, and this legislature has given them that authority in another situation. So I wonder, that may be one way to approach this, but have that advisory group that create a feedback loop. So I will probably talk to Melinda Johnson and some of the other advocates to see if we can find a model. I see the need for community involvement to be there as well. So I hear what you're saying. I found your testimony very helpful, and thank you for, as you said, being the voice for the voiceless and using your experience to make sure that others don't experience this. So I appreciate that. Thank you for your leadership.
Thank you, Senator Anwar. And if I may just take another minute of your time, I have found specific language that the YWCA has come up with. They recommend a commission composed of a mixed group of stakeholders with vested interest, including physicians, healthcare workers, formerly incarcerated individuals, family members, that as I had mentioned, experts in reproductive health care and gender affirming, corrections professionals, private practitioners, Office of Health Strategy, Department of Public Health, licensed mental health practitioners, racial justice and gender equity advocates, experienced professionals in communicating the needs of persons with disabilities and intellectual disabilities. And these are just examples of who could possibly take part in this commission.
Thank you for that. Thank you. And seeing no other comments or questions, we will move on to the next person on our list, which is number 70, Amber Valangas. Please go ahead.
Hi, can you hear me?
Very well.
Okay, great. So good afternoon, Chairs Abrams and Steinberg, Vice Chairs Anwar, Kushner, Gilchrist, and ranking members, and the distinguished members of the Public Health Committee. My name is Amber Valangas, and I'm with an organization called Restorative Action Alliance. We work with people who are impacted by the criminal legal system, as well as anti-carceral survivors. We are here today supporting Senate Bill 448, an act concerning the delivery of healthcare and mental health care services to inmates of correctional institutions. We did submit written testimony. Our president, Jason Wasserman, did send in testimony joint with the Cattell Center for Equity, Health, and Justice. And we would like to echo some of the things that have been talked about today, particularly the idea that this really is about the humanization of individuals who are in the care of the state while they are incarcerated. I do have a background working in congregate healthcare settings. And one of the things that I see as quite concerning is the ratio of one nurse on staff for 43 people. And one doctor for every 579 people. That would never be something that would happen in any other setting. And it is certainly not acceptable even in DOC. I want to echo some of the framing of Barbara Fair, who talked about the toxic environment for both the people who are incarcerated and the people who are working within DOC. I also would like to make recommendations around the advisory committee and the makeup that was just discussed in the previous testimony of the YWCA. I do support that. And then I would just like to talk a little bit. I am the spouse of somebody who was formerly incarcerated, and I just want to speak to some of the terrifying situations that you feel as a family member when you don't know what's going on with your loved one and you can't get information. In fact, when my loved one was incarcerated, he actually had me reaching out to other people who whose families couldn't get information when I was able to speak to him on the phone. So I really want to call attention to that we're talking about entire families that are impacted by this lack of healthcare and this lack of oversight. So I do appreciate this committee treating the health of incarcerated people as public health, because it absolutely is. These individuals are part of our communities and they will be returning home. So I appreciate and happy to take any questions.
Thank you so much, Ms. Flangus, for your testimony. We appreciate that, and we took notes of your information. So thank you for that.
Thank you.
No other questions or comments. We'll move to number, I think, a second before number 7069 had joined. That's Karen Ressler. So Ms. Ressler, you're next.
Hi, good afternoon. My name is Karen Ressler, and I'm the owner of the Taylor Madison Eyewear Group, and I'm an optician with 40 plus years experience in both the wholesale side of the industry as well as the retail side of the industry.
Ms. Ressler?
Yes.
We cannot see you, and if that's on purpose, that's fine.
Oh,
but,
no. I
it-
don't know why. Hold on. How's that?
We can see you now.
Okay.
You fix Senator Anwar's vision with one visit.
So I have, as I was saying, 40 years of experience. I also sit on the Connecticut Opticians Association board, and I'm a partner in industry with the association. And I'm speaking to you today to oppose the SB 329 bill, that I feel that having a licensed optician on premises in order for an optical establishment to be open is positive, so as to not to compromise the public safety and welfare of a patient. I believe a licensed optician is needed to make sure the appropriate frame is chosen for a patient with regards to the patient's facial features, their prescription, measurements, the type of lenses they may need, and any individual issues regarding allergies, sinus issues, and facial deformities. I also believe that appropriate measurements also need to be taken to make sure that the eyewear is correctly made to afford the patient's optimal vision. A licensed optician is also need to confirm all eyeglasses, that they are adjusted properly and the prescription has been made in accordance to their prescription, and so that there is no visual problems. Visual problems can be as follows: double vision, blurry vision, which also can impact patients' abilities to walk, to drive, and accomplish everyday tasks. A licensed optician is also needed to perform adjustments on eyewear to make sure the fit is correct and is not to cause sores, headaches, and to make sure the patient is looking through the center of the lens, which will provide their best vision. I thank you very much for allowing me to speak to you today, and if you have any questions.
Thank you for your testimony, Karen. Yeah, we've heard from pretty routinely today from those in the business that they have concerns. It's a challenge for us. Our job is the public health and not commerce. We want to enable consumer access to all sorts of products, but we also have a responsibility to make sure that they are provided safely. And I guess the most salient bit of testimony I've heard today is remembering this is a medical device.
Correct.
And, there are consequences for failure to provide quality service.
Yeah, and that is including non-prescription eyewear like sunglasses, ill-fitting frames. I have seen in my history of, and again, being in this industry for a long time, where someone has purchased non-prescription sunglasses and they were not fit properly, and they came in with horrendous sores on their nose, they're behind their ears, pressing into the mastoid bone, which then caused, almost migraine headache situations. The patient had to be referred out to a dermatologist to have the sores treated because they were so severe. So
they look really great.
What?
They looked really great, they looked good.
They looked good. They didn't fit well.
All right, thank you for that. Representative Berger Chervalo.
Thank you so much, Mr. Chairman, and thank you very much, Karen, for your testimony. I just have one quick question for you. If this legislation were to require that an optician were present at both points of sale, so the initial ordering and purchase and at the pickup, would that make you feel better about the rest of this, so that a store could remain open, but no purchase could be made on either side of that if an optician were not present?
I mean, my belief is that if you have somebody walking into an optical store and the frames, sunglasses, et cetera, are all out there to see, the customer or the patient walking in is going to feel like, oh, I can come in and I can purchase what I want. And they're going to expect that the person that they're dealing with is a licensed person or is knowledgeable, and there is that they can feel with certainty that they're going to be taken care of correctly. And I feel that if it's in a situation where that a licensed person is not available, that's putting our patients at risk.
Well, again, if they're not allowed to make that purchase, they're protected from the risk. So I think maybe that's where kind of some of this disconnect could possibly be going forward, as if this were to change in any way. My feeling is if I walked into a store expecting that I would be able to make a purchase, and I am told because of state statute I cannot purchase because no one is there, I would probably look poorly upon that business. But if they're following the law, I would not be able to purchase, and I would go somewhere else that would only let me in the doors if there were someone on premises. So I just want to kind of throw that in your lap to kind of process too. I mean, it would, the perception of the business itself versus what is law is law. So if it were not permitted, so just going back to that question one more time, if it were not permitted to either sell or dispense at the end when the prescription is filled and it's ready, unless there were an optician present, would that then be something that you would be okay with?
So if, let's just say for argument's sake, everything was like closed off so that they can't have access to the frames and all that kind of stuff, but they could buy a gift card or something to that effect, like a sundry item?
So they could browse, or they could try glasses on and take Instagram pictures, whatever it is that they wanted to do, as long as they could not order the glasses.
But then doesn't that open then the fact unfortunately in the case of someone that has a bricks and mortar and online retail at the same time, allows that to circumvent the whole issue?
Not if they can't legally perform the transaction, right? I mean, they can't.
But if they're that, I know, but I think it leads to the question of, so they have some sort of iPad available and they say, well, okay, so the licensed optician isn't here, but you can of course go onto the iPad, you know, and make your transaction there. That is a slippery slope. That's a slippery slope on that matter.
Well, there's also nothing right now preventing me from doing that. I mean, I can come into your place, you give me my measurements, and then I can walk right into the hallway of whatever business you're in and go and order through an online business. So I don't think that's, but I appreciate your point of view. I appreciate where you're coming from. And thank you for your time and for letting me kind of hypothetical you a little bit.
Absolutely.
Thank you, Representative. I don't see any further questions. Again, thank you for your testimony today. We're trying to see if there's a way that we can thread this needle and make it possible for these businesses to prosper while we protect the public health. So thank you.
Oh, you're welcome.
Next up is Liz Gustafson, followed by Mag Morelli.
Hey everyone, Senator Anwar, Representative Steinberg, and distinguished members of the Public Health Committee. My name is Liz Gustafson, and I am the State Director of Pro-Choice Connecticut. In solidarity with the Regulate DOC Healthcare Coalition, we testify in support of Senate Bill 448. Connecticut has historically been a leader in the fight to protect and expand reproductive freedom, which includes ensuring everyone is able to exercise their bodily autonomy and access sexual and reproductive health care services with safety, support, and dignity. Currently, Connecticut is the only state in which the Department of Corrections oversees and operates its own healthcare system, which has led to subpar quality of care for incarcerated individuals and poor health outcomes for returning citizens. Connecticut has paid out millions of dollars in lawsuits related to medical negligence within the DOC, including the failure to provide safe pregnancy and birthing care. But it's critical to remember that the deeper cost is the immediate and long-term impact this has on individuals such as Tiana LeBoy, their families, and the communities of returning citizens. Access to humane, adequate sexual and reproductive health care is integral to reproductive freedom, including those whose bodily autonomy is limited due to incarceration. This is also a matter of racial and gender justice, as the number of incarcerated women, particularly women of color, continues to increase across the country. It is the responsibility of correctional facilities to implement robust policies such as SB 448 to meet all sexual and reproductive health care needs, as well as adopt oversight mechanisms to prevent further negligence and harm. SB 448 moves the needle forward to providing improved health care for incarcerated individuals. And as members of the Regulate DOC Healthcare Coalition, Pro-Choice Connecticut, and our movement allies, Planned Parenthood supports recommendations made today by coalition leaders and has included them in our submitted testimony as well. And so in conclusion, it is imperative for this legislature to act and ensure all individuals can access the essential reproductive healthcare services they need with dignity and safety. And we urge the committee to support SB 448 and consider the additional recommendations to improve outcomes for incarcerated individuals, DOC healthcare workers, and returning citizens. Thank you so much for your time.
Thank you, Liz, for your testimony. Yes, there's so much we need to do in the corrections environment to really protect their rights, which they have not forfeited merely because they're incarcerated. We take your comments very seriously. It's something that we will consider as part of a broader attempt to really remedy what has become a very difficult situation here in Connecticut. I don't see any questions, so we will move on, if that's all right, with Meg Morelli, followed by Kathy Flaherty. Welcome, Mag.
Thank you, Representative Steinberg. And good afternoon, Senator Anwar and members of the Public Health Committee. My name is Meg Morelli, and I'm the president of Leading Age Connecticut, a statewide membership association representing not-for-profit provider organizations serving older adults across the continuum of aging services. I'm pleased to be here today to testify on several bills before you. First of all, on Senate Bill 371, an act allowing infection prevention and control specialists to provide services to adjacently located and commonly owned or operated facilities. Leading Age Connecticut fully supports this proposal, which would bring a level of flexibility and efficiency to the newly implemented infection preventionist requirements imposed on nursing homes and dementia special care units in Public Act 21-185, and does so without compromising quality of care. The bill proposes several things, including taking into consideration the size of the nursing home or special care unit. The language clarifies the surveillance responsibilities of the infection preventionists, and it would permit the employment of one infection preventionist to oversee both a nursing home and a dementia special care unit when they're located on the same campus and have common ownership and operation, such as in a continuing care retirement community. We also ask that as the committee addresses needed modifications to the infection preventionist requirements established in this public act, that the committee also consider amending the section related to the new social work staffing levels to allow the levels to be applied proportionately to the individual nursing home's resident census. And we've provided some suggested language. And we view the proposed changes to both of these sections as minor modifications to the important provisions adopted last year. In Senate Bill 453, an act concerning the DPH recommendations regarding transfers and discharges from the residential care home residents, Leading Age Connecticut represents 11 not-for-profit RCHs, and we strongly support this bill and the state's efforts to qualify the RCH as a CMS-approved home and community-based setting. On House Bill 5481, an act concerning the DPH's recommendations regarding change of ownership for a healthcare facility. Similar to my colleagues, we are supportive of the concept of the bill, which is to restrict the ownership of healthcare facilities by unscrupulous people, but we are concerned about the breadth of the requirements and the restrictions on the decision-making that does not provide the Department of Public Health with an appropriate level of discretion. It's essential that we all work together to develop a system that allows DPH all the necessary information to make an informed decision, but also balances the need to develop a process that doesn't put unnecessary hurdles in the way of appropriate ownership of a healthcare facility. And we provided specific comments on that section. And finally, on House Bill 5485, an act concerning various revisions to the public health statutes, and specifically Section 7 of the bill, which proposes to modify the assisted living statute by adding an additional permissive condition upon which one could be admitted into an assisted living facility. We ask the committee not to make the proposed change at this time, and we've explained in our written testimony why. And we also ask that if the committee is considering modifications to the assisted living statutes, that you consider addressing the model of affordable assisted living services provided to residents living within elderly housing complexes, assisted by HUD, that have received funding through the Federal Assisted Living Conversion Program. This excellent model of providing affordable housing with services is currently failing because the Medicaid reimbursement system doesn't support the use of the dedicated services of an assisted living service agency. We've been working together with various state agencies and HUD and the affordable housing sites to seek a remedy. We've been actually working for several years now. And through this work, we've developed some suggested modifications to the current statute that would allow Medicaid providers other than ALSAs to support the activities of daily living for these residents. And we've provided that language in our testimony, that suggested language in our testimony. And we ask for your consideration. I want to thank you for the opportunity to testify on these bills and for your consideration of our association's opinions. So thank you.
Wow, Mag, you've really mastered the 3-minute testimony on a bunch of bills. Well done. Let me just ask about the issue with the assisted living. You said not now. If not now, when? When are we going to get to that point?
Well, one of the things that we talked about, we've discussed this because we didn't really know where this was coming in. Apparently, it's a small assisted living in an area of the state that's providing excellent end-of-life care. And looking at their model it may be a really great model to bring into the state. And if so, if people are interested in replicating it, then I think we take a look at it and see if there's anything else we have to change in the statute to accommodate and ensure quality of care for others that replicate it, and then make the appropriate changes at that time. I believe they can get a waiver from the state, so we wouldn't be stopping their operations, which would be very important not to do. So if we could do that and then take a look at their model, and if others want to replicate it, I think it would be important to see, is this the only change we would need to make in the statute, or do we need to make others to make this sort of this end-of-life model appropriate?
Thank you for that. It's clearly something which needs further conversation, but it also needs to be addressed sooner than later, not on a one-off basis, but really to look at the entire needs of the industry as people's needs evolve. So we're going to be looking to you to help us shape it with your knowledge of the nursing home industry to make sure that what we're doing is going to keep people safe.
Absolutely, we're happy to help. And I just want to reassure the committee that people that currently live in assisted living do receive end-of-life care in their apartment. So it's not that people are discharged to receive end-of-life care. This just has to do with, this change had to do when people are admitted. I just wanted to reassure the committee that people do receive hospice and end-of-life care in their assisted living communities right now.
Thank you for that. You've given us a lot to think about. I'm gonna have to reread your testimony. You spoke so fast that I didn't absorb it all, but that was excellent. Thank you. I don't see any questions, surprisingly. We'll move right along. Welcome, Kathy Flaherty, followed by Emily DeLarme.
Good afternoon, Representative Steinberg and all the members of the Public Health Committee. My name is Kathy Flaherty. I'm the Executive Director of Connecticut Legal Rights Project, and we provide legal services to people who are eligible for mental health services from the Department of Mental Health and Addiction Services. My written testimony is posted online, but only under Bill 375, but I'm actually going to testify on 5 bills, but that's where you'll find it. Very quickly, in support of 375 and 5480, to improve access to care. In addition to being the ED of Connecticut Legal Rights Project, I'm also a member of the Catal Center for Health Equity and Justice, and I stand with the other members of the Regulate DOC Healthcare Coalition in supporting Senate Bill 448 about the healthcare of incarcerated people. But I would call your attention to Section 1B of that bill, which does not appear to recognize that incarcerated people, like everybody else, retain their right to refuse medical treatment and recommended medical treatment. It appears that there is an intent that this should only apply to voluntary consented to mental health treatment, but there actually are rules and existing policies in DOC for involuntary mental health treatment of people who are incarcerated. And I don't believe that 448 complies with that. You heard from my colleague, Kevin Brophy at Connecticut Legal Services earlier this afternoon about Senate Bill 453 about residential care homes. CLRP stands in solidarity with our colleagues at Legal Aid, and I strongly encourage this committee to look at their recommendations regarding substitute language for that bill. And the last bill I want to testify on is 5485, but I am focusing only on Section 6 of that bill. I really suggest you consider amending the bill by deleting lines 186 through 211, which is Section 6 of the bill. I do not understand why, despite the fact that we come here year after year after year to tell you what we are looking for in terms of mental health treatment, that it's voluntary, that it's admitted, done at home and in the community, that there are constant proposals to increase the universe of people who are allowed to write emergency certificates to force people into hospitals against their will, when we know that rates of suicide go up upon discharge from an involuntary hospitalization. It causes trauma, it impacts care, and it really destroys people's ability to establish therapeutic alliances with their treaters. I talk about this from personal experience, not just professional. Once you learn that some people have the authority to get you locked up, you don't tell them the truth. You tell them what they want to hear so that you get to go home from that appointment at the end of the appointment. So I really encourage this committee to think long and hard about what you're proposing. You heard Margaret Watt mention peer-run respites earlier today. We need to have a system that's built on connection and not coercion, and that recognizes people have autonomy, strength, choice, and recovery that's based on those things is more likely to be successful. Thank you.
Kathy, I hear you. I've heard you for years. I think we're heading in the right direction. I think we have been moving away from the concept of simply control over people who may be seeming to act out, and try to get them connected to appropriate therapeutic support, and then we take care of them for the long term. Changing a paradigm that has existed for a long time is really hard to do. And we struggle, but our intent is good, and we hope you will not have to admonish us for years into the future. We're working on it.
I agree. Take out section 6. I think we're all good.
Thank you, Kathy. Next, I don't see any questions. Thank you. Next up is Emily Delarme, followed by Jennifer Jacobson.
Okay, thank you for giving the opportunity to speak today. I'm a licensed optician who has worked in the field for 14 years. I know that, you know, you've heard a lot from us today. I'm going to try not to repeat any points that were made. I'd really like to focus on, I know there were a lot of questions about, you know, potential problems with frame selection. So I kind of wanted to focus on that. So Connecticut is a leader in public health and safety. I think that's important to remember. And as opticians in Connecticut, we follow the national ANSI standards to ensure the wearer's welfare and safety is a priority, meaning that there's a very small window for error. When glasses are ordered online and not properly measured, inspected, and dispensed, who is ensuring that the ANSI standards are followed from start to finish? This bill cannot be likened to telehealth or innovative eye care when there's no medical professional to assist with protecting the wearer's health. There is a presumption of competence when a consumer walks into an optical establishment. In regards to a sign being up, the general public will not know the difference between an optician and a sales associate, and will just presume that the person helping them with frames and lens options is educated. This bill is for the business model to sell more products without a licensed optician. Non-regulated accessories make up about 1% of non-optical sales. It would cost more to pay an associate to stay open just to sell accessories than they would make in revenue. It would also open the door to other establishments to push boundaries. So we often have people coming in to ask us for help with glasses that they purchased online and can't see out of. Last week, we had someone who came in with 2 pairs of progressives that she ordered online. The vertical and horizontal measurements were way off, and she said that she felt like she was drunk while wearing them. She could not understand that there was an error in the fabrication of her glasses because she used the tools on the website to measure them and even talked to someone over the phone. It's unacceptable to allow uneducated associates to give guidance on optics, resulting in the wearer to walk around and drive with glasses that make them feel intoxicated. And then this morning, I had a gentleman come in with glasses he had ordered online. The frame was way too big for him, and he said that it felt like he was looking through a fishbowl. So the frame, again, was too large for his prescription, and that causes distortion on the sides, giving you that fishbowl effect. So when a person wants to solely order glasses online in a self-service, they would do it from the comfort of their own home. Proposed subsection 2151C shows that there's an understanding that the consumers go to brick and mortar stores to get the help and expertise from a medical professional. This bill is not the future of eye care, it is actively excluding the need for a medical professional. So I had a gentleman this morning again who wanted to buy a pair of wrapped sunglasses. So you can see these are the sunglasses that he wanted. They have a large curve to them. His prescription is strong enough that the lenses are very, very flat. So this frame, if you went to order this online, you physically cannot make these lenses to curve like this. If we tried to do that, it would cause the frame to bow out, and it would also affect the way the light is transmitted through the eye, again affecting the vision. I also wanted to
Excuse me, Ms. Delarme, your time is almost up if you.
Okay, thank you.
Thank you.
So I also had a pair of sample glasses, and I also wanted to mention that a lot of us, myself included, have uneven ears. So when you put on a pair of glasses that are not adjusted, making sure that your glasses are adjusted properly before taking the measurements is extremely important. Because now if these glasses were made for me without a proper adjustment, making them straight, I have one center of the lens way up here, another one way down here. So if the glasses were made like this, I would be walking around with a lot of distortion, headaches, dizziness. I would have displaced images. Also, when you're making a pair of glasses and the vertical measurement is not measured, the default measurement, which I believe is how they do it online, is just half of the height. So my pupils are up here, and in this frame, half of the height is way down here. So I would have to go around looking like this to see out of the clearest part of the glasses. And that is something that we also find very often too with glasses that were not measured properly, or frames that were not fit properly that were ordered online as well. So thank you for your time, and I'd be happy to answer any other questions.
Thank you for your testimony, for these very specific examples of how things, no matter how well intentioned, can go awry. And it is something we're going to have to look at very carefully. So I don't see any questions. Again, thank you for taking the time to testify today. We really appreciate it. Next up is Jennifer Jacobson, followed by Diane Manning.
Hi, good afternoon, everyone. I'm Jen Jacobson. I'm a Fairfield Board of Education member and here to discuss HB 5479 about air quality in schools. And just thank you for raising this issue again, critical to our students, staff, and the health of our buildings themselves. I'm going to jump really quickly because I have a lot to say in a very short amount of time into technical components of this bill. First, just want to talk about your definition of school facilities. I know that you've captured rented, leased, operated space by local boards of education into this definition, but I just want to make it clear that local boards of education do not have authority to dictate to commercial spaces that they may be renting about what standards they have for their buildings. So I've included several examples about how this may play out in terms of, say, an therapeutic aquatics program for special ed students that go to a local YMCA, or our 18 to 22 adult transition learners who may be going to a university for work transition jobs, apprentice sites, etc. So I've got into that into my written testimony, so I'll move on. Your school activity hours are not constrained to the school day. So now we're talking about before and after school care programs, again, a local boys and girls club, extracurricular activities. I think it would be really helpful if we had a definition in here around what you mean by education services. I mean, obviously a classroom is clear, a daycare is clear, but I'm unclear what you mean by education services. So does a rented ice hockey rink for the ice hockey team fall under this rented space? I'm going to jump into the school closure and the gym piece. We talked about this last year. You guys have a rolling 2-hour consecutive school closure provision. It is not necessarily possible for us to actually do because I don't know how they're getting home. If our buses are already out and the school hits the 2-hour mark, who are we releasing them to? Also, even at the height of pandemic, our schools were not closed. Our kitchens were open for our free and reduced lunch meals. In fact, all kids were getting meals at that point. Maintenance was happening, administrative was happening, sports were still happening. So when we close, everyone goes home, right? That means all games are canceled. That means there's no buses to games that day. That means there's no outdoor activities happening. So I would encourage you to rethink about what we mean by closure. And you may mean closed for in-person learning and not actually closing the building, but those are two different things.
Jennifer, sorry to interrupt, but just so you know, that has nothing to do with this bill, and we're not the education committee. So
I know. So right, I'm sure that you're gonna, to send it over there at some point. Just raising for your awareness, we can't just close schools on a rolling 2-hour basis like this. There's a lot of other things around this for the school closure, but I'll get to the gym piece. I understand you've got an 85. You've included gyms in your definition of school facilities to be compliant with standard 62. But then you have a separate piece on gyms that isn't with 62. And I'm not sure why that's necessary if we're being compliant with 62. Also, I don't know why that would be any more important than an OT-PT room or a general ed classroom or the library media center or anywhere else in our buildings. So I just want to, let's get this done, but let's get this done in a way that's not, chaos or even unsafe in certain regards. So happy to provide other language, and I understand what you're trying to do and why, but we just really need to get it done. But so thank you. I think my time's probably up.
Well, first of all, let me say it's exciting to meet somebody who finds this as important as I do. Your passion for getting it right and getting it done is duly noted. And we need a participation of activated Board of Ed members and other people in the community to help us try to get it right. And we've taken your point. This can't just be about gyms. It really needs to be about every place where our students and staff, are expected to be learning or exercising, whatever. We need a holistic approach, which makes it even more challenging.
It does.
with systems that were perhaps not well designed for the task, haven't been well maintained, and don't reflect necessarily the state of the art of what we know will keep everybody healthy. It's daunting, but we can't afford, exactly to your point, to dither and wait too long to make it happen. So we appreciate your input on this. This bill may go to education, but I think there's another bill that's either before them.
Yeah, 423. That was in labor.
Well.
Yeah,
You know,
423.
when you describe chaos, sometimes I think you're describing the legislature, because we are going in different.
Well,
committees.
423 actually like requires it to get done in a certain sense, but I shared the same concerns around closures and definitions that they've had as well when labor had the same hearing. And I agree with you. This is a collaborative approach. We can't do it ourselves, right? We need people to put these projects on an agenda. We need to get them through town bodies. We need DAS to be ready. We need the construction guys to be ready, right? So, I mean, the bonding commission, the funding, all of it. So this is, we're just the Kickstarters, really, on these things. But, guys, we got to move forward.
Well, you can count on us involving you in that. I see Senator Wong would like to comment and say hi.
Thank you, Mr. Chair, and welcome, Jen. Thank you for your speed presentation. And indeed, thank you for being a Board of Education member of Fairfield as well. One of the thoughts that I had, and we talked about this, the comprehensiveness of this initiative. It's absolutely agreed upon that we need it, but have we really thought out the broad scope of it from a standpoint of the challenges? Trying to kind of coordinate chaos into this, but what about the budgetary constraints? I just think that ultimately, as we've encountered many construction projects in the town of Fairfield, some well-intentioned that led to other projects, that there are cost burdens that may occur. Do you have, as a Board of Ed member with your experience, shed some light in regards to concerns you have about the potential fiscal note, not only from a state basis, but also imposed on select municipalities?
Yeah, I mean, we could probably talk about that for a long time. But yeah, so, of course, there's, going to be a very hefty bill on this. We already have our buildings ready to go. We've done the work to be prepared for this. So I know what the costs are. I think probably every municipality has its own, benchmarks in terms of what they will be able to, produce or participate in, or bonding caps or what have you. What I can tell you is that the faster you do it, the cheaper it is, but then you're bonding more up front. And the longer you take, the more expensive it is, but you're keeping under certain bonding caps. So that's kind of the give and take here. Obviously, there's plenty of bills thankfully, in the legislature this year. What we're always concerned about is what is that reimbursement rate going to look like? And are these projects going to qualify as standalone? So typically, sometimes they're funded, sometimes they're not, especially if they're a standalone. Like say you're not doing anything else, you're just going to put the AC in, so to speak. Historically, that hasn't been something that, the state has wanted to do if it's not part of a larger renovation or build project. So I know that there's plenty of bills right now out there looking at amending some of those to make them applicable for or eligible for this reimbursement. So yeah, I do. What I will say is, Senator Huang, is this. It's going to cost a lot more to tear down buildings because of mold. It's going to cost a lot more in terms of, healthcare and of students and staff in the long run. And at the end of the day, it's 2022. Long-term, short-term, I think is what we're looking at, right? So is it in the short term, maybe it's cheaper to just not do it, right? And then when mold comes up or, a wing needs to be done, then we just do crisis management. I'm not sure that that's any less expensive. So I'm more concerned about the overall health, not only of students and staff, but actually of the investments, because I know that people are, frustrated that they invest a lot of state money into buildings or renovations or projects, and then there isn't the money to maintain them, right? So it's a very large, I get it. It's a large, comprehensive, complex conversation. But at the end of the day, do we value this or not?
Well, I think it is something we do need to do, and it is a worthwhile investment. But the second part of my question is the question of fairness. Even within the town of Fairfield, you've got brand new schools, but then you have late 60s, early 70s schools that are in they're in actually flood zones that you can't rebuild to the same size and capacity, Sherman. And then too, on a fairness basis, we border Bridgeport. We try to be very good neighbors, but there is also fairness from the standpoint of those communities being able to get the same equality, the same fair distribution of quality and safety that every school should have in our schools. It's going to be disproportionate, some of the challenges that may occur. How do you feel about that as a Fairfield Board of Ed member in regards to the fairness question that occurs in town and throughout all of our states and our various communities? Yeah, not only urban, but rural communities as well. What do you think about that?
I think let's make it a requirement and get it done in every building. And then it'll be fair.
Well, we'll be having many chats. Thank you very much for your work, and thanks for showing and participating in the Public Health Committee.
Yeah, thanks, guys. Have a great rest
I
of
have a
your
question for you, Jen.
Sure.
Don't run yet.
Okay.
What does the Fairfield Board of Education use by way of monitoring the conditions of your schools? Do you use tools for schools?
Yes, we've
Some
got
other
tools for
methodology?
schools. Yes, we've got tools for schools. And we also just, to be honest with you, just got done doing facility condition assessment reports in preparation for some of this work, and, have built into our district improvement plan. So, I know you're not the ed committee, but, districts have to have district improvement plans. So there's indoor air quality initiatives, and they're like cleaning of ducts, just ongoing things that contribute to the overall package of this. But yes, and then the monitoring program. So I know that you've got that in here. The other bill had an assessment actually beyond the monitoring. And I did share a concern of my administration that you would be putting that bill anyway, puts everyone on the same 3-year cycle. So you've got every school in the building, every school in the state on the same 3 years, and a little bit of a concern either just internally on making, especially for large districts, getting that all done on a 1-year basis, but also having the state capacity to do every building. So that's a different bill. But if that comes before you, that assessment piece was requested to be more on a rotational basis, maybe by level or something like that, so that we're not doing the whole state in 1 year.
Well, you brought up a good point, because there really are two aspects to it. One is sort of the tools for schools rubric, which is ongoing monitoring. You catch problems before they become really big. But there's also this idea of the need for an assessment to really have done an inventory of all the schools in the state, so we know where we stand and how many of them really are going to require a full switch out of their entire systems, and how many might be remediated or retrofitted, or just change up the controls such that it runs more efficiently than it did before. If we're going to make the dollars that we have, which are just plain out not enough to do what we need in every school, we're going to really make them stretch. We're going to need the active participations of superintendents, boards of ed, your facilities people, to come up with a customized plan for each school. Right. That, we recognize that's a tall task, but it's the only way we're going to be able to stretch our dollars and really help a lot of schools.
Right. So we have that. We just finished doing that, and I can give you a rough cost estimate, at least for what it was. So, but yes, it is down to the building level, right? Because some buildings are partially already done, right? You might have a floor that's not done. You might have one wing that's not done. But the other parts are, or a lot of the bigger spaces are done, but maybe the smaller spaces are not. So it is definitely an individualized and customized thing by building, for sure. And then, of course, as we know, when you open up the walls and you open up ceilings, you never know what else is going to find. So that's always an unknown, and you've built in that contingency piece for that.
Always shocking to find that when you open the wall, it's not what it says in the plans. This happens almost all the time.
Well, we hope not.
All right. Thank you for that. Again, we're going to need a lot of help. If you want to marshal the forces and get us good information, we could really use it. Thank you for your
Absolutely.
testimony.
Anytime. Thank you, guys.
All righty. Next up, we have Diane Manning, followed by Namor Edwards.
Hello, I'm Diane Manning, President and CEO of United Services, which is the local mental health authority and mobile crisis provider in the Northeast. I'm testifying in support of Bill 5485, an act concerning various revisions, and particularly Section 6. Mobile crisis teams work with individuals in the community who are exhibiting behaviors that may put themselves or others at risk. If these individuals are not presenting a present danger to themselves or others, trained clinicians can offer help in a variety of ways once they assess the needs of the person involved. They may work to get someone connected to treatment, back on medication, into safe housing, get them food or clothing or heating assistance, whatever it takes to stabilize the person so that the police are not called again and again, making repeated visits to respond to something they cannot fix. And individuals are not being sent to the hospital unnecessarily. Most of the time when we respond, we can avert a trip to the hospital. Sometimes, though, we need additional information like medical clearance or a blood test or a psychiatric evaluation to determine whether someone needs a different level of care, like the hospital or detox, that they cannot get at home. Usually the individual can be persuaded to go to the hospital voluntarily for those additional evaluations, but sometimes a determination is made that they need to be transported to an emergency department involuntarily for their safety and the community's safety. That is where this legislation helps crisis response teams. Currently, only licensed clinical social workers and APRNs who are trained and members of crisis teams and similar identified programs can complete an assessment and issue an emergency certificate authorizing and directing that an individual be taken to a general hospital for further evaluation. Police officers can also make this determination, but they do not have the same training and experience in assessment, and it is not the best use of their resources when no criminal activity is involved. Adding other licensed clinicians, such as licensed professional counselors and licensed marriage and family therapists from mobile crisis teams to those who can provide the emergency certification for transport, expands the capacity for behavioral health providers who are facing a workforce shortage of licensed clinical social workers to respond to a behavioral health crisis at a time when we are seeing exponential increases in need. Please support this change to statute that will provide a professional level of behavioral health assessment for individuals in crisis, as well as the ability for mobile crisis teams to ensure that individuals who need additional assessment are transported to the appropriate medical facility to receive it. Thank you.
Thank you for your testimony. We're going to look very closely at the sections that you refer to in the bill. That should be very helpful to us.
Thank you.
I don't see any further questions or comments. We'll move on to Namor Edwards, followed by Francis Pillardo.
Hi, good evening, everyone. My name is Namor Edwards. I would like to say thank you to everyone here at the Public Health Committee meeting. I am the mother of Norvan Edwards as well as Norvay Edwards. I just wanted to come in today and take the time to thank those who are taking part in raising the bill in honor of my children. Senator Kelly, thank you so much for speaking today in regards to my children and just honoring their names and also just speaking on just what we have went through. I hope that by this bill being raised, it services everyone, any committee, children, also to support families as children or people are going through a mental health crisis. I just really believe that everybody just really needs to work together so no one has to go through what I went through. Because although my son is not here in physical form, you know, I lost both children. My daughter is just not well and she's trying to get better, but we're working on that. And I just never want to see this happen to anyone again. I just also want everyone to really take heed to my mother's testimony because I have been working side by side with her and the recommendations we've been thinking about together. And I hope that it benefits the task force and any other providers on providing the accurate services that people need. So please take view of my mother's written testimony And again, I appreciate everybody allowing me to speak today.
Thank you, Namor. We all know the story of your kids, and we are dedicated to the proposition of making sure this doesn't ever happen to anybody else if we can prevent it. We also heard from your mother, who's been a real stalwart with this committee and expressed many of the same desires that we can do better. And
Yes.
I just can't thank you enough for taking time. We know you're working today, and you didn't get a break any more than we did. You came right here to join us as soon as you were done. We thank you for your advocacy, for your patience in dealing with us as we try to deal with a really, really difficult problem.
Absolutely. And I'm sure that you guys will eventually be able to get it together. I have faith in you guys.
So that's what we need sometimes, is a little faith in our ability to get our act together. Sometimes it seems a bit elusive, but hopefully we get there in the end. Again, thank you, Namor, for taking the time.
Thank you.
Francis, we didn't forget about you. Sorry, it seems to have taken a little longer than we would have thought to get back, but we do appreciate it. Please provide your testimony.
I saw you, I was going through the order and I thought maybe you had gotten onto the Zoom just a little too late. Well, Mr. Chairman, Ranking Member Pettit, members of the committee, thank you. I'm Francis Polaro. I'm the Executive Director of Renew Northeast. My organization unites environmental advocates and developers and operators of the region's largest clean energy projects. I'm here to testify in opposition to Senate Bill 248 concerning Connecticut drinking water supply. Excuse me. This bill will further discriminate against solar resources by diverting more of those projects to the Siting Council's permitting process, which is really designed for large fossil fuel generators, and that's known as a certificate process, rather than allow projects like solar to be approved by the declaratory and ruling process, which is the intended path for small energy resources, including the renewable ones. So Renew feels that this change is unwarranted. Proponents of the bill portray a set of guidelines that the Siting Council has put out as there's a list of information in it that they're really saying are standards or environmental considerations that the council uses when it evaluates petitions. That's actually not the case. It really is just a list of information that it seeks. And the council's guide, though, does put in there what an actual standard is, and what the petitioner has to satisfy for the council is that it's going to comply with the air and water quality standards set by DEEP, and that the project can't have a substantial adverse environmental effect. So the environmental issues that the council is going to consider is quite broad. And as the bill proponents even noted, the council recently denied a project over concerns about drinking water. So to say that it doesn't consider that when you note that it actually rejected a project for those reasons, undermines the need for this part of the bill. And the council went to great lengths to explain in its findings that water supply and watershed management are important factors to consider when you're going to remove a lot of trees from a site for the solar project. So really nothing is gained by requiring a project to go through really something that a gigantic fossil fuel plant would have to go through to be built in Connecticut. And just the last issue I would note, the RWA said it only learned about the petition through the media. That's actually not true. You can go to the docket and see that the developers did provide it with the required notice to its property that it owns at 450R Gaylord Mountain Road. So I'm not sure how it only learned about it through the media. It was provided the notice. And then just last, just note that that DEEP is conducting a major initiative on solar energy development regulations called their STEPS program. It is going to identify policies and best practices for solar siting and permitting. So I would just encourage this committee to let DEEP finish up that process, I think it'll be very helpful to this committee and to the Energy and Technology Committee as well. So with that, I thank you for the opportunity to testify.
Well, thank you, Francis, for injecting a little energy and technology into the public health hearing. I'm watching my colleagues flee in droves since we're talking about energy policy.
I'm sure you can totally understand, right?
Right. To your point, though, help us out. We're trying to protect precious water supply lands, and we're very concerned. And we've been down this road before when we talked about clear cutting the trees in order to put up grid scale solar. And that really kind of backfired. To see the energy folks and the environmentalists at each other's throats was not a good vision. And we want to avoid that, while we want to take advantage of the fact that we have a lot of land that might be very suitable for solar if we can protect it. And nothing is more concerning to us than putting these large solar projects on lands that could have an impact on our critical water resources. And you may have heard me talk to one other person who's talked about this bill, about how excited I am to see that they're actually floating solar arrays that can go on water bodies that would actually not have, in theory, a negative environmental impact. I'm actually very open to the concept of locating solar in a variety of locations, but we have to make sure that it's going to be safe. We can't take the risk of endangering our water supply. The referral to the siting council is reflexive in the sense that who else can we send them to who will give the kind of time and effort necessary to determine whether or not this is an appropriate site? Do you have an alternative vision for how we can accomplish that?
I think, Mr. Chairman, the policy that the state has set and the expertise at the siting council worked. I mean, if I'm not taking a position on the projects per se. It's the developer isn't actually a member of my organization either, but I can just say that the project was actually rejected on the grounds of drinking water. So I'm not sure where the failure is here. If you truly believe that the project wasn't good because its location in the watershed, well, the siting council sided with that position, its body of experts. That's why decades and decades ago, this legislature created the siting council to have a panel of experts decide these issues impartially. It did consider not just energy policy, but environmental policy. So I think it works. I still, I understand your concern, and I think that's why DEEP has this STEPS program to try to fine tune it. But I think, the legislature and the siting council should be commended for having an open and transparent process filled with a body of experts. And they did, render this decision, which rejected the project. And I think, it's very challenging, and there's going to be, tension and pulling and tugging between different interests. I can certainly see, having just looked at the maps for this project today, why it picked this location. It wasn't intentionally trying to somehow do something with the water supply, I'm sure, but I can see where it was located next to a high voltage transmission line. I think there's even a substation. I don't know if it was built or was to be built there. So there's a cost. The reason a project would choose to locate in a particular place is because it's going to be very competitive. And as we move projects to other locations, it can drive up costs. So, again, there's a tension between the environment and cost. There's a lot of different factors in play. And I think the siting council does a very good job of trying to sort all that out. It has a very tough task, not just on the scientific issues, but also on the policy issues. The state has a lot of different policies it's trying to do, and sometimes they're in conflict with one another. But I think it's been doing a very good job, and it doesn't accept all projects on environmental grounds. So I think it's to be commended for its impartiality and its competence.
Well, thank you for that. And if you have specific suggestions for how we might guide the siting council for these kind of projects, if there's more we need to do to make sure that we're using the right criteria, because this is kind of an outlier to that degree, that would be greatly appreciated.
Right. Yeah, and that's, that's why really they're there to be the check. And I know my organization will be participating or we have been participating in the DEEP process. So we'll be contributing to recommendations I think that DEEP's going to come up with and provide to you. So I would just say, hold off this session. The process is, working. You do see these projects, but they don't always go through. And let's see what DEEP comes up with a very extensive stakeholder process.
Thank you for that. And again, I don't know if you submitted written testimony, but make
I
sure.
I did. Yeah,
Great.
thank you.
Thank you for that. Any other E&T committee members want to speak up? We have a number, by the way. Those two committees seem to attract certain kinds of gluttons for punishment. I don't see any further questions. Again, Francis, thank you for your testimony and more importantly, your patience as we wended our way to you. Next up is Adam Bentley, followed by Dr. Mona Shahriari.
Hi. So first, Chair Abrams, Chair Steinberg, Vice Chairs Anwar, Kushner, and Gilchrist, ranking members Huang, Summers, and Pettit, members of the committee. First, hello, my name is Adam Bentley. I'm a licensed optician in New York State. I'm a former chair of the California Board of Optometry's Dispensing Optician Committee and the head of optical operations for Warby Parker. I've been practicing as a licensed optician. I practiced in Kentucky, New York, Ohio, and California. So I wanted to thank you for an opportunity to testify in support of Senate Bill 329. Warby Parker, we provide designer quality eyewear at affordable prices, both online and in locations across the country, including 4 in Connecticut and Farmington, Greenwich, New Haven, and Norwalk, each employing a number of Connecticut licensed opticians. And we understand fully the importance of the work of the licensed opticians, what they do, and are not in favor of removing them from an optical retail space. SB 329 would make a small change to the optician statute to allow optical retailers to remain open when an optician is not on site due to an unscheduled absence. As my colleague testified earlier, we request an amendment to clarify that the stores may remain open, but should not engage in regulated acts, commonly called dispensing prescription glasses in current statute. So currently Connecticut is one of only 2 states along with Arkansas that require an optical establishment to close completely when an optician is not on site, compared to like a pharmacy that may remain open when they're not dispensing drugs, or a big box store that simply closes the optical section and offer non-prescription items like sunglasses, cleaner, cases, and other accessories elsewhere in the store. Almost everyone has been in like a CVS or a Walgreens when the pharmacist is not on site and the pharmacy counter is closed, or has seen the sunglass display near the checkout area of those big box stores separate from the optical section. Warby Parker supports SB 329 because it would clarify in statute that an optical retailer may remain open but not dispense glasses, and to engage in these same legitimate business practices that do not involve dispensing glasses. In addition, it is unfortunately poor customer experience when a store has to be closed during advertised hours. If our doors were to, if they were able to remain open, our staff would be able to explain that the optician is not on site and we cannot provide the customers with prescription glasses until the optician returns. The bill would also require clear and conspicuous signage to ensure that customers know that an optician is not on site. And what I think is exciting is this also is a great way for consumers to even learn what an optician is and the importance of the services that they provide. Warby Parker requests the committee's support for the Senate Bill 329. It's a light touch to update to the optician statute that allows retail stores, both small independent and national retailers alike, to operate on the same plane as an optical department in a big box store. So thank you for the time to speak, and also happy to answer any questions.
Thank you, Adam. I don't know if you heard much of the testimony that preceded yours. On balance, if you could call it on balance, it has been critical.
Yeah.
In fact, you've heard a number of suggestions that there could be bad outcomes. And that's obviously very concerning to the Public Health Committee. It is not our intent to frustrate any business model or good way of delivering customers quality. But let me just ask the simplest of questions. Why not just make sure you have an optician on staff all day?
And that is always our intent. 100%, that's always our intent. But we have found a little struggle with just the optician population is a little bit smaller. So fulfilling some of our locations with open roles has been a little bit difficult, but our intent is always 100% to have an optician on site. But it's the unforeseen circumstances that they might be running late or out of the business for an unforeseen circumstance.
I'm sure you understand that it seems a little disproportionate for us to be changing state law to accommodate an optician running late. We're hoping that the circumstances you describe are so rare as to be not really a problem, and maybe having some optician on call in a particular region might be sufficient to fill that gap when it occurs. We are reluctant to change our law, which we think protects our citizens, for something that seems to benefit, first of all, at least at this juncture, only one company, and secondly, seems to address a problem that might be resolved in other ways.
Thank you.
We have other questions for you after my long statement. Representative Berger-Travallo, followed by Representative Foster.
Thank you, Mr. Chair, and thank you, Mr. Bentley. Representative Steinberg kind of touched on it when I was going to ask how frequently would you not have an optician on site. I don't need an exact number. It sounds like you're aiming for almost never, but it would be lovely to know, maybe it's something that you can provide for us, is historically how often people would be calling in sick or coming in late or whatever, but just something to think about. I am hearing, and please correct me if I'm wrong, that you would potentially be in support if the language were tightened to define dispense as sort of a two-step process, the ordering and paying and fit/pickup. Would that be accurate? So if there were no optician available, the customer/patient would neither be able to place the order for the lenses and frames, nor would they be able to leave with their purchased and delivered eyewear. So they couldn't go through a fit and pickup without an optician on site. Would that be acceptable to you?
Yes, and it's similar to how we operate in other states as well, because this is just a unique instance that we do have to, close our stores down, but it is retail, unfortunately, in a retail environment. So the hours are not, 8 to 5, it could be a 10 to 9. So, ensuring that someone is always there, just in case there is like an unforeseen absence, like because like in other states, we recognize there are regulated acts, because that's what me as a licensed individual, I am trained to perform regulated acts. So we do understand that in any other state that we operate in, we ensure that our teams follow the state regulations as far as like, we are not allowed to do a specific task, whether that's exactly how you outlined it. And I think, that's a conversation that we can get into, is what exactly does dispense? How can we define that? And how can we clearly define what are those regulated acts that protect the consumers?
And if I may just follow up with one further question, Representative Steinberg. Thank you very much. So in other states, what sort of brick and mortar are you guys in? Are you in indoor malls? Are you in strip malls with your own entrance? Because I know that can also very strictly dictate the hours that you must remain open in order to not be fined by the companies that own the spaces and all of that. So I just want to get kind of a sense of that.
Everywhere. So it is both. It's both, like it could be a mall setting, it could be a street setting, it could be a standalone location. So it does vary a lot. So not all of our locations are 8 to 5 standalone locations.
Okay. Thank you very much. With that, I will turn it over to my colleagues. I appreciate your time. Thank you very much, Mr. Chair.
You don't get to turn it over to colleagues. Only I can do that. But I think you're onto something, Representative Berger-Travallo. We've been trying to find a compromise for a long time. And you may have hit on sort of the crux of the matter. If we could fashion language which addresses existing statutory limits, maybe the only path I can think of. Representative Foster.
Thank you so much, Mr. Chair. Thanks, Mr. Bentley, for joining us today. I guess I'm a little confused as I've been listening to the testimony today that these like little mom and pop shops that have like 3 or 5 employees are adamantly opposed and convinced that you must have an optician at staff and that they want that model. They're worried about you having the model. Why is it that they can staff and accommodate this, but a $3 billion corporation can't?
Multiple locations versus one location, maybe shorter hours, or it could, is there a doctor on site that they're working under the doctor's license? I think there are a few different factors that could be a little bit different from our model or like a retail setting.
But if you have multiple locations, couldn't you float opticians between stores in a pinch more easily than you could if you had like a small mom and pop that's singularly owned?
Yeah, I think, ideally, we're there to staff, like 4 opticians per store. But since we've opened, we've, have open roles. There's a smaller population of opticians, so it's not our goal, and it's not our goal to staff more. It's obviously a goal for us to make sure that we always have an optician on staff.
I guess from the small mom and pop optician shops that they feel like this would change the practice for a place like your company, but then for them they continue to operate the same way, and then you'd be fined, right, if you didn't have an optician on site and you just eat that. And so the standard of care for the field might be decreased. That's what I'm hearing, that they're concerned. Is there anything you could say that would offer consolation to, the small mom and pop shop that say like, well, there were $3 billion, so they'll just pay the fine and then operate with lower standards and then sort of devalue people's credibility in the field and make people feel less confident in the products that they're getting and the safety of them?
Well, I think that's because that's talking about we don't want to hire opticians. Obviously that's our goal, and we're not going to provide those services without the licensed optician present. So you're going to get the same value, the same value of service as an optician whenever if an optician's present, it's the same regulated acts that you're going to get at this smaller practice as well, the same services.
I guess I just find myself still confused as to why small places can staff adequately in their model, but a bigger place that could handle more can't. So, and I guess maybe it's because you're working different hours, but then I would just say, if you can't staff it, then you shouldn't be open at that time under current law. And I'm not sure why that's a problem. So I don't know that I've had my concerns assuaged, because I feel still concerned that that it seems inconsistent with what I'm hearing from the mom and pop shops, that there's only one business that's having a hard time staffing. That seems unusual, as Representative Steinberg shared, to change the legal system for a single business entity. That's going to change the way of the field practices. So I don't know if there's something you could say that would make me feel less concerned, but that's where I'm feeling concerned right now.
Yeah, I guess because I'm coming as we're coming as Warby Parker. We're not representing a large group of corporations. I mean, I know there are larger lobbying groups that do represent those larger organizations, and they speak as a group. But I know that there are many open roles within Connecticut for licensed opticians, but I'd say we're coming as an individual company trying to address an issue that we see with current Connecticut, and us being able to provide our services to Connecticut consumers.
All right, well, I appreciate your answer. Thank you.
Okay.
Well, thank you for listening to us. It's not lost on me that we can all be a little inconsistent on this. I've been a big proponent of direct sales of electric vehicles, which initially only benefited Tesla. And there are some similarities here in terms of recognizing an innovative business model that may offer benefits if we can be assured we're protecting the consumer. So it's not as if we're all in opposition. There may be some skepticism. There may be some lack of knowledge, some lack of understanding that we need to get our arms around. But I don't think anybody here is reflexively against the idea of enabling an organization like yours to be successful. But we're still scratching our heads on how to make that happen. Senator Wong.
Thank you, Mr. Chair, and thank you very much for your testimony, Ms. Bentley. Warby Parker is obviously well-recognized national brand. Did the company just go public that I read?
Yes, that was last year.
And how many stores do you have right now in Connecticut?
In Connecticut, we have
retail stores.
4. Yeah.
Now, do you franchise out to, or are all the stores corporately owned?
Corporately owned. We do not franchise, and we do not wholesale our product either.
Okay. So from a standpoint, and I want to follow up with Representative Foster's question in regards to her confusion in regards to the difficulty. In talking to many of the optometrists that spoke, they don't talk about struggles in hiring and staffing. Local businesses is what I see as a common theme in that. Maybe that perhaps could be the difference between. What do you say to kind of the good chair's commentary in regards to open market and innovation, which I fully support? But what about the idea of being able to be part of a local business, be able to franchise your operations to a local business person who maybe an optometrist, I'm sorry, that wants to buy into a business and own, to be able to build their business in the community? Has all of the optometrists that have testified, they are in the community. They own their business. They are integrally involved in the community, beyond the important aspect of healthcare delivery for our eye care. What do you say to that? Are you in a position to be able to offer that commentary on a corporate basis?
Unfortunately not. I apologize. I cannot speak to that part of our business.
And that is one of the powerful differences, as you hear in the many testimonies that I've heard from local businesses. These optometrists are local business owners. They speak for themselves and their business interests. And that is the challenge we have in this legislature, as the good chair cited, is I'm supportive of open market. I'm supportive of innovation, but I'm also supportive of our small, locally owned, community-based, family-owned businesses. And that's the challenge and the crux that we're dealing with. But I have also learned quite a bit today in regards to the medical concerns and the challenge that Warby Parker, as you stated, having trouble finding optometrists to be able to staff on a sustainable basis. So I appreciate your feedback. I truly appreciate your presentation, and I appreciate your honesty and not being able to make a statement because of the corporate nature and the hierarchy of the decision-making process. So thank you, Mr. Chair. Thank you, Mr. Bentley.
Thank you, Senator. And now you've given me a thought too, which is others have mentioned that we're a great state for education. Maybe you want to consider partnering with one of our great community colleges and put together a program where we can generate more opticians. And my guess is they'd be really excited to work for you. And that might kill two birds with one stone.
Chair Steinberg, may I address?
Please.
Yeah, so we recently actually gave our employees $10,000 towards education. So any Connecticut employee can actually utilize up to $10,000 to attend the local community college to become an optician. So we want to make sure that we do promote that within our business. We are creating opticians because we have the open positions. We are ready to hire opticians. We're ready to create the jobs for opticians as we grow in the state. And with my effort, I was able to get that approved and really help promote both the local school attendance and our employees' option to actually obtain like an associate's degree versus like an on-the-job apprenticeship.
That sounds like a step in the right direction and does address Senator Wong's desire to have you put down roots in the state, which might make a lot of things easier. We appreciate your desire to expand in the state. We'd like to see more business. You're going to have to work with us as we try to figure out how we can feel confident under those circumstances with the various unknowns that have been put forward. I don't see any further questions. My guess is we'll be talking further before this is all done. But I would take the suggestions of Representative Berger Travallo very much to heart in terms of maybe seeing if that's the only path we can find to compromise. Right now, compromise is the only way this gets done. And we need to find that common ground.
Thank you.
Thank you. Seeing no other questions, we next have Dr. Mona Shahriari, followed by Martin Schulman.
Hi, everyone. Thank you so much to the entire committee and Representative Steinberg for allowing me to give a testimony today. So I'm Mona Shahriari. I'm a board certified dermatologist practicing in Cromwell, Connecticut. I'm also the current president of the Connecticut Dermatology and Dermatologic Society. I'm actually here on behalf of 800 physicians and physicians in training in support of Bill 449, the recruitment and retention of physicians in the state. So I have submitted written testimony as well. But I just want to really thank the legislature for returning its attention to this very important aspect of access to care for our Connecticut patients. Our residents in Connecticut really deserve to have access to qualified physicians with high levels of training right here in our state. They shouldn't have to go to Boston or New York in order to get the quote unquote best care. But what we're seeing is that a record number of providers of all types are planning to reduce care or leave practice entirely. Some of this was compounded by the pandemic, absolutely, but also a lot has to do with the way physicians practice in Connecticut, and a lot of the bureaucracy that ties up our day-to-day. And we also see that there's a reduction in the number of minority practitioners coming into the state. And patients who are minorities sometimes would rather see a minority practitioner. And that partly has to do with the regulations, but also a lot of studies show that individuals from underrepresented minorities, they end up with more debt when they go through the medical training process. So a lot of times they find it challenging to stay within the state of Connecticut, given the high cost of living and that debt burden that's put upon them. I actually teach dermatology residents at both UConn and Yale, and I always try to actively recruit for my home state because I'm a Connecticut native and I love this state. And they basically tell me one of the reasons that they leave the state is because it's gotten so hard to practice medicine here, and they want to practice medicine. That's what they went to medical school for. And what they find is there's just so much red tape and bureaucracy and other measures that make it hard to be a doctor, and they have to focus a lot more on the administrative burden, which again, I do see on a day-to-day basis. But when you're from Connecticut, you love this state, but when you're not from here, it can be a little bit harder to get people to stay. So I do think we need to make an environment in the state that can get our trainees to stay, but also recruit physicians from the outside so that we don't lose this important part of the entire healthcare system and group. So this bill does a great job of including debt reduction programs and a grant for relocating to Connecticut, which can really help, given that a lot of our trainees do go into significant debt. Connecticut's considered one of the top states when it comes to the debt our trainees go through. And also it's ranked 5th in the country in terms of the high cost of living, which doesn't help. And I'm very grateful as well for the inclusion of reduction of systemic barriers to practice, like temporary reduction in licensing fees to allow physicians who really were trucking through during this pandemic to recover from a lot of the issues that came about. Being in private practice and being a private practice owner, it hurt the pandemic for us. So definitely putting this incentive into the bill will definitely help people come to our state. And finally, I support any efforts to reform Connecticut's onerous tort system, which again, we need to make sure the system is made to help out individuals who are deserving, as well as allowing other individuals to not delay the process in essence. So I really think it's a critical time right now for us to be turning our attention to this crisis we're facing in terms of physicians coming to the state or staying in the state. So I really appreciate this bill being brought forth to the committee. Thank you.
Thank you, Doctor, very much for your testimony. We're very much sensitive to the fact that we're a high cost of living state, that physicians particularly come in with potentially extremely high debt loads that have to be addressed. But I was also struck by your comment that Connecticut also throws up other obstacles such as red tape and other hurdles. Could you just be a little bit more specific on those other obstacles to recruitment and retention?
Well, I think part of it does have to do with the legal system. When it comes to getting sued, malpractice, that's a huge part of our day-to-day. A lot of times we practice defensive medicine because we're so scared of that aspect of things. But the way our tort system is put in place, it delays and dilutes the appropriate remedy to whom it's due. And it also prolongs difficulties and expenses in the cases with less merit. So I think that we should do some degree of reform. Other states have done it. The other aspect of it is a lot of the bureaucracy when it comes to being an employed physician in a private practice. Like I know as an LLC owner, there's a lot of extra legality that we have to go through. Insurance companies in the state of Connecticut can make it very tough for us to be able to come to the table and get reimbursed for the care that we're providing. Like again, as a private practitioner, every day I see my reimbursement getting smaller and smaller, but I have to pay my employees. I'm providing jobs to my employees. And if you're an employed physician who's not a business owner, you're going to leave the state. And you're less likely to come onto a job like I have and become a partner and actually make more jobs for the residents of the state.
Thank you for that answer. Really illuminating. And I think we've heard from other physicians who have talked about the difficulty in negotiating with the insurance companies, particularly if you're in a smaller group, and maybe we can find you a way to amalgamate your resources and have some negotiating power on that. As far as tort reform goes, I think I'm going to hand off to Representative Carpino, one of our resident attorneys. Maybe she'll address that. Representative Carpino.
Chairman, I hate to disappoint you. Having spent 10 years on the Judiciary Committee, I promise you that is a much longer conversation than Dr. Shrari wants to have with me right now. I really just wanted to say hi, Dr. Shrari. How are you?
How are you?
Good. You are so generous with your time. You and I have discussed these concerns on many occasions. And I just want to say thank you for coming and sharing them with the committee. I know that you face challenges every day, and yet you and your partners still seem to persevere. You kept your doors open when it mattered most. You provide really, really top-notch services to your patients. Full disclosure, I'm one, so I can vouch for that. But to the community as well. I'd like to take you up on some offers you've made in the past, so as not to delay things today, but I know that you and I have discussed real specifics that are difficult. And I know that you and your partners faced some challenges as well that I think would be helpful to the committee. So if we could chat more about those in details, I think I'd be happy to bring those specifics back to the committee, because I think they would be helpful, even going beyond this session, because we can do more to keep our physicians. I know you have also struggled with keeping high quality staff in your office. And I know that only adds to your burdens, and thanks for being here.
Oh, thank you so much. No, that definitely hits on a lot of the high points. But like you said, there's definitely specifics that we face. But today I have my representative hat on to really represent the physicians that we want to bring into the state and hopefully keep in the state.
Thank you, Representative. Well, she didn't bite on malpractice. Maybe one of our physicians will. We'll go from Representative Pettit and then Senator Anwar.
Thank you, Mr. Chair. You actually asked the question I was going to ask about the specifics, but the other one is, and Dr. Russo had testified long ago and thought we'd need a significantly larger pot of money to be able to attract people. Studies and surveys I've read seem to suggest that people are more likely to end up here if they have family here, if they finish their training here, and have a significant other that's here in some other job. Do you see that the people in dermatology that you see staying here, do they fit that criteria more, as in spouses and family, as opposed to a money or other inducement to be here?
That's a great comment. So historically, I do think that people who were from the state of Connecticut, who had those ties to the area, myself included, were more likely to stay in the state. The reason I'm concerned and I'm worried about this crisis is we don't see that anymore. I have trainees who have families in Connecticut. they leave, they go to Boston, they go to New York City, they go down to DC or Florida, because they're not seeing that long-term outlook, because they're straight out of residency. They have the next 30 years of their life to look for, and they keep seeing constant changes and struggles within our state, and they don't see those struggles in other states. I have 2 residents that I can think of off the top of my head. One of them is practicing now in Florida, one of them is practicing in Texas, and both have family in the state of Connecticut, and they just went there on their own accord because they want to build something for themselves. That's why I think that this crisis is getting to the point where our traditional measures just aren't keeping our trainees here. So we need to act now before we lose those top-notch specialized physicians that we need to deliver care.
Interesting, because probably took us 5 or 6 years to recruit an endocrinologist, and we finally got someone. That's because his family was in Hamden, and he moved back home from another job. Otherwise, we probably had never seen him. But I thank you for that answer, and thank you, Mr. Chair.
Now, I'll just submit that if you move to Florida or Texas, you live in Florida or Texas, and we think we're a hell of a lot better than that. That's my drop the mic moment right now. I'm going to hand off to Senator Anwar, both to ask you a question and to take over as chair.
Thank you so much, Representative Steinberg. Dr. Shaviari, thank you so much for your testimony. If you could actually explain how long it takes to become a dermatologist in your field. And I know the answer to that, but I think it's worthy because there are people out there who are practicing and claim to be dermatology experts. But they have not had the formal training. And that's the painful part, is that medical specializations are getting diluted in a manner which is going to come back and haunt all of us. So can you speak to that?
Absolutely. So it took me 12 years of training. So 4 years of undergraduate, 4 years of medical school, 1 year of internship, and then 3 years of dedicated dermatology residency. And some of my colleagues do a 1 year additional fellowship. So you're talking 13 years. And there are other providers that can provide dermatologic services in the state. We have our nurse practitioners, we have our physician's assistants, and there's always this thought that, well, if we don't recruit physicians to the state, they can take their place. My biggest concern about that is each of us play our own integral part in the healthcare system. And we work best when we're all together working as a team. When you have a lot of mid-levels who do not have the same level of training, who do not have that standardized training across the country, who are now your key dermatologic providers, you are going to unfortunately not get the same level of care. Because my training is unique in the sense that I learned about pathology, mechanisms of disease, treatment options for the whole gamut of everything I could ever possibly see within dermatology. And then I stay up to date with things. I'm someone who goes to conferences every other month to make sure I have the latest and greatest innovations when it comes to treating my patients. And that's very different than somebody who may have done less years of training and they learned more on the job. Because the difference is, if I see 100 different cases in my residency training, but if that 101st one comes into my office that I've never seen before, I probably read about it. I probably know the mechanism of that disease and can come up with how to treat it. But somebody who hasn't had that same training, when that 101st patient that they've never seen before walks through the office, they're going to have more challenges to treat them. The reason I know that is I work with all different types of providers in my practice. We have nurse practitioners, and I've worked with other PAs in the past, and I think they offer a good level of service. But again, we work better as a team, and sometimes the questions they come and ask me, it makes me wonder, if I wasn't in the office, would that patient have been misdiagnosed? Would that patient be started on the wrong treatment and then suffer adverse events? So we can't substitute that high level specialized training that a physician has for the level of training that someone of a different grade of provider has. Because again, everyone has their unique role in the system, but we have to work synergistically. You can't take one piece out and expect the system to still continue to work.
And earlier today, the Commissioner of Public Health said, well, we need to try to get everybody to come to the state, which is a very good answer. But right now, the issue is that the trajectory of losing the physicians to the state is going to the point that even today, and I would ask any of the members of my Public Health Committee to start to call for and then reach out to get a primary care, internal medicine, board certified primary care, and see how soon you can make an appointment. And at the same time, if you have an endocrinologist, a dermatologist, of board certified people in the state for any of your illness or your loved one's illness, and see how long it takes for you to get there. And every few months, that time is going to increase to the point that it'll be not possible to get any appointments. Just like in OB services, we are not able to get anybody to have OB services. And everybody is sort of happy that, okay, we're going to be able to use other individuals to provide those services. But there's something to be said about excellence in training. And that's part of, I think, the message that you're also giving. So
exactly.
Thank you so much.
Oh, I was just going to say that's exactly what this bill is really bringing forth. So I do appreciate every bit and piece that was put into this to recruit physicians to this state and hopefully keep them here. Because honestly, if you think about it, if our patients don't have access to care in the state and they opt to go to Boston or New York, the people who can afford to go to Boston and New York are our affluent population. Our underserved minorities don't have that option, and they shouldn't have to suffer from a lower level of care just because they don't have the resources to travel.
If you could, just one more little point that I think I wanted to maybe have you expand on is that on the West Coast, we have literally the Silicon Valley. Like everybody in the IT industry would be over there. In the East Coast, we historically, from Boston all the way to New York and then Pennsylvania for that matter, all the way down, we were the best in healthcare, the top-notch healthcare. And Connecticut has been part of that as well. But now we are going to actually move in the direction where at least there's going to be Boston, and then we'll skip Connecticut, and then we'll go to New York, and then maybe other states. And that's part of the painful thing that in the last 10, 15 years, we have seen excellence be eroded from our state because people with the highest level of training are saying we can't live here anymore. Not because of the cost as much as because of the fact that we are not getting the support that people are.
Exactly. I couldn't agree more with every statement you just said.
Good. Thank you so much.
Thank you so much,
Dr. Shariari, for your testimony, and we thank you so much. Thank you.
Appreciate your time. Take care.
Moving on to the next person on. Thank you. Stay well. The next person on the list, I am going to say is Martin Schulman. I hope I have this accurate.
Yes, it is.
Yes, good, perfect. Hi, Mr. Schulman. Thank you for your patience and welcome.
Thank you, Mr. Chairman. I appreciate it. I want to tell you, I've been on this call since 8:30 this morning, and when Senator Wang offered what I thought was a friendly repartee about your endurance and your flexibility and your intelligence and your strength, I thought it was a joke. But 9 hours into this, I am in awe of this committee, and I am in awe of your capacity for understanding a diverse group of questions on several bills. I want to tell you that I stand in opposition to Senate Bill 329, an act concerning the retail operations of optical establishments and stores. Let me tell you a little bit about myself, because you've heard some interesting facts on both sides of the equation, but not from anybody like me. Currently, I'm the district governor-elect for Rotary International District 7230. I've served in my career as a director and president of several not-for-profit boards that offer child psychiatric care, early childhood education, home health care. So I'm kind of educated in many facets of community care, but my business career is entirely different. I received my Connecticut optician's license in the spring of 1980, 42 years ago. I opened a store on Greenwich Avenue in Greenwich, Connecticut, around 6 years later, about 24 years ago. And I'm the principal managing partner in a multi-store retail optical business that operates in Greenwich, in Scarsdale, New York, in Rye, New York, and in Bronxville, New York. And I hold appropriate licenses in New York as well as Florida, Vermont, and Virginia. So coming from my perspective, you might think I could speak in favor of Warby Parker and their proposal, because I've experienced the difficulty in hiring a licensed optician in Greenwich, Connecticut. Primarily, it's because it's hard to access Greenwich, Connecticut from parts of the state where people live who earn the kind of money that an optical practice can pay. I mean, we're not a financial hedge fund, as you see on the avenue, but we've maintained a steady business for this many years, and I have not staffed the shop without an active license on the premises. There's a narrative behind that. I will not bore you with it. It's in my testimony. But just suffice it to say that for many, many years, I've been a proponent and supporter of the education program at Middlesex Community College. And when I go there for continuing education for almost a dozen hours a year, I sit in the same room as the mom and pop opticians, and I'm their peer, even though I have multiple stores doing multi-million dollars worth of business. But I feel for them, I appreciate their diversity and their inclusion. They are a unique group. Every one of them toes the line when it comes to following the law in Connecticut. On the behalf of the proponent, I want to point out that neither speaker, Mr. Grimm or Mr. Bentley, identify themselves as being licensed opticians in the state of Connecticut. And neither one was able to demonstrate sufficient knowledge of the law in Connecticut. In fact, when they were asked to define dispensing, their answer floated around big box stores and pharmacies. That's apples and oranges, totally different from opticianry. I have to say, you could look at this request to raise this bill from the lens which is used when someone seeks a variance on a zoning law. The first hurdle to prove is that the hardship was not in fact caused by the applicant themselves. In those cases, the limitation stands, the law stands, and there's no need to remedy a self-imposed problem. This bill illuminates self-imposed hardship to a legal limitation created by the proponent, in this case, Warby Parker, after the law had been in effect for many years.
Excuse me, Mr. Stillman, your time is almost up. If you could summarize.
I'm sorry, I thought I was only a minute and a half into it. I apologize.
That's
I will
okay.
say, I will say this, that
Go ahead. I was going to ask you the question, but go ahead if you want to finish.
Thank you. Thank you. A very important point here is that beyond the erosion of the protection of the patients and the general population to poorly constructed or improperly fit glasses, this corporation also dispenses contact lenses. No one has touched on that. And it's important to pause for a moment and think about that. Contact lenses are a regulated control device. The manufacturer and dispensing controlled by the FDA and the FTC, as well as strict laws in the state of Connecticut. The FDA, you can go to Google FDA.gov risks of contact lenses and see a laundry list of things that can go wrong. I'm not going to bore you with that, but just suffice it to say, one of them is going blind as a result of malpractice. And when I talk about malpractice, I'd love to ask the people from Warby Parker if they would attest that their insurance will cover anything that goes wrong in their store if there's no license present, or will they be denied coverage because of the fact that they didn't adhere to the law? So my suggestion is, in the case of Warby, understand that they answer to their shareholders who've seen a 41% drop in the market value last week after the analysts weighed in on their future. Their bottom line is influenced by high rent locations, exorbitant advertising, and high overhead. I understand this makes it difficult to find people when you're in those locations, but this too might contribute, along with the above criteria, to their failure to sufficiently staff their licenses in their high volume stores. My suggestion to the Public Health Committee is to reject the bill. Caution companies like Warby Parker that their money would be better spent in support of expanding public awareness of the licensing programs available to prospective employees, not just the ones that work for them already. That's sort of like undercover boss material. It's kind of cool, like a black shirt and a guitar box next to you, but it doesn't talk to telling the public about what it is that's important about getting an eye exam properly and having a professional fit your eyewear, be it lenses, contact lenses, or eyeglasses. And then supporting the programs of education themselves by funding chairs, furnishings for the laboratories. If you look across the state of Connecticut, many corporations have led the way with endowments to schools of business and technology. Why not them? The single best control to effect a measure of professional oversight in the measurement, design, and fitting of a patient's eyewear, and I'll close with this, is the person holding the credentials of a licensed optician. That optician must be on the site when the patient puts their trust, their health, and their vision in the care of any establishment. I recommend you don't advance this bill to a vote. And one quick comment on Representative Berger-Givallo. Dispensing doesn't just occur in two distinct areas, at the beginning and at the end. My God, if that was the case, I wouldn't have to open my stores up on a Monday morning when people rolling in the door, one after the other, have slept on their glasses or had an episode and they need an adjustment. You need a license in order to touch behind the ears. If you want to close up the wording, the verbiage about what constitutes dispensing, don't ask the wolf to guard the hen house. Form a committee at DPH level of optometrists, opticians, ophthalmologists. And congratulations, Chairman, for pivoting on when the representative for the multidiscipline practice was speaking and asking her to weigh in on what the ophthalmologist felt about this bill. And after a while, you did get an answer in opposition. If you have any questions, I'm happy to answer.
Thank you so much, Mr. Schulman, for your testimony. I think on the contact lens part, the contact lenses can be dispensed through telehealth now. This is that's allowed. So I wonder if that's part of the business model going forward. And that's obviously increasing the market share over time. So I have more questions, but I feel Dr. Pettit may be able to weigh in and better. Dr. Pettit.
Hey, thank you, Dr. Anwar. Thank you, Mr. Schulman, for your testimony. So, given your testimony, I guess I probably know the answer, but you don't see any way for there to be compromised language that a facility could be open to sell cleaning supplies for people to view frames, et cetera, unless there's a licensed practitioner on the premises?
I will give you an answer that hits right to home on that question. I was sitting in my store in Bronxville, New York, a year and a half ago. One of my good customers came back from the city on Metro North, stopped in the store. He said, "Marty, how the hell do you stay in business?" I said, "What are you talking about?" He says, "Warby Parker has a line out the door at Grand Central Station." I said, "Momo, at $99 a pair of glasses, they better have a line out there. Do you know what the rent is inside Grand Central Station? If they don't do the volume, they won't exist. If you think they could exist anywhere selling bottles of cleaner or cloths without touching the face and adjusting a pair of glasses, when someone walks in and says, 'I'm here because I have a problem with my glasses,' or 'my contact lenses are irritating my eye, can you take a look?' If they turn around and say, 'I'm not allowed to do that,' you're making, first of all, it's a disingenuous answer from them to say they would do that, because you don't have, they know full well that the enforcement of such a decision is almost impossible. You have one or two investigators. So how will you know whether they actually dispensed or adjusted glasses or performed the duties of a licensed optician without the license being present, particularly with the pressures that come from a corporate that has a bottom line that's suffering?
Does New York require a licensed practitioner on site in New York City?
Yes, the language is different than New York slightly, and the definition of dispensing is slightly different. And I have to say, I live in New York. I've practiced in both New York and Connecticut. I get a warm, fuzzy feeling about being in Connecticut because I feel protected by you. I feel protected by the laws that you've upheld over these years. And I am dedicated to going and continuing the requirements of education as an optician in Connecticut from the various sources, particularly Middlesex Community College. They have a very effective program.
Thank you for those answers, and thank you, Mr. Chair.
Thank you. Representative Berkovich-Ivanov.
Thank you, Mr. Chair. Thank you very much, Mr. Schulman. I appreciate all of your comments, and I appreciate that you've been listening all of this time, too. I'm not sure if you were listening earlier in the day when I asked probably my first question on the subject, and it was really because I am 100% convinced that in the store that I will not name, where I picked up my glasses, I was not given a fitting by them. I am nearly 100% certain that is not the department that person works in. They went into the drawer, they found my name, they handed me my glasses, asked me to shake my head, does it fit? This is why I'm asking the question about tightening up the language. I want to understand what it is that we could do to ensure that that doesn't happen, because I'm pretty sure I've just spent the last year wearing glasses that are not appropriate for me. So there's definitely a personal investment here in this question. But what I would like to know, because you seem to have a pretty broad understanding of, and please do correct me if I'm misinterpreting this, of what is happening outside of your types of establishment, your type of establishments, having commented on the lines out the door at Warby Parker. I'm trying to understand, as well as some of my colleagues as we kind of talk offline, why do they need this when no one else is asking for this? And do we suspect that does it have anything to do with salaries being paid to opticians? Is it harder to staff because they don't pay enough? Or is it, what do you think is going on here that makes this one company ask for this when your lens crafters and your Costco's aren't asking the same thing?
I love that question. Thank you. It's so well thought out. And the answer is not a short answer. I hope you bear with me. If you look at the 2019 proceedings of the Department of Public Health Disciplinary Committee, you'll see that one of the big box companies, one of the large companies, was fined a significant amount of money for practicing without a license. Their optical selling permit was at jeopardy. There was a consent order with a large number. In fact, aside from the individuals who've crossed the line on the law, the biggest fines seem to have come from that type of a business. But the business model of Warby Parker goes way back to the founding duo, Gilboa and Blumenthal, and they made it quite clear that they were going after companies like Luxottica, which owns lens crafters, as well as IMED. You know, they're vertically integrated, and the way they were going after them was to show people that you could click online and get 5 frames sent to you, and you could try them on yourself. Well, that didn't work. That was bleeding, hemorrhaging money, and now they decided they had to have brick and mortar operations. Connecticut is one state where if you open a brick and mortar operations, you better be willing to pick your location carefully enough so that you toe the line on what it takes to maintain your optical selling permit and your licensed staff. It's not easy. Look, owning a business with multiple employees, my biggest headache after 40 years is staff. I love my staff. We're a big family. But you know, people are people, whether they're doctors or opticians or associates, doesn't matter. Everybody's got the 9 million stories in the naked city. This is true. So the answer on Warby Parker is it's a lot of slick. I mean, you saw who came, very well spoken, very chic, not wearing the tie, not standing up. I apologize for not standing up, Senator Anwar, but that's one of the problems with Zoom. I don't have a podium and a camera behind it, but I do stand in opposition. So the other companies that you mentioned, lens crafters, they have a larger pool of employees. They've had a number of years behind them. Warby's a newcomer. Call them a carpetbagger if you want, because they couldn't produce anyone today who had a license in the state of Connecticut. And I think that's significant for them to tell you how to operate your state. I'm begging you as a person who's told the line to think about the people that we serve. They're the most important people, the community that requires eye care and health care, not the bottom line of a public corporation.
I appreciate the detail on that. I don't want to take up too much more time because I know that we've talked a lot about this. Maybe I could reach out to you offline afterwards, because some of the questions that I have to do with filling box stores that are going out of business. You know, if Warby Parker is going to come into my community and take a space where in a mall where that would be closing otherwise, what's the answer? So I would love to get a little bit more give and take from you that I could share with my colleagues. So I would expect to hear from Rep. Berger-Germano.
Thank you. The answer, by the way, on that is to promote education, not just for their current employees. Build a public awareness to the people of Connecticut that a well-paying job will exist in your community if you take the time to become a licensed optician. It's a secure job. It's an environment that's calm, that's protected. There's a lot of respect involved in the job. It's not a very high-paying job unless you become an owner. And those people that I've met across the spectrum at the education seminars, many of them work for corporate, some work for ophthalmology practices or optometrists, some are small independents. The perspective I have from Greenwich is a lot different than people who are in the smaller towns of Connecticut, but they're there on the front line. And I don't think Warby could open in a small town, even someplace like West Hartford. I doubt it. It's just hard enough to find a licensed optician. So support the schools, endow the schools, pay for some teachers so that they can take in more students. you'll create the workforce.
I appreciate that. Barking dog appreciates that. So I'm going to hit mute. Thank you very much, Mr. Schulman. I do appreciate your time, and thank you for your indulgence, Mr. Chair and my colleagues.
Thank you so much. Mr. Schulman, quick question. Think artificial intelligence is going to impact opticians' jobs? Because, for example, there are some fields where they looked at some radiologic tests and radiology studies, and the computer read them almost equal to radiologists and pathology as well. Is artificial intelligence and in 3D scanning going to be able to predict fitting and so on?
Yeah, so the state of the art now is that primarily we see prescriptions coming out of ophthalmology offices where a technician is applying a 3D scan or some sort of an AI scan to come up with a refraction. The standard of care for hundreds of years has been a more cultivated medical opinion. A doctor standing next to you asking you, what's your lifestyle like? What are your demands visually? Because those machines will come up with a physics equation, a vector equation that shows how to focus light on the sharpest point of the retina, if possible. They may even detect diseases that you would love to have examinations uncover. Over the years, our examinations with dilations have uncovered serious situations that have saved lives, as well as systemic disorders in their early stages. So yes, the technology, I hope, will improve to where AI can actually understand a person's needs. But earlier today, you heard from a person who talked about having a cataract removed in one eye, but not the other, and how her eyes were at different heights and how she couldn't see with the pair of glasses that was made originally until she was refit by somebody who sat her down and asked her about her computer use, her lifestyle. I tell my people that our business is 40% medical and 60% service. Own that, because you need to know the medical. You need to know the anatomy as it relates to contact lens fitting and to fitting glasses and to how the finished product's going to look optically. But the 60% is talking to your patients.
Thank you so much. And I think to I was going to say Dr. Berger-Giavalu, but Representative Berger-Giavalu's question, I think the company prides itself that they're going to disrupt the market. And the way you disrupt the market is to try to remove everybody in the middle. And then you use artificial intelligence technology, get outsourced frames and everything else, and send it directly to the consumer in a very efficient manner. And that's the part which is going to create a lot of people without technological background. I appreciate your testimony. Thank you for waiting. And we are appreciative that you waited this long because I learned a lot from your testimony. And with that, we are going to go to our next person on the list, which is Chelsea Bellafleur. I hope I pronounced it right. I was practicing in my mind.
Bellafleur. Good evening. I was on here earlier, didn't think I'd be able to testify, so I'm glad I was able to come back. My name is Chelsea Bellafleur. I'm the Adult Outpatient Services Program Manager at United Services in Mansfield, Connecticut. We are the local mental health authority and mobile crisis provider in the Northeast. I'm here to testify in support of the Bill 5485, an act concerning various revisions to the public health statutes, specifically Section 6. As a licensed professional counselor, or LPC, I am a clinician who is trained to treat clients in our community that present to us with severe and persistent mental illnesses and substance use diagnoses. Our clinicians that I supervise are trained to treat these individuals at an outpatient level. When a client meets medical necessity for this level of care, they are not in danger of hurting themselves or others, although are in need of a professional to provide treatment to help stabilize their presenting symptoms. The treatment that is provided consists of utilizing various evidence-based modalities as well as theoretical perspectives. The amount of lives that our clinicians help improve on a daily basis is exactly why I do the work I do. At United Services, our crisis response team helps various programs within our agency assess a client when they are in danger of hurting themselves and or others. Sometimes this consists of helping safety plan with the client, identifying protective factors, supports, and contracting for safety. Other times, safety planning is not enough and the client requires a higher level of care. These acute symptoms and behaviors presented often will put a client at risk and those around them if they are unable to access more intensive treatment. If it is determined that hospitalization is required, clients will often agree to go voluntarily. In other situations, clients are unable to recognize this need and refuse to go to the hospital on their own. This is when the crisis response team will be able to plan and determine if someone requires hospitalization or not. When on a mobile crisis call, there is often a limited number of providers available to authorize someone to be transferred and evaluated to an area hospital. This is where the legislation will help our crisis response team at United Services. At this time, only licensed social workers and nurse practitioners are trained and members of the crisis response teams or other similar programs in our agency are able to assess and evaluate someone who's at risk. If someone requires further evaluation, an emergency certificate is required to authorize and direct an individual to a local hospital. In the community, police officers also have this authorization to issue the emergency certificate, although do not have the same experience or training when doing so. In addition, it's not helpful to utilize their resources when there's not a legal matter at hand. By allowing other licensed clinicians, such as myself, a licensed professional counselor, or a licensed marriage and family therapist from our crisis response team or management team to provide these emergency certificates for further evaluation, it will allow for individuals to receive a smoother process that is more sensitive to their mental health needs. Thank you for taking the time to hear why I'm so passionate about this much needed change. I'm hopeful there will be continued positive change for the future of mental health and substance use treatment.
Thank you so much, Ms. Belfleur, for your testimony. We appreciate that, and thank you for staying with us throughout the day. I think your testimony was very helpful, and we appreciate that. I do not see any questions or comments, and we will move to the next person, who is Mr. Stan McCauley. Hi, Mr. McCauley. Good to see you. Welcome.
Good afternoon, and once again, thank you and everyone else for your dedicated service. Very interesting day. I get my glasses from Ocean State, so I had no idea of the intricacies of optometry, and I learned a valuable lesson, particularly with the testimony of the gentleman that just went, changed my whole perspective. But today I'm here as the president of the Greater Hartford African American Alliance, standing with Antonia Edwards, who is a member of our organization. I have the privilege of representing an extremely diverse and very broad organization in terms of our members. And so many of them have testified, and many have also submitted a testimony. So I won't go over all of the things that they went over, but I am here because our organization, in order for things to move forward, there's only really one voice for the organization, which would be that of the elected president. And so I am here to proudly stand with Antonia, and we would do whatever is required of us should we be elevated to be able to serve on the task force that she's put forward our name. We have very dedicated people, particularly on our Health, Equity, Environmental Justice Committee. And myself, along with, a designee from our committee, would love to serve. Also want to recognize the committees, your committees, honoring of Antonia's grandchildren by naming the legislation or the task force with their names, with Narve and Narvan. A very, very thoughtful gesture. In addition to that, I do want to say that once again, that we think it's very, very important that non-governmental, external, culturally competent, and medically diverse family liaison / coordinator services be mandated upon intake by mental health providers. And also another point that it's already been made, but I'll highlight this one as well, that all DCF-136 forms must include race as mandated reporters. This should be mandatory, not optional, as a follow-up to 2021's SB 1 Public Act 21-35, an act declaring racism a public health crisis. That pretty much sums up my comments for today. Thank you once again for your service. It ain't easy. And my hat goes off to all of you that volunteer to represent us. Thank you.
Thank you so much, Stan. Good to see you. And thank you for your testimony. And thank you for your volunteer work that you've been doing in the community for so many years. I have Representative Berger-Javallo who has a question. Representative Berger-Javallo.
I don't have a question. My colleagues will probably be very happy that this will be super brief. I just want to thank you for sticking around as long as you did and for continuing to advocate for a cause that is so important, but also for people who are in need of this kind of legislation for sure, but also storytellers like you to keep this going and keep that part of what it is that we're all doing here alive. So thank you very, very much for all of your words today.
I thank you for those kind comments. It's always my desire to be the last speaker, but I always keep missing it by a couple. I'll have a wonderful day.
Thank you. Thank you. And I agree with you. Antonia she's an amazing individual. Her entire family is just an amazing, beautiful force. And we are blessed in our state that they are dedicating with their advocacy work to make our state better.
Amen to that.
Okay, thank you so much. And seeing no other comments or questions, we'll move to the next person on our list, which is Margaret Miner.
Thank you. Thank you, Senator Anwar and Representative Steinberg. I'm not where I have a camera, so you have a picture of me on the rock. I'm Margaret Miner, formerly with Rivers Alliance, but still working on water consulting and working on water issues at the Water Planning Council Advisory Group. I'm here to testify on Bill 248, which I find a concerning bill, conceived with good intentions, but I fear that it accelerates an erosion of the protections that we have for our drinking water watershed lands. You addressed this, the legislature addressed this problem with Public Act 2017 or 1720, 2017, when you extended protections to agricultural land and core forests. What we need now is more protection for forests that are the majority of our forests and meadows that are not defined as core forests. I want to say that although I oppose this bill as written, I support the testimony of Karen Bernaska from Save the Sound and Denise Savageau representing the conservation districts. The amendment they suggest would be very helpful and would help to cure a couple of the problems that I see with this legislation. We start this in terms of protecting our drinking water watersheds with the problem that when applications go to the siting council, by law, they are decided by declaration, not by the usual certificate of environmental compatibility and need. So in the last few years, it's become apparent that the siting council process does not really serve to protect natural resources. And I think you all are aware of the controversial cases that have arisen there. I cite in my written testimony, which I submitted, all the state plans, including the state water plan, which put the highest priority on protecting drinking water watershed lands. And basically, these should not be touched unless there's no other option. What I would like to see and what might be helpful is when an agency or individual is called upon to do an assessment of a project proposed in a drinking water watershed land, there should be, given state policy, a rebuttable assumption, and I say rebuttable because there are always exceptions, but a rebuttable presumption that no vegetation should be removed from these lands. Anything that you remove is going to lower the protection. And that presumption could be worked in a number of different places. I'm concerned that a really heavy burden is being put on DPH to be sort of the sole agency that is responsible for advocating for protection of these lands. No one agency should be isolated that way. The drinking water aquifers, the aquifer protection areas, that's a DEEP program. That's not originally a DPH program. And if you're talking—
Excuse me, Ms. Minor, excuse me, but your time is almost up. If you please summarize. Thank you.
So I do believe that DPH should not be burdened solely with this responsibility. It's legally a heavy responsibility. And I think, I believe and urge you to require that other colleagues working on this issue, other agencies, join with DPH in any assessment of a project in drinking water watershed lands. I'm through.
Thank you so much for your testimony. Thank you so much for your testimony, Ms. Minor. I have Representative Steinberg, my co-chair, who has a question or a comment.
Thank you.
Margaret, I'd say it's great to see you, but I can't see you.
Well,
you know, usually we have people complain about how we have too many agencies involved, too many cooks for the soup. And here you're recommending that DPH alone is insufficient. So that's refreshing in and of itself. Help us out here. You're a good renewable energy person, even as you're protecting the environment and the rivers and streams. You can understand our desire to find ways in which we can become more energy independent, more zero carbon by promoting more grid scale solar. That is going to help us get off fossil fuels, which we all agree is the biggest threat we could possibly have to the environment. We have in Connecticut a lot of watersheds because of we have the benefit of water abundance. We have a lot of waterways around. Isn't there some way for us to reach an accommodation? You know, I was talking to Francis and to one other person before about, I've seen these projects that are floating solar arrays that you can actually put in your reservoirs that don't, in theory, affect the reservoir, and yet give you a tremendous amount of solar power that you can use. If we can avoid cutting trees down to that degree, isn't there a way to accommodate both our environmental protection interests as well as our clean energy interests?
Well, yeah, the basic answer is yes. And I make the point that we have always supported DPH when it has approved solar projects on water company property. We're not talking about protecting watersheds in general, just drinking water watersheds. I do believe a lot more could be done on water company property in terms of their acres of parking that could have a canopy on it. And we strongly support, I strongly support, and water advocates do, the various climate change proposals for encouraging and incentivizing more solar in Connecticut. And you know, with a rebuttable assumption, I'm saying maybe there's an exception. Now you're floating solar panels. That's been on, that question has come up in the Water Planning Council, and I've talked to Laurie Matthew about it quite often. It's a complicated issue. Where they seem to work are not really on what we call reservoirs, what we would call reservoirs, but they're more like canals. London has used them. They've been used in Japan. It's not clear that they would work in a reservoir with the standards that we have and with our weather and with the problems of materials and maintenance. However, it's not off the table, Jonathan. This is something we have been talking about, and you can make some arguments before it. I would like to talk about just your reference to greenhouse gases and global warming. I raised in my testimony the question, if you have 5 acres of woodland, which is approximately what you need for 1 mg of energy, and you have 5 acres of solar panels being proposed to be put in, which one are you sure? What does the math tells us about which one will do more to reduce greenhouse gases? And I think there's a pretty good argument that could be made that the wooded land, the trees install themselves, they're there, they don't need any maintenance, they sequester carbon, they take it out of the air, they do all this work for free. The solar panels require manufacture, moving them there, maintenance, and eventually decommissioning and taking them down. It's not clear to me that in terms of reducing greenhouse gases, one option for those 5 acres is better than another. It might depend case by case. So we strongly support more solar in Connecticut, almost any place you can put it. But at least if you want to go to our drinking water watersheds, I'm not talking about every river, drinking water watersheds, where the state policy has put the highest priority on preserving them. And, in every state plan, they get the top priority for acquisition and conservation, then we should be very cautious. And I feel there are a lot of ambiguities in this bill. Well, they ask for DPH to come forward. At the same time, there's some subtle implications that DPH should speak to. The only place they're required to consult with is the water company. So there's an implication in this bill that DPH should do everything, but they shouldn't be so independent that they don't talk to the water company who's submitted the application. So I worry about the trend and implications of this bill, which I don't think have been fully analyzed.
Well, now that you're semi-retired and only consulting, you have a lot of bandwidth left to help us figure this out. I'm glad it's not an either or for you, as long as we can promulgate appropriate restrictive language, maybe we can find common ground. I have to admit, I could not be more conflicted. I like to think of myself as a water guy, but I also consider myself a solar guy, and I can really see both sides of this one. So help us figure a way to accommodate both worthy outcomes.
So I would say put solar every possible place you can before you begin to lower protections for natural resources. And there are a lot of places to put solar, including on water company property.
Thank you for that. We look forward to further conversations. Thank you, Mr. Chair.
Thank you.
Thank you so much for your testimony. This was very helpful. We will follow up and we'll be reading your testimony. And seeing no other comments or questions, we will go to our next speaker, which is Jill Mitchell. Ms. Mitchell, thank you so much for your patience. Welcome. Please go ahead.
Thank you and good evening. My name is Jill Mitchell, and I'm the nursing supervisor and assistant director of the Fairfield Health Department. In my role as nursing supervisor, I oversee the school nurses in the district schools. My thanks to the committee for this opportunity to discuss HB 5485 as it relates to Connecticut General Statutes 10-212A, which is the administration of medications by school personnel. While HB 5485 does not directly address the statute, I, on the advice of my representative, thought it was a good opportunity to put the issue forward and improve the existing regulations. As currently written, the statute allows for coaches and athletic trainers to administer medications to students with certain medical diagnosis. This includes epinephrine autoinjectors for severe allergic reactions, inhalers for students with respiratory conditions, and intramuscular glucagon for insulin-dependent students with type 1 diabetes. Glucagon is used to correct life-threatening hypoglycemia, low blood sugar, and student athletes with type 1 diabetes are at an added risk for hypoglycemia during exercise. It is an emergency situation and requires immediate treatment. Since the statute was written in 2018, glucagon administration methods have evolved. Nasal glucagon administration is now available. Nasal glucagon is safe and effective and has been approved by the FDA. While intramuscular administration of glucagon is a complicated process and involves reconstitution of glucagon powder with a diluent, injection of the medication into a muscle using syringes, needles, an added risk of bloodborne pathogen exposure due to a possible needle stick, nasal glucagon is administered using a simple pre-filled nasal pump. In a hypoglycemic emergency, a timely and accurate response is essential for a successful treatment and positive outcome. My request today is for CT General Statute 10-212A be amended to HB 5485 to include the administration of nasal glucagon as another route of administration. Once the statute is amended, I will petition the State Department of Education to revise existing regulations that limit coaches and athletic trainers to the administration of epinephrine autoinjectors and inhaler medications only. Currently, coaches and athletic trainers do not have the authority to administer even intramuscular glucagon. As a result, if a student athlete had a severe hypoglycemic episode and fell unconscious, the only option would be to wait and waste several minutes for EMS to arrive. Nasal glucagon is a safe, effective, and efficient treatment for severe hypoglycemia, and I urge you to consider its inclusion in the statute. I want to thank you very much for this opportunity to bring a very important issue to your attention, and I appreciate your prioritizing the issue. And I certainly apologize if this was not the correct forum, but I hope something can be done about it. Thank you.
Thank you so much for your testimony. Well, I agree with you. Glucagon is very effective nasally to be able to get the results in some of these situations. So appreciate your thoughts on that. I don't see a comment or a question, and we appreciate your patience and in sharing your thoughts. I will move to the next person on our list, which is David Galito. Mr. Galito.
Thank you. Thank you very much. Senator Anwar, Representative Steinberg, and distinguished members of the Public Health Committee. My name is David Galito, and I currently hold the position as President-elect for Connecticut Realtors. Connecticut Realtors has submitted written testimony, so allow me to highlight some of the items in my testimony. We are opposing House Bill 5484. Connecticut Realtors represents over 19,000 members involved in all aspects of real estate in Connecticut, and our members work with thousands of buyers, sellers, landlords, and tenants annually. This bill would require water testing, quality testing of private and semi-public wells prior to the sale, exchange, purchase, or transfer of real property, and reporting those test results to local health authorities, as well as the Department of Public Health. Connecticut Realtors believes this legislation would be harmful to the state's housing market. We have consistently opposed any mandate occurring at the time of transfer. If there is a state concern, we believe it should apply to all property members and all property owners, not just those purchasing or conveying homes. The requirement of testing occurring at the time of transfer could delay the closing process. For example, if an inspector is not available, it could even void the closing if a seller is not able to get the test completed within the contractually obligated time. The cost for this test, which is expensive, will be passed on to the prospective buyer at some point during the process. This expense could push the cost of the purchasing the home outside of the range of what the buyer has the ability to pay. The language creating a mandated program should not be an additional cost or burden for a buyer. If the state wishes to enact such a program, it is our belief that it should be solely funded by state dollars. In the state of Connecticut, it's always been my practice, as well as the practice of my fellow colleagues in real estate, to recommend our prospective buyers perform, among others, a water potability test as a part of their home inspection process. This typically takes place within 10 to 15 days following a fully executed contract for sale. These tests are already voluntary and should not be a mandated transaction cost. Now, CTR has reached out to the Department of Public Health to discuss the implications of this bill, and we do welcome additional conversation as to how this will impact the real estate process, all while working with the department to gather information about private wells and semi-public wells across the state. Please keep in mind, we are currently in a situation where we have a significant inventory problem, and we need to be certain that we do not do anything to further impede that inventory or the home buying process. Now, I've been alerted by our general counsel that during the course of today, the department has reached out to Connecticut realtors, and we are currently in the process of setting up a time to discuss this bill in greater detail. And to the department, we thank you for that. But as it is currently drafted, we do oppose this bill. And I want to thank you for your time and attention to this very important matter, because we believe, as I'm sure you do, the importance of proper and potable water for all residents of the state of Connecticut. Thank you.
Thank you so much for your testimony, Mr. Galito. I was actually waiting and I was wondering, where is the Connecticut Realtor Association? Like, you're hoping you would weigh in on some of these bills. I have some comments and questions. We'd love to have more conversation, but I want Representative Carpino to weigh in first. Representative Carpino.
Thank you, Mr. Chairman. David, it's nice to see you, and thank you for answering a couple of the questions before I even got a chance to ask them. I'm glad to hear that the department has reached out. And I'll be honest with you, I'm torn over this. I understand how important well water quality is, but I struggle with whether or not this should be a mandate. So here's the question you didn't get a chance to answer in your very short 3 minutes. Do we even have the testing capacity in the state of Connecticut right now with the high volume of real estate transfers? My fear is, no matter how well intended this is, it would hold up transfers. I know you didn't get this bill very long ago. I didn't know if you had anything that you could add.
Well, that's true, and good to see you too, Christy. It would, and that's what our concern is. There are testing facilities throughout the state that do water potability testing, that test for a number of items, especially the items that are mentioned in this bill. And, you know, the cost of that can run anywhere from $275 to $350, depending on what specific tests you are that a buyer, a prospective buyer, might request to be done. My concern is, if this is mandated with the amount of transfers, as you just mentioned, that are occurring across the state, that we will not have the personnel to be able to handle these requests in the timely manner that is required by way of this bill. And look, I want to make it very clear. We want everyone in the state of Connecticut to have potable water. I could speak personally to this. For over 35 years, I've had artesian well water and septic on my property. And like anything else, it's just something that you have to stay on top of, and you have to maintain, and you have to test. And I try to do it every 2 years or so. for my own purposes. So why not anyone at this point in time that has a well can test at any point of the process. And but your concerns are valid, because I don't know if the state has enough personnel to be able to handle those requests.
Thank you. And then I just have one more question, Mr. Chairman, if I may. And I do understand this. Both my brother and sister have well water, so I understand what they do to keep their families safe. But is there anything that prevents a potential buyer from conducting these tests voluntarily now if they're concerned?
Absolutely not. In fact, we recommend that. Anytime I have a prospective buyer that I take to a property and they're considering it for purchase and it happens to have a well, I recommend to my client to have these tests done. And I've done this thousands of times over the course of my 20-year career. And it's the information that is provided to the prospective buyer is very important. And if there are issues, this is something that in the past that can be addressed by the seller prior to the conveyance of the property. And oftentimes it is taken care of, just like any other issue that may come up in a home inspection for that matter.
Thank you very, very much. I appreciate your help as I struggle with this. Thank you, Mr. Chairman. I'm all set.
Thank you.
Thank you so much. I wanted to ask questions, but I know the questions I'm going to ask, most likely Representative Dr. Foster will ask. So I will yield to Dr. Foster.
We have very many overlapping constituents with this issue. So I appreciate the opportunity to talk, Mr. Chairman. Thank you for joining us today to talk about this. I've been perhaps different from Representative Carpino, as I've been learning about constituents of mine who have this concern. There's part of me that wants us to be much stronger about our communications and requirements for well water testing, to perhaps blanketly require everyone to do annual or biannual water testing requirements. Because what I will tell you I am hearing is that I have constituents who moved to a new home, have been there for 2 years. This is actually a very specific example. Have had a baby that they fed formula mixed with tap water from their house with added sodium in it because there was excessive road salt. And it wasn't until they decided to implement a home brew system and tested their water for beer brewing purposes that they realized that their sodium limits were like quadruple standard requirements. That's not enough to taste a difference. And so that means that little infant, their primary food source was extra sodium for the first 2 years of their life, when the existing medical recommendations are to have no added sodium in your diet from 0 to 2. And they had no way of knowing that. And so I am certain there are lots of other examples that we could capture at different times if this law were different. But what would you recommend we do? I mean, if we just blanketly said every 2 years people have to test and they have to disclose that at point of sale, would you be opposed to that kind of language?
Anything that can be done to provide our clients and the residents of Connecticut proper drinking water, the realtors would be in favor of that. I think the thing to understand is, and for someone that has had a well for many years and represented clients that are purchasing property with wells on them, it's no pun intended, but it is a fluid situation that the wells change. And whether when the earth moves, or if someone is building down the road, or if someone is drilling another well in the area, it can affect what is going on in your own well. So to stay on top of it, each homeowner has to stay on top of it like anything else, because you don't know from one day to the next. For example, any good water testing company will tell you, and I've dealt with a few of them over the course of my career, that even in the period of time that you may go away on a vacation for a week, maybe 2 weeks, there could be coliforms that have occurred in your well. Just over that short period of time, by not utilizing the well at all or running any water. So it's just something that needs to stay on top of. There isn't any perfect answer to it other than the proper testing by each homeowner that has a well.
So if that's the case, like the recommendation is proper and regular testing, then if people were doing that, point of sale testing wouldn't be a problem because they would already have that. But the problem is people aren't doing it. So from the public health standpoint, what else could we do that would address this, that would require more regular testing to protect consumers' health? I think we heard from a representative, Nuccio, this morning that in her community, people are finding out when they have pipes that are eroding. That's the case in my community as well. But there's a large number of people who have heart conditions and kidney disease and vision issues that are related to blood pressure. And all of those things are significantly worsened by sodium or any number of other toxic chemicals. And if we don't, we need to like take a bite at this apple somewhere. So where would you recommend we start if not at point of sale?
That's a good question. I don't know if I have the be all end all answer to that. I mean, point of sale is one place to do it. There's no question about that. But again, as I mentioned in my testimony, these are tests that we do recommend as realtors for our clients that are purchasing homes. So the tests are currently voluntary. If the mandate were to come up, there might be other language that we can agree upon that would not prevent the sale from being extended or not taking place. That's all that we are concerned about. Not that we at all believe that testing of wells is something that we don't agree with. I mean, I wouldn't recommend that to any one of my clients. It's just the concern that we have that may prevent the sale from taking place or the transaction process being elongated at all.
So you want to make sure that the contamination doesn't need to be remedied for the transfer to happen, but the knowledge of the water quality is allowed to be part of the sale transaction. Requiring testing is the problem. You just don't want it to impact the sale. Though quite honestly, there might be people who they find out the water is not well, and that does.
Well, I'll give you an example. I've had clients that have had their well tested as a part of their home buying process, and the test came back with issues. One example, they had coliforms. Another example, they had that in E. coli. Other had hard water and so forth. So what do you do as a prospective buyer that they love this property, that they've fallen in love with this property, but they have issues with the water? As a part of our process, a buyer can request of the seller to remedy that situation prior to the sale. But because it is a part of the home inspection process, there are contingencies that are built into our contract that allow that prospective buyer to remove themselves from that sale or that purchase, receive their deposit monies back, and move on. So there's protection for the buyer throughout that process. And if we were to do this at time of transfer, after the home inspection process, what would be the recourse for the buyer at that point in time?
That actual simplicity was really helpful. I feel like that gives us something actionable on it. So thank you for answering the questions. And I appreciate your collegial approach to this because it's just such a concern for me from a public health standpoint. But I also know that folks with contaminated wells are concerned about their home resale value. And so I don't want to cripple those folks either. So your perspective is really helpful. And I'm just super grateful. So thank you very much.
We'd like to help with it anywhere we can. We're all in this together to make Connecticut our home, right? We want to make it a healthy home.
Thank you.
Yep, you're welcome.
Thank you so much. So I just wanted to make a couple of comments. It's not necessarily a back and forth conversation, but look, this is the Public Health Committee. Most of the time, the water may not have the taste to tell us what's in it. Water is essential for life. And then when there is something that you cannot taste and may have carcinogens based on the environment, and the well water, which is 1 out of every 4 homes in the state of Connecticut, may have some of these contaminants, we have an obligation to have a checkpoint. We do not have enough checkpoints like other states do because we do not like to change our habits at times. But right now, one way to approach this is that you actually have the check at the time when the well is set up, and then whenever it's going to exchange hands. That's part of responsibility for having a protection built in for the person who is going to be next in line to be able to buy that, because there are humans who are going to live there and pets who are going to live there. And as a result, there's going to be long-term implications for them. And that's part of our collective responsibility as a public health committee to make sure that we create a safety net of some of these tests, just like lead in the environment, right? So we do the lead testing in some of those places, and some of the smart people, when they buy the homes, they are also looking for other carcinogens and the gases that can radon gas and so on, because you can actually be exposed to carcinogens while you're just watching television at home or drinking your water at home or and so on, or cooking your food or having coffee in the water that's made. So this is only the responsible thing to do. And I know the lens that you are using it, that you want more and more closings, which will happen as well, but we want to make sure there's a risk stratification and understanding of who is getting into what. And if they're little children, we have a responsibility to protect them. That's how I see this issue. And I just wanted you to at least be aware that where I personally, in my capacity as one individual, one vote, feels we should be looking at.
Well, Senator, if I may comment on that, I couldn't agree with you more. All we're talking about is timing and when it takes place and how it takes place. The testing isn't an issue. We agree with that part of it. It's all about timing. And I'm confident that in working with the Department of Public Health, we'll be able to work that out. Because I think we all are viewing the same ending here that we want for the residents of the state of Connecticut. So I'm very hopeful that we'll be able to hammer this out and have something agreeable to all parties.
Thank you. Thank you so much for your testimony. Appreciate you staying for this long and listening to our comments and answering questions.
It was my pleasure.
Seeing no other comments or questions, we will move on to the next person on our list, which is Tracy Bernardi, followed by Dr. Guy Minetti. So Tracy Bernardi.
Hi. Hello, Senator Anwar, Representative Steinberg, Ranking Members, Senator Summers, Senator Twing, Representative Pettit, and all the distinguished members of the Health Committee. My name is Tracy Bernardi, and I'm a leader with the ACLU Smart Justice Campaign, and I am here to testify in support of Senate Bill 448, an act concerning the delivery of health care and mental health services to the inmates of correctional system. The ACLU has submitted written testimony, but I wanted to take this time to discuss my own experiences at your correctional institution in Niantic, because I believe that it informs the goals that this bill attempts to achieve. I was incarcerated in York for 23 years, from 1993 to 2015, beginning when I was 19 years old. I've been home for 6 years. I am a recovery support specialist, and I also work for one of the largest community reentry organizations in Connecticut. I am, in my personal life and in my work life, I am in daily contact with people that are still incarcerated and individuals who were released. I have a great deal of experience and knowledge when it comes to healthcare, the healthcare systems, particularly in DOC. Being able to access quality healthcare is a human right. Yet for a person who is behind these walls, isolated in a cell and hidden away, the reality is that people are suffering and being victimized by a healthcare system that does not work and in fact harms them. Today, I'm not going to talk about myself. 23 years is too long to sum up into 3 minutes. So what I'm going to talk about is someone else, and I'd like to call her Nini. She's a dear friend of mine at York. I'm using a pseudonym for her to protect her privacy. She was a vibrant young woman who loved to exercise and do yoga. But Nini began to feel tired and lethargic and began to experience cramps. She saw the sick call nurse And the sick call nurse decided and determined that Nini didn't need to see a doctor. We only had one doctor for the entire inmate population, and we shared the doctor with the male prison next door, JB Gates. So hardly anyone got to see the doctor, and if they did, it was a very rushed visit. Needless to say, DOC initially denied Nini access to a doctor and sent her back to the prison tier that we were on with a prison cure-all, Motrin. Medical gave it to us for every ailment you can think of. For 2 weeks, Nini continued to tell the staff that she was bleeding, but no one took her seriously. She got desperate and finally took off her underwear and gave them to a guard. And Nini's underwear was covered in black blood. The guard could not believe it. He made numerous phone calls demanding that Nini be seen immediately. It turned out that Nini had stage 4 ovarian cancer. The next thing I knew, beautiful Nini was taken to Ywca Hospital. I did not see her again until I went to Ywca for a medical issue of my own. Nini was a shadow of her former self. She told me that the doctors told her she had a knot in her intestine. Normally, doctors can go in and pull it out like a hose and fix it, she said, but hers was cemented to her stomach. They performed emergency surgery, and Nini woke up with a permanent colostomy bag and a catheter. They did all of it they could for her, and they sent her back to York. Not too long after, I saw Nini in hospice. She was allowed to pick 5 fellow inmates to say goodbye to. Nini was only 28. I'm not saying DOC could have prevented her cancer, but they should have taken her seriously and had her seen by a qualified doctor immediately. By prescribing Motrin and sending a person back to their, unit was the common practice. And from what I hear from the people inside, it still is. SB 448 represents a beginning step towards providing health care for people who are incarcerated, but the bill needs to be strengthened. The bill can improve accountability by establishing a commission to oversee the DOC healthcare process. And that commission must include justice impacted people like myself.
Excuse me, Ms. Bernard, your time is almost up. If you please summarize.
Okay. I
Actually, I
urge
was
the
going to
committee.
ask her to finish her testimony. So go ahead, please.
Thank you. Thank you so much. The bill should also require an appropriate amount of healthcare workers, and SB 448 should ensure that isolated confinement is not used as a treatment for management for a person's mental health, disease, or during an epidemic. I urge the committee to support SB 448 and consider these additional recommendations that will improve access to quality health care for people who are incarcerated. Thank you for listening to my testimony, and I am happy to answer any questions that the committee may have.
Thank you so much, Ms. Bernardi, for your testimony, and thank you for sharing your experience. This is very, very valuable because, the lived experience and direct understanding of what happens reinforces what we are trying to do and hopefully commits more of us to make sure that we stand with this bill and improve this further as recommended and make this happen so that we do not have any more Ninis and any more of individuals who have been impacted. So I just want to ask you a quick question. Do you want to add about your experience if you feel like, because you mentioned that there wasn't enough time and you felt you wanted to speak to that?
Well, I can honestly say that I have suffered from migraine headaches. I mean, just picking out one thing, because again, it was 23 years. I've suffered from migraine headaches for most of my life. And I don't know if anybody on this call has had migraines, but when you're incarcerated, getting the right kind of medication for what you have going on is so hard because migraine medication, as you all probably know, is pretty expensive. So they deemed it non-formulary. And so a non-formulary meant that you had to get a doctor to agree to write a letter and request it. But a lot of times the doctors didn't want it, like there was like bureaucratics, like all the stuff going on, and they didn't want to request it. They didn't want to like do that. And so they would try all these other things. And being somebody that has been having migraines since I was 12, I had already tried so many things. And I would tell them like, but this is the one medication, and it's Imitrex or sumatriptan. And sometimes I would have it. Some doctors, people that were there, they're never really doctors. They're mostly APRNs or prescribers. They would go and they would write the formulary. And then I would get another doctor and he wouldn't write the formulary when those 6 months were up. So I'd be on the medication and I'd be able to control my migraines. And then for other times I'd be at medical and I'd be just like literally there's been times that I've laid in the mental health holding cell and just cried on the floor for hours and hours and hours, and they couldn't do anything because it was non-formulary. I couldn't have it. They would give me Motrin, the usual thing that they gave. They would give, try other things, but they only would upset my stomach. I would get more nauseous and it just made it worse. There was actually the medical unit at York. What the problem about it is there was some good staff, but the problem was you had to be really cool with them in order for them to give you the treatment that you deserved. Same thing with dental. If you were cool with them, you could just, send a message through the compound through somebody that worked in medical that you needed an appointment. But if you weren't cool with them, you had to wait. And also not even about that. They pull your teeth instead of taking your teeth, instead of giving you a filling. I needed a filling and they pulled my tooth. So now I fast forward, I come home and I have the tooth next to it, the tooth next to the pulled tooth that needs a root canal. And I've just got home. I've been in prison my whole life. I've totally disenfranchised. So I'm not going to have a huge paying job. I'm on Husky. And Husky will not pay for that because there's too many missing teeth. But they said, they didn't understand the logic of pulling teeth when they could have been saved. And so now I ended up having to borrow $1,800 to pay for, can you hear me still? I think my computer's low from staying on for a while. So I ended up having to borrow this money to pay. And it's like you get further and further behind when I'm already 23 years behind. And I just wish that the medical care in prison was better, because in the future, when we come home, which most of us do, we end up in such worse conditions. And just yesterday, the cap that they gave me broke. So now I have to go to the dentist tomorrow. It's an ongoing, thing, and it could have been prevented.
Thank you. Thank you so much. And I have Representative Kennedy who has a question or comment. Representative Kennedy.
Thank you, Mr. Chairman. Thank you, Tracy, for your very passionate testimony. I just want to make sure I wasn't sure if you just didn't have enough time to finish, but you said you supported SB 448 with some additional recommendations. Are those recommendations in your written testimony?
Yes, they are.
Okay. Okay,
Yes.
so I can just look at your written testimony to see those recommendations?
Yes, I definitely just, oversight is my thing. For any of the bills coming across, I believe that oversight is the answer. I believe that oversight is going to weed out what's right, what's wrong, and it's going to contribute to public safety in the end.
I appreciate that, because I think that those recommendations sound like they could be very important to us. I just want to thank you for your testimony and wish you the best of everything going forward. I'm sure you're going to do great. So I wish you all the best, Tracy. Take care. Thank you,
so
Mr.
much.
Chairman.
Thank you.
Thank you, Representative Kennedy, and I have Representative Cavros DeGraw. Go ahead.
Thank you so much, Mr. Chairman. And Tracy, I just wanted to thank you for being here tonight and make a comment that, we see you and we acknowledge your humanity, and what was done to you was frankly inhumane. And I think that there's probably an acknowledgement by the entire committee of that, because, that's, it really is something to experience bad medical care that really didn't have to happen. And as you said, it's now exacerbated over time. And it's one of those things that taking care of your teeth, taking care of your mouth, it's something that some of us take for granted. And so the fact that that was taken care of the way it was, I just really wanted to, acknowledge and apologize that happened to you.
Thank you so much. I appreciate that.
Thank you, Representative Cavros DeGroff, for your comment, and thank you, Tracy, again for being here. You've been very helpful to all of us. We appreciate your time today. Thank you.
Thank you so much. If you guys have any further questions and you need guidance, please contact me. I'm that expert.
We will reach out to you. Thank you. And that brings us to the next person on our list, which is Dr. Guy Minetti. Dr. Minetti, thank you so much for your patience. I know you've been busy and we appreciate you staying on. So please go ahead.
No problem. Can you hear me okay?
Very well.
Okay. All right, good. Good evening, Senator Anwar, Representative Steinberg, and other distinguished members of the Public Health Committee. My name is Guy Minetti, and I'm a board-certified urologist and a partner in a 6-physician private practice in Danbury. I've been a part of this practice for the past 10 years and have witnessed a significant change in the landscape of urologists practicing in Connecticut in that time. As president-elect of the Connecticut Urologic Society, I'm here today representing over 800 physicians and physicians in training in medical specialties of urology, otolaryngology, ophthalmology, and dermatology in support of any legislation that will help recruit and retain physicians in Connecticut, including SB 449. After completing my residency at Yale and practicing in Danbury for the last 10 years, I've maintained relationships with urologists throughout the state. Administrative burdens, including documentation requirements imposed by health plans, have placed a strain on the staff of numerous private practices, as well as individual physicians, leading to physicians retiring earlier, selling their practices to become employees of hospitals, and simply leaving the state to practice elsewhere. Unfortunately, Connecticut has a reputation for being decidedly not doctor-friendly for a number of reasons. And this has led to significant challenges recruiting graduating residents and fellows to our state. Our practice struggled to recruit for over 6 years as our older physicians are slowing down and retiring. Prospective candidates were drawn away from our state, citing quality of life and lower cost living in other states with higher starting salaries and long-term compensation opportunities. Preserving the independent practice of medicine in Connecticut with its unique ability to provide high quality and value to patients requires support from legislative and regulatory agencies. For example, the Certificate of Need legislation in Connecticut limits access to ancillary revenue streams for private practices that are available to physicians in many other states. Allowing physicians to have access to some of these revenue streams will not only help sustain the independent practitioner, but can also be designed to provide a lower cost of care for patients. My practice's story is not unique. When physicians retire, we cannot shrink to profitability. We need new physicians to stay afloat as a business. The overhead burden is significant, made worse by inflationary pressure and staffing shortages since COVID. Independent urologic practices across the state have had open positions for years that cannot be filled. As a result, when physicians retire, their partners have been left with few options but be absorbed by hospitals or leave the state entirely. And that's exactly what's happened. Thank you for your consideration in supporting legislation that will continue to make a difference in the quality of healthcare that we deliver in the years to come. I'm open to any questions you guys might have.
Thank you so much. Thank you, Dr. Minetti. I wanted to start off with a question. What usually happens is if there's, let's say, a 5 individual practice and there are only 3 left, the 3 will be doing 5 people's job. And it's not that your workload doesn't decrease, so the quality of life gets worse. And that actually creates a snowball effect that 3 becomes 2, and then it becomes the end of that practice. Can you speak to that a little bit?
I couldn't agree with you more. That's exactly, and physician burnout is a hot topic, and we all are living it in that, reimbursements are going down. You have to see more patients. Now you don't have the staff to do it. So you're trying to see that many patients and care for your community the way you did. And I think that as a private practice physician, the burdens on the staff also are mounting, right? So, we're as physicians, kind of having to kind of continue to, you're burning the candle at both ends. So then you're getting, as you alluded to, those older physicians that are burning out sooner, that are leaving sooner than they might have, and potentially those younger physicians that are, not willing to continue to work this way, and they end up leaving as well. And so perhaps, some of the other, things that can be addressed are helping to take some of the administrative burdens off of the physicians and their staff. Because I do think that there is a big component to that is contributing to burnout as well. So certainly recruiting and retaining those physicians in the practice for the reasons that we said before, so that you can sustain that. But, trying to, a few things that come to mind now are, for example, prior authorizations, right? You're in the middle of seeing patients, you have a number of patients in your clinic that day, and something that's already been approved and is medically necessary according to guidelines is now you have an insurance company that's saying we need to do a prior auth. Well, okay, we have staff that are trying to do that, but then sometimes they want to talk to the doctor. So now between patients, you have to get on the phone, and it's appropriate. It's always approved, but now you've taken out that 10 minutes that, you'd be running behind with your patient, right? And now you've taken the time from your staff in the back that's been doing all this processing, and it's a cycle. So I really think that, that potentially is one place that we could, improve sort of quality of life potentially for those physicians. In addition, for medications specifically, sometimes you know the right medication for the patient. That's according to our guidelines as a from the American Urologic Association to speak. Because there are some medications that have potentially hazardous side effects to certain patients that are getting older. For example, anticholinergics, for example, come to mind. But you have these costly and sometimes dangerous requirements for this step therapy that, becomes, taxing. Again, also, you're trying to fight for your patients. You're an advocate for them, saying this is the right medication. We know it. But, we're sort of brought into this sort of vortex of having to get on the phone. And then ultimately, sometimes they can't get that medication until they've failed something that is potentially could be detrimental for them in the long run. So trying to address those things to allow the medical doctors to, make those decisions in the best interest of patients, I think would also help. And again, that's also contributing to that back staff that's having to do all this work that, again, when you're a small business, like a private practice physician, like we are, it's really kind of pulling you in many directions. And so I think those are a couple of things that I think, potentially could help, the administrative burdens on some of these, high deductible plans, for example, that patients have. My front office now, I'm hearing it from my office administrator, you're trying to get the copays and the deductibles and doing all these things. And it's just, that's time they can't do something else. So now, the physicians are trying to see that many more patients because they're that much shorter staffed. You're trying to employ, extenders to try and bridge that gap, but they need supervision because physician extenders haven't gone to medical school and residency and fellowship like we have. So we really need to supervise them. And, you're trying to, leverage them as well as you can. And then you're having all these other burdens on your staff. So I think trying to address all of these things in a multifaceted manner is not easy. But I think all of those things potentially can contribute to a better environment to provide, optimal care in Connecticut.
Dr. Melanie, in a shorter answer, from what I understand, if we do not intervene, we are 7 to 10 years away from having very few, if at all, any urologists in our state if we don't intervene. And if that was the situation, can you name 5 conditions that are urologic emergencies that we as a state may not be able to manage in our communities across different parts of our state?
Right. So, for example, a renal colic and sepsis from a ureteral stone. Right. We take care of that. Torsion. A child has, for example, a twisted testicle. That's an emergency. If you don't get something taken care of immediately, that person loses their testicle. There's infections that are emergencies that we address, either by immediate decompression of the bladder or the catheter or stent or something, or, very dangerous skin infections that can lead to something called Fournier's gangrene, for example. To name a few, certainly the patients that can't empty their bladder, for example, right? That's an emergency. And if they have a lot of blood, then you don't have somebody that's going to be able to decompress that, and they can have bleeding issues, right? And then renal failure. So we're the surgical subspecialist and can help to do these things, and we are there to try to optimize the care in as fast a manner as possible.
Thank you so much. And I can tell you, everybody who gets a hysterectomy, they can have a ureter that can be dissected, which is very commonly seen, and you guys save lives at that point.
Well, yeah, so
sometimes C-sections.
Just some of those, those complications. I mean, certainly, when somebody has an emergency C-section, the priority for that obstetrician is to get the baby out safely and protect the mother. And when they're doing that, if someone, if a ureter, for example, which is the tube that goes from the kidney to the bladder, gets injured, or the bladder, frankly, which is very close proximity to the uterus at that time, if that gets injured, we have to be available, and we come in immediately and repair that so that, there are no significant long-term sequelae. So certainly all of those things, I think, could suffer if you continue to have less and less urologists available.
Thank you so much. I cannot thank you enough for waiting for a long time. I know you had a busy day, but I appreciate you coming in and helping us out and understanding the situation better.
No problem. Thank you for having me.
And with seeing no other comments or questions, we move on to the next person on our list, which is Ann Smith. Ms. Smith.
Good evening, Senator Abrams, Representative Steinberg, and ranking members and members of the Public Health Committee. I am Ann Smith, and I serve as the Executive Director of AFCAMP, Advocacy for Children, a parent-driven nonprofit celebrating 20+ years of empowering families and engaging systems to improve children's lives. As some of you may have seen from my testimony over the years, I am a strong supporter of mechanisms designed to, 1, improve the mental, behavioral, and emotional well-being of all of Connecticut's children, especially those who have disabilities and those who are children of color. And 2, to support parents and caregivers in their efforts to eliminate systemic barriers to accessing the resources and services needed to achieve the best outcomes for their children. With regard to Senate Bill 451, I suggest to the committee that there is a more efficient means of furthering the end goal of recommendations concerning methods of expanding the availability and provision of mental health resources to children in the state. I also serve as a tri-chair of the Connecticut Children's Behavioral Health Plan Implementation Advisory Board, the Advisory Board, enabled by Public Act 1527. This advisory board comprises representatives of 12 state entities, including from the executive, legislative, and judicial branches, DCF, DMIS, DSS, DPH, OEC, CSDE, DDS, CID, OCA, OHA, JBCSSD, and the Commission on Women, Children, Seniors, and Equal Opportunity. And it also includes others that have a role in the children's behavioral health system, including family members, providers, and various other stakeholders. It was established by statute and informed through extensive input from families, providers, and stakeholders. The Connecticut Children's Behavioral Health Plan continues to stand as a comprehensive blueprint for promoting the emotional well-being of all children in our state. In my written testimony, I have a link to that plan. In October 2021, the advisory board submitted its legislatively mandated annual report to the Committee on Children. The report highlighted current work and indicated 4 recommendations. I'm going to highlight only one of them. I don't want to run out of time. Amend the statute to expand advisory board membership. The following statements were included elsewhere in the report. During 2021, the advisory board continued to focus on the unprecedented challenges to state agencies, providers, and families posed by the novel coronavirus, COVID-19, and its variants since March of 2020. As we endeavor to accommodate the needs of our citizens, we must ensure that resources are available to prevent or reduce the current and long-term adverse impact of this global pandemic on the mental, emotional, and behavioral health of Connecticut's children. Again, if you look at that language in our report that was done in October of 2021, and look at the language in proposed Senate Bill 451, it is identical. We must also take steps to address racial and social inequities that have been extensively documented as adversely affecting Black children in many of our communities. Given these challenges, the work of the advisory board in promoting realization of the goals of the plan should remain among the top state priorities, end quote. In my testimony that's submitted, you can have a link to the full report and see all of the recommendations. I suggest that recommendation number 2 above.
Excuse me, Ms. Smith, but your time is almost up. If you would please summarize. Thank you.
All right, thank you so much. Recommendation number 2 presents an existing vehicle for including those proposed members in SB 451, subsection B, who are not already advisory board members. I support providing administrative staff to the advisory board and retaining a tri-chair leadership structure. I encourage you to consider building on the work of the existing Children's Behavioral Health Plan Implementation Advisory Board as a more efficient and effective alternative to creating a new entity as proposed in SB 451. I remain committed to working with systems and the legislature towards improving children's lives, respectively submitted, and I appreciate your opportunity that you've given me to present testimony this evening.
Well, thank you for all the amazing work that you've been doing for years that has brought us to this point where you can be endorsing Senate Bill 451 and that we're finally on the right track. Just help us understand, why is it important that we expand the advisory board?
Even though the legislature, in its wisdom, incorporated a dozen state agencies and entities, our children's behavioral health system is very complex. And amongst the recommendations that I did not read to you, there was one that asked that we look at some additional agencies that are not already in the advisory board, because our children's behavioral health system has changed over the years. So case in point, DOC is not one of those 12 state agencies that was originally in the statute that created the advisory board. However, over the years, there were changes in our system that now has some of our children, yes, they are children, in our Department of Corrections, an adult facility, because we no longer have CJTS for those, for some of that population. So they are not in that original dozen of state entities, but they do have our children. And we do know that they have very severe, serious, unattended to behavioral and emotional issues. There was a recent webinar with some youths from Manson Youth Institute. I believe our Office of the Child Advocate has indicated before this committee and others on the findings of our U.S. Department of Justice around the conditions for our youth at Manson Youth Institute being civil rights violations. So that is one of the reasons why it's important to expand the membership. Another factor is that we don't have OPM listed here, but if we want to do anything at all with our children's behavioral health system, we need to be talking to those folks that control purse strings along with the PROPs. So that is another agency that ostensibly should have representation on our advisory board. Absent the focus on state entities, We need to have broader representation from families whose children are in the system. We need to be able to hear from them directly. What are some of the challenges and barriers that they are experiencing in trying to obtain the services that they need for their children? I know that we've heard and will continue to hear much about the need for additional beds and services at the highest levels of our behavioral health system. I would posit that we also need to be making sure that we are looking at where we can make investments in prevention and interventions at the lowest level so that our kids never have to get to the ED. It's important for us to hear from families who represent those communities that are underrepresented in terms of their ability to give voice to what they experience. So those are some of the reasons that I would put forth for expanding the membership and representation across the advisory board for the Children's Behavioral Health Plan.
Thank you. That was right on the mark, and you gave us any number of good reasons, including very sensibly having the money people at the table too, if you want to get things done. I don't see any further questions, but again, thank you for your dedication to this task, and we hope that this moment will afford you opportunities to do many of the things you've been talking about for years. So thank you again for your testimony. We'll talk again.
Here to assist the committee in any way that I can. Thank you very much for this opportunity.
Have a great evening. Next up is Brian Lynch, followed by Ed Hawthorne. Brian, good to see you.
Good to see you again, too. Senator Anwar, Representative Steinberg, Senator Wong, Senator Summers, Representative Pettit, the members of the committee. First, I would like you've heard a tremendous amount of testimony regarding this issue. I've submitted testimony, so I'll just highlight my key points so that we can all go home early tonight. I first want to commend you on your efforts to resolve this issue. Representative Steinberg, you and I have been at a few meetings regarding this, and again, I commend your efforts. I have also been privy to most of the conversations attached to this. My opinions here represent those of the Connecticut Optometric Association, and we believe that this initially started out as an issue where we wanted to be able to cover certain limitations in optical establishments where an optician would have to step out for a break, for a short absence, and to be able to still conduct business rather than the inconvenience to both customers as well as the business having to shut down in their absence. And that was the original intention, as I thought, and what I had heard in the conversations around this. But as drafted, the bill has no time limits over these absences, which include termination, resignation, illnesses, family emergencies. And meanwhile, patients could be dispensed or fitted for glasses or contact lenses in the absence of a trained individual. I am a private business owner, and I can tell you my biggest expense is payroll. Substituting lesser trained individuals for more highly trained, higher paid professionals is one way certainly to enhance the bottom line. We're confident that this committee will be able to balance the needs of all three stakeholders here: corporations, opticians, as well as, most importantly, patients. Those are the highlights of my testimony before you, and I wish you good luck in resolving this issue. And certainly if I or anyone within the Connecticut Optometric Association can be of help to you, please don't hesitate to call.
Well, thank you for your testimony. You've heard that we're wrestling with this, and I see that one of our key wrestlers, Representative Berger Gervalo, would like to weigh in, because she's sort of been trying to chart, as we all have, a path to compromise, though we struggled to get to that point. I'll turn it over to her for now. Representative?
Thank you very much, Mr. Chair. Yes, I'm really just trying to understand where everybody's coming from on this. And you're one of the few who has talked about something that works for all the stakeholders. Can you elaborate on that a little bit? Do you have a vision for what that looks like?
Not as wise as this committee I apologize. I think it is a tremendous inconvenience for a patient, customer of an optical establishment to not be allowed to gain access to do things like buying a bottle of contact lens solutions or a contact lens case. I see that, I hear that. But on the flip side, you're on a slippery slope there. If the individual's out and you might have a completely untrained person dispensing a pair of glasses or dispensing contact lenses, and they have no idea what they're doing. So I see both sides of the argument. I know how important it is to have trained individuals to accommodate patients when they come in there with optical as well as contact lens needs. But I don't have a resolution to this. I know that in my personal office, I oversee pretty much all of that. The people that I have working with me, tremendously trained, and they're very well knowledgeable, but the office doesn't really run in my absence. So you've got a tough nut to crack here, because you have the corporate side, as I've seen it in being privy to the conversations attached to it, you have the corporate side who really wants to kind of get away or distance themselves from having an optician on site. And possibly using a single optician for multiple locations without any direct personal supervision. And then on the flip side of it, the consumers in the state of Connecticut have become very used to a very high level of care here, administered by a licensed, trained optician who's on site. To my knowledge, there's no shortage of opticians out there, but there may be a desire not to utilize an optician and use somebody at a lesser pay scale.
You're the first person I've heard talk about a model that could potentially use a single optician for multiple locations, which is obviously something that I don't think any of my colleagues would want to see happen. And as statute exists, it's not something that would be able to happen. I understand your slippery slope. You worry that could open up for that. I do understand that. I just want to. Again, we're asking all these questions because we really want to understand what this means. With the single optician for multiple locations, as it stands in Connecticut, that can't happen now.
Cannot happen now. But let's say the legislature decides to move forward with something that says, okay, you don't have to have direct personal supervision. And conceivably, you could have one optician overseeing multiple locations with untrained staff here and there. Or let's say, here is another scenario I hadn't thought of until the other day, and that is, let's say an optician is in the throes of fitting a patient with contact lenses. Opticians are allowed to fit contact lenses in this state. And they're in the middle of it, patient comes in, they want their lenses, and the optician has been terminated. Well, who's going to pick up that ball in that period of time for the location to get an optician to take their place? And how long a time frame is that? Is it months? Is it years? We'll be told that there's an optician at another location that maybe is overseeing it, but without direct personal supervision, the optician being there on site, I don't see how that can happen. I know I certainly can't delegate eye examinations to my technicians from a remote location in the islands. It'd be nice.
Well, and I also think that even when you've got someone on staff, if the customer themselves don't know, that they can ask if this is right, can I be seen by someone who is qualified rather than just a salesperson who's handing them the piece? I mean, there are a lot of questions that we have to try and understand. There's no doubt about that, and I do very much appreciate your perspective. I am sure that my colleagues are really over my line of questioning on this, so I'm going to let this one go. But I would appreciate if it would be okay if I reached out to you as I have. I'm going to be having a lot of conversations in the next few days.
Absolutely.
And if I have any follow-ups, I would appreciate if I could follow up with you.
I would be more than happy to entertain any questions or concerns you have.
Thank you so much. I really appreciate it. Mr. Chair, back to you.
As you can see, Representative Berger Travallo has volunteered to solve this problem for us, after which we will hand her world peace.
Indeed.
Which we could really use, one step at a time. But I don't see any further questions. Brian, thank you for your testimony today, and we'll talk more.
Thank you for giving me the opportunity to chat this evening. I wish you all the best of luck. Thank you.
Thank you. Have a good night.
You too.
So next up, Ed Hawthorne, followed by Maureen Dinnan.
Good evening, Representative Steinberg, Senator Anwar, and distinguished members of the Public Health Committee. My name is Ed Hawthorne. I'm proud to represent more than 200,000 working men and women as the president of the Connecticut AFL-CIO. Thank you for the opportunity to testify in strong support of HB 5479, an act concerning indoor air quality. The COVID-19 pandemic has exacerbated the need for updated HVAC systems in our schools to provide our students, teachers, counselors, custodians, nurses, and other school staff with safe air quality standards. For too long, school staff have been forced to work with excessive heat, cold, humidity, mold, dust, and other unhealthy factors. With no enforced or guaranteed air quality standards in place, we've seen an increase in workers' compensation claims, lost school days due to closures, high number of sick days taken by students, and conditions that inhibit student learning and effective teaching. We applaud the governor's budget and the inclusion of the $90 million for improved indoor air quality in schools, but we must go further, setting minimum air quality standards and temperature standards more than just gymnasiums to guarantee that, and also to guarantee that the HVAC is performed by trained and certified technicians, and also to ensure long-term funding beyond this one budgetary item, because it's not something that is going away. We need to ensure that we repair, install, and maintain these systems in every school to ensure that a standard is set and is met. I mean, overall, we need to learn from the pandemic. I know we all want it to be over, and I'm thankful there's light at the end of the tunnel. The way I look at it, if not now, when is the right time to do something like this? I always say where there's a will, there's a way. This bill provides us with a way. I urge this committee to find the will to protect our students and school staff by supporting this bill with the changes outlined in my written testimony. Other committees are looking at this as well. I hope you all, and I'm sure you all are, collaborating with them to come up with a really comprehensive package that will make a real difference in the lives of everyone that sets foot in a school in the state of Connecticut. I thank you for the opportunity to testify, and I'd be happy to answer any questions you may have.
Thank you for your testimony. I very much appreciate your optimistic attitude, and I agree with you. This may be a moment that will not come again anytime soon, mainly because there's money on the table that we can apply appropriately. But also to your point, I think the pandemic has heightened our awareness of how broad scale these issues are, that now that we're talking about other types of contamination beyond those that you mentioned, maybe finally we have everybody's attention and we'll get serious about it. I see Representative Zupkis has a question.
Thank you, Mr. Chair. Thank you. Good evening, Mr. Hathorn. Thank you for coming. A quick question. Can you give me schools where this is taking place?
So the problem right now with the schools is, oh, wait, just to specify, are you talking about updating the HVAC or
no?
installing
So
the HVAC
you,
system? Or?
I believe in your testimony, you were talking about how, you know, the schools need, you're hearing from your teachers and folks that the temperatures are too hot or too cold and all of these things. So, sorry, that's my doorbell. So I just am curious as to know, are there specific schools that you can tell me where this is happening?
Well, I know a lot of the schools, they were telling them to increase airflow within the school to open the windows. And we're talking about the dead of winter. My kids, you know, sometimes have coats on, and I'm your neighbor in Woolpit. So, you know, I think about the older buildings too. I know my wife used to teach in Naugatuck at Salem School right on the green. Beautiful building, built in the, I believe, late 1700s, early 1800s. And she taught in a converted attic on the third floor. And I mean, she was in there while she was pregnant. And in the classroom, they had one of those fans in the windows, and that was the only source of air conditioning that they had in there. And it had a temperature on there that, you know, often hit over 90 degrees. She would then call down to the office. They would say, okay, that's too much. Why don't you bring the kids downstairs to the basement at an adjacent room and teach them down there? So they actually removed the kids from the classroom and brought them downstairs. This is not something new. That was 8 years ago when that happened. It's happening everywhere. And the problem is the funding mechanism isn't there in order to install, maintain, and repair HVAC systems that are in place. So it is a lot more common than you think.
So, so you gave me 2 examples. So Naugatuck and Wildling are the examples that you gave. So I'm just very surprised that the health districts have not come in there. I mean, if I was your wife and had to do that, you bet I would be calling the health district. So I'm surprised she didn't. But so I'm going to look further into Wolcott and Naugatuck, because I obviously know the representatives there who are very strong, and that's a problem. If it's not happening, that's a problem, and the health districts and the DPH should go into those schools. So thank you for that. And I will follow up with those schools and make sure that it's fixed.
That's great. There's also many other schools that are out there that this does happen to. Waterbury was a good example where they had to go remote due to COVID infections. If we had quality air filtration systems within the schools, it wouldn't be as prevalent as it was, just trying to get airflow and fresh air into the classroom, talk about move ratings and things such as that.
I thought Waterbury went remote, they went remote, but I know people brought in different like trailers and stuff for kids because of the distance. They were demanded that kids had to be so many social distanced apart. And I know that was a problem in a lot of schools, but if you send me a list, I'll be more than happy to follow up on those schools. Number one, and number two, DPH should be in those schools in the health districts if that is still happening.
One of the problems with social distancing is social distancing was effective when we believed it was droplets, but then we found out it was an airborne pathogen. So that airborne pathogen will spread beyond 6 feet. I mean, I always think of, remember Friendlies when they had the smoking and non-smoking sections? That whole place was a smoking section way back when. And the same occurred with COVID-19, where it just spread no matter where we were. That's the point of the masking and trying to stay further apart, but it would not be as effective as a high quality MERV 13 rating air quality system within the school with proper filtration. And that's what I think this bill is aiming to achieve in the end.
So actually, you just reminded me, because I was speaking to someone earlier in this hearing on this exact thing. And I know there was a bill passed, and it was regarding the COVID and the HVAC system. So I haven't been able to look into that today either, but I know a bill was passed for schools mandating that they have these HVAC systems. So we're putting another mandate on top of the mandate that we had. So it's just, I've got to do a little homework. And I remember flying in planes, sitting in the smoking section and non-smoking section. So thank you.
Thank you, Representative.
I think you've just reached the tip of the iceberg, Representative Ywca. Part of our problem is we don't even know the nature of the problem in some of these schools because they don't have effective monitoring. So DPH wouldn't even know where to go in. In my town, where we had tools for schools, a wealthy community with the wherewithal to do whatever is necessary, we had to strip a school down to the studs and spend close to $30 million to bring it back up again, all because of a little water incursion and an ineffective HVAC system. It's not enough simply to suggest that every school needs a functioning HVAC system. I think Mr. Hawthorne's example for a school from the 18th century is not as uncommon as you might imagine here in Connecticut. I've seen a couple of schools in Bridgeport that were named after presidents that I think were alive at the time in which they were named after them. Like Harding High School. They're really in rough shape, and we can't come up with a one-size-fits-all solution for this. But I will say, before I hand it off to Senator Anwar, this is probably the one mandate that no school district is going to argue about, as long as we supply the resources to get their schools fixed. This is a mandate that I think that they actually want. This is one where they want to protect their students and their staff. Senator Anwar.
Thank you so much, Mr. Co-Chair. Thank you, Mr. Hawthorne, for your testimony. I just wanted to follow up on a couple of things. If, let's say, there was a problem in a school right now, and let's say, as it was suggested earlier, that we reach out and then ask for Department of Public Health to come. In the absence of any regulations and standards, what would DPH do at that point?
I don't think, without a standard, I don't believe DPH can do much of anything. I mean, there was an issue out in Wallingford where they were saying that the dog kennel had higher standards than the actual schools did. So if it got too hot in the dog kennel, there was an enforceable standard to go in and say, you need to put in air conditioners, but there's not that same standard in schools. So, I mean, if we're really going to do this, we really need to do this.
Yeah, and I think that's what I wanted to allude to, is that part of the bill is also creating standards so that we actually have some guidelines. And if somebody falls outside of those guidelines, we can actually make sure that that is safe for our children. I mean, I know people don't like mandates, but I love my children and I love the children in the state of Connecticut more than the people may not like the mandates. So it's like your dislike for a mandate is costing the well-being of the children. So we have to navigate that. And the teachers are also getting impacted because they're spending significant amount of their time in that environment. Look, the indoor pollution is a real thing. 90% of the time that we spend is in indoors, and we talk about outdoor pollution, but the indoor pollution is majority of our physical day time that we're spending. And in the school system where you have vulnerable children by definition are vulnerable because they're a higher risk group, and then also because of the teachers who are spending a lot of time in that same environment where there's indoor mold and dust mites, which some of these school systems have quite a bit of. That is why it becomes relevant. So I just wanted to make those comments. I don't want people to think that just because you cannot name and give the address of all the schools doesn't mean it doesn't exist. I would sit with a group of groups of teachers, and I have had that opportunity. And this is one of the top things that they're asking for, amongst a few other aspects about violence at times in school. Some of the children, that's another thing that's been impacting the teachers, but more so right now is about the indoor environment. They cannot breathe, and then we need to help them and the children breathe better. So thank you for your testimony.
I think we've agreed on a standard. Anything we wouldn't do to our pets, we shouldn't probably do to our kids or our teachers. So if there's your lowest common denominator. I will say that in my community, our superintendent of schools at one point said when he had complaints from teachers and parents about an incipient health problem, that mold was ubiquitous and there's nothing we could do about it. I would hope that no superintendent of schools ever says that again to anybody. This is a serious problem. Representative Zupkus for the second time.
Thank you, Mr. Chair. And I just want to be perfectly clear here. I'm not saying mandates over the health of our kids. I certainly love my kids, your kids, and everyone's children. That was not my intent, nor what I was saying. So I completely understand the welfare of kids and teachers because they are the leaders of tomorrow and our future. So I certainly put our children first, even over animals. And I'm just curious as to, I think it's unacceptable that these things are happening in the schools. They're not happening in my school. And what schools are they happening? So I was hoping to find a list because I would personally look into it and follow up. So I just wanted to make that point and be very clear that mandates are not over the health of kids. Thank you.
Thank you. I don't think anybody assumed that that's what you were saying, Representative. But I will say that the point you keep making, which is where are these schools, is really an important question. We need an effective inventory of all of our schools. Every district has to take on that responsibility for understanding what the condition of each of their schools are, which is why having effective controls of the HVAC system and having a good maintenance protocol is so important. It's not a matter of what we need to do to fix these schools now. It's so we avoid having this problem again in the future. And we have a huge mountain to climb just to fix what we've got. But hopefully once we get beyond that point, we won't have this kind of problem ongoing. And that's what we all desire. Thank you, Mr. Hawthorne, for taking the time to testify. This is something very important to this committee and apparently also to other committees as well, because they're working on it too. hopefully we have both the commitment and the wherewithal to do good for as many schools as we can. Seeing no further questions, we'll move on to Maureen Dinnan, followed by Dorothy Reynolds.
Thank you very much. I am Senator Anwar, Representative Steinberg, Senator Summers, Senator Wong, Representative Pennant, and the honorable members of the Public Health Committee. My name is Maureen Sullivan Dinnan. I am the immediate past Executive Director of Haven, which is the Healthcare Professional Assistance Program in the state of Connecticut. I am here to testify in objection to Section 3 of Bill 449, which is an act concerning the recruitment and retention of physicians in the state of Connecticut. And I really want to be very clear, Haven very much supports the recruitment and retention of physicians. However, we oppose Section 3, which waives the physician licensing renewal fees from July 1, 2022 to June 30, 2025. And we ask that that section be eliminated from the bill. As I think you may have heard me testify in the past, but Haven is essentially the professional wellness program in Connecticut. If there's a concern that a professional is suffering from any number of reasons that could impact their ability to provide quality care to the patients, they're referred to Haven. And our goal is to show that that professional is taking care of themselves and they are fit to return to practice. I think Haven is an important tool in the retention of our professional healthcare workforce in the state of Connecticut. So what does Section 3 do? By waiving the fees, about half of our budget is from these licensing renewal fees of $5. So when I did the math, I could find the number of physicians in 2020. Haven would lose annually about $100,000. And you'll see in both the written testimony I've given and the written testimony of our medical director, Dr. Olson, this would decimate our program. In addition to this, this particular bill, there's been other bills, right, that have been impacting potentially Haven's funding. I was here before testifying on the compact bill, and at that time I asked for just a plan. How does the Department of Public Health or OPM intend to make Haven whole from any loss from the compact licensing? So we met with them, and the loss of the compact was from the psychology compact, and it's a lower amount of money. That's about $2,500. The plan that they've shared with us is their expectation is that the physician compact will bring in more physicians and that we should be made whole from the $5 that are given from these new physicians coming to the state of Connecticut. So when I do the math, and math is not my forte, to make up $2,500, that means they've got to bring in 500 physicians. So are we really anticipating that the compact licensing is going to be bringing in 500 physicians? And the first year that they come in, Haven will get no money because remember, we only get that $5 from the renewal fee. And then the other bill that's out there right now is the pharmacists have asked to join Haven, and we would very much welcome pharmacists into Haven as long as we could fund serving them properly. And of course, the reporting for pharmacists is going to go to the Department of Consumer Protection. The pharmacists would like to come in at the same funding rate as the other professionals, which is $5, and that's already not adequate to meet the needs. And so I really am asking all of you, you've had a long day and I appreciate that, to please work with Haven and to show that professional wellness and fitness, as well as mental health and substance use, is truly valued in the state of Connecticut. Thank you.
Thank you for this testimony. Certainly, it was never our intent to put Haven over a barrel, so to speak, by in our efforts to attract and retain critical talent. And boy, we could really use 500 more physicians if we could get them. To put you in a position where you can't carry on the good work that you do. I'm thinking maybe we need to come up with some sort of plan that would provide a dedicated funding source, at least until such time as these waivers from fees expires. And maybe we make the the waiving of the fees contingent on available appropriations. But it does sound like something we want to solve. There's some of us who have actually tried to get Haven's per practitioner fee increased, maybe to as high as $10, so that we wouldn't be over the barrel on this basis, or is subject to the vagaries of year-to-year licensing. That was not met with great enthusiasm by DPH either. But at the very least, we shouldn't make things worse. We should adopt the Hippocratic oath of doing no harm to Haven. So we have a bit to talk about, but thank you for highlighting the fact that we put you in a tough position. It's something we never intended and will seek to avoid. I see Representative Pettit has a question.
Yeah, thank you, Mr. Chairman. Thank you, Maureen. Sorry, my internet's going in and out. Hopefully it'll hang in there. Yeah, I would agree. I thought $10 I thought was an easy ask for the services that Haven provides in the grand scheme of things, but certainly you probably heard Dr. Russo earlier, who thought we need to have a different funding structure completely, and I can't disagree with that. So I just want to say thank you for staying so late to testify, and thank you for all the work you do for Haven. Thank you, Mr. Chair.
Well, thank you both very much for those comments. This is important, right, for I think for the professionals in the state of Connecticut and the patients in the state of Connecticut. And Haven would be happy to work with you to try to figure out a creative way to solve this. Thank you.
Thank you for that, and for your charity in being so willing to work with us after we pretty much screwed with your program. So we'll see what we can do to get it back on track.
Thank you very much.
Seeing no further questions, we will move on to Dorothy Reynolds, followed by Paul Kidwell.
Hi, thank you for taking the time. I know that you have heard all day about the technical issues behind why having a license on the premises is a good thing. So I am going to address other things. I am obviously Dorothy Reynolds. I'm Connecticut licensed optician. I am the president of the Connecticut Opticians Association, and I own an eyeglass shop in Fairfield, Connecticut on Black Rock Turnpike. To Warby Parker talking about their opticians and not being able to find them, Fairfield County is the hardest place to find a license due to the cost of living in Fairfield County. No one wants to travel 40, 45 miles to work, especially with the gas prices going up. That being said, I'm also aware that it is my responsibility due to the current statutes that if I will not be in my store will be closed if I cannot find a license to cover. Warby obviously did not do due diligence before coming to this state to realize about the shortage where they opened 2 of their stores. They have also stated that they have trouble finding licenses. Well, again, as Ms. Rivard mentioned earlier, 59 licenses have been issued since COVID. Out-of-state licenses are now applying to receive their license. And Warby also stated that Connecticut and Arkansas are the only 2 states that require a license on the premises to be open, which is not true. New Jersey also requires a license. Less than 1% of my sales, and I ran the numbers before this meeting, are from accessories, cases, cleaners, cloths, solutions, and non-prescription sunglasses. If that being said, Warby has stated they do not want to do anything that is regulated, which means basically you can't really do anything. To me, why would you be open then? It would cost you more money to keep the store open than it would for what you would make. It's kind of like, to me, going to Dunkin' Donuts and asking for coffee and they tell me they're out of coffee. Why are you open? I want coffee. For non-prescription sunglasses, there are certain occupations that you would have to ask questions before selling a pair of glasses to, like an airplane pilot should not be wearing polarized glasses. If they are not aware of the fact that their glasses have polarized lenses and they tilt their head, the whole world will disappear on them. There are certain occupations that should not wear particular colors. We do not like to put electricians in brown lenses because brown can distort colors. Red, you're dead. The brain can adapt to many, many things. And I have a patient recently that bought glasses online and had induced prism of 4 diopters. They have now spent almost $800 being weaned off of the prism that they did not need. It was not prescribed. Also, Warby has stated that, someone stated earlier, why have there been no complaints in states where there's no licensing? Well, Warby offers a full refund if you return their glasses to them. So how would anyone know if there were any complaints? The customer returned the glasses and got their money back.
Excuse me, Ms. Reynolds, but your time is almost up. If you please summarize. Thank you.
Okay, my biggest point here would be there is no distinction between selling and dispensing. The frame process and the lens process is probably more important than the frame adjustment from a visual point of view. There is no distinction. How will we know whether or not Warby is actually selling glasses with no optician on the premises? There's no way to monitor that. The only other thing I have to say in closing is that, again, someone brought up measurements horizontally and vertically, and they brought up glasses being crooked. If people were symmetrical, my job would be really boring. You really need to be on your game with what you're doing. I mean, these are medical devices, and that seems to be the part Warby is forgetting. That is all I have to say. Thank you very much. And if you have any questions, I will gladly answer them.
Thank you for your testimony and your candor, particularly about us all being asymmetrical. I think that we can adjust to that fact, we'd all be happier. Representative Berger-Travala.
There we go. Thank you, Mr. Chair. And if I can just let you know that, and maybe it's because we're all tired and punchy, but usually by the end of every night, I have the highlight, the line of the day that makes me the happiest. And I kind of want to walk away with a t-shirt that says, if people were symmetrical, ... So thank you for that.
You are very welcome.
So you touched on a lot. I took a lot of notes, a lot of stuff that I need to process and questions that I will take to ask as I go to speak with Warby and to others. So I very much appreciate all of that input. I have one question for you. Being a Fairfield County rep myself, of course, whatever you have to say about our county is particularly relevant to me. But what I'm wondering is, you mentioned how staffing is very difficult here because of the cost of living. By any chance, have you compared that to anywhere else in the state? I mean, do you have any sense of what it is like elsewhere, or is it really specifically Fairfield County that you've looked at in terms of being able to staff opticians?
I've looked mostly at Fairfield County because that's where my store is. Now, I bought the store in October of 2019, but I bought the store I had been managing, and I was here for the 10 years it was here. We looked for our licensed optician for a very long time. People don't want it. I'll be honest, I've lived in Fairfield County my whole entire life. There is not enough money in the world you could pay me to drive past Fairfield. The traffic is too horrific. I can see where they would have trouble in Norwalk and Greenwich, which is why I said they obviously didn't do their due diligence. That probably was not areas that they should have opened in. And I understand their pain, but again, ongoing health problems have forced me to close my store if I can't find coverage. The law is the law, and I don't think that we should be changing the law for someone who did no due diligence. Again, they said they don't want to do anything regulated. Then why open?
Well, I very much appreciate you're really helping me to punctuate my list of questions for all who have given their input. So truly grateful to you, and seriously, I'm getting that t-shirt made tomorrow. Have a lovely night. Thank you so much. Thank you, Mr. Chair.
I take an extra large, Representative Berger.
Oh, okay.
Seeing no further questions, we'll move on to Paul Kidwell, followed by Joseph Pandolfo.
Good evening, Representative Steinberg and members of the committee. Thanks for the opportunity to speak with you this evening, and I'm glad we made it before the Yukon tip-off at 9 p.m., which was my my goal here this evening. I'm Paul Kidwell with the Connecticut Hospital Association. We've submitted written testimony on a number of bills before you today. but I wanted to limit my comments this evening to SB 449. Our state should be a net importer of physicians and other clinicians, not an exporter. As you've heard today, we need to retain and attract additional healthcare staff. We support many of the provisions of the legislation and encourage a broader effort to support the healthcare workforce. Not surprisingly, I think the workforce challenges that you've heard about today are also being experienced by hospitals and health systems. The shortages that we're experiencing now certainly predated the pandemic, but the pandemic has exacerbated them. 2 years of COVID response have left nurses, doctors, and other caregivers experiencing burnout, some considering early retirement, and others simply leaving acute care or healthcare altogether. High vacancy rates and employee turnover in hospitals are driving labor costs up. We're doing what we can to retain the current workforce and recruit additional staff. We're working with the state colleges and universities to consider improvements to the pipeline, working with the Office of Workforce Strategy to train individuals as quickly as possible to get them into the workforce. It's why we support many of the provisions of SB 449. And while I appreciate that the bill before you was limited to recruitment and retention of physicians, what we've been noting in testimony to other committees is we need a broader effort. We need to think about not just our physician colleagues, but our nursing colleagues, our ED techs, our respiratory therapists. It runs the gamut today. And so as you think about, and I'm sorry, behavioral health, I can't even imagine that I moved on without mentioning the need there. But, we look across the sort of adjoining states to some of the things that they're doing, and we're certainly in direct competition with many of them. And if you look across the border at New York, the governor there outlined an initiative to increase the state's healthcare workforce by 20% over the next 5 years through a $10 billion investment, including $4 billion to support wages and bonuses for healthcare workers. And I'm not going to ask you tonight for $10 billion, but I think it's just to illustrate the point that we do need a pretty comprehensive, aggressive effort here. And we're happy to provide specifics around where we think those investments should be made. I finally wanted to note our opposition to Section 2 of the bill, which makes changes to the current covenant not to compete statutory framework. I think as you've heard earlier today, in 2016, changes to the statute were adopted, and we believe any additional changes should be considered further before the state legislature takes action. There is a group that was formed by the Office of Health Strategy, the Physician Practice Work Group, that's charged with examining this type of issue. And we recommend that prior to any legislative change, the work group have an opportunity to consider the issue. Again, I appreciate your time this evening. I know it's been a long day. I'm happy to answer any questions.
Well, thank you for your testimony. Yes, maybe it is about time we asked that working group to come back to us with some thoughts about how well the bill we passed in 2016 has worked before we move forward. And I really want to thank you for focusing on our desire to address access issues across the entire practitioner spectrum. And it's not for lack of trying in many cases. We've been focused on nurses for quite a while, ever since we saw that we'd be able to get the physician compact together. The nurses compact has proven to be frustratingly elusive, and we recognize that they're perhaps one of the most important classifications in the entire spectrum of care. And we're still hopeful maybe we can work out a compact for nurses, even if we can't get it done this year. I think we'd say the same thing for different reasons about social workers that fulfill so many roles, particularly at the front end of a lot of the identification and prevention aspects of things. We recognize the magnitude of the problem, but I think that to your point, Governor Hochul's commitment of $10 billion shows that other states have been willing to put their money where their mouth is, to a degree that Connecticut still needs to step up. So thank you for that. I see Senator Anwar has a question.
Thank you so much, Mr. Chair. Mr. Kidwell, have you looked at the data about the employed physicians for large corporations do not necessarily stay in the area, and then the turnover for them is quite high compared to the ones who are in private practices? Have you been able to analyze why that happens?
I don't know if I've seen the data that you're referring to. Senator, happy to review it. I would say certainly our hospitals and health systems are going to great lengths to ensure that the employed physicians in our organizations are retained. Certainly happy to have additional discussion related to how we can improve those efforts and why individual physicians may be turning over. I think interestingly, listening to many of the physicians testify today, I think there's a lot of common cause here with those physicians in those small group practices. I think they've noted some of the burdens of the prior authorization process, certainly which we think need to be improved. And I was listening to Dr. Minetti very closely because I think he really described how that can be burdensome throughout the day, right? The 10-minute interval having to go talk to the insurance company about a prior authorization that he knows is going to be approved, but he has to talk to someone on the other end of the phone to say yes. Certainly the review of malpractice costs certainly is something that we support as well. But happy, certainly, Senator Anwar, to continue that discussion with you related to.
I think what happens is some of the larger corporations and groups, when they employ a physician, and I've those situations. One of the other hats I wear is I'm a chairman of Department of Internal Medicine for hospitals, 2 hospitals in the area, and when physicians are leaving, I am the one who may know them and then helping complete the forms for their next job outside of the state. And we see people leaving over the last many years, and the numbers are increasing. It's worthy to start to see why the independent practices are staying on board, the ones who can survive, and the ones who are employed are actually not able to stay in the same place, and then the restrictive covenant restricts them. And then the only option they have is to either go out of the state, and then we are all without the physician. So there are a lot of internal challenges. I know one of your responsibilities to make sure you protect the hospitals. I think that there is an opportunity to work together, but look at the bigger picture. There's an immediate feeling that the hospitals may have that they need to have a market share. They need to actually have their own specialties in place, which is good. But creating sustainability around that requires collaborative strategies. And then that's something that is needed. And those have been the strategies that the rest of the country, or at least many other parts of the country, have been very successful with. So maybe there's an opportunity to have conversation around some of those. With respect to the other workforce and behavioral health, there's a bill that is going to look at that. And then we have to address that, no question at all. We need to get physicians, PRNs, PAs to be able to address that part for the behavioral health part. And there's a bill looking at this. But while we're looking at this, we do not want to take away from the physicians, because what's happening is large corporations' interest is to try and get increase the workforce with not necessarily the highest level of training, because it's lower cost, and the return on that the reimbursement that they get, their financial gain is higher in that set. And as a result, they're increasing that workforce at the cost of getting excellence in care or highly trained individuals. We see that pattern. I know that pattern because I live in that space. So we have to identify sustainability within that arena. So I just wanted to leave you with some of those thoughts. And this is part of what the bill is about too. So thank you for your testimony.
Yeah, thank you, Senator. Thank you for that very much, and appreciate that. Absolutely agree with you. Collaboration is essential here, and certainly CHA and the hospitals are always willing to come to the table to think through sort of unique or new ways to support care delivery to our patients, which is certainly the #1 priority, and I know for you as well.
Thank you so much, Mr. Chair.
Again, thank you for your testimony. We know we'll be talking further about ways in which we can hone some of these sections of this bill.
Thank you so much. Have a good evening.
You too. Joseph Pandolfo, followed by Jenna Lee Cobb.
Thank you, Representative Steinberg and Senator Anwar, Senator Huang, Senator Summers, Representative Pettit, and members of the committee. Thank you for your service and thank you for your endurance for public hearings like this. My name is Joe Pandolfo, and I serve as a non-practitioner public member of the board of directors of the Connecticut Society of Acupuncturists. And I'm here today to offer our group support for Section 10 of House Bill 5485, the act concerning various revisions to the public health statutes. This section increases flexibility around the supervision required for acupuncture detoxification specialists. And as a professional organization for fully licensed acupuncturists in the state, we fully support the supervised practice of these certified specialists. While their practice is narrow in scope, we know that it's a very effective adjunct therapy for patients who are undergoing professional addiction treatment. And we've long been encouraged by the Department of Health's recognition of this supervised practice as a way to help meet the pressing need for effective addiction services. And under this bill, we wholeheartedly support the provision of the treatment by these specialists under the supervision of a licensed acupuncturist or a physician assistant or advanced practice registered nurse, as well as what's in the current statute, which is supervision by an MD. With the extensive training and expertise in the complete system of acupuncture, we feel particularly that the licensed acupuncturists are well suited to provide useful supervision for these specialist services. It was interesting to hear there's a lot of compelling testimony today about the need for addiction services generally. And we think this Section 10 in this bill is just a smart change. It will improve the availability of this valuable acupuncture treatment in addiction treatment programs. And we appreciate the opportunity to support this change. And I'm happy to answer any questions.
Thank you for your testimony, and thanks for pointing out that maybe we got something right in one section. So
absolutely.
Yeah, we're very open-minded about ways to address the problems. We recognize we have a long ways to go yet, but thank you for your focus on that, and we will read. You did submit written testimony?
I did, yes.
We will look at it very carefully. We appreciate that.
Thank you.
I don't see any questions, so we will keep going. Next up is Jenna Lee Cobb, followed by Douglas Wilson.
Good evening to all the members on the Joint Committee of Public Health. My name is Jenna Lee Cobb, and I'm a first-year student at Yale University. I'm testifying in strong support of SB 448, an act concerning the delivery of healthcare and mental health care services to inmates of correctional institutions. I'd like to start with reading off a few names and dates. Philip Richardson, March 26, 2012. Isaias Perez, May 2nd, 2012. Cassandra Baker, January 25th, 2016. Daniel Ocasio, August 12th, 2020. James Harris, November 10th, 2020. These are just some of the names of the many inmates who have committed suicide in recent years while in a Connecticut correctional facility. Some studies show that the average annual rate of suicide in Connecticut state prisons is around 24 per 100,000 inmates across the CDOC. Suicide should not be a regular part of life for Connecticut inmates. In a state with one of the highest per capita numbers of mental and behavioral healthcare professionals, those in the care of the state should not be suffering due to lack of access. While most of the individuals I named died before the COVID-19 pandemic, inmates today say that the pandemic and the regulations instituted by the CDOC have only worsened the mental health of prisoners at large. According to Crystal Liss, an inmate at York Correctional Institution, inmates are often locked in their cells for 23 hours a day and are only let out for 30 minutes at a time, once in the morning and once at night. Sometimes staff deny them even that, simply because they can. These regulations are inhumane and only serve to harm the mental health of all Connecticut inmates. The least the state can do is expand access to mental and behavioral health resources, and SB 448 would do just that. Not only would this bill ensure that every correctional facility in Connecticut has at least 4 licensed mental health professionals, it would require that those professionals see patients whenever they request care, in addition to when they are referred from practicing physicians. This is vital to protecting the health and lives of those within the CDOC and decreasing the chance for recidivism in the future. Inmates facing mental health issues are many times more likely to recidivate than those without. Providing them adequate care while in prison can help mitigate this fact. SB 448 will make great strides to reducing rates of serious mental health issues in Connecticut prisons and preventing future recidivism. And as a result, I urge you to vote in favor of SB 448. And I thank you for the opportunity to speak today.
Well, thank you for your testimony. Very focused. I have to say, I'm quite impressed by the research you did to identify those who have really been let down by the system in any number of ways. Very impressive for a college freshman. I remember my freshman year at Yale, I was focused on a lot of things, a lot different than what you are. And I have to ask the question, how did you get on, how did you develop an interest on this subject? And what led you to testify today?
So that is a great question. While I am a freshman, I have been working around criminal justice reform for about 3 to 4 years now, a lot of which I spent reading letters from inmates who needed help with civil or criminal cases. And reading those letters, reading their direct words about the situations that they're facing in prisons, about what led them to being in prison, is incredibly impactful. It's very clear that a lot of these people are suffering from very serious mental health issues that led to them being in prison in the first place. And if they're not receiving any help while they're in the care of the state, then the state is not doing the job that they are supposed to be in terms of rehabilitating and re-entering them into society. So I do find it incredibly important because of that.
Well, we certainly concur with you. I was taken by your phrase, this will allow us to take great strides. Well, we need to take a large number of great strides just to bring the system up to snuff. So we appreciate, it's important to hear that you're supportive of this. I can't guarantee we're going to get it all done in one foul swoop this year, but we're very dedicated to the proposition of improving conditions. Seeing no other questions or the like, thank you. Have a lovely evening. Continue your good work. I'm not going to ask you to sing both verses of Bright College Years or anything like that. And you don't even know what that is. That tells me a lot. All right, we're going to move on. Douglas Wilson, followed by Paul Hoare.
Good evening. Can you guys hear me?
We can.
Yes, awesome. Hey, thank you, Representative Steinberg and everyone on this committee here for the opportunity to speak. My name's Doug Wilson. I'm a 10-year, I've been in the optical field for 10 years. I've been licensed for, I believe, 5 or 6. And this has been my first and only career after I left high school. And I wanted to speak on State Bill 329. You'll have to forgive me because I'm doing this on my phone. I've been listening while I've been here at work. So I'm going to be kind of going back and forth between my notes. But I submitted some written testimony, but I wanted to speak on some specific notes that have kind of come up during the discussion on prior testimony. And the biggest things that I've noticed that we should also keep into consideration are going to be things such as safety eyewear and the ability for someone as an apprentice optician unsupervised to recognize when a frame is a safety frame, when it would require safety lenses. The other one is, things that apprentice opticians met routinely in my time, and I've fostered plenty of apprentice opticians, is understanding the importance of measurements for children. Dr. Arlen talked on it very briefly, but what he didn't say, which I wanted to make sure, or didn't make very clear, is that the inability to take proper measurements for a child kindergarten age or younger, it would cause lifelong vision impacts and sometimes loss of vision in one eye, if not sometimes both, when the measurements aren't taken correctly. This is part of my job as a licensed optician to make sure that these things are not just right, but they're perfect. Other thing is that in Connecticut, the optician has the unique ability not only to fit contact lenses, but one thing that I haven't heard on this entire 12-hour call is we prescribe contact lenses, the only thing that we're allowed to prescribe. And so this means that I can fit and prescribe contact lenses of any kind, whether they're specialty lenses, rigid lenses, for anything, without the supervision of a doctor. And this bill would also allow unintendedly apprentice opticians to fit and prescribe contact lenses without the supervision of an optician. The biggest thing I wanted to talk to is about how many opticians I have at my job. I'm the optical manager here at Costco. You can kind of see it behind me. And there's 6 of us in total. And so, at every Costco that I can think of, there's enough licensed opticians to cover all working hours. We're open 10 to 8:30, Monday through Friday, and about 9:30 to 6 Saturday and Sunday. And I have no problems ever covering my store with licensed optician staff. And we've opened a new store about 15 minutes south of here, 20 minutes south of here. And we were able to open the new store, and we expected to be a little bit less business, but we had 4 licensed opticians in no time flat. We also operate another optical shop in Norwalk. They have 6, if not 7 opticians. And it's not that far from some of the Warby Parker places. The thing that I submit to you guys is to think hard about how the Connecticut opticians, we've made almost 60 new licenses in 2 years, which is the highest it's almost ever been. But to me, that seems like 60 opportunities that Warby Parker has dropped the ball on finding adequate coverage and licensed help. They aspire to have 4 licensed opticians in every store. They have 3 stores in Connecticut, and none of them seem to have any licensed staff. I actually know one of the opticians that works on with their staff, and they spend quite a lot of money and time trying to cover her going from Connecticut to also all the way to Boston to cover places. This is not an issue in just Connecticut alone that Warby Parker has. Warby Parker has a hard time attracting licensed, professional, very good help. And I think that their solution to this is to move the goalposts a little bit so that if they don't find a licensed optician ever, they would never really have to worry about not having one. The other thing that
Mr. Wilson, your time is almost up. If you could summarize. Okay. Thank you.
Yeah. I think I've touched on a lot of the other things. I just wanted to make sure to say that I don't think that I don't trying to be very stern about this, but I don't find a way that we can find a compromise on this without compromising the health and safety of the Connecticut resident. This profession has been something that has been my absolute passion since I was 19 years old, and I love everything about it. And I would hate to see the hard work that I put into learning and honing my craft whittled down to something that someone with about 5 minutes worth of experience would now be licensed and qualified to do, and which they're not. Thank you again for your time. I'm open to any questions.
And it seems as if we have one. I see Representative Berger-Chavallo, followed by Senator Anwar.
Thank you so much. Thanks for sticking around and for listening. And I appreciate actually very much that a lot of your testimony was addressing things that you had heard throughout. I wonder if your notes are as long and cumbersome as mine are at this point.
Not quite, because I've had to keep my ear on it and then leave. But I've been listening.
Well, you've actually also helped me add to the questions that I will ask as I get to Warby Parker and to others. My question for you: you are one of the few who has mentioned apprenticeships. Is that something that you have any experience with?
Yes, absolutely.
Okay, so can you just broadly speak to what that is meant to look like? And if you can, contrast whatever, if you know, I'm not looking for you to project anything or to make any guesses, but if you have any thoughts about what that looks like in Warby Parker with the person who you know who has been there. Again, I'm not looking for you to speculate. I'm just wondering if you know anything about apprenticeships.
I want to be very careful. I don't want to speak on what Warby Parker has for apprentice opticians. And I know that I will say I know that they have made good efforts to try and take the apprentice opticians they have and turn them into licenses. And I know some of them do go to the school. But the thing is, I mean, what it comes down to is dollars and cents, right? When I got my license, I want to know, I need to, especially to grow my family, I need to make sure that I'm making the highest dollar amount possible and the most attractive job. And it seems to me that if you can even harbor, some young person, a young man or woman to learn this field, but then when they become licensed, which happens very often, that you're not able to offer a high enough wage to them, they will go elsewhere with that license because, the good thing is that this is a job that's in demand. I did that exact same thing. And when I got my license, I was working at a private practice. And unfortunately, just at the time, the practice just couldn't support me being there at full time as a licensed optician. So I respectfully, and I still have great relationship with those doctors, but I respectfully moved on to somewhere where they could pay me better. To answer the other question about how it looks at where I'm at, Costco doesn't normally do apprentice opticians. I can only think of there's 2 locations out of all the Costco locations in Connecticut that I know of that have apprentice opticians, and it's really, there's only 1 at each location. And that's for the simple fact that we don't want to run into any instance that there wouldn't ever be a licensed optician available to help anyone with any question. I just wanted to say, just very briefly, in my time as an apprentice, just dispensing, or not an apprentice, but licensed optician, just dispensing, I can think of 3 things on the top of my mind that I've literally saved someone's vision. I even had one woman that perfectly described to me a retinal detachment, even though to an average person, a layman, this may just be blurry vision, and you may send the patient home. I referred her immediately to the doctor, and she came back that same week and she said, "Thank you for sending me, because I got my new glasses. I expected better vision. You checked everything out and you saved my vision." And I just had another one just last week where I referred him after he had been seen by several doctors. And so I say that all to say the last thing just very quickly is that dispensing is not just a handing glasses to them. I apologize to any optician or apprentice that ever handed glasses to you and never took the time to make sure that everything was fitting right. But what is supposed to happen is that we are supposed to make sure everything is fitted properly, making sure that you're seeing well. All those types of things that kind of go on when you're doing those things. And it gives you the ability to check for things that could be just very minor. Maybe this measurement isn't right. Maybe we have to change how they're adjusted, to something very serious like loss of vision, which I've proudly saved in my career.
Well, thank you for doing that. And I appreciate all of the detail on that. If I could just ask you one quick follow-up.
Yeah.
And in a number, if you can. How long are you an apprentice? How long does that, is that required?
I was an apprentice, just solely apprentice for 2 years. And then at that second year, I kind of realized if I didn't go to school at this time, it's like my do or die. So I decided, going to school was 2 years. I had 2 years left of apprenticeship, or I could go to school for 2 years. And I knew my success rate would be higher if I went to school. And just to speak to that on real numbers, because I also administer the licensing exam, usually, just to give you real numbers, the state of Connecticut issues anywhere between 5 to maybe about 15 or 20 licenses every 6 months. We've done way more than that, more than we've ever done. So the argument that you're not able to find licensed help at a time like this, to me, is mind-boggling. As I watch many of my colleagues and even my coworkers open new stores and find licensed optician, licensed help just fine, including in Norwalk, which is in Fairfield. So I know it can be more challenging down there. The last thing I'll speak just very quick, I'm so sorry, is just that, we get, as opticians, we all get mailers and letters. These people seek us out. And I get mailers and letters every day about jobs that are available to me. And I feel that instead of Warby spending the time to find great licensed help to grow what I think could be a great business for them, it seems to me that the shortcut, easier answer is just to do it without the licensed optician, which to me can be very dangerous.
Well, I appreciate all of that and all of your input and the input of everyone who has come in the hours before you. the hours and
Yes.
hours for you.
Yes.
Because what it is doing is it's helping us to get to what really the question is here. And maybe it's not just, is this acceptable? It's why is it necessary? So thank you very much for that. I very much appreciate it. And I will
Thank
turn
you.
to the next. Thanks, Mr. Chair.
Thank you, Representative. Senator Anwar, followed by Representative Kavros DeGraw.
Thank you so much, Mr. Chair. I actually just have a comment. It's a quick comment. I just wanted to share with you, Mr. Wilson, that you had a very intelligent testimony. You actually identified the areas that were missed by some of the others. You're very persuasive, and you knew exactly the vacuum that we may have in our information about the situation, and you did that very well. And the second thing I want to mention is that I get inspired by anybody who loves their profession. It's very clear you love your profession. I'm inspired by you. Thank you so much.
Thank you. Thank you. I appreciate all your time, because I definitely can't be on a Zoom call for 12 hours like you guys do all the time. So I know that, I really appreciate all the effort that goes into making the state a lot better, where I live a lot better.
Thank you. Yeah, wait till we do a 24-hour one, which you can join us for that. Representative Kavros DeGraw.
Thank you, Mr. Chair, and thank you, Mr. Wilson, for being here. I posit that these 12-hour hearings are going to keep opticians in business for many, many years to come, because I know my eyes are tired at the end of the day. Regardless of that, I just wanted to, I haven't actually spoken, I was on another hearing earlier today, and I have been listening a lot to the testimonies today, and I just wanted to go back to what you said about catching things like a partially detached retina. That is my understanding, and from just people that I have anecdotally spoken to that have said, oh yeah, thank goodness, they were able to find this or that. And then I guess my other thing is regarding like contact lenses. I with all due respect to Warby Parker, I just don't know how you could be appropriately fit for contact lenses and that sort of thing, because I know they're doing that now as well. And as someone who has off and on struggled to wear them, I just didn't know if you had any comment about that. But the big thing for me is that we are catching, eye health is so critically important. And to have people on premises that are catching the, whatever it might be, whatever eye health issue, the beginning of cataracts, the beginning of a detached retina, or any number of things, especially, people who maybe don't know they have diabetes and are starting to have eye issues that they're not aware of.
Right.
If you can speak a little more to just that piece of it.
Yes, so to put it into perspective, I work at Costco, as you know. I do myself personally, I submit 2,000 orders of glasses myself. My store will probably do somewhere between 12 to 14,000 pairs of glasses, and will gross net somewhere around in some of the bigger stores, almost 3 million in this area per store. My average sale being only $175. On a daily basis, on a serious daily basis, I find clerical errors in prescriptions, and I have to call the doctor's office and clarify exactly what's happening with stuff. And my guys here actually are, I think, some of the best, man. I'm so proud of them all, because, we go through every single day, and I submit anywhere between 40 to 80 jobs a day. And I see anywhere that many prescriptions, and I do see clerical errors. I also do see things, that could be very dangerous to the health of the eye and stuff like that. And this is something that not just me, but also Costco themselves takes very seriously. And you can see the way the business is run here versus way other corporate opticals can run. They want to make sure that the members that are here are receiving great qualified help. And so making sure that we have licensed help, that's where we look to first. And so that's the reason why, if you go into any Costco, I can almost guarantee you, at least in the state of Connecticut and also Massachusetts and surrounding states that are licensed, you'll always have a licensed optician there, or if not literally a feet away, that can also intervene and help. And also, and any time that there's an apprentice, we're also going through it and teaching them everything that they would need to know. And they also actually, in the handbook, I almost forgot, have wording in there that once you're an apprentice, you also have to obtain your license at a certain amount of time. You're not allowed to just be an apprentice indefinitely, that you can't be on the payroll and fail the test time after time. So that it's a very, very serious role, and it's not only the onus on you as an apprentice to learn this and know how to do this, but it's my job as your manager and as your optician that you're learning under, that you know what you need to know to get through this test the first time. So, you know, that's what I want to highlight, because I think it's so important, because we talked a lot about the mom and pop shops and what they do, and versus, you know, Warby, but I want you guys to be able to see what a real corporate optical can look like, and how we operate business here, and why we operate business the way that we do.
Well, I thank you so much, and I just echo Senator Anwar's comments that you obviously have passion for the subject, and that's, you know, we love to see people who are passionate in their jobs, because that often means that they do a better job at their job. So thank you so much.
Yeah, the last thing I submit to you is just that I find it funny that there's only one company that I know of that has this issue. Recently, as I said, Costco's opened new stores. America's Best has moved into Connecticut. They've opened 5 locations very quickly, found license coverage, no problem. There's a lot of places that are opening, especially in Connecticut. And it seems that there's only one place that seems to have an issue finding people. And I think it's deeper within as to why they can't find help. Because we've passed, and like I said, they've had nearly 60 opportunities to find a licensed optician brand new, or anybody looking for a job. And there's hundreds, if not thousands of us, into the thousands of us, and they can't seem to attract anybody. So this is their last ditch effort, in my opinion, respectfully.
Well, I only have one last question for you, based upon your testimony. Do you need to have a Costco card to get glasses?
Yes, you do. They require that you have a membership, but I would say that it's definitely worth it. It's only $60. So even with the membership and the glasses, you probably still would have gotten glasses for less than what you would have found elsewhere. And then you can get gas even cheaper, because that's expensive now. So.
Well, we'll work on that next. Thank you for your testimony. Have a great evening. We appreciate
I appreciate the time.
Commitment